Rồi, rồi mình cái gì? Cho đây cái Facebook ra trên đời. Facebook magazine. Con không biết cái audio. Không hay tám. Đừng có làm cái kia nha. Đừng có chơi nữa nha.
health promotion and maintenance. The psychosocial integrity. The practical vocational nurse provides care that assists with promotion and support of the emotional, mental, and social well-being of clients. The licensed practical nurse must be able to assist in or reinforce education to caregivers, family, on ways to manage client with behavioral disorders. Participate in behavior management program by recognizing environmental stressors and/or providing a therapeutic environment. Participate in reminiscence therapy, validation therapy, or reality orientation. Participate in client group sessions. Identify signs and symptoms of substance abuse, chemical dependency, withdrawal, or toxicity. Collect data regarding client psychosocial functioning. Identify client use of effective and ineffective client abuse and neglect. Abuse and neglect can take on physical, psychological, and financial forms. The types of abuse and neglect are sexual abuse, physical abuse and neglect, psychological abuse and neglect, and financial abuse and neglect. The term elder abuse refers to any physical, psychological, sexual, or financial abuse that is carried out against an elderly person. Domestic violence entails the use of physical, psychological, sexual, or financial abuse against a spouse, family member, or significant other. Child abuse and neglect includes acts of violence or neglect against children that can include physical, psychological, sexual, or financial abuse, as well as physical, psychological, and financial neglect. Physical abuse can include things like punching, burning, and twisting limbs. Psychological abuse can include things like threatening harm to another, locking a person in a room, and bullying. Sexual abuse includes all sexual contact that is not agreed to by one party. Financial abuse is withholding funds that belong to another and abusing things like a power of attorney for the person's own gain without regard for the needs of the victim and their welfare. Examples of physical neglect can include things like not providing physical care and not providing for the physical needs of the victim when the abuser has the responsibility to do so. Psychological neglect can include things like isolating the victim for others and isolating the victim in their own home, away from other members of the family unit. Financial neglect is not providing the victim with basic and essential needs, even though ample financial resources are available to provide for these needs. Identifying the signs and symptoms of physical, psychological, and financial abuse and neglect in the client. The signs of physical abuse include physical injuries such as fractures, burns, cuts, and bruises. The signs of psychological abuse can include depression, apathy, isolation, and withdrawal. The signs of financial abuse can include shabby dress attire and poor basic hygiene and grooming. Signs like a weight loss or a failure of a child to gain weight according to the norms can indicate the presence of a physical, psychological, and/or financial abuse or neglect. The lack of family involvement in the care of a patient can indicate the possible presence of all of the types of abuse and neglect. Recognizing risk factors for domestic, child, and/or abuse, neglect, and sexual abuse. Recognizing risk factors for domestic, child, and/or elder abuse, neglect, and sexual abuse. Some patient populations are more at risk for abuse and neglect than other populations of patients. For example, females, pregnant women, infants, children, cognitively impaired individuals, the developmentally challenged person, those with physical or mental disabilities, and the elderly are at greater risk for abuse and neglect than other patient populations. Some of the traits and characteristics associated with abusers include substance abuse, a psychiatric disorder, poor parenting skills, poor anger management skills, poor self-esteem, poor coping skills, a personal history of abuse and/or neglect, poor impulse control, and the presence of a current crisis. The perpetrator's past history of their own abuse and neglect is perhaps one of the strongest forces that lead these people to abuse and neglect others. In terms of spousal abuse, the cycle of violence, also referred to as the cycle of battering, consists of the honeymoon phase of calmness and peace, the tension-building phase, the explosion phase in response to a trigger, and then finally, the reconciliation phase, which begins this endless cycle all over again unless treatments and interventions are successful in terms of preventing it. Providing a safe environment for abused and neglected clients. In addition to nurses' mandatory reporting, other interventions that provide a safe environment for abused and neglected patients include interventions such as safety planning, the identification of resources in the community, and psychosocial support of the nurse and other members of the healthcare team within a trusting, open, supportive, and non-judgmental professional relationship. Very often, neglected and abused children are removed from the home and placed in an alternative setting by law enforcement authorities. Abused spouses and intimate partners may be referred to a safe house. The elderly affected with abuse and/or neglect may be removed from their current home to protect these vulnerable victims. Providing emotional support to the client who has experienced abuse or neglect. Nurses and other healthcare professionals not only provide physical care to patients in terms of their physical care, they also provide emotional support and encourage enhanced coping skills among victims. The experience of abuse or neglect is a traumatic psychological crisis that must be addressed as such. The healthcare team must emphasize the fact that the victim has not done anything wrong. They must also emphasize the fact that the victim's life and the lives of their children can be in danger if the abuse is not addressed. It will not disappear with a lack of action. An order of protection against the perpetrator is often recommended. Reinforcing teaching related to coping and coping strategies. Abusers and victims alike need the reinforcement of teaching relating to coping and coping strategies. For example, abusers may need reinforcement about the need to attend anger management or parenting classes. Victims, on the other hand, may need reinforcement about the need to separate from the abuser to prevent the ongoing and endless cycle of violence. Evaluating client responses to interventions. The evaluation of the patient's responses to interventions determines how effective the care of the victim has been. For example, nurses determine whether or not serious and non-serious physical injuries are treated and stabilized. Nurses determine whether or not the patient has made decisions relating to their safety plan. Nurses also evaluate the patient's responses to psychological interventions and support. Were these interventions effective in meeting the patient's expected outcomes? Behavioral management. Monitoring the client's appearance, mood, and psychomotor behavior and observing for changes. The client's appearance, mood, behaviors, and changes of these indicators gives nurses rich data and information about the patient, their current state, and possible adverse behaviors that have to be managed before they occur. Reactive behavior management is far less effective than proactive behavior management that prevents poor patient behaviors. The patient's appearance is monitored in respect to the person's posture, gait, hygiene, grooming, and other things like the appropriateness of their attire. The patient's mood and affect are mentioned by interpreting their verbal and nonverbal communication. For example, is the patient's mood happy, elated, somber, sad, depressed, or flat and without any emotion whatsoever? Is the patient making eye contact, making any facial grimaces or unusual sounds, and/or having any unusual bodily movements that can indicate the patient's mood? For example, pacing may indicate agitation, anger, hostility, and/or restlessness. Exploring the causes of inappropriate client behavior. As nurses explore the causes of inappropriate and dangerous behavior, they consider environmental, physical, psychological, and social factors that may trigger and provoke these behaviors for their patients. Some of these environmental forces and factors that can precipitate inappropriate and dangerous patient behaviors can include hot or cold ambient temperatures, noxious odors, noises, and lights. Physical forces and factors that can precipitate inappropriate and dangerous patient behaviors can include physical illness, pain, fever, fatigue, and sensory or perceptual disorder, such as impaired sight and hearing. Some of these psychological forces and factors that can precipitate inappropriate and dangerous patient behaviors can include the presence of an existing psychiatric mental disorder, delusions, delirium, psychological trauma and crisis, and abuse. Additional explorations into the causes of inappropriate and dangerous behavior include the determination of events and situations that were present just prior to the behaviors, where the behaviors occurred, when and what time of day the behaviors occur, and what environmental factors may have contributed to the triggering of the event. The best way to incorporate all of these forces and factors into your determinations is to know your patients and the things that tend to trigger them into poor and inappropriate behaviors. Assisting the client with achieving self-control of behavior. Nurses assist clients with achieving their own self-control of behavior with a number of different strategies, including behavior modification, modeling, desensitization, operant conditioning, contracting, and aversion therapy, among other strategies. Behavior modification is a planned and systematic intervention that aims to change the patient's behaviors with the consistent reinforcement of positive and adaptive behaviors with praise and rewards, and the consistent use of negative reinforcement for negative maladaptive behaviors, such as acting out. Modeling gives the patient an opportunity to observe and mimic appropriate behaviors that are most often provided by the psychological therapist. Desensitization is the purposeful and systematic exposure of the patient to progressively more provocative and intense stimuli so that the patient can learn how to cope with these stimuli in a progressive manner with the support of those involved in the care of the patient. Operant conditioning, akin to Skinner's theory, is the provision of positive reinforcement and rewards for appropriate behaviors. Contracting entails a formal written and signed contract that details what the patient can and cannot do. Aversion therapy is the use of negative reinforcements, such as the cessation of privileges, when the patient demonstrates inappropriate or dangerous behaviors. Assisting the client in using behavioral strategies to decrease anxiety. Behavioral strategies to decrease anxiety include cognitive reframing and a wide variety of stress management relaxation techniques like those that we will discuss now. Cognitive reframing is done to teach the patient to stop negative thoughts by consciously replacing these negative thoughts and impulses with positive thoughts. Meditation is deep focus and thought. Meditation is often difficult for beginners because they are not used to sitting quietly with nothing other than one's own thoughts. But with practice, most people can master this deep focus and thought. Meditation can be done anywhere and at any time provided that the person is not easily distracted. Many cultures and religions use meditation for spiritual and religious purposes. Prayer is a formalized form of religious meditation. Like meditation, prayer requires deep focus and thought. Journaling provides the opportunity for people to record and document their feelings and thoughts. At times, people incorporate events or interactions that trigger their feelings and thoughts so that, at a later date, the person can look back over their journaling entries to identify patterns or trends. For example, the person may notice that their stress and anxiety increases when they are tired or when they are interacting with a particular person. Deep breathing consists of taking deep and cleansing breaths while using the diaphragm. The procedure entails taking as deep a breath as possible, holding it, and then slowly exhaling while thinking peaceful thoughts. Progressive relaxation involves contracting and releasing all muscle groups in the body. Most people begin with their feet. Then they work their way upward in an orderly and systematic manner. The procedure for progressive relaxation involves contracting and creating tension in the muscle groups and then relaxing and releasing the muscular contractions. Guided imagery is quite similar to meditation. In fact, guided imagery is often used with meditation. Guided imagery involves the person's visualization of a peaceful scene like a sunset or a quiet beach with rolling waves while they think peaceful thoughts. Music therapy can be used alone or in combination with other anxiety-reducing techniques such as deep breathing, meditation, and guided imagery. Biofeedback is not done as often as the other stress management and anxiety-reducing techniques. Biofeedback involves the patients being hooked up to externally placed electrodes and then connected to a visual display of the patient's heart rate, pulse rate, body temperature, breathing, etc. when exposed to stressors. The patient then performs some relaxation techniques, such as deep breathing, as they watch their internal bodily control over these bodily responses to stress. Mindfulness entails becoming acutely aware of the environment and the person's immediate surroundings to gain insight into it as anxiety is reduced. Resetting priorities allows the person to think about and renumber their priorities so that things can be manageable and put into perspective. Assisting in and reinforcing education to caregivers, family on ways to manage client with behavioral disorders. Caregivers, families, and friends often provide a support system for the client when it comes to coping with and adapting to psychological disorders, such as those requiring behavior management. These supports should encourage the patient to use positive behaviors. They should provide the patient with support and compassion. They should know how to prevent and de-escalate inappropriate behaviors. Nurses, therefore, should instruct and reinforce teaching for patients and their caregivers about all of these issues and the known triggers that precipitate the inappropriate behaviors for the patient, including environmental, physical, and psychological triggers. Participating in a behavior management program by recognizing environmental stressors and/or providing a therapeutic environment. Poor behaviors are best prevented within an environment that is without stressors and triggers that precipitate poor behavior. Milieu therapy, as well as the establishment and maintenance of a therapeutic relationship, can eliminate as many stressors and triggers from the environment as possible. Milieu therapy entails the planned and systematic changing of the patient's environment so that the patient has the opportunity to better cope and adapt when all extraneous variables in the environment are eliminated. When these factors are consistently eliminated, the patient is better able to identify and stay in keeping with the established boundaries and rules. They are better able to avoid stressful stimuli and triggers. They are better able to participate in appropriate activities and communication. Participating in reminiscence therapy, validation therapy, and reality orientation. Some of the therapies that are appropriate to meet the special needs associated with stress and anxiety include reminiscence therapy, validation therapy, and reality orientation. Reminiscence therapy is the sharing of life stories, memories, personal biographies, and histories with others. Reminiscence therapy gives the person who is sharing their story an opportunity to not only relate historical facts, but also to share how they felt about and coped with the events of their life. Reminiscence therapy gives the person a feeling of self-esteem and value. Validation therapy is beneficial to patients because it allows the patient to resolve conflicts and issues as the therapist recognizes and empathizes with the patient's experiences and responses as conflicts and issues are resolved. Reality orientation promotes the patient's identity, the time, and the place. Reality orientation is most often used among patients who, as a result of a temporary or permanent condition, are not oriented ×3 to person, place, and time. Participating in client group session. Nurses not only participate in group therapy sessions, but they also encourage their patients to participate in them. Group sessions facilitate the patients sharing their feelings, fears, concerns, and experiences with others. These things give patients the opportunity to vent. It also gives the participants an opportunity to provide feedback to the person who is doing the sharing. Reinforcing client participation in therapy. Therapy, including individual therapy, group therapy, and family therapy, is necessary for patient recovery and the prevention of relapses for psychiatric mental health disorders. All patients should be encouraged to participate fully in their group therapy sessions, and they should also be recognized and positively reinforced by the nurse and other members of the healthcare team when they do participate. Using behavioral management techniques when caring for a client. Behavioral management techniques, in addition to the behavior management strategies such as contracting and modeling that were previously discussed, are other strategies that can also be helpful to the patient. Some of these techniques, among others, are setting clear limits, setting realistic goals and expectations, and providing the patient with positive reinforcement with rewards and praise for positive progress and appropriate behaviors. Evaluating client responses to behavioral management interventions. As with the evaluation of all nursing care and patient responses to behavioral management interventions are compared to the pre-established expected outcomes to determine whether or not these interventions were successful in meeting these expected outcomes. Chemical and other dependencies. Substance abuse is one's overindulgence on a substance, which can be alcohol, prescription drugs, and/or illegal drugs. Some of the commonly used terms and terminology relating to substance abuse will now be defined. Chronic drug abuse is defined as the abuse of a substance that causes the person to have physical, psychological, social, and/or economic harm. Addiction is defined as the compulsive need for the person to have the substance. Addiction can occur with and without physical dependence. Psychological dependence is defined as the person's need to continue the use of the substance to avoid any unpleasant feelings and experiences that can occur when the substance is not taken. Physical dependence is defined as the occurrence of adverse ill effects when the substance is not taken. Physical dependence does not necessarily indicate that the person is addicted. Identifying the signs and symptoms of substance abuse, chemical dependency, withdrawal, and toxicity. Drug-seeking behavior is a sign of substance abuse. Drug-seeking behavior is defined as patient behavior that the person uses to get prescription medications, such as narcotic pain medications. Some of the signs of drug-seeking behavior are the person's feigning pain or anxiety to get a prescription medication, the person's claiming that they have lost their ordered medication and they ask for another prescription, the person's use of forged prescriptions, the person's use of altered prescriptions, the person's illegally using a false form of identification to get medications from another provider, and threatening healthcare providers for not giving them their needed medications. Although the physical signs and symptoms of substance abuse vary among the different possible substances, there are some signs and symptoms of substance abuse that are commonly occurring. These signs and symptoms include track marks on the body, unkempt appearance, poor hygiene and grooming, hyperactivity, sweaty palms, cold hands, shakiness, and unusual breath and/or body odors. Some of the commonly occurring behavioral and emotional signs and symptoms of substance abuse, in addition to drug-seeking behaviors, can include moodiness, paranoia, forgetfulness, a lack of focus and attention, irritability, and nervousness. Some of these specific signs and symptoms specific to some of the commonly used and abused substances include: for opioids, tremors, diarrhea, fever, nausea, vomiting, bone pain, muscular pain, goosebumps, piloerection, pupil dilation, and muscle spasms are signs. Opioid withdrawal signs and symptoms can include high levels of anxieties, diaphoresis, muscular aches and pains, insomnia, a runny nose, abdominal cramps, diarrhea, and dilated pupils. Toxicity to opioids can be signaled with pinpoint pupils, bradycardia, slow, shallow breathing, a decreased level of consciousness, unresponsiveness, cyanosis, circumferential pallor, muscular spasms, and seizures. For alcohol, tachycardia, abdominal cramps, delirium, vomiting, and tremors are signs. Alcohol withdrawal can lead to a variety of physical and psychological or emotional symptoms when a chronic drinker suddenly discontinues drinking. Some of these signs and symptoms are mild, others are moderate, and still more can be severe. Some of the most commonly occurring mild to moderate symptoms of alcohol withdrawal are nausea and vomiting, pale and clammy skin, shakiness, nervousness, anxiety, depression, fatigue, nightmare, diaphoresis, headaches, a rapid heart rate, and tremors. Some of the most commonly occurring severe signs and symptoms of alcohol withdrawal are agitation, fever, convulsions, and at times, a very pronounced state of confusion known as delirium tremens. These severe symptoms can lead to injuries, and even death. For cannabis, tremors, abdominal pain, fever, irritability, aggression, and headaches are signs. For cocaine, agitation, depression, fatigue, cravings, and psychomotor slowness are signs. For amphetamines, hypertension, hypervigilance, extreme irritability, cravings, and depression, particularly when it is not used, are signs. For inhalants, the slurring of speech, a stuporous state, dizziness, and a lack of coordinated bodily movements are signs. For sedatives, nausea, vomiting, agitation, seizure activity, anxiety, and tremors are signs. Anxiety, seizures, hallucinations, uncontrollable shaking, and possible heart failure can occur when the patient is withdrawing from sedatives. The signs of sedative toxicity are anxiety, depression, psychosis, confusion, and panic. For hallucinogenic drugs, anxiety, dilated pupils, depression, flashbacks, a rapid heart rate, and panic attacks are signs. Planning and providing care to client experiencing substance-related withdrawal or toxicity. Depending on the substance, some patients can experience substance-related withdrawals and toxicities that can be life-threatening. In addition to physical monitoring and the care of the physical needs of the patient, such as the administration of medications for the signs and symptoms of withdrawal or toxicity, and the maintenance of the fluid and electrolyte balances, some general interventions for substance withdrawal and toxicity include the creation and maintenance of an environment that is at a low level of stimulation and without any potential for sensory overload, the creation and maintenance of an environment that is physically and psychologically safe for the patient, the ongoing provision of emotional support without any biases or judgments, the teaching of the patient, family members, and significant others about addiction and codependent behaviors, assisting the patient with an emergency plan that they can use when they believe that a relapse is possible, developing the patient's motivation and commitment to recovery and sustained abstinence, and facilitating the patient's attendance in frequent self-help groups like Alcoholics Anonymous and Narcotics Anonymous. In addition to referrals to self-help groups like Alcoholics Anonymous and Narcotics Anonymous, other behavioral interventions for patients affected with substance abuse and misuse include individual and group therapy, the development of a contingency management strategy that the patient can use, the development and maintenance of a therapeutic milieu and a therapeutic community that provides the patient with the support that they need, aversion therapy, and the development of a relapse prevention strategy. Patient education to avoid relapses. Patients who abuse substances are always at risk for a relapse. The relapse rate for this population of patients is disappointingly high, so ongoing support and education should be provided to prevent this negative outcome. Some strategies to prevent a relapse include the following interventions. Nurses should discuss and explore the positive effects of abstinence, discuss and explore the negative consequences of continued substance use, discuss and explore ways that the patient can recognize and avoid high-risk situations that may place them at risk for a relapse. For example, many patients benefit from avoiding people and situations that they had in their past when they were using or abusing substances. Work with the patient to develop the skills necessary for them to avoid any trigger situations and to be able to or cope effectively with abstinence when these trigger situations occur. Develop a relapse emergency plan in order to limit the length of severity of relapses should they occur. Involve family, friends, and other support people about who they and the patient can contact for help if a relapse occurs or a relapse is possible. Help the patient to identify and cope effectively with substance urges and cravings. Teach the patient about the steps they must take to reconnect with the services that they need during a relapse, and arrange for regular informal check-ins with patients that can help reduce potential problems before they become severe enough to threaten recovery. Providing care and support for client with impulse control disorders like gambling, sexual addiction, and pornography. Impulse control disorders, such as compulsive gambling, sexual addiction, and addiction to pornography, kleptomania, pyromania, shopping addictions, Trichotillomania and even addictions to work are often referred to as compulsive behavior disorders or process addictions. Some of the signs and symptoms of impulse control disorders include substance abuse, abusive behaviors towards others, aggressive actions towards others, destructive behaviors like the destruction of personal property and the property of others, inflicting self-harm, suicidal ideations and suicidal tendencies, compulsive theft and shoplifting, and other dysfunctional or maladaptive behaviors. The most common risk factors associated with compulsive behavioral disorders or process addictions include genetics, physical abnormalities, and an individual's environment. It appears that multiple members of one family may have a compulsive behavioral disorder. Therefore, it is possible that genetics play a role in this psychological disorder. Imbalances in specific neurotransmitters chemicals in the brain have been found among patients who are adversely affected by and diagnosed with impulse control disorders. Environment may also play a role. Environmental risk factors include growing up in and/or living in an environment that is affected with substance use, aggression, violence, neglect, and/or abuse. The two most frequently used treatments for impulse control disorders include cognitive behavioral therapy and/or drug therapy. Some of the drugs that can be used to treat compulsive behavioral disorders include selective serotonin reuptake inhibitors and antidepressants. Reinforcing information on substance abuse diagnosis and treatment plan to client. Chemical and other dependencies have a tendency to relapse. Although the recidivism or relapse rates vary among different substances and other addictions, nurses must be aware that relapses do occur. Therefore, nurses must be prepared to support and reinforce information about substance abuse and treatments in order to prevent a relapse. Nurses and other healthcare professionals provide emotional support and reassurance, educate client family about addiction and codependent behaviors, advise the family about removing prescription medications from home environment, facilitate the client's development of the motivation and commitment necessary for abstinence and recovery, help the client develop an emergency plan, and encourage attendance at self-help groups. Encouraging client participation in support groups like Alcoholics Anonymous and Narcotics Anonymous. Although there are other types of support groups in the community to address alcoholism and substance abuse, Alcoholics Anonymous and Narcotics Anonymous are perhaps the most well-known and the most often utilized support groups among those patients with a substance abuse disorder. Bill Wilson and Bob Smith founded and established Alcoholics Anonymous in 1935. Alcoholics Anonymous is a spiritual program that helps alcoholics to achieve and maintain their sobriety by attending group meetings and following the 12 steps of this non-religious but spiritual group. Those who attend Alcoholics Anonymous get the support of the other members or the group. In addition, they get the special guidance and support of their chosen sponsor, who has a one-to-one relationship with the alcoholic in terms of their recovery and sustained abstinence. Alcoholics Anonymous meetings are held throughout the world in the community, in healthcare facilities, in jails, and in other places. All members maintain the confidentiality of all other members, and they follow the 12 steps. The 12 steps of Alcoholics Anonymous are: 1. We admitted we are powerless over alcohol, that our lives had become unmanageable. 2. Came to believe that a power greater than ourselves could restore us to sanity. 3. Made a decision to turn our will and our lives over to the care of God as we understood Him. 4. Made a searching and fearless moral inventory of ourselves. 5. Admitted to God, ourselves, and to another human being the exact nature of our wrongs. 6. We're entirely ready to have God remove all these defects of character. 7. Humbly asked Him to remove our shortcomings. 8. Made a list of all persons we had harmed and became willing to make amends to them all. 9. Made direct amends to such people wherever possible, except when to do so would injure them or others. 10. Continued to take personal inventory, and when we were wrong, promptly admitted it. 11. Sought through prayer and meditation to improve our conscious contact with God as we understood Him, praying only for knowledge of His will for us and the power to carry that out. 12. Having had a spiritual awakening as the result of these steps, we try to carry this message to alcoholics and to practice these principles in all our affairs. Narcotics Anonymous, similar to Alcoholics Anonymous, was founded in 1953. Narcotics Anonymous groups also follow the 12 steps. They also have group meetings throughout the world, and its members choose a sponsor. The group members, however, consist of those who have abused drugs. Some patients may be a member of both Narcotics Anonymous and Alcoholics Anonymous. Monitoring client responses to the treatment plan and contributing to the revision of the plan of care as indicated. Nurses monitor client responses to treatments, and they contribute data that can be used for the revision of the plan of care as indicated. Coping mechanisms. Coping, simply defined, is the patient's ability to maintain and regain psychological homeostasis. Coping can be adaptive, and it can also be useless and maladaptive. Coping is adaptive when it resolves the stress, and it is maladaptive when it leads to more problems and it does not resolve the stress. Collecting data regarding the client's psychosocial functioning. Data and information that should be collected in respect to the client's psychosocial functioning should include the patient's specific psychosocial disorder, the patient's age at the onset of the disorder, the number of episodes that required intense treatment, the duration of these acute episodes, and the family's history of any psychiatric mental health disorders. Two standardized measurement tools that can be used to collect psychosocial data and information are the Range of Impaired Functioning tool and the Integrated Longitudinal Interval Follow-up Evaluation tool. The Range of Impaired Functioning tool measures the patient's level of functioning in terms of their work, their interpersonal relationships, their recreational activities, and the patient's levels of satisfaction. The Longitudinal Interval Follow-up Evaluation tool integrates into the Range of Impaired Functioning results. It measures the patient's progress over time in respect to their psychosocial functioning in terms of their work, their interpersonal relationships, their recreational activities, and the patient's levels of satisfaction. Identifying client support systems and available resources. Psychosocial support consists of individual, group, and family therapies, as well as the utilization of available community resources. Nurses should be knowledgeable about a wide number and variety of available resources so that they can recommend ones that the patient can benefit from and those that are also affordable and accessible to the patient. They should encourage the client to participate in several of these external support methods as appropriate to their need, and they should also educate family, friends, and whoever else is supporting the client about psychosocial functioning disorders and ways they can assist and support the affected patient. Identifying the client's use of effective and ineffective coping mechanisms. Coping strategies are perceptions, thoughts, behaviors, and emotions that a patient can use to cope with stress and any of their disruptions of psychosocial homeostasis. Stress is an important factor that greatly impacts on mental illness because it can worsen symptoms, it can lead to relapses, and it also impacts on all the other people who interact with the patient and who are not adversely affected directly with the psychiatric illness. Stress occurs as a result of significant life events such as illness, divorce, moving, parenthood, financial problems, and the death of a loved one. It also occurs as the result of the daily stressors that occur in normal life. Stress can affect the body in physical ways and in emotional or psychological ways. For example, stress can lead to anxiety, irritability, depression, a lack of focus, and forgetfulness. The physiological bodily responses to stress include headaches, sleeping impairments, trembling, stomach aches, muscular tension, and other somatic complaints. Some patients use a wide variety of coping mechanisms, and other patients may have few, if any, coping mechanisms. Coping mechanisms are learned. Some are effective, and others are not. Patients with no effective coping mechanisms must be taught about new and effective ways to cope with stress and stressors. Those who have effective methods of coping should be encouraged to use them during times of crisis. Commonly used coping mechanisms include changing one's perception of the issue at hand, using humor, using problem-solving skills, employing stress management and relaxation techniques, seeking out and using the support of others, ventilating feelings, embarking on a physical exercise and activity routine, decreasing personal expectations, and avoiding self-blame. Identifying stressors that may affect recovery, health, maintenance. Many factors, including stressors, affect a client's recovery from illness and their ability to maintain health. For example, lifestyle choices, bodily changes, and environmental factors that can affect a client's recovery from illness and their ability to maintain health. The Dimensions of Health model is helpful to remembering and understanding the factors that impact on the patient's recovery and health maintenance. The Dimensions of Health model consists of the biological, psychological, environmental, behavioral, sociocultural, and health systems-related factors that impact on the patient's recovery and health maintenance. The biological or biophysical factors, according to the Dimensions of Health model, include factors and forces such as the person's bodily changes, the person's genetics, and the person's level of functioning. The psychological factors that impact on the patient's recovery and health maintenance include the patient's level of stress and the effectiveness of their current coping mechanisms. Environmental factors that can influence health include the safety of the patient's environment, air pollution, home safety standards, and contaminated water. The behavioral factors that impact on the patient's recovery and health maintenance, according to the Dimensions of Health model, include things like lifestyle choices, such as the patient's exercise routine, their nutritional choices, and their consumption patterns relating to things like smoking, substance use and abuse, coffee drinking, and alcohol abuse. Sociocultural factors, according to the Dimensions of Health model, include things like the patient's available social supports, support systems, and cultural beliefs and practices. Health systems factors, according to the Dimensions of Health model, affect the patient's recovery and health maintenance because the accessibility, availability, and affordability of healthcare services for the patient may be contrary to health maintenance and recovery. Recognizing the abilities of the client to adapt to temporary and permanent role changes. Nurses must recognize and be able to address the client's ability to adapt to temporary and permanent life changes. Permanent role changes are often more stressful to the patient than temporary role changes because permanent role changes may cause major life changes and dependencies on others. Nurses can assist patients with their responses and reactions to permanent and temporary role changes by allowing and encouraging the patient to vent their feelings. They can also assist by helping the patient explore and identify realistic goals and to establish realistic expectations of what they are able to do despite some role changes and losses. Recognizing client responses to illness. Some of the most commonly occurring psychological and emotional alterations associated with illness include anger, denial, rationalization, grief and loss, fear, guilt, depression, suicidal and homicidal ideation, distress, loss of hope and meaning, and nearing death awareness. Anger can be turned outward, and it can also be turned inward and lead to depression. Anger turned outward can manifest with socially unacceptable hostility, physical violence, harm to others, and destructiveness. Anger can also be displaced to other more safe objects or people rather than the one who is the object of the person's anger. For example, a terminally ill patient may be extremely angry at the doctor, but they will not openly express that anger or act on the anger toward the doctor. Instead, they will direct their anger to the spouse, who is much safer than the doctor. Denial is a psychological defense mechanism. Denial occurs when the patient subconsciously ignores the existence of a threatening event or situation. Denial and rationalization, which is characterized with the patient's explaining away the threatening event or situation, is fully discussed later in this review with the topic, Recognizing the Client's Use of Defense Mechanisms. Grief and loss will be described and discussed in detail soon in this review with the topic, Grief and Loss. Depression, suicide, and homicidal ideation are fully discussed later with the topic, Identifying the Client Risk for Self-Injury and/or Violence. Fear, another patient response to illness, is characterized with feelings of dread as the response to an impending or actual danger, including psychological illness. Some of the signs and symptoms of fear that the patient can demonstrate are tachycardia, increased respiratory rate, hypertension, aggression, hostility, pupil dilation, vomiting, muscular tension, and feelings of dread, panic, and/or terror. Nurses address the needs of patients who are experiencing fear with a supportive environment, with the promotion of stress management and relaxation techniques, by assisting the patient to alter their perceptions of the threat and the severity of the threat, and by helping the patient to distinguish between real and imagined threats. Patients can also respond to illness with guilt. The ultimate purpose of guilt is to let the person know that they have done something wrong. The knowledge of and the recognition of guilt then allows the person to have the opportunity to change their unacceptable behaviors and to make amends for their transgressions and wrongdoings. Unresolved guilt, however, can lead to physical, psychological, and spiritual distress and despair. Nurses can help the patient to resolve their guilt by allowing the patients free expressions of their feelings, by encouraging the patient to change their behaviors, and by encouraging them to make amends to others for their wrongdoings. Clients and family members may need psychological, spiritual, and religious support to resolve feelings of guilt. Distress can range along a continuum from mild to severe and even disabling. Distress can also be signaled with a number of signs and symptoms, some of which can be emotional, some of which are physical, and some of which are behavioral. The signs and symptoms of distress include headaches, dilated pupils, muscular tension, oral dryness, moodiness, depression, nightmares, forgetfulness, racing thoughts, frustration, irritability, rapid speech, nail biting, restlessness, and an inability to sit still or sleep. Again, relaxation techniques, counseling, and the support of family, friends, and nurses are used to help the patient overcome their distress. The loss of hope can have psychological, spiritual, and/or religious impact on the patient who is responding to their illness with this feeling. Some of the signs and symptoms associated with the loss of hope include apathy, withdrawal, a lack of motivation, spiritual distress, psychological distress, and a lack of involvement in the plan of care. Levels of awareness impact on how the nurse communicates with and cares for patients and their family members. The three types of awareness are open awareness, closed awareness, and mutual pretense. Open awareness occurs when the patient and family members know about the illness, impending death, and/or terminal illness. They are able to freely talk about it and discuss things like future plans and even the finalization of matters such as funeral arrangements. Closed awareness is defined as a complete lack of unawareness of the illness, impending death, and/or terminal illness. Lastly, mutual pretense occurs when the patient and family members are aware of the illness, impending death, and/or terminal illness, but they do not talk about it with each other. Open awareness facilitates full discussions and the freedom to express thoughts and feelings. Closed awareness and mutual pretense are isolating because they do not promote full discussions and the freedom to express thoughts and feelings. Open awareness can be facilitated with honesty, a trusting patient-nurse relationship, and the emotional support of the patients and family members who are impacted with the illness, impending death, and/or terminal illness. Providing support to the client with unexpected altered body image. Alterations and changes in the body image can occur predictably and expectedly along the developmental and maturational continuum of life. Alterations and changes in the body image can also occur unpredictably and unexpectedly as a result of illness and therapeutic treatments. For example, predictable and expected alterations and changes in the body image occur as a result of pregnancy, the normal deterioration changes associated with the aging process, and also as the result of the changes associated with puberty. Unpredictably and unexpected body image alterations as the result of illness and therapeutic treatments include changes such as alopecia secondary to chemotherapy, the loss of the breast as a result of breast cancer, the loss of functional ability secondary to paralysis, and the loss of the sexual body image with an orchiectomy secondary to testicular cancer. Patients with actual and perceived body image changes and alterations need the support of nurses and other members of the healthcare team in order to successfully cope with these losses. Using therapeutic techniques to assist the client with coping abilities. In addition to therapeutic communication and milieu therapy, nurses should promote the identification and utilization of more effective coping mechanisms. They should also establish boundaries that are necessary to achieve optimal outcomes. They must also promote relaxation and stress management techniques to assist the patient and their coping skills. Assisting the client to cope and adapt to stressful events and changes in health status. Some of life's most stressful events include acts of abuse, neglect, and violence, as well as highly significant life and physical changes that occur at the end of life and upon the diagnosis of a terminal disease and impending death. Abuse and neglect were previously discussed with abuse and neglect. Acts of violence such as suicide, homicide, and suicide-homicide will be discussed shortly with the topics collecting data on the client's potential for violence to self and others, and identifying the client risk of self-injury and/or violence. End-of-life care is also fully discussed later in this review under the topic End-of-Life Concepts. Assisting the client in maintaining their level of independence after unexpected bodily image. Patients who have been affected with an unexpected bodily change, such as paralysis or an amputation, need the psychological and physical support of the healthcare team to cope with these changes. For example, the patient affected with paralysis or an amputation can benefit from psychosocial healthcare services as well as the services of the rehabilitation and restorative healthcare team, such as those provided by a physical therapist, an occupational therapist, and a prosthetic expert. Monitoring the client's progress toward achieving an improved body image. With holistic physical and psychological care, patients who have an alteration of bodily image, such as can occur with a mastectomy, a colostomy, an amputation, a tracheostomy, or paralysis, can effectively cope with and adjust to this change of their body image. After the patient has effectively coped with the grief and loss, some of the signs that can indicate that the patient is progressing toward achieving an improved body image can include their visualization of and care for the affected bodily part, the resumption of their normal activities and interactions, and using assistive, enhancing prostheses like a breast form after a mastectomy and an artificial limb after a traumatic, unexpected amputation. Crisis intervention. A crisis is an acute but temporary episode, usually lasting from 4 to 6 weeks in duration, with which a client is subjected to an emotional reaction that their normal coping mechanisms may not manage. The components of crisis that make them so serious include an incident or event that has arisen without any warning or preparation, and the perception that this incident or event is highly serious and even life-threatening. These components of crisis often incapacitate patients. Crises can be classified as maturational, situational, and adventitious. Maturational crises include events such as retirement, pregnancy, and puberty. Examples of situational crises include the loss of the home to foreclosure, the loss of a spouse, and divorce. Examples of adventitious crises are the personal losses experienced as the result of Hurricane Katrina and a violent burglary in the patient's home. Identifying the client in crisis. The severity of a crisis can be categorized with levels of severity from 1 to 4. A 1 level of severity is the least disruptive of crises. A level 4 crisis is the worst of crises in terms of severity. The typical signs and symptoms experienced with the patient that can and should be identified by the nurse according to the level of severity for the crisis are as follows. Patients experiencing a level 1 crisis typically experience anxiety. They usually employ ego defense mechanisms that will be fully discussed later in this review course. Patients experiencing a level 2 crisis typically experience some loss of their ability to function. These patients may attempt to experiment with new and often ineffective ways of coping and increased anxiety because ego defense mechanisms are not effective enough to deal with this severe crisis. Patients experiencing a level 3 crisis are characterized with fight, flight, and panic. Those with a level 4 crisis will be completely overwhelmed, detached, disoriented, and even violent towards self and others. Identifying the client risk for self-injury and/or violence. Suicide, homicide, and suicide-homicide are severe psychological crises that must be prevented. The best way to prevent these adverse events is to prevent them by identifying patient risks and intervening to prevent these risks from transforming into these often deadly responses. For example, depression must be identified and treated so that it does not lead to suicide or suicide-homicide. The commonly occurring signs of suicide include saying goodbyes, a lack of interest in the future, guilt, shame, oral or written statements about suicide, changes in appearance, changes in personality, giving treasured possessions away to others, unusual behaviors, sleep alterations, and self-harming behaviors. Collecting data on the client's potential for violence to self and others. In addition to identifying a patient at risk by determining their risk factors, data and information is also collected in terms of the patient's intensity and duration of the depression, the elements of their suicide plan, their intensity of their suicidal intent, and an ongoing determination of the patient's current feelings about suicide and death until the risk has been eliminated and the patient is psychologically stabilized. All threats of suicide must be taken seriously and not minimized. The primary intervention is prevention. The environment of care must be open, supportive, honest, non-judgmental, caring, and filled with trust, compassion, and understanding. Constant observation and the use of restraints or seclusion may be necessary when the risk of suicide and self-harm are high. The safety of the suicidal person must be preserved and maintained. Homicide and suicide-homicide risk is also great among clients who are adversely affected with crises and depression. Some patients may decide on homicide or suicide-homicide because they are lashing out at those who they perceive caused their problems. Others may try to save others by killing them and keep them from the pain and suffering that the crisis brought to them. Still more, kill others and then promptly kill themselves to avoid further pain and suffering. Assisting in managing the care of the angry, agitated client. Information about managing the care of the angry, agitated behavior was previously discussed under behavioral management. Using crisis intervention techniques to assist the client in coping. In addition to maintaining the patient's safety, emotional and physical interventions are employed to assist patients with their coping and coping skills that are necessary to resolve the crisis. The first step is establishing trust and then allowing the patient to fully and freely ventilate their feelings in the therapeutic patient-nurse relationship. Nurses employ therapeutic communication. They remain respectful and caring. They give the patient feedback and guidance about coping skills. They encourage the patient's participation in one-to-one and group psychotherapeutic groups. They promote the client's use of alternative treatments such as meditation and guided imagery. At times, medications may be ordered and given to the patient on a temporary basis until the crisis is resolved. Providing opportunities for the client to understand why the crisis occurred. Nurses and other members of the healthcare team provide opportunities for the client to understand why the crisis occurred so they can gain some insight into it, how it occurred, and why it occurred, so they can gain a fuller understanding of how to prevent future occurrences. Guiding the client to resources for recovery from crisis. Client recovery and the prevention of future occurrences can be facilitated with follow-up care, information about crisis and coping skills, and with the use of local community resources as well as the maximization of social supports as based on the unique needs of the patient. Reinforcing client teaching on suicide, violence prevention. Teaching on suicide and violence prevention should include the signs and symptoms of crisis, the signs and symptoms of depression, the risk factors associated with suicide and violent acts, the importance of following the treatment plan, when to call for help, and who to call for help, including their doctor or a suicide prevention hotline. Reporting changes in client behavior. Nurses must be fully knowledgeable about the signs and symptoms of a possible impending crisis so that they can immediately report patient changes to the charge nurse or supervisor so immediate attention to the client and interventions can begin. Cultural awareness. Similar to the widespread misinformation that spirituality and religion is the same thing, many also believe that ethnicity and culture is the same thing when they are not. An ethnic group shares a common characteristic, such as a language. Culture is a set of practices, customs, beliefs, and attitudes that is passed from generation to generation and not shared by others outside of the culture. Identifying the importance of client culture when planning, providing, monitoring care. Madeline Leineger's theory of transcultural nursing is useful to nurses and the nursing profession in terms of understanding culture and how culture impacts on the care of the patient and the care of patient populations or groups. Madeline Leineger's theory of transcultural nursing is quite popular in nursing. This theory supports the belief that nursing care for patients with a culture different from ours must be carried out using one or more of the following three nursing modes, which are 1. cultural preservation and maintenance, 2, cultural accommodation and/or cultural negotiation, and 3, cultural restructuring and repatterning. During the assessment phase of the nursing process, the nurse determines the patient's cultural background, as well as their cultural beliefs, practices, preferences, and needs. The nurse then develops a plan of care that addresses and accommodates for these cultural beliefs, practices, preferences, and needs. Culture is very integral and central to patients, who they are, and what they do as a unique and valued individual. Culture greatly impacts on the client's health, the patient's needs, and their responses to care. Cultural competency allows nurses to gain insight into different cultures. It allows nurses to integrate cultural knowledge into the treatment of patients. It allows us to remain respectful of all humans and their cultural beliefs. It also gives us a deeper understanding of our patients and the importance of nurses' understanding of human beings as holistic beings. Recognizing client cultural practices that may affect interventions for procedures, surgery, and care. Culture impacts on all aspects of the patient-nurse relationship. Family dynamics, levels of self-efficacy, perceptions and views relating to health and illness, communication, space orientation, time orientation, and nutritional patterns are often driven by culture and cultural beliefs and practices. Now, we will discuss these beliefs and practices. Family dynamics. The roles of different members of the family, the size of the family, inter-family dynamics, interpersonal interactions, and communication patterns within the family unit often vary according to one's culture. For example, some families are paternalistic with the male as the predominant figure of the family unit. Some families have top-to-bottom communication patterns where the leaders communicate with the followers in the family unit and not from the bottom up. Some families value their elders and others do not. Still more culturally bound dynamics can include decisions and decision-making. For example, some families elicit the help of those outside the family in terms of decision-making. Others restrict decision-making to only one person, only the nuclear family members, or only the members of the extended family size in collaboration with the nuclear family. Self-efficacy. Simply defined, self-efficacy is the personal belief that they have the ability to do something successfully. Patients with the belief that they have self-efficacy will be motivated to learn. They will be motivated to participate in healthcare, and they will be motivated to change behaviors when they believe that they are able to do these things to promote health, prevent illness, and solve their current problems. Patients with low levels of self-efficacy believe that they cannot succeed, so they do not even try. Culturally, some cultural groups believe in and practice self-efficacy, and others do not. Perceptions relating to illness and health. Some cultures place a high value on health, health promotion, and wellness, and others do not. Some cultures believe that illness is stigmatic and outside of any control by the members of the culture. Still more may have culturally bound rituals and practices to promote health, to prevent illness, and to cure disease. Communication patterns. As fully discussed in the beginning of this review under the integrated process of communication and documentation, nonverbal and verbal communication elements such as vocabulary, terminology, silence, eye contact, facial expressions, and touch are influenced by and impacted with culture. Space and distance orientation. Space and distance orientation and tolerance also varies among cultures. It appears that cultures who live in crowded areas, such as in heavily populated urban areas, are more tolerant of closeness than those who have become accustomed to less crowded rural areas. Time orientation. Some cultures place more of a focus on one aspect of time more than the other two aspects of time. For example, some cultures focus more on the past than on the present or futures. Other cultures place an emphasis on the present rather than the past or future. Still more focus on the future rather than the past or present. Patients who focus on the future tend to be more committed to health, wellness, and prevention of future diseases, as well as solving the current healthcare problems in hopes of a better future. Nutritional patterns. Cultures differ vastly in terms of the meaning of food, preferred and favorite foods, cooking methods, and their rituals and practices relating to meals. For example, the Hispanic and Asian cultures prefer rice as a staple of their meal. Hindus, Sikhs, and Buddhists are vegetarians. Recognizing cultural issues that may impact on the client's understanding of and acceptance of psychiatric diagnosis. Cultural issues probably impact psychiatric patients and psychiatric diagnoses more than physical disorders. Culture may impact on the psychiatric mental health patient's willingness to seek out and use the professional services of the psychiatric mental health team. It may impact on the patient's and family members' perception of the psychiatric illness in terms of where it came from and whether or not the mental illness is imagined or real. Culture can also impact on how and where the patient verbalizes their inner thoughts and symptoms. Some cultures attach a social stigma to psychiatric disorders rather than viewing a psychiatric mental health as an illness in the same manner that physical diseases and disorders are. Making adjustments to care with the consideration of the client's spiritual and/or cultural beliefs. Nurses identify clients' spiritual and cultural beliefs in respect to mental health disorders and the treatments of psychiatric mental health disorders, after which they respect these cultural and spiritual beliefs and incorporate them into the patient's plan of care. Respecting the cultural background and practices of the client. To the greatest extent possible, nurses and other healthcare providers respect all patients by incorporating their cultural practices and rituals into the plan of care. Documenting how the client's language needs are met. As previously discussed, many clients have language needs that must be accommodated for in order to provide client care. Language and communication needs, such as those needs that require the use of a professional language interpreter, were fully discussed with the integrated process of communication and documentation. End-of-life concepts. Patients at the end of life and their family members have uniquely different needs than those who are experiencing other losses. Death, like all other life processes, can vary among individuals, but the process of death can also take on some predictable phases. Some people are at the end of life because of a relatively rapid but steady decline and deterioration over a short and brief period of time. Other people may decline and deteriorate gradually over a long period of time. Still more may be at the end of life and death with a very sudden and abrupt cessation of life as the result of some traumatic or physiological event, like an automobile accident or a myocardial infarction. The peri-death process consists of the first phase of the process, which is the preparation for death, the second phase of the process, which is the death itself, and the third phase of the process, which is the period of time immediately following the death. Some of the signs and symptoms that occur during the preparation for death include restlessness, incontinence, lethargy, social withdrawal, bodily coolness, respiratory changes, including Cheney-Stokes respirations, confusion, a lack of orientation to person, time, and place, a refusal to eat or drink, letting go, visual experiences and hallucinations, and saying goodbyes to loved ones. Identifying client end-of-life needs. End-of-life needs include physical, psychological, social and spiritual, cultural, and religious needs. Some of the physical needs at the end of life are anorexia, dehydration, and fluid and electrolyte imbalances. Patients in the peri-death process often experience a loss of appetite, anorexia, and weight loss. Intravenous fluids, total parenteral nutrition, and tube feedings can be used if the client chooses to have these treatments. When the client refuses these treatments, nurses and family members have to accept the patient's choice. Dehydration occurs when losses are greater than fluid gains. Fluid losses occur at the end of life as the result of symptoms such as vomiting and diarrhea. Fluid gains are often restricted and low when the patient is not eating and drinking, and also when they choose to forego artificial means of hydration and nutrition, such as intravenous fluid supplementation and tube feedings. Mild to moderate dehydration at the end of life can be manifested with dry skin, dry oral mucosa, constipation, a headache, thirst, orthostatic hypotension, dizziness, and diminished urinary output. The signs and symptoms of severe dehydration at the end of life are oliguria, anuria, sunken eyes, poor skin turgor, confusion, hypotension, tachycardia, tachypnea, fluid and electrolyte imbalances, fever, delirium, confusion, and unconsciousness. Simply stated, electrolytes and fluids are lost at the end of life as the result of dehydration and the lack of fluid and electrolyte replacements. More information about fluids and electrolytes and fluid and electrolyte imbalances is fully described in detail later in this review with fluid and electrolyte imbalances. Some of the psychological needs of patients and family members at the end of life include those relating to anger, hostility, anxiety, denial, depression, guilt, the loss of hope, the loss of meaning, sleep disturbances, the lack of intimacy, distress, confusion, fatigue, agitation, delirium, which will be fully discussed later in this review, financial fears, and fears of the unknown. The signs and symptoms of acute confusion include increased cognitive changes, agitation, hallucinations, restlessness, the lack of goal-directed behavior, and altered levels of conscious. The signs and symptoms of chronic confusion include impaired long-term and short-term memory, alterations in personality, altered responses to stimuli, impaired mental capacity, and the other signs and symptoms of acute confusion. Confusion resulting from psychological causes can typically be corrected with physical interventions. For example, confusion secondary to delirium can be corrected with the treatment of an underlying physiological disorder. Confusion secondary to hypoglycemia can be corrected with the administration of glucose or sugar. Fatigue, simply defined, is excessive tiredness that is often accompanied with a person's inability to perform their daily activities. Patients affected with severe fatigue may not even be able to do even minimal physical and mental work. Some of the factors that can lead to fatigue include physical weakness, stress, depression, and sleep deprivation, all of which can commonly occur among patients who are at the end of life. Fatigue at the end of life can manifest with lethargy, listlessness, a lack of motivation to do anything, guilt, and decreased levels of awareness and the ability to focus and concentrate on things like the basic activities of daily living. Some alternative treatment options for fatigue can include sleep promotion measures, stress and relaxation techniques, nutritional support, the correction of any biological causes that are leading to the fatigue, and psychosocial support. Clients who experience this agitation and restlessness at the end of life can manifest hallucinations, psychotic episodes, constant complaints, significant changes in behavior, and foul language that is not characteristic for the patient. Agitation and restlessness at the end of life can occur as the result of several causes, including fluid and electrolyte imbalances, decreased liver function, impaired renal functioning, and changes in terms of the acid-base or pH balance of the blood. When an underlying cause of agitation and restlessness can be treated, it is typically done. When the agitation is significant and not able to be corrected with the treatment of an underlying cause, anti-anxiety medications are often used. Some of the commonly occurring fears at the end of life include financial fears, fears of the unknown, fears relating to the loss of control, fears relating to the loss of a patient's independence, and fears relating to one's control over their own actions. At the end of life, many clients lose control over their physical, psychological, and social needs, and they also lose their independence. Nurses should facilitate and encourage as much independence and control as possible for the client, as based on their unique needs and capabilities. Roles and the ability of the person to perform their multiple roles also change at the end of life. The loss of role functioning, like the loss of independence, can lead to social isolation, depression, poor self-esteem, and despair. Identifying the client's ability to cope with end-of-life interventions. The ultimate goal of end-of-life care is to facilitate the client's and the family member's ability to effectively cope with the end of life and all the stressors associated with it. Patients and family members manifest effective coping when they are free of all psychological and emotional symptoms such as depression, agitation, fear, anger, and the other psychological and emotional symptoms at the end of life that were discussed above. providing care and support for the family and caregiver support at the end of life. Nurses and caregivers play a highly important role in the physical, psychological, and social support of the client at the end of life. Caregivers, however, need the support of the nurse to overcome their own fears about caregiving and to overcome the physical and psychological burdens of caregiving. Care of a loved one is often stressful and overwhelming. Caregivers need the support of the nurse. Respite care and other methods of social support can be helpful, as well as other interventions which are based on the caregiver's needs. Patients at the end of life have several essential comfort and dignity needs that should be addressed with measures such as the provision of comfort and privacy, maintaining the patient in a clean and dry condition, good oral hygiene, proper turning and positioning, and the continued determinations that indicate needs that can be met with comfort measures like massage, pain management medications, and the treatments of any other end-of-life symptoms. Assisting the client in the resolution of end-of-life issues. Death visuals vary among individuals, families, religions, cultures, and ethnic groups. For example, many families may want only members of the immediate nuclear family present and close to the loved one during their final hours. Some religious practices include a clergy person like a Catholic priest to perform that religion's sacrament of the sick. Some cultures, as well as some ethnic groups, may have special cultural death vigil practices and rituals at the end of life. Nurses accommodate for these vigils and the needs of all in attendance by providing simple measures such as the provision of comfortable and private seating, the provision of coffee or another drink of preference, and ongoing psychological and emotional support. After pronouncement, the client is then transported to the morgue or funeral home according to the planned final arrangements. If an autopsy is to be performed, the body should remain undisturbed, and things like tubes, lines, and catheters should not be removed. If, however, an autopsy will not be done, post-mortem care is done by the nurse. Grief and loss. Losses and feelings of grief can be actual, perceived, or anticipated. In other words, grief and loss can occur when the person has had an actual loss, like the loss of a beloved pet or death of a spouse. Grief and loss can also occur when the person has a perception of a loss that has not actually occurred, such as when they perceive that death is near when the patient's condition is not life-threatening or terminal in nature. Lastly, a patient can be affected with grief and loss when they anticipate a loss, such as that which can occur when a spouse is diagnosed with a terminal disease. Identifying the client's reaction to loss. There are some theories and models that relate to grief and loss. The most popular of these theories and models includes Engel's stages of grieving, Sanders' phases of bereavement, and Kubler-Ross's stages of grieving. According to Engel's stages of grieving, the stages of grieving in sequential order are 1. Shock and disbelief. 2. Developing awareness. 3. Restitution. 4. Resolving the loss. 5. Idealization. And 6. Outcome. Shock and disbelief are characterized with denial, a psychological defense mechanism that protects the person from overwhelming emotional responses that the person cannot yet cope with. When the person is ready to abandon the shock and disbelief, the person moves to a conscious awareness and acknowledgement of the loss. Then they resolve the loss with emotional responses that can even include anger and depression. Later, during the resolution stage, the client copes with the loss with a wide range of emotions and behaviors, including assuming a dependent role on others. Idealization is characterized with the grieving person's deification and idealization of the lost person, although at times, the grieving person may also have ambivalence and guilt. The outcome stage is marked with the resolution of the grief. The affected person is now able to resume their life as they knew it before the loss and the grieving process. Kubler-Ross's stages of grieving in sequential order are 1. Denial. 2. Anger. 3. Bargaining. 4. Depression. And 5. Acceptance. With the exception of bargaining, the other stages of grieving, according to Kubler-Ross, are self-explanatory. During the bargaining stage, the person attempts to avoid the loss by negotiating with others, including their God or higher power, to be able to do things such as the wedding of a daughter or the graduation of their grandson before they die. The phases of bereavement, according to Sanders' theory, in correct sequential order are 1. Shock, 2. Awareness of the loss, 3. Conservation and withdrawal, 4. Healing or the turning point, and then finally 5. Renewal. The shock phase of this theory is similar to Engel's stage of shock and disbelief and Kubler-Ross's denial stage. The awareness of the loss, according to Sander, is similar to Engel's stage of developing awareness. The person withdraws from others and experiences distress during the conservation and withdrawal phase. The healing phase is characterized with the person's attempt to resume their life. Finally, the renewal phase marks the resolution of the grief and loss. For example, during the conservation and withdrawal phase, the person will withdraw from others and attempt to restore their physical and emotional well-being. During the healing stage, the person will move from emotional distress to the point where they are able to learn how to live without the loved one. During the renewal phase, the person has resolved the grief, and the person is now able to resume their life as they knew it before the loss and the grieving process. Supporting the client in anticipatory grieving. As just mentioned, anticipatory grief occurs prior to the occurrence of an actual or perceived loss. The same interventions that will be discussed in a moment for patients experiencing all losses are also used for patients and family members affected with anticipatory grieving. Community peer support groups are also helpful to the patient and the members of the family unit when they are affected with anticipatory grieving. Reinforcing client teaching on expected client reactions to grief and loss. Patients must be knowledgeable about the grieving process, the expected and normal responses to a loss, and that grieving is a normal response to a loss. Grief includes physical, emotional, spiritual, social, and intellectual responses to losses. All losses have a potential impact on the patient. The amount of grief that a person experiences should, under normal circumstances, be proportionate to the severity of the loss. For example, the death of a pet goldfish should not lead to the same intensity of physical, emotional, spiritual, social, and intellectual responses as the loss of a grandparent does. The nurse assists the person with the grieving process by establishing trust, encouraging the person to vent their feelings, by encouraging effective coping strategies, by involving the family and significant others in the care of the client, and, when needed, referrals for additional emotional and spiritual or religious support. Providing the client with resources to adjust to loss, bereavement. In addition to establishing trust, encouraging the person to vent their feelings, encouraging effective coping strategies, and involving the family and significant others in the care of the client, patients are also to be supported when maladaptation, complicated grief, and excessive or prolonged sorrow are present and persistent. Some of the resources that may be helpful include psychological counseling, spiritual or religious counseling, and community support groups. The interventions for the management of complicated grieving include developing a trusting relationship with the client, the management of problems secondary to grieving, the facilitation of coping skills, and the utilization of all available support systems. Referrals to community resources such as bereavement groups and internet bereavement groups may also be helpful. Mental health concepts. Identifying expected behaviors of the client with an independent or dependent personality. Patients with an independent personality can be aggressive, addicted to work, antisocial, controlling of others, and egocentric without regard and without any respect for others. They may have difficulty having and maintaining interpersonal relationships. They may have approach avoidance conflicts. They may be exceedingly independent and view asking for the help of another as a sign of weakness. Patients with an independent personality fear failure. They typically expect perfection from themselves and others. Patients and people with a dependent personality lack confidence in their own judgments and decisions. Dependent people want others to make decisions for them because they believe that others, rather than themselves, are much better decision makers. These people are more prone to abuse by others than those with an independent personality. They can, at times, be adversely affected with feelings of apathy, feelings of helplessness, despair, depression, fears of rejection and abandonment, and substance abuse. Identifying client symptoms of acute or chronic mental illness. Now, we will discuss the signs, symptoms, and treatment of several acute and chronic mental illnesses. Some of the most commonly encountered anxiety disorders include panic disorder, obsessive-compulsive disorder, generalized anxiety disorder, social anxiety disorder, and phobias. Anxiety can be classified as mild, moderate, severe, and at panic level. Some of the presenting characteristics of mild anxiety include irritability, mild agitation, restlessness, fidgeting, attention-seeking behaviors, and overall uneasiness. The signs of moderate anxiety can include trembling and shakiness, an increased pulse rate, an increased respiratory rate, memory loss, poor concentration, decreased attention span, muscular tension, a headache, backaches, and pacing about aimlessly. Severe anxiety is characterized with tachycardia, high blood pressure, feelings of impending doom, shortness of breath, confusion, rapid rambling speech, dizziness, nausea, and sleeplessness. The signs and symptoms that are associated with panic-level anxiety include chest pain, dilated pupils, immobility, feelings of absolute terror, hallucinations, delusions, pronounced severe hyperactivity, and possible physical exhaustion. Minor tranquilizers, cognitive behavioral therapy, stress management techniques, assertiveness training, and the development of more effective coping mechanisms are some of the interventions for patients with anxiety. Phobias manifest with overwhelming, illogical, and unreasonable fears of a completely harmless object or situation that poses little or no actual danger to the person affected with the phobia. Some patients with a phobia can become so limited in their daily life that it could be incapacitating to the person, their social relationships, and their travels. Phobias can be classified as specific, social, and agoraphobias. Specific phobias entail an object that is clearly identified by the patient as the trigger. For example, a person knows that they have an overwhelming fear of spiders or clowns. At times, the patient can have more than one specific phobia. Social phobias are characterized with intense fears and self-consciousness when the person is in a social situation like a group meeting. Agoraphobias can include both a fear of open spaces and a fear of closed spaces. For example, a person may have a phobia relating to standing in line in a crowd to enter a sports event. The signs and symptoms of phobias can vary in terms of intensity and severity. However, some of the general signs and symptoms include sweating, panic, intense anxiety, tachycardia, dyspnea, feelings of dread, and the avoidance of the stimulus that is causing the patient's overwhelming, illogical, and unreasonable fears. Post-traumatic stress disorder, or PTSD, is a condition that has an onset after a traumatic event like a gruesome murder or combat warfare. The signs and symptoms of post-traumatic stress disorder include physical and psychological symptoms, nightmares, intrusive and recurring memories of the event, memory problems, hopelessness, emotional numbness, irritability, anger, aggression, guilt, and a wide number of avoidances such as avoiding any discussion about the traumatic event, avoiding social interactions, and avoiding thinking about the precipitating traumatic event. Anorexia nervosa is marked with excessive food restriction and/or extreme physical exercise to prevent any weight gain. These factors can lead to complete emaciation and body wasting. Adolescents, young adults, gymnasts, and models are at greatest risk for anorexia nervosa. The signs and symptoms of anorexia nervosa include severe weight loss, fluid and electrolyte imbalances, muscle loss, purging behaviors, impaired personal relationships, a preoccupation with food and ways to avoid eating, secretive eating, irritability, anemia, brachycardia, amenorrhea, dental caries, impaired renal function, gastrointestinal tract erosion from the forced vomiting, and Russell's sign, which is calluses on the knuckles that result from the person's inducing vomiting with the fingers. Anorexia nervosa can be life-threatening when left untreated. Bulimia nervosa, another eating disorder, is characterized with eating binges that alternate with dieting or purging episodes. Purging can include vomiting, but also the excessive use of laxatives and cathartics. Patients with bulimia nervosa tend to be impulsive, extroverted, and sensitive to the feelings of others. The body weight may be normal or slightly overweight. Bipolar disorder is characterized with periods of excitation and elevated mood, referred to as the manic phase of this disorder, and periods of sadness and depression during the depressive phase of this disorder. The signs and symptoms of the depressive phase of bipolar disorder are depression, sadness, hopelessness, helplessness, restlessness, irritability, a loss of interest, poor concentration, suicidal thoughts, an inability to make decisions, and changes in the client's eating and sleeping patterns. The signs and symptoms associated with the manic phase of bipolar disorder are hyperactivity, an elevated mood, restlessness, insomnia, irritability, a loss of focus, rapid speech, racing thoughts, poor impulse control, impulsiveness, and risky behaviors. Depression leads to physical, emotional, and cognitive changes. The signs and symptoms of depression include feelings of hopelessness, feelings of helplessness, sadness, feelings of dejection, despair, sleep loss, poor problem-solving skills, diminished performance, listlessness, headache, weight loss, anorexia, social withdrawal, a loss of libido, crying, poor concentration, poor decision-making, personality changes, a lack of self-worth, and poor self-esteem. Personality disorders are defined as a pattern of psychological experiences and behaviors that are not congruent with society's norms and expectations. Some populations at risk for a personality disorder include victims of abuse, children from dysfunctional families, children of substance abusers, and children who grow up in cults or other extremist groups. The different types of personality disorders, their signs and symptoms will be discussed now. The paranoid personality disorder. Paranoid personality disorder is marked with an excessive and persistent distrust and suspiciousness of others, a failure to forgive others, uncontrollable anger, holding long-term grudges, and a need to maintain power and control in relationships. The obsessive-compulsive personality disorder. Obsessive-compulsive personality disorder is characterized with a preoccupation with control, orderliness, and perfection. For example, the person may be a compulsive hand washer. The borderline personality disorder. The patient affected with a borderline personality disorder can have a history of unstable relationships, fears of abandonment, impulsivity, a poor self-image, poor anger management, and persistent chronic feelings of emptiness. Schizophrenia affects the normal function of the brain in terms of the person's ability to feel, act, and think in an appropriate manner. The symptoms of schizophrenia include hallucinations, primarily hearing voices, a failure to differentiate between real perceptions and misconceptions, confused thought, delusions, and disordered speaking, which is often referred to as a word salad. Recognizing the client's use of defense mechanisms. Psychological defense mechanisms, also referred to as ego defense mechanisms, are subconscious mechanisms that protect the patient from extreme stress and anxiety that can arise from inner tensions and conflicts. Because these ego defense mechanisms protect the psychological integrity of the patient, these ego defense mechanisms should not be debated with the patient or stripped away by the nurse. The psychological defense mechanisms, their purposes, and some examples will be discussed now. Displacement. Displacement moves anger and hostility from one person or object to another person or object that has fewer repercussions. For example, a nurse who gets fired by the director of nursing decides not to punch the director of nursing, but instead, the nurse punches the office door. Projection. A person who is using projection will project and assign their failures and weaknesses on other people, the situation, or the environment rather than accepting the fact that the person is the cause of their own failure, weaknesses, and shortcomings. Projection allows the patient to protect their own self-image and self-esteem by placing blame on others and other things. For example, the aspiring nurse who fails out of nursing school will blame the nursing school and the nursing instructors rather than accept the fact that their lack of studying led to the failure. Reaction formation. A patient using reaction formation acts in a manner that is completely opposite of their true feelings. For example, the patient may intensely despise their spouse, but they act by supporting all the spouse's ideas and opinions in a loving manner. Repression. Repression pushes threatening thoughts deep down into the subconscious so that the person using repression is not aware of these thoughts or a stressful event until the person is able to effectively cope with it. An example of repression is when a person who was violently raped has complete amnesia about the rape. Regression. Regression brings a person back to a less threatening stage of development when they are threatened with extreme stress relating to the current time. For example, a 9-year-old child who wets the bed in the hospital during a severe illness is using regression back to infancy and toddler years. Sublimation. Sublimation is the replacement of a socially unacceptable feeling or urge with a socially acceptable urge or activity that substitutes for the unacceptable urge. This defense mechanism protects the person from acting in a socially unacceptable, impulsive manner and/or illegal manner. For example, a father with incestuous feelings and urges may become a highly active member of a church. Undoing. Undoing permits the patient to feel as though they have made up for and atoned for a wrongdoing. Undoing permits the person to avoid feeling guilty. For example, a wife may make her husband's favorite dinner after they have had a sexual relationship with another man earlier in the day. Compensation. Compensation protects the person's ego and self-esteem by overachieving in one area when they have failed in another. For example, the aspiring nurse who fails out of nursing school may decide to go to veterinarian tech school and over-excel in this school. Identification. The ego defense mechanism of identification permits the patient to avoid devaluing of self and to preserve their own self-worth by imitating the behaviors of the person they fear the most. For example, a girl who imitates her feared abusive mother's behavior is using identification. Minimization. Minimization involves the person's minimizing and decreasing the significance of a problem. For example, a diabetic client with severe leg ulcerations and/or lost eyesight may state that it is no big deal. Rationalization. Rationalization is used when the person attaches faulty logic and/or socially acceptable motives to behavior that is not socially acceptable or based on sound logic. Rationalization helps the person to cope with their lack of ability to meet standards and goals. A wife who pushes her husband may rationalize it by stating that her husband was not hurt. Introjection. Introjection, another ego defense mechanism, prevents the person from being shunned by society when the person accepts the values or beliefs of others, even when these values, beliefs, and norms are completely contrary to what they really believe. For example, an alcoholic may stop drinking and accept responsibility for destroying the family unit when they really do not feel this way. Intellectualization. Intellectualization is using rational thinking to explain some stress event or circumstance that was traumatic and stressful. Identification protects the person from psychological trauma and pain. An example of intellectualization can include a grieving spouse's belief that their deceased spouse just gave up, rather than accepting the fact that the spouse caused their own demise with poor lifestyle choices, like alcohol abuse. Recognizing changes in the client's mental status. Nurses must be skilled in the identification and recognition of changes in the client's mental status. Some of these changes in mental status can be sudden and dramatic, such as those changes that can occur with the rapid onset of delirium, and others may be much more subtle. Some of these changes can also gradually occur over time. Some ways to recognize and identify gradual changes in the patient's mental status can include the use of a standardized test tool like the mini mental status tests, and then comparing the client's current score with a prior baseline score. Some other possible signs of a changing mental status include restlessness, agitation, the onset of confusion, personality changes such as withdrawal or recall of information, memory loss, and changes in the person's level of activity. Recognizing client symptoms of a relapse. Many patients with a mental disorder, including substance abuse, have periods of relapse which can be quite disconcerting to the healthcare team. In addition to determining the cause of the relapse and addressing it, Nurses must also be knowledgeable about the signs and symptoms of a possible relapse. The signs and symptoms of a possible relapse can include neglected the filling of medication prescriptions, the worsening of symptoms, the development of complications, the emergence of abnormal laboratory test results, missed appointments, and multiple hospitalizations in a short period of time. Exploring why client is refusing or not following treatment plan. The fact that a client has an understanding of their treatment plan does not ensure compliance with it. Some of the factors that could lead to the patients refusing the treatment plan and not following the treatment plan can include socioeconomic hardship, the lack of health insurance, the inaccessibility of healthcare services, an altered mental or emotional state, and cultural, religious, and/or spiritual conflicts with the treatment and the treatment plan. Assisting in the care of a client experiencing sensory and perceptual alterations. At this time, we will discuss the care of the patient who is expecting a sensory or perceptual alteration, such as an auditory deficit, a vision deficit, sensory deprivation, and sensory overload. Depending on the gravity and extent of the patient's visual impairment, some possible interventions can include the nurses giving the patient their corrective lenses if they use one, use of large print materials with the patient, using the patient's name when coming into the proximity of the patient, identifying yourself when you come into close proximity with the patient, remain in the patient's field of vision when you are communicating with the patient, use of braille materials when appropriate, providing details about procedures before touching the visually impaired patient, informing the patient when you are exiting their room, and providing details about meals and the placement of all food items on the patient's meal tray or plate using the clock method. For example, the nurse may say, "Mr. A, your potatoes are at 3 o'clock on your plate." Depending on the gravity and extent of the patient's hearing impairment, some possible interventions can include the nurses giving the patient their hearing aid if they use one, always sitting while facing the patient when communicating with them, speaking slowly and enunciating words carefully. Shouting is not acceptable. Use of simple words, writing information and using printed material, minimizing all extraneous noises, and requesting an American Sign Language interpreter when indicated. Now it is time to discuss sensory deprivation and sensory overload. Sensory deprivation, which occurs when there is a lack of or deficiency of sensory stimulation, makes people more acutely aware of the few stimuli that are present in terms of sights and sounds. This heightened awareness leads to abnormal responses, such as hallucinations and delusions. Other signs and symptoms of sensory deprivation include apathy, a poor attention span, a lack of focus, sleepiness, depression, confusion, an impaired memory, and somatic complaints. Sensory deprivation can be prevented by providing the client with their assistive devices, such as eyeglasses and hearing aids, by providing devices and materials like a book or television which can stimulate the patient, by communicating with the client on a frequent basis, and by encouraging the client to participate in groups when possible. Sensory overload affects patients when there is far more stimulation in the environment than the patient can process and cope with. Some of the signs and symptoms of sensory overload include anxiety, muscular tension, sleep deprivation, fatigue, poor problem-solving skills, poor performance, restlessness, anxiety, and disordered, racing thoughts. Some of the ways that nurses can prevent sensory overload include the reduction or elimination of unnecessary stimuli such as noise and light, by controlling pain, by limiting visitors, by encouraging the patient to employ stress management techniques, by sticking to a routine schedule, and by slowly explaining things to the patient. Assisting in the care of the cognitively impaired client. Some of the things you can do while caring for a cognitively impaired patient will now be listed. Speak slowly and clearly. Keep conversations as brief and as short as possible. Give the patient enough time to fully comprehend and understand any information before continuing. Greet and call the client by name. Talk to the patient at their level, not over them. Maintain eye contact during communication. Use simple close-ended questions that only require a simple yes or no answer. Use nonverbal communication like hand gestures to further support the communication, and empathize with the patient if they express or demonstrate frustration while attempting to communicate. Assisting in promoting client independence. Patient independence must be maintained and, when needed, restored to the highest possible level that the patient is able to be. Independence not only maintains the patient's functioning, it also maintains and enhances the patient's self-esteem and their integrity. There are many ways that nurses can promote independence among their patients. Ways with which the healthcare system can enhance and maintain independence include assistive devices like eyeglasses, hearing aids, walkers, and wheelchairs, the services of a physical therapist, an occupational therapist, and/or a speech therapist, and maintaining a safe environment within which the patient can safely perform activities without the risk of injury. Promoting the positive self-esteem of clients. Poor self-esteem can be chronic or situational. For example, a child may have temporary situational poor self-esteem after they accidentally wet their pants in kindergarten. An adult may have temporary situational poor self-esteem after they were laid off from their job until they find another one. An adolescent may have temporary situational poor self-esteem after their boyfriend broke up with them. Social and emotional support typically promotes positive self-esteem without any intense interventions. Patients with chronic low self-esteem, on the other hand, are affected with long-term poor self-esteem that may have resulted from some ongoing issues or from an accumulation of issues that are additive in nature. Patients affected with low self-esteem are passive, withdrawn, fearful of failure, overly sensitive to the negative feedback by others, they avoid eye contact, and they may have feelings of shame and guilt. Patients with impaired self-esteem can benefit from a number of interventions to promote positive self-esteem. Some of these interventions include praise when appropriate, helping the patient to set realistic and achievable goals, allowing the person to freely vent and express their feelings, and by showing the patient respect, understanding, and compassion. Religious and spiritual influences on health. Religions are formal institutions that are characterized with a formal set of practices, beliefs, principles, and values that a person with that religion believes in and follows in their daily life. Religions offer humans the ability to have a meaning and purpose in their life. Spirituality, on the other hand, is informal. Spirituality is without any formal set of practices, beliefs, principles, and values. Spirituality is, however, a way with which humans establish and maintain a holistic connectedness with others, the environment, and the universe. Many people who are spiritual believe in a higher power who is not necessarily God. Identifying client emotional problems related to religious and spiritual beliefs. Spiritual and religious needs often increase and become increasingly important when a person is affected with a physical and/or emotional illness, disorder, or disease. These needs are perhaps the most pronounced when the patient is affected with a terminal disease, such as cancer. In the vernacular, nurses care for the biopsycho, social, cultural, and spiritual, religious needs of patients. Some of the adverse emotional problems that can occur when the religious and/or spiritual needs of the patient are not cared for and addressed include spiritual or religious distress and a loss of meaning that transcends the everyday realities. Spiritual distress, which occurs when spiritual needs are not addressed, can result in emotional responses such as the loss of hope, the loss of meaning, the loss of a sense of purpose, feelings of abandonment, feelings that one is just lost, anger, and despair. Spiritual wellness and well-being, the opposite of spiritual distress, manifests with peace and calm, a sense of hope and meaning, and overall feelings of wellness. Patients with spiritual wellness can forgive others, they can express love, they have faith, they have hope, and they can transcend the here and now. Forgiveness is the spiritual belief that humans are far from perfect and that all people make mistakes and that all people are capable of transgressions. Humans can forgive others for their actions, and God can also forgive all people when the fallibility of human nature is understood. Recognizing the effect of the client religious and spiritual beliefs on the plan of care. Religious and spiritual beliefs and practices greatly impact on the plan of care. After these beliefs and practices are determined, the plan of care is modified and adjusted to accommodate for these patient needs. Some of the spiritual and religious beliefs, practices, values, and symbols that healthcare providers, including nurses, should be aware of are healing beliefs, such as prayers, formal religious healing ceremonies, spiritually based individual healing rituals, and other healing rituals like the kuyarumi, which is used in Peru and incorporates the use of healing stones, are possible spiritual or religious healing beliefs that can and should be incorporated into the patient's plan of care. Muslims pray while facing Mecca, so their room should be accessible to a direction towards Mecca. Beliefs relating to birth, death, and the afterlife are also included in the plan of care according to the patient's religious or spiritual beliefs. For example, newborn Jewish babies have a Brit Milah, which is a ceremonious male circumcision performed by a rabbi. Catholics have the sacrament of the sick when a person is extremely ill. At the end of life, many religions have a strong belief of the afterlife in heaven, hell, and purgatory. Some religious dietary practices can include periods of fasting like on Good Friday among Catholics and on Yom Kippur among the members of the Jewish religion, meatless Fridays during Lent for Catholics, and a kosher diet for Jewish people. These religious dietary practices should also be incorporated into the patient's plan of care. Sacred symbols and readings which can be included into the plan of care can include a Muslim mullah, the Quran, the Bible, the Christian cross, and a Jewish menorah. Religious and spiritual beliefs relating to various treatments and procedures also impact on the patient's plan of care. For example, Catholics and other religions forbid elective abortions, and Jehovah's Witnesses are not permitted to receive a blood transfusion. Dress beliefs that can and should be accommodated for include things like a Jewish yarmulke and saris for a Hindu patient. Assisting the client to meet religious and spiritual needs. Nurses are also aware of the fact that they make referrals and accommodate pastoral support and visits with the clergy. Additionally, the clients should also be assisted to attend church or a synagogue when they desire to do so. Assisting in the evaluation of the client's religious and spiritual needs related to nursing interventions. As nurses provide care, they determine the patient's needs in reference to their personal religious and spiritual needs. Then nurses facilitate the fulfillment of these needs. For example, nurses provide opportunities for end-of-life religious and spiritual rituals, and they determine the patient's responses to these interventions. Respecting the client's religious and spiritual beliefs. Nurses respect all clients' beliefs, opinions, values, and practices, including those relating to the client's religious and spiritual beliefs, regardless of whether or not the nurse shares these same beliefs, opinions, values, and practices. Sensory and perceptual alterations. Identifying the needs of the client with altered sensory perception, delirium, and hallucinations. As previously discussed, the primary symptoms of delirium include fear, anger, anxiety, depression, restlessness, agitation, irritability, combative behavior, reduced awareness of the environment, decreased level of cognition, and hallucinations. Patients with delirium have a significantly altered sensory perception, which places them at risk for injuries, accidents, and emotional distress. Nurses must ensure the patient's safety and the patient's emotional comfort, in addition to the elimination of any possible triggers for adverse emotional and physical responses such as the lack of sleep, loud noises, and insufficient oral fluid intake secondary to delirium. Hallucinations are a serious concern for patients experiencing them. Safety is a priority of care. Verifying the client's ability to effectively communicate needs. All clients, including those with sensory and perceptual alterations, must be able to effectively communicate their needs to nurses and other members of the healthcare team. Alternative methods of communication must be considered. For example, the client may be able to communicate using pictures, and the nurse must be able to use behavioral signs like a grimace or a sad face to determine the client's needs. Stress management. Stress is a double-edged sword. Without stress, we would not even breathe or learn. For example, we breathe and take a breath when the psychological stressor of increased carbon dioxide is experienced by the person, and we are able to learn when we are motivated with a low degree of stress. In these respects, low and moderate amounts of stress are beneficial and essential to life. However, high levels of stress are physically and emotionally harmful. For example, high levels of stress, particularly when the high level of stress is also of long duration, can lead to distress, panic, hypertension, and other ill effects. For this reason, all humans, including patients, should be able to manage and control their stress before it takes control of them. Most hospitalized and ill patients have stress and anxiety. Stress and anxiety can be managed with non-pharmacological and pharmacological interventions. Some of the non-pharmacological interventions for stress and anxiety include meditation, prayer, deep breathing, progressive relaxation, distraction, imagery, and other techniques such as those that were previously detailed under the topic Assisting the Client in Using Behavioral Strategies to Decrease Anxiety. Identifying actual and potential stressors affecting clients. Physical, psychological, and environmental stressors can actually and potentially impact on the client and their families. For example, physical stressors include things like extreme environmental temperatures, a burn, and a medical emergency such as trauma or anaphylaxis. Some examples of psychological stressors, in addition to the stress and anxiety experienced with illness, can include the psychological abuse and neglect, the loss of a job, and financial jeopardy. Environmental stressors can include things like air pollution, contaminated water, and noise. Nurses identify stressors that are impacting on the patient, and then they plan care with interventions and strategies that can eliminate actual stressors and interventions and strategies to prevent the occurrence of potential stressors. Implementing measures to reduce environmental stressors. Healthcare facilities are filled with environmental stressors, such as noise and constant lighting, both of which interfere with a patient's comfort, rest, and sleep, and both of which can be prevented by nurses and other members of the nursing team. Community health nurses address and reduce air pollution and unclean water on a local, national, and global basis. Nurses in an acute care and long-term care facility identify and correct environmental stressors, such as noise and ambient temperatures, that interfere with the client's comfort and stress-free environment. Monitoring the client's effective use of stress management techniques. Nurses can monitor the client's effective use of stress management techniques in a number of different ways after teaching these techniques to the patient. For example, the nurse can directly observe the client's return demonstration of a stress management technique, such as deep breathing or guided imagery. Nurses can also determine whether or not the client's stress level has decreased with the patient's self-reports and the nurse's observations of the physical and behavioral signs of stress and anxiety. Determining the client's abilities to provide client support. Humans, as an interactive system, must be able to find and utilize support systems and social supports. Some patients are fully aware of and knowledgeable about the supports that they need and how to garner them. Other patients are in need of the assistance and help of a nurse to identify their needs, to find available supports, and how to use these necessary supports and support systems. Identifying the client's support systems and resources. Nurses identify and determine what client support systems and resources the patient is currently utilizing. After establishing this baseline relating to current supports, the nurse then determines whether or not these supports are appropriate for the patient and the patient's needs. They also determine what additional supports and resources can be tapped into to meet the patient's current needs. Identifying family responses to the client's illness. In keeping with the systems theory, the family and family members are affected in many ways when faced with an acute, chronic, or terminal illness that affects another member of the family. Family responses to illnesses vary according to the family, and they vary among different members of the family unit. The family dynamics, family and individual perceptions, past and present methods of coping, culture, spiritual religious beliefs, and severity and duration of the disease, the age of the person who is affected with the illness, and other factors impact on the responses of the family and its members in terms of the client's illness. For example, a severe chronic illness, with a prolonged duration places more stressors and stress on the family and its members than a short-lived acute illness that is not severe and is also one without any significant functional or role losses. Families and individual members of the family typically respond to acute episodes of an illness with low or moderate levels of stress and anxiety. Families and individual members of the family typically respond to chronic and severe illnesses with high levels of stress and anxiety. The most common reactions to illness include grief and loss as previously discussed, guilt, depression, a loss of hope and meaning, anger, denial, fears, financial concerns, sleep disturbances, poor coping, maladaptation, role changes, intimacy and relationship issues, and overall fatigue and anxiety. The signs and symptoms of anxiety include affective signs and symptoms such as fear, fright, helplessness, irritability, and worry. Behavioral signs and symptoms like vigilance, hypervigilance, and insomnia. Sympathetic nervous system signs and symptoms such as tachycardia, hypertension, and anorexia. Physiological signs and symptoms like trembling, muscular tightness, and diaphoresis. Parasympathetic nervous system signs and symptoms like weakness and fatigue. And lastly, cognitive signs and symptoms such as a lack of focus and attention, as well as poor problem-solving skills. Therapeutic communication. Providing emotional support to the client and the family. As discussed throughout this review course, nurses provide emotional support to the client and the family members in an ongoing manner within the professional and therapeutic nurse-patient relationship. Some of this emotional support is formal and complex, and other emotional supports are simple and informal. For example, individual and group psychotherapy is a formal and relatively complex form of emotional support, and a gentle, caring touch, as well as attentive, active listening, is relatively informal and simple. Assisting the client in communicating needs to healthcare staff. Patients may have difficulty communicating their needs to healthcare staff for a number of reasons. For example, some patients may not communicate their needs because they are too embarrassed to ask for help, or they do not want to bother others, such as a nurse. Still, more patients may have physical barriers to communication. For example, some patients may not be able to communicate their needs to the healthcare staff because they have a decreased level of consciousness, aphasia, or a cognitive disorder. Special methods of communication and modifications of communication must be used when the patient has a physical condition that impedes communication. Caring, compassion, and attentiveness to the patient and their needs helps to overcome emotional barriers to communication. Developing and maintaining therapeutic relationships with the client. The first step in developing a therapeutic relationship with a patient is the establishment of trust. Without trust, there can be no therapeutic relationship with a patient. Trust is developed with honesty, openness, caring, compassion, and respect. After trust is established, it must be maintained throughout the working stage or phase of the therapeutic relationship with the patient. The second stage of this therapeutic relationship is encouraging the patient to ventilate their feelings, fears, and anxieties. Other components of a therapeutic nurse-patient relationship and therapeutic communication are open and honest communication, the encouragement of the patient's expressions and venting of feelings, values, beliefs, and views, the provision of an environment that is unconditionally accepting and respectful, and the nurses maintaining a non-judgmental, unbiased attitude relating to the patient's views, feelings, and ideas of the client regardless of whether or not the nurse agrees with them. Using therapeutic communication techniques with the client. There are many factors that negatively or positively impact on the communication process, including attitudes, perceptions, emotions, cultural values and beliefs, roles and relationships, and environmental factors. Attitudes, both negative and positive, impact on communication. Perceptions impact on how a message is interpreted and processed by the receiver. Emotions such as fear, anger, anxiety, and pain impact negatively on the nurse-patient relationship and communication. Relationships and roles, as well as the patient's perceptions of these roles and the nurse-patient relationship, also affect communication. For example, clients may not freely communicate some information to the nurse and other members of the healthcare team because they perceive that the nurse is in a perceived position of power and that they are powerless. Environments that are conducive to communication and therapeutic relationships include privacy, physical and psychological comfort, trust, respect, and unhurriedness. Some of the most commonly occurring barriers to therapeutic communication are false reassurances, probing, changing the subject, defensiveness, disagreeing, judgments, and challenging. False reassurances increase patients' anxiety. They also lead the patient to believe that the nurse does not care about the patient and their thoughts. False reassurances include statements like, "Don't worry, you have a great doctor." Nurses may give false reassurance when the nurse is not able to cope effectively with the patient's thoughts and concerns. Nurses can prevent giving false reassurances by examining their own feelings and effectively coping with them during interactions with the patient. Probing can be described as an invasive violation of the patient's right to privacy when the nurse questions the patient about things that have no relevance to the nurse-patient relationship, but instead, these questions satisfy the needs of the nurse. For example, the nurse may probe the patient because they are curious about something. Humans, including nurses, change the subject inappropriately during a conversation when the person is just too uncomfortable to continue the discussion. Changing the subject is a conversation stopper. The patient may perceive that the nurse is changing the subject because the nurse does not care or is not at all interested in the patient and their needs. Again, the nurse must examine their feelings and overcome their tendency to want to change the subject. Defensiveness occurs when the nurse believes that they have to defend themselves and/or the healthcare facility that is providing care and services to the patient. The patient-nurse relationship revolves around the patient and their needs, not the nurse's needs. So, there is no need for the nurse to be defensive of themselves or the healthcare facility. The patient must be free to express and vent all of their feelings and thoughts. Disagreeing is another barrier to effective communication with patients. Like judgments, disagreements occur when the nurse and the patient have a difference of opinion. Again, it is the patient and the patient's beliefs and opinions that are valued and the most paramount. Therefore, there is no room for disagreements in the therapeutic nurse-patient relationship. Judgments force the patient to feel that they must agree with the nurse and change their own feelings, opinions, and beliefs. Nurses must communicate with patients without placing any value or judgments on the patient's personal beliefs and concerns. Challenging occurs when the nurse directly or indirectly asks the patient to justify, rationalize, and defend their personal beliefs, thoughts, and feelings. Challenging attacks the client and the validity of the patient's own thoughts and feelings. Respecting the client's personal values and beliefs. As repeatedly stated in this review, nurses must unconditionally respect and support the client's personal values and beliefs despite the fact that the patient's personal values and beliefs are not shared by the nurse. Establishing a trusting nurse-client relationship. As previously discussed, establishing trust is the first step of the nurse-client relationship. Using therapeutic communication techniques with the client. As fully discussed with the integrated process of communication and documentation under the title The Therapeutic Relationship and Therapeutic Communication, there are a variety of therapeutic communication techniques that should be employed during client communication. Some of these therapeutic communication techniques are attentive, active listening, silence, reflection, focusing, paraphrasing and restating, restating and paraphrasing, clarification, providing leads to the patient, and summarizing. Encouraging the client's appropriate use of verbal and nonverbal communication. Nurses should encourage patients to communicate with nursing staff using verbal and nonverbal communication. The nurse's caring presence and the nurse's willingness to spend time with the patient are probably the best ways to encourage patients to communicate with nurses and other members of the healthcare team. Monitoring the effectiveness of communications with the client. Communication, a dynamic interpersonal process, is considered effective and therapeutic when sent messages are fully comprehended by the receiver and when received messages are also fully comprehended. The therapeutic environment. Identifying external factors that may interfere with client recovery. Like all other healthcare-related issues, recovery is impacted by intrinsic and internal patient-related factors and also with extrinsic factors which are external to the patient. For example, physical recovery can be delayed and interrupted when the patient has diabetes. Physical recovery can be facilitated when the patient has family support. Similarly, psychological recovery can be enhanced when the patient has a strong support system. And psychological recovery can be impeded when the patient is not compliant with their medication regimen. Other factors that interfere with psychological recovery include disrupted family dynamics, the accessibility and affordability of healthcare resources, levels of stress, social stigma, and the lack of culturally competent care. Participating in community meetings. Psychological recovery is enhanced when patients and significant others participate in meetings within the healthcare facility and outside of it. For example, community meetings in the therapeutic healthcare environment can include such foci as socialization skills enhancement, self-care promotion, group psychotherapy, and psychological peer support. Community group meetings are available to also assist with psychological recovery. For example, disease-specific support groups like those for depression are available. Peer support groups like Alcoholics Anonymous and Narcotics Anonymous meetings are held 7 days a week in the patient's local community. Contributing to maintaining a safe and supportive environment for the client. Nurses contribute to establishing and maintaining a safe and supportive environment. Environments must be free of all physical safety hazards and also free of anything that could potentially jeopardize psychological safety. Physical safety, safety needs, and measures that must be taken to establish and maintain a safe physical environment free of hazards were thoroughly discussed within the safety section. Psychological safety is ensured with a consistently safe and supportive therapeutic milieu that meets the patient's needs. Monitoring the client's responses to environmental factors. Clients' responses to environmental factors vary among individuals. Some of these environmental factors lead to different patient responses depending on the patient's physical and psychological condition. For example, some patients can tolerate noise and continuous activity, and others do not. Some patients may become intolerant of a roommate when they have a fever or an acute illness after they have spent several days cohorting with the same roommate without any issues. Physiological integrity. The practical vocational nurse provides comfort and assistance in the performance of the activities of daily living. The practical vocational nurse must be able to institute bowel or bladder management, perform an irrigation of urinary catheter, bladder, wound, ear, nose, or eye. Provide for mobility needs, for example, ambulation, range of motion, transfer to chair, repositioning, or the use of adaptive equipment. Use measures to maintain or improve client skin integrity. Provide care to an immobilized client, for example, traction, splint, or brace. Assist in the care and comfort for a client with a visual and/or hearing impairment. Use alternative complementary therapy in providing client care, for example, music therapy. Provide non-pharmacological measures for pain relief, for example, imagery, massage, or repositioning. Evaluate pain using a rating scale. Provide feeding and/or care for client with enteral tubes. Monitor and provide for nutritional needs of client. Monitor client intake/output. Assist with activities of daily living. Assist in providing post-mortem care and providing measures to promote sleep rest. Basic care and comfort. Assistive devices. Assistive devices facilitate the performance of the activities of daily living, the maintenance and restoration of independence in terms of the patient's activities of daily living, the prevention of dependence on others, the prevention of complications such as those associated with immobility, and it also enhances the patient's feelings of self-esteem and self-worth. Assistive and adaptive devices are helpful to patients who need assistance with mobility and ambulation, as well as other self-care activities of daily living, such as bathing and grooming, which was discussed previously under the topic self-care. Identifying the appropriate use of assistive devices. Some of the commonly used assistive devices relating to mobility and ambulation include canes, walkers, crutches, wheelchairs, and prosthetic limbs. Crutches are typically used among relatively healthy and fit younger patients who have had an acute sprain, strain, or fracture. Crutches require arm strength to use them safely and properly. Many older people lack this necessary strength. A specific gait is ordered for a patient based on their physical condition. These gaits include the 2-point gait, the 3-point gait, the 4-point gait, the swing-through gait, and the swing-to gait. Patients are also fitted for crutches. The hands should be able to be firmly placed on the grips, and the armpits should not sustain any weight or pressure when the person is walking. All the weight is on the hands, which are on the hand grips. The patient's elbows should be slightly bent when holding the hand grips, and the hand grips should be even with the hip line. Canes can be a standard cane with 1 foot, a tripod cane with 3 feet, and a quad cane which has 4 feet. The length of the cane should be such that it only allows the patient's elbow to be slightly flexed. The cane is held in the hand on the same side of where support is needed. For example, the client will hold the cane with the left side when the left leg is affected. Walkers are indicated when the patient needs more support than a cane can offer. Walkers without wheels require that the patient is able to pick it up and move it forward. Other walkers have 2 wheels, and still more have 4 wheels with a seat and brakes. Although many patients prefer walkers with wheels, they can be unsafe and not fit for the patient when the patient is not able to control the walker without it rolling away. Walkers should be adjusted to a height that is level with the patient's wrist crease when they are standing erect. The patient's back should be erect and not hunched over when using a walker. Wheelchairs offer the greatest support in terms of the patient's mobility needs. Electric wheelchairs and scooters require some manual dexterity. Non-electric, manually powered wheelchairs require the upper arm strength of the patient or the assistance of another to push the wheelchair when the patient is unable to locomote and move the wheelchair on their own. The footrests of the wheelchair must be placed to the side before helping the client into the wheelchair. The brakes on both wheels of the chair must be locked during the patient transfers into the chair. When moving the client in the wheelchair, the feet must be on the footrests above the ground for safety. The rubber tips on a walker, cane, and crutches should be inspected often and immediately replaced if there is any sign of wear or bareness. Contributing to the care of the client using assistive devices. The therapist providing the assistive devices usually instructs the patient about its use, but nurses must also be familiar with the device so that they can assist the patient with the device and reinforce teaching when necessary. Some of these devices include feeding and eating devices like special utensils, plates, and drinking glasses, modified computers including voice-activated computers, telecommunication devices, touchpads, and communication boards. Reinforcing teaching for clients using assistive devices. Many people, including patients, do not always remember everything they are taught. Nurses, therefore, must observe patients and identify any techniques that are unsafe and performed incorrectly when the patient is using an assistive device. The nurse will then reinforce teaching related to identified learning needs in respect to their using an assistive device. Reviewing the correct use of assistive devices to clients and staff members. Nurses also review and observe staff members and their use of assistive devices, such as telecommunication devices, and then they reinforce teaching until the staff member or patient is competently using it. Elimination. Urinary and bowel elimination. Some of the commonly used terms relating to urinary and bowel elimination will be discussed now. Anuria is the lack of production of urine. Dysuria is painful burning upon urination. It often occurs as the result of a urinary tract infection or trauma. Oliguria is less than the normal amount of urinary output. The most commonly occurring causes of oliguria are impaired renal blood flow, renal disease, decreased fluid intake, and excessive fluid losses. Polyuria is an excessive amount of urine produced by the kidneys. Some commonly occurring causes of polyuria are diabetes mellitus and diabetes insipidus. Excessive and prolonged polyuria can cause dehydration. Urinary incontinence is the involuntary leakage of urine and a loss of bladder control. Urinary retention is the accumulation of urine in the bladder because, for one reason or another, the patient is not able to effectively empty their bladder. Constipation is less than 3 bowel movements per week. Diarrhea is a watery, loose stool. Fecal impaction is a collection of hardened stool in the rectum. Flatulence is gastrointestinal gas. Identifying the client at risk for impaired elimination. Some of the factors that place patients at risk for impaired elimination include some medications, some foods, an altered level of hydration, advanced age, weak muscular tone, the presence of some physical disorders, and psychological factors. There are a number of medications that can affect the body's normal urination and bowel elimination processes. Some medications can lead to the retention of fluids, increased urinary elimination, constipation and diarrhea, for example. High-sodium salty foods impair and decrease urinary output and increase fluid retention. Some foods cause constipation, and other foods can cause diarrhea. Excessive hydration can lead to polyuria. Dehydration can lead to the scant urine and constipation. Older males can experience urinary retention and urinary incontinence because of an enlarged prostate gland. Older females can have urinary stress incontinence as the result of the loss of pelvic muscle tone secondary to having vaginal deliveries of babies. Both genders can be adversely affected with impaired sphincter control, which can lead to both bowel and bladder incontinence. Urinary function and urinary excretion can be affected by a variety of disorders, such as an anatomical defect, renal failure, hypertension, shock, vomiting, diarrhea, and other disorders. Bowel function and bowel elimination can also be affected by a variety of disorders, including an anatomical defect, infectious diarrhea, and other disorders such as ulcerative colitis and Crohn's disease. The lack of privacy, the lack of sufficient time to void or defecate, the lack of psychological comfort, and the need to use unusual devices such as a bedpan and/or urinal can impair normal urinary and bowel elimination for many people who are hospitalized. Instituting bowel and bladder management. Bladder and bowel management is a broad term that includes a number of different treatments and interventions. Some of these treatments and interventions include bladder training, bowel training, urinary catheterization, enema administration, and ostomy management. Bladder incontinence is more common among female patients rather than male patients. This increased frequency of urinary incontinence results from the female anatomy that has a shorter urethra than the male population, childbirth trauma that weakens the muscles of the pelvic floor, and menopause. Although females are more often affected than males, males can also be affected with bladder or urinary incontinence. Some of the factors that place males and females at risk for urinary incontinence, among other disorders, include poor pelvic muscle tone and strength, the lack of urinary sphincter control, urinary tract infections, injuries to the spinal cord, decreased levels of cognition and/or consciousness, and cerebrovascular accidents. Managing urinary incontinence includes bladder training, pelvic muscle exercises, maintaining skin integrity, and using external urinary drainage devices such as a condom catheter for male patients and briefs. Indwelling urinary catheters are strongly discouraged because they are a major source of hospital-acquired urinary tract infections, which can be very serious. Briefly described, bladder training entails the patient's practice in terms of resisting the sense of urgency, following timed voiding, and prompted voiding after the patient's urinary patterns have been determined. Common problems with fecal elimination include constipation, fecal impaction, diarrhea, bowel incontinence, and flatulence. When constipation cannot be prevented with interventions such as a high-fiber diet, exercise, and ample fluid intake, it may have to be managed with things like suppositories and enemas. There are 4 types of enemas: a cleansing enema, a retention enema, a carminative enema, and a return flow enema. The cleansing enema removes fecal matter that the patient is not able to expel. A cleansing enema is also used for preparation for surgery and for some diagnostic tests, such as a colonoscopy, so that the colon can be visualized without the presence of feces. A medication or an oil solution is instilled in the rectum and sigmoid colon with a retention enema. After installation, the contents of the enema are retained for at least 1 hour or more so that the hardened stool can be softened and more easily eliminated by the patient. A carminative enema is a fluid enema that is used to promote the patient's expelling flatus. A return flow enema is also used to expel flatus and also to decrease abdominal distension and pain, such as often occurs after surgery and general anesthesia. This type of enema is also referred to as a Harris flush. Fluid is instilled into the rectum and colon by the nurse, who holds the enema bag of fluid above the patient's hips. After this fluid is instilled, the nurse lowers the fluid bag near the floor so flatus and the instilled fluid return to the bag. This installation and lowering the bag are done a number of times until the abdominal distension is dissipated and the patient is relieved of the pain and discomfort. A colostomy can be either permanent or temporary. Colostomies are done for a number of different reasons, including bowel rest, to bypass a bowel obstruction caused by a tumor, and to remove bowel contents when the distal colon and rectum have been surgically removed, as is often done when the patient has cancer. The different types of colostomies are an ascending colostomy, a transverse colostomy, a descending colostomy, and a sigmoid colostomy. The location of the stoma and the characteristics and composition of the stool depends on the type of colostomy that was done. Monitoring the client's bowel sounds. Bowel sounds are monitored in all 4 abdominal quadrants, which include the upper right quadrant, the upper left quadrant, the lower left quadrant, and the lower right quadrant. Bowel sounds are normally from 5 to 30 bowel sounds per minute. Bowel sounds can be decreased and even absent when the patient is affected with a bowel disorder, such as a paralytic ileus after surgery. Performing an irrigation of a urinary catheter and the bladder. When you perform an irrigation of a urinary catheter, you clamp the catheter between the injection port and the extension tubing. Clean the port with antiseptic wipes. Insert a syringe and slowly inject the irrigation solution. Remove the syringe, and then finally, remove the clamp and permit the irrigation solution to drain into the drainage bag. The procedure for bladder irrigation is as follows. Hang and prime the irrigation solution. Clamp all the clamps. Swab all ports with a disinfectant. Unclamp the irrigation clamp. Set the flow at the ordered and desired rate. Measure and document the volume of irrigating solution instilled, and then also measure and document the volume of urine in addition to the irrigating solution that is put out. Providing skin care to the client who is incontinent. In addition to keeping the incontinent client clean and dry, there are a number of topical agents used for the protection of the skin, including skin sealants that protect the skin from urine, stool, exudate, chemicals, dirt, and debris. Zinc oxide-based moisture barrier ointments that also protect the area, thick moisture barrier pastes that seal the area off and protect it from any moisture, solid skin barriers in the form of rings, strips or wafers that protect the skin in wounds, and skin barrier powders that are sprinkled lightly on the denuded skin to increase the sticking power of ointments, pastes, and solid skin adhesive barriers. Mobility, immobility. Immobility leads to severe complications and consequences in terms of virtually all bodily systems. Immobility leads to skin breakdown, pressure ulcers, and poor skin turgor. It can lead to contractures, muscular weakness, muscular atrophy, stiff and painful joints, and disuse, osteoporosis. The urinary system can be compromised with renal calculi, urinary stasis, urinary retention, urinary incontinence, and urinary tract infections. Respiratory system complications include atelectasis, pneumonia, and decreased respiratory vital capacity. Some of the cardiovascular and circulatory system complications associated with immobility include venous stasis, venous insufficiency, orthostatic hypotension, decreased cardiac reserve, edema, emboli, and thrombophlebitis. Immobility also leads to constipation and the loss of calcium from the bones as the result of the lack of weight-bearing activity during periods of immobility. Identifying the signs and symptoms of venous insufficiency and intervening to promote venous return. Additional risk factors, in addition to immobility, that can lead to impaired vascular perfusion and venous return include hypotension, decreased cardiac output, hypoxia, and immobilized limb, postoperative status, and diabetes. Compression anti-embolus stockings, elevation of the lower extremities, ambulation, intermittent sequential calf compression devices, and prophylactic anticoagulant therapy with a low molecular weight heparin or low-dose heparin are used to promote venous return and to prevent deep vein thrombosis and emboli. Providing for mobility needs. It is highly logical to understand why nurses must provide the patient's mobility needs, knowing how numerous and serious the hazards of immobility can be. The best way to prevent the body-wide hazards of immobility is to minimize immobility by providing for and assisting with patients' mobility needs. Encouraging ambulation and using needed assistive devices for ambulation, as discussed previously with self-care and assistive devices, is one way to provide for the patient's mobility needs. Other strategies include range of motion exercises and repositioning in a manner that maintains proper body alignment so the patient's ability to ambulate in the future is not impeded. Range of motion exercises can be active, active-assisted, and passive. Patients able to perform full joint movement on their own and without the assistance of another should be encouraged and monitored for their performance of full range of motion to all bodily joints several times a day. Nurses assist patients with range of motion exercises several times a day when patients are not completely independent in terms of their own performance of range of motion exercises. Passive range of motion is done by the nurse when the client is not able to even assist with range of motion exercise. Patients in a coma, for example, should be given complete passive range of motion to all joints several times a day by the nurse or a therapist. Some of the commonly used anatomically correct positions that are used by patients in bed are the Fowler's position, which is a sitting position with the head of the bed elevated, the dorsal recumbent position, and supine positions, which are laying on the back with or without a pillow for the head. The prone position on the stomach, the lateral position, which is a side-lying position with the uppermost knee bent and often maintained in that position with a pillow, and the Sims position, which is a semi-prone position. Reinforcing client teaching on methods to maintain mobility. Despite the fact that physical and occupational therapists assess and teach clients in terms of mobility measures such as preambulation exercises, active-passive range of motion, strengthening exercises, balance, gait, and isometric exercises, including those exercises that can and should be done in bed, nurses must not only reinforce this teaching, they must also remind the client to perform them and also assist them as needed. Using measures to maintain and improve the client's skin integrity. Pressure ulcers are a commonly occurring complication of mobility. Intrinsic and extrinsic factors and forces place patients at risk for impaired skin integrity. Some of the intrinsic factors that place clients at risk for pressure ulcers, in addition to immobility, are a poor nutritional status, cachexia and emaciation, hypotension, decreased cardiac output, poor tissue perfusion, hypoxia, bony prominences, any alterations of the fluid and electrolyte balances, aging, obesity, a condition that prohibits a client's free movement like paralysis, and some diseases and disorders such as diabetes, vascular deficiencies, and incontinence. Some of the extrinsic factors that place clients at risk for pressure ulcers, in addition to immobility, are radiation therapy, some medications, moisture, humidity, shearing, friction, and pressure. Interventions to maintain skin integrity and to prevent skin breakdown include the ongoing, continuous observation and monitoring of the client and their skin, keeping the patients dry when they are incontinent, turning and positioning clients at least every 2 hours, using special protective and preventive devices such as specialty beds and mattresses to prevent pressure, the avoidance of all friction, and encouraging mobility. Maintaining correct body alignment. Maintaining positions, such as the supine position that was just discussed, ensures correct bodily alignment. Assistive positioning devices such as pillows, wedges, and bolsters should be used to promote proper bodily alignment and to prevent harmful malalignment. Providing care to the immobilized client with traction, a splint, or a brace. Traction and other forms of immobilization, such as a brace or a splint, must be applied carefully and monitored frequently to ensure that the skin maintains its integrity, and to also ensure that the circulation is maintained and adequate, and, when traction is used, that the weights are as ordered and that they are freely hanging. Non-pharmacological comfort interventions. Identifying the client's needs for palliative and comfort care. Hospice and palliative nursing, scope and standards of practice, was developed by the Hospice and Palliative Nurses Association and ANA to further advance the practice of hospice and palliative care and to set benchmarks for all registered nurses and advanced practice registered nurses who practice nursing within the realm of life-limiting, progressive illness, or end-of-life care. The goal of hospice and palliative care nursing is to promote and improve the patient's quality of life through the relief of suffering along the course of illness, through the death of the patient, and into the bereavement period of the family. ANA and HPNA 2007, page 1. This specialty practice resource also focuses attention on educational preparation, advocacy and ethics, professionalism, collaboration, systems thinking, cultural competence, communication, and clinical judgment for hospice and palliative care nurses. Assisting in the care and comfort for a client with a visual and/or hearing impairment. As thoroughly discussed in the integrated process, communication and documentation, and in the section called Assisting in the Care of a Client Experiencing Sensory and Perceptual Alterations, nurses must facilitate communication and care with those who are affected with a visual or hearing impairment. The visually impaired patient, along the continuum of visual losses, after being supplied with their corrective lenses and eyeglasses, can benefit from large print materials and even braille materials. The hearing impaired, after being supplied with the corrective hearing aids, can benefit when the nurse faces the patient and speaks slowly during care and communication. Assisting in planning comfort interventions for the client with impaired comfort. Practical nurses collaborate with the registered nurse and other members of the healthcare team to plan a wide variety of comfort measures to meet the unique comfort needs of the client. Some of these comfort measures, among others, include the administration of pain medications, the application of heat and cold, the use of alternative and complementary comfort measures, and the use of other non-pharmacological measures. Applying therapies for comfort and the treatment of inflammation, swelling. Nurses promote comfort with the elevation of the affected limb above the level of the heart and the application of heat and cold applications. These measures decrease painful swelling that results from inflammation by dilating the vessels and constricting the vessels. Venous return and the prevention of swelling are accomplished with the elevation of a swollen limb. Heat constricts the vessels, and cold dilates the vessels. Vasodilation moves fluid and blood away from areas of inflammation. Vasoconstriction decreases the flow to the inflamed and injured area of the injury. These actions prevent and reduce swelling, inflammation, and muscle spasms. Both are used to reduce the pain and discomfort of inflammation and swelling. They can both be applied as a moist or dry application. Moist applications tend to be more effective than dry heat and cold. Cold applications are usually applied immediately after the injury and up to about 72 hours after it. Heat is usually used after 72 hours after the injury has passed. Because the use of heat or cold after 20 minutes reverses its effect, applied and then removed after 20 minutes. Using alternative complementary therapy in providing client care and comfort. The number and variety of non-pharmacological interventions, including complementary, alternative, and integrative modalities, are numerous and varied. Some examples of alternative and complementary therapies that can provide the patient with comfort are meditation, prayer, magnets, chiropractic services, homeotherapy, Reiki, music, acupuncture, acupressure, massage, deep breathing, progressive muscular relaxation, distraction, guided imagery, biofeedback, hypnosis and self-hypnosis, mind-body exercises, and herbs and dietary supplements. Providing non-pharmacological measures for pain relief. In addition to these non-pharmacological alternative and complementary interventions, ways to promote comfort and decrease pain are positioning, repositioning, and the use of devices such as a transcutaneous nerve stimulation or TENS device. Providing palliative and comfort care interventions to the client. Nurses provide palliative care and comfort care interventions to address the physiological and psychological needs of patients at the end of life. Palliative care is distinctly different from medical curative care. Palliative care is given when the patient chooses to cease medical, curative treatments and to turn the attention of and the focus of care from cure to physical and psychological comfort. Some of the commonly occurring physiological disorders that affect clients at the end of life and the related nursing care will be discussed now. Hypercalcemia, which affects many oncology patients, can lead to nausea, vomiting, bone pain, and abdominal pain. Nurses must manage this pain and also ensure the patient's safety because bone fractures can occur. Hemorrhage and shock can lead to extreme fear and anxiety. Septic shock can lead to respiratory distress and pulmonary edema. Tumor lysis syndrome can cause nausea, vomiting, abdominal pain, and flank pain. Spinal cord compression can lead to back and leg pain. Superior vena cava syndrome is often accompanied with symptoms such as respiratory distress and hypoxia-related air hunger, which disrupts the patient's levels of psychological comfort. Pneumonitis can be accompanied with shortness of breath and respiratory distress. Malabsorption syndrome can cause abdominal pain and disconcerting explosive diarrhea. End-of-life respiratory gurgling can be distressing to family members, so repositioning the patient may be helpful to correct this physiological change at the end of life. The syndrome of inappropriate antidiuretic hormone often leads to changes in the patient's mental status, irritability, and other mood swings. The commonly occurring cognitive and psychological disorders that affect clients at the end of life and the related nursing care will now be discussed. Sometimes, reversible delirium leads to decreased cognitive functioning and behavioral changes that can result from the patient's hallucinations, fear, anger, anxiety, agitation, and irritability. And irreversible dementia can also lead to the same alterations of cognitive function and behaviors as dementia. The most commonly occurring emotional and psychological responses to illness that impairs the patient's psychological comfort are anger, hostility, anxiety, death anxiety, feelings of helplessness, irritability, fright, denial, depression, fear, loss of hope and meaning, distress, dread, panic, relief, guilt, insomnia, and other sleep disturbances. In terms of psychological changes at the end of life for both the patient and their significant others, interventions focus on the management of these changes in terms of a therapeutic environment, allowing and encouraging the patient and others to vent their feelings. Non-pharmacological psychological interventions such as psychological counseling and, when indicated, medications such as antidepressants. In terms of the physiological changes at the end of life, physiological interventions often include the treatment of the symptoms that result from the physiological disorder rather than treating the underlying cause. For example, the underlying cause of hypercalcemia may not be treated, but the symptoms of pain and the patient's compromised level of safety may be addressed. Pain management is a common intervention to address the physiological disorders at the end of life. Respecting the client's palliative care choices. Nurses provide palliative and comfort, physical, psychological, social, and spiritual religious care to the client who is receiving palliative care. Nurses respect and support the client's palliative care choices despite their own personal beliefs and opinions. Reinforcing client teaching on stress management techniques. Nurses identify the need for a client to perform stress management techniques, including progressive relaxation, exercise, meditation, and imagery. They also reinforce client teaching in respect to the proper use of these techniques. Reinforcing client teaching on palliative comfort care. Nurses reinforce teaching relating to palliative and comfort care as often as needed. Some of the primary areas of teaching include the signs and symptoms of imminent death, the progression of the death and illness progression, pain, the impact of pain, and pain management plans. Patients and significant others must be knowledgeable about the signs and symptoms of imminent death so that the psychological consequences of not knowing, such as fear, stress, distress, and panic, can be prevented. Some of the signs and symptoms of imminent death that the patient should be knowledgeable about are respiratory changes, such as Cheney-Stokes respirations, a refusal to eat or drink, decreasing levels of consciousness, bodily coolness, fecal and urinary incontinence, confusion, restlessness, and social withdrawal. They must also be knowledgeable about the normal and expected progression of the patient's specific illness or illnesses and the peri-death process in order to allay fears and to promote coping when these changes are expected and anticipated. Pain and the plan of care in place for the patient should also be reported and reinforced with the patient and significant others. Fears of pain and pain itself significantly decrease the patient's level of comfort, their degree of involvement in the plan of care, their interactions with others, and it shatters the remaining quality of life. Patients and significant others must know about the pharmacological and non-pharmacologic pain management interventions that will be used. Patients and significant others must also know how and when to report their pain. Monitoring the client's nonverbal signs of pain and discomfort. Some of the nonverbal signs of pain and discomfort can include guarding, grimacing, crying, and calling out in pain. Monitoring client response to non-pharmacological interventions. Nurses monitor the client's responses to non-pharmacological interventions in terms of the client's level of comfort. As with pharmacological interventions, non-pharmacological interventions have expected outcomes like a reported or observed decrease in the levels of pain and discomfort and increased levels of comfort as reported by the patient or observed by the nurse. Monitoring the outcome of palliative care interventions. The expected outcomes of palliative care interventions are numerous. For example, expected outcomes include both the client's and the family member's decreased stress and anxiety and increased levels of comfort and communication. Evaluating pain using a rating scale. Based on scientific evidence that people of all ages, from neonate to the elderly, and people in all states of consciousness and unconsciousness experience pain, all human beings, young and old, conscious and unconscious, must be evaluated for the presence of pain so that effective interventions can be planned and implemented for the patient in pain. As just discussed, there are a number of pediatric pain scales that can be used for this population to evaluate pain. Most of these scales and tools are standardized tests for behaviors that indicate pain, such as grimacing and crying. Others, like FACES scale, are basic standardized tools that can be used among children who have developed some insight into their pain and the related emotions, such as sadness, which occur as the result of pain. As the child further develops and can communicate in a more refined manner, numerical rating scales for pain from number 1 to number 10 in terms of pain intensity can be used. A numerical rating scale for pain is also used among adults, but, at times, a FACES-type scale is used when the patient is not able to communicate details about their pain for one reason or another. nutrition, and oral hydration. Adequate nutrition consists of the ingestion and utilization of water, essential nutrients, vitamins, and minerals to maintain and sustain health and wellness. A normal diet should consist of all of the food groups including fruits, vegetables, dairy foods, protein, and grains according to the United States Department of Agriculture. Like other basic human needs such as elimination, nutrition can be negatively impacted by a number of factors and forces such as diseases and disorders like anorexia, nausea, vomiting, dysphagia and malabsorption, cultural and ethical beliefs about nutrition and foods, personal preferences, level of development, lifestyle choices, economic restraints, psychological factors and disorders such as eating disorders, medications, and some treatments like radiation therapy and chemotherapy. Identifying the client's potential for aspiration. A number of client factors and treatment factors place the client at risk for aspiration. Some of these factors include sedation, decreased gastrointestinal motility, vomiting, the presence of a feeding tube, a tracheostomy tube and/or an endotracheal tube, dysphagia and other swallowing disorders, an impaired or absent gag and cough reflex, and a diminished level of consciousness. Preventive measures, such as keeping the patient up at a 30-degree angle, must be implemented to prevent life-threatening aspiration. Checking the client feeding tube placement and patency. Nasogastric tube patency and placement are determined and confirmed at least every 4 hours with continuous tube feedings and before each feeding when intermittent tube feedings are being given. Tube placement is determined by a number of different methods and techniques, including testing the aspirated contents for pH and checking the initial placement with a radiographic examination. After initial placement is checked and confirmed, ongoing monitoring of tube placement and patency are done by aspirating and checking the aspirate for pH with a pH of more than 6, which is an indication that the tube may be in the respiratory tract rather than the stomach, and/or testing the aspirate for bilirubin when it is possible that the tube is present in the intestine or the lung when these findings are not normal for the stomach, which is normally from 1 to 5, and/or by checking the radiopaque tube placement with radiography, and/or by osculating the epigastric area with the stethoscope to hear air sounds when about 30 milliliters of air are injected into the feeding tube. Providing feeding and/or care for the client with enteral tubes. Enteral nutrition provides liquid nutrients and necessary nourishment to patients with a gastrostomy or nasogastric tube. The components of these solutions include calories, fats, carbohydrates, and proteins, and tube feedings can be delivered to a patient on a continuous or on an intermittent basis. The complications associated with enteral feedings include aspiration, inadvertent improper placement, inadvertent tube dislodgement, leakage and/or irritation at the insertion site, diarrhea, constipation, nausea, vomiting, and an occasional foodborne illness that may result from contaminated enteral nutrition solutions. In addition to monitoring the patient for the complications of enteral feedings, the nurse should also clean the nostril and tube using a benzoin swab stick. Applying a water-soluble lubricating jelly just inside the nostril to prevent dryness and soreness. Providing frequent mouth care and replacing the securing tape as often as necessary. In terms of maintaining tube patency, nurses check and measure residual about every 4 to 6 hours. They irrigate the tube with about 15 to 30 milliliters of warm water before and after each intermittent feeding, and at least every 4 hours when continuous feedings are being given. And they maintain the head of the bed up at least 30 degrees during feedings and at least 1/2 hour after feedings. No feedings are given when the tube is not properly placed, or when the residual volume is excessive and/or the tube is not patent. The doctor is notified with these occurrences. Additionally, nurses can decrease the rate of feeding when gastrointestinal complications, such as diarrhea, constipation, or abdominal cramping, and pain occur. Monitoring and providing for the nutritional needs of the client. As previously discussed somewhat, nutritional needs differ among the age groups during the lifespan. The age groups and the maturational events that are most often associated with variation in nutritional needs are infancy, childhood, adolescence, older adulthood, and during menopause, lactation, and pregnancy. Nutritional needs also vary according to the physical status of the client. For example, nutritional needs change and the forms of the diet and nutrition vary when a patient is affected with a disorder such as diabetes or a swallowing disorder. Therapeutic diets are used for patients with specific nutritional needs and restrictions. Some of the most commonly used therapeutic diets include a clear fluids diet, a full fluids diet, a pureed diet, a mechanical soft diet, and a low-fiber diet. All clear fluids, including tea, clear broth, water, ginger ale, clear Italian ice, hard candy, and gelatin are permitted with a clear fluids diet. Milk, fruit and vegetable juices, eggs, ice cream, strained cereals, and puddings are included with a full fluids diet. A pureed diet consists of foods at different consistencies according to the patient's needs that are pureed with a blender. A mechanical soft diet consists of ground meat, soft fruits, vegetables, cereal, bread, soft cake, fish, eggs, and poultry. A low-fiber diet consists of easily digested foods with low fiber and little seasoning. Monitoring the client's ability to eat. A patient's ability to eat can be adversely affected with things like an inability to chew, an inability to swallow, inadequate or absent teeth, psychological impairments, altered levels of consciousness, and other physical and medical problems such as nausea, vomiting, and anorexia. Monitoring the impact of disease, illness on the client's nutritional status. Many diseases and illnesses impact the client's nutritional status. For example, psychological eating disorders like anorexia nervosa and bulimia nervosa can lead to malnutrition and underweightness. Disorders that affect the central nervous system can impair nutrition when the levels of consciousness is decreased or the patient is confused and uncooperative. Fevers cause malaise and nausea. Gastrointestinal diseases and disorders such as vomiting, diarrhea, malabsorption, failure to thrive, cancer of the stomach, colorectal cancer, cancer of the esophagus, hepatic cancer, and cancer of the pancreas also adversely affect the patient's nutritional status. Monitoring the client's intake and output. Intake includes all foods and fluids that enter the patient's mouth or internal bodily cavity. For example, consumed ground beef, clear fluids, intravenous fluids, and enteral feedings are considered intake. Output is all fluids and eliminated wastes that leave the body. For example, feces, emesis, and urine are forms of output. Solid intake is monitored and measured in terms of ounces. Liquid intake is monitored and measured in terms of mLs or cc's. Solid output is monitored and measured in terms of the number of bowel movements. Liquid stool is monitored and measured in terms of mLs or cc's. Urinary output is monitored and measured in terms of mLs or cc's for toilet-trained adults and children, and in terms of a diaper count for neonates and infants. Emesis is monitored and measured in terms of mLs or cc's. A urinary output of less than 30 mLs or cc's per hour is considered abnormal. Indirect evidence of intake and output can be determined with the patient's vital signs, the signs and symptoms of fluid excesses and fluid deficits, weight gain and losses that occur in short term, laboratory blood values and other signs and symptoms such as poor skin turgor, sunken eyeballs, and orthostatic hypotension. Reinforcing client teaching on special diets based upon client diagnosis, nutritional needs, and cultural considerations. Individuals and cultures vary in terms of their food preferences. Adherence to dietary restrictions and therapeutic diets is challenging to most clients. As much as possible, nurses should accommodate for the client's cultural and personal preferences and reinforcing teaching regarding these dietary treatments. Promoting client independence in eating. Patients should be encouraged to maintain as much independence as possible when it comes to eating and dietary choices. At times, assistive devices such as special utensils and weighted plates and verbal cueing can be effective in terms of establishing and maintaining independence in terms of eating. Personal hygiene. Personal hygiene includes bathing and washing, foot care, hair care, nail care, perineal care, shaving, mouth and oral care, and denture care. Determining the client's usual personal hygiene habits. There are a variety of different factors that influence hygienic practices. They include culture, religion, environment, developmental level, level of energy, and personal preferences. Cultures and cultural practices relating to hygiene vary around the globe. In North America, for example, there is a high cultural value on cleanliness, daily bathing, an odor-free body, and the absence of leg hair on females. Other cultures, however, may only bathe once a week or less, and they are not offended with bodily odors or the presence of underarm and leg hair among females. Some religions have religious ceremonial bathings and washings, and other religions may have no impact on hygiene practices. The patient's environment also impacts on hygiene and hygiene practices. For example, patients, such as the homeless and those in third world countries, have no running water. Level of development also impacts on hygiene. For example, neonates are bathed and provided with all their hygiene by the parents, and adults are typically independent in their hygiene self-care. Acutely and chronically ill patients often lose independence in terms of their hygiene and hygiene practices because they lack the energy and strength to perform hygiene. Lastly, personal preferences impact on hygiene and hygiene practices. Some prefer to shower in the morning, and some prefer to shower at night before going to bed, for example. Nurses identify and accommodate for the patient's strengths and weaknesses, cultural and religious practices, and personal preferences whenever possible to plan hygiene care that specifically meets the needs of the patient. Assisting with the activities of daily living, hygiene. In the healthcare setting, there are 3 different types of baths that clients have available to them. They are a complete bath, a partial bath, and a tub or shower bath. With all types of baths, the water temperature must be checked to ensure that it is safe and less than 110 degrees to prevent scalding and burns. A shower chair, tub chair, grab bars, and non-skid bath or shower mats are highly important to prevent accidents. Clients may prefer to shower over baths. Clients may need assistance getting in and out of the shower and tub when a bed bath is not given. Perineal care, like bathing of the skin, prevents infections, odors, and irritation of that area. Perineal care is done with a bed bath, shower, or tub bath. Perineal care is done more often for patients affected with incontinence and diaphoresis, for example. Special perineal care is given to patients with an indwelling urinary catheter. Male clients often want a facial shave once a day or once every couple of days. Female patients usually want their underarms and legs shaved about once a week. Shaving for patients is often not risky, except when the patient is taking an anticoagulant blood thinner. This places them at risk for nicks and bleeding. Oral hygiene is done at least twice a day and more often is needed. Oral hygiene consists of brushing the teeth, flossing the teeth, and rinsing the mouth. Partial and full dentures are also brushed and rinsed. Feet are washed with the bath and more often as needed. Diabetics and other patients at risk for infections should get special foot and toenail care and monitoring. For example, the feet must be completely cleaned and dried and examined daily for any signs of skin breakdown, corns, bleeding, broken, chipped, or absent nails, as well as blue or pale nail beds. Patients' hair can be washed with shampoo and conditioner in the shower, bathtub, and in bed with a special bed tray or dry shampoo. Patients should also be encouraged to comb or brush their hair a couple of times a day. Client nail care is another important area of hygiene. Clients' nails need to be checked daily to observe them for any irregularities. The client's nails should appear clean because dirt can cause infection. The client's nails should be trimmed short and smooth, as jagged nails have the ability of causing injuries to the client or to the staff attending to them. Assisting in providing post-mortem care. Standard precautions are maintained after a patient's death when providing post-mortem care. Post-mortem care consists of washing and drying the patient's entire body and removing all medical equipment, such as indwelling urinary catheters and intravenous lines. The deceased patient's hands and legs are gently placed in good alignment. The eyes and the jaw are held closed, and the body is then wrapped in a shroud after an identification tag has been placed on the client's greater toe and on the outside of the shroud prior to transfer to the morgue. Reinforcing teaching to the client on required adaptations for performing activities of daily living hygiene. Clients in need of assistive devices and other adaptations to ensure safety and/or maximum independence should be instructed on their proper use and reminded to use them consistently. Some of these devices and adaptations include shower chairs, grab rails, handrails, back sponges, and special tools for nail care. Rest and sleep. Good sleep habits and rest promote health and well-being in people. The sleep cycle consists of several stages of varying duration and characteristics. The stages of the sleep cycle are non-rapid eye movement stage 1, non-rapid eye movement stage 2, non-rapid eye movement stage 3, non-rapid eye movement stage 4, and the stage of rapid eye movement, which is often referred to as REM. The duration of sleep that is needed to promote and maintain health varies among the age groups. For example, newborns sleep 14 to 17 hours per day. Infants require 12 to 15 hours of sleep each day. The toddler needs 11 to 14 hours. Preschool children require 10 to 13 hours of sleep per day. School-age children need 9 to 11 hours of sleep. Adolescents require 8 to 10 hours of sleep every day. Adults need 7 to 9 hours, and older adults can get only 7 to 8 hours of sleep each day to maintain health. Many factors can impact on the quality and duration of a person's sleep. Some of the factors that impact on sleep include illnesses, the presence of pain, the presence of stress and anxiety, the environment, poor lifestyle choices like consuming coffee and alcohol before sleep, cigarette smoking, and some medications such as steroids and antidepressants. Commonly occurring sleep disorders are insomnia, which can include difficulties falling asleep and/or staying asleep, hypersomnia, which is sleeping too much and not being able to stay awake, parasomnias, which are things like sleepwalking and sleep talking, narcolepsy, which is the abrupt sudden falling asleep during daytime hours, and sleep apnea, which can be categorized as obstructive sleep apnea, central sleep apnea, and combined sleep apnea, which is the combination of both obstructive and central sleep apnea. The most common treatment for sleep apnea is the use of a CPAP machine during sleeping hours. Identifying the client's usual rest and sleep patterns. Hospitalized patients often experience sleep problems that result from a number of factors, including their medications, pain, anxiety, and a noisy, unfamiliar environment. As often as possible, nurses should overcome these problems by identifying and accommodating for the patient's needs, their normal sleep patterns, and their sleep rituals and routines, many of which are highly individual. Some people have established bedtimes. Others vary their bedtimes according to their level of fatigue. Some clients need silence and total darkness in order to sleep, and others sleep best with music or white noise. Still more go to sleep with a cup of warm milk or decaffeinated tea. Providing measures to promote sleep and rest. The promotion of sleep often depends on correcting the problem that causes the sleep disruption whenever possible, and also providing a quiet, peaceful, and environmentally comfortable environment that promotes sleep and rest, encouraging sleep reduction and relaxation exercises, administering analgesics to reduce pain, and providing a soothing back rub. Scheduling client care activities to promote adequate rest and sleep. Some scheduling suggestions to promote adequate rest and sleep include encouraging a regular bedtime and wake time, encouraging daytime exercise, limiting daytime naps, and discouraging exercise, caffeine, and other stimulants before bedtime. Pharmacological therapies. The practical vocational nurse provides care related to the administration of medications and monitors clients who are receiving parenteral therapies. Licensed practical nurses must be able to perform calculations needed for medication administration, reinforce education to client regarding medications, evaluate client response to medication, for example, adverse reactions, interactions, therapeutic effects. Follow the rights of medication administration. Maintain medication safety practices, for example, storage, checking for expiration dates, and compatibility. Reconcile and maintain medication list or medication administration record, for example, prescribed medications, herbal supplements, or over-the-counter medications. Collect required data prior to medication administration. Administer medication by oral route. Administer intravenous piggyback secondary medications. Administer medication by gastrointestinal tube, for example, G-tube, nasogastric in G-tube, G-button, or J-tube. Administer a subcutaneous intradermal or intramuscular medication. Administer medication by eye, ear, nose, inhalation, rectum, vagina, or skin route. Count narcotics-controlled substances. Calculate and monitor intravenous IV flow rate. Monitor transfusions of blood product. Administer pharmacological pain medication and maintain pain control devices, for example, epidural, patient control analgesia, or peripheral nerve catheter. Indications, interactions, therapeutic effects, precautions, adverse effects, side effects, and other common pharmacological considerations. Before we begin this major section, let's start with some basic definitions and terminology relating to pharmacology. Indications are the intended uses of a particular medication. Interactions include the results of a medication's interaction with another drug or medication, foods, and lifestyle choices such as alcohol consumption. Side effects are the effects of a medication other than the expected therapeutic effects. Some side effects, such as nausea and vomiting, are primarily harmless and only slightly troublesome. Others can be more severe and troublesome to the patient. Adverse reactions are serious life-threatening side effects to a medication. Medications are discontinued when an adverse reaction occurs. Therapeutic effects are the desired therapeutic effects of a medication. Idiosyncratic effects are unusual responses to a medication that are particular to a patient. Cumulative effects are effects of a drug that occur when it builds up in the body because of poor metabolism of the drug and/or poor excretion of the drug. Cumulative effects can lead to an inadvertent overdose of a medication. A potentiating effect is an additive, synergistic effect that results when two drugs are taken by the patient. One or both of these drugs will have additive greater effects. An inhibiting effect results when a combination of two or more drugs decreases the effect of one or both of these drugs. Precautions are patient conditions that indicate that another medication would be a better choice. Contraindications are patient conditions that prohibit the safe use of a particular medication. The drug's trade or brand name is the manufacturer's name of the drug. The drug's generic name is the formal name of the drug. One generic name can have more than one trade or brand name. Drug absorption is the action that occurs when the drug moves through the digestive tract and becomes absorbed into a form that can be used by the body. Drug distribution, which occurs after drug absorption, is the movement of the medication to the targeted area via the circulation. Drug metabolism or biotransformation is the breakdown of a drug by the liver. Drug excretion is the elimination of the drug from the body. Most drugs are excreted by the kidney and the urinary system. An anaphylactic reaction is a life-threatening allergy response to a medication, most often penicillin. Identifying potential and actual incompatibilities of client medications. Incompatibilities of medications are numerous. It is, therefore, highly recommended that you look up a possible incompatibility using a reliable chart of incompatibilities supplied by your healthcare facility or found on the Internet. Identifying the contradictions to the administration of a prescribed or over-the-counter medication to the client. Many medications, including prescribed and over-the-counter medications, can be contraindicated for clients for a number of different reasons. Nurses must be thoroughly knowledgeable about all aspects of the medications that they administer. Therefore, it is the nurse's responsibility to hold any medication that is contraindicated for the patient until the order is clarified with the patient's ordering physician. Identifying the symptoms of an allergic reaction. Nurses observe for and identify any possible allergies to the medications. All allergies are documented in the nursing assessment and also on the medication administration record, in addition to other areas in the medical record, according to the facility's policy and procedure. Many healthcare agencies also use allergy bands and/or barcodes with embedded allergy information to enable nurses to readily identify any allergies to medications. Commonly occurring medication allergies include allergies to penicillin, which can be particularly dangerous and life-threatening, allergies to sulfonamides, and allergic reactions to cephalosporin medications. It is estimated that about 10% of people have had a reaction to penicillin. Some of these actions are an allergic response to the penicillin, and others are simply a side effect of the penicillin. The first exposure to penicillin, referred to as the sensitizing dose, sensitizes and prepares the body to respond to a second exposure or dose. The signs and symptoms of this allergic sensitizing dose response include a body-wide rash and itching. It is this second exposure or dose that leads to anaphylaxis or anaphylactic shock. The signs and symptoms of anaphylaxis and anaphylactic shock, a type of distributive shock, are the massive collapse of venules and arterioles in the body's circulatory system, decreased cardiac output, histamine release, a drop in blood pressure, pooling of venous blood, laryngeal edema, respiratory distress, a rash, a rapid bounding heartbeat, and death unless it is immediately treated. All allergic responses, including those secondary to medications, must be immediately documented and reported to the doctor and other members of the healthcare team, as indicated and according to the facility's specific policies and procedures. Implementing procedures to counteract adverse effect of medications. Procedures to counteract the adverse effect of medications depend on the patient's adverse responses. For example, constipation will be symptomatically treated, and severe life-threatening adverse responses are treated with the ABCs and other emergency, life-saving measures, as in the case of when anaphylaxis occurs. At times, the dosage of the medication will be decreased, the medication will be discontinued, and/or the client will be safely re-challenged with the medication under the supervision of the physician to confirm the adverse reaction. Re-challenging is not done when a severe allergic response is suspected. All adverse drug reactions are reported and documented according to the facility's policies and procedures. Withholding a medication dose if the client experiences an adverse effect to a medication. Nurses must withhold a medication when the client experiences and/or is possibly experiencing an adverse effect to a medication. In addition to holding the dose or stopping the intravenous flow of the intravenous medication, the nurse will notify the registered nurse and/or the doctor and completely document the adverse reaction. Monitoring and documenting the client's response to actions taken to counteract the adverse effects of medications. After treatment to counteract the adverse effects of medications are rendered, the nurse will monitor and document the client's responses to these treatments. Monitoring the client for actual and potential adverse effects of medications. This monitoring for actual and potential adverse effects of medications is done not only for prescribed, doctor-ordered medications, but also for supplements, herbs, and all over-the-counter medications. Monitoring the anticipated interactions among client-prescribed medications and fluids. Nurses also monitor the anticipated interactions of prescribed and over-the-counter medications and fluids, including those interactions that can occur among oral, intravenous, subcutaneous, intramuscular, and even topical medications. These interactions are also reported and documented according to the facility's specific policies and procedures. Monitoring and documenting the client's side effects to medications. Side effects are the effects of a medication other than the expected therapeutic effects. Some side effects, such as nausea and vomiting, are primarily harmless and only slightly troublesome, but many others can be more severe and troublesome to the patient. Documentation and reporting are also done when a side effect has occurred or it is suspected that a side effect has occurred. Monitoring and documenting the client's responses to the management of medication side effects. As previously discussed, prescribed, over-the-counter, and herbal supplements have potential side effects. Nurses monitor and document client responses to any and all interventions that were used to manage any side effects that the client may experience. For example, the nurse will monitor the patient's responses to interventions, such as an enema, that are used to treat the side effects to medications like constipation secondary to opioid analgesic medications. Reinforcing client teaching on the possible effects of medications. Patients and significant others must be knowledgeable about all of the medications that the patient is taking, including the signs and symptoms of side effects and adverse reactions. They should also be instructed about when to call their doctor to report suspected side effects and adverse reactions. Notifying the primary healthcare provider of actual potential adverse effects of client medications. Nurses must document and notify the primary healthcare provider about any actual or potential adverse effects and side effects of medications. Dosage calculations. Safe nursing care mandates accuracy in the calculation of dosages and solution rates. The three measurement systems that are used in pharmacology are the household measurement system, the metric system, and the apothecary system. The household measurement system is typically only used for patients who are in the home and not in a hospital or another healthcare facility. Measurements used in the household measurement system include teaspoons, tablespoons, drops, ounces, cups, pints, quarts, gallons, and pounds. The apothecary measurement system has weight measurements like dram, ounce, grain, gr, scruple, and pound. The volume units of measurement in the apothecary measurement system are a fluid ounce, a pint, a minium, a fluid dram, a quart, and a gallon. The metric measurement system has volume measurements including liters, cubic milliliters, and cubic centimeters. Its units of weight are kilograms, grams, milligrams, and micrograms, mcg. Each of these measurement systems can be converted to another measurement system by using equivalents. The most common conversions from one system to another with its accurate equivalent are: 1 grain is equal to 60 milligrams. 1 kilogram equals 2.2 pounds. 1 milligram equals 1,000 micrograms. 1 gram equals 1,000 milligrams. 1 kilogram equals 1,000 grams. 1 tablespoon equals 3 teaspoons. 1 tablespoon equals 15 milliliters. 1 teaspoon equals 5 milliliters. 1 liter equals 1,000 milliliters. 1 ounce equals 30 milliliters. The ratio and portion method is the most popular method for calculating dosages and solutions. Here is how the ratio and proportion method is done for medication dosage. The doctor's order is to give 500 milligrams of an oral medication 1 time a day. The label on the bottle states that each tablet contains 125 milligrams. How many tablets should be administered daily? The problem is solved by doing this. 500 milligrams is to X tablets equals 125 milligrams is to 1 tablet. You then multiply 500 milligrams times 1, which equals 500 milligrams x 1 equals 500 milligrams. 125x equals 500 milligrams. X equals 500. 125, or 500 divided by 125 equals 4 tablets. Intravenous fluids. Doctor's order: 0.9% NaCl solution at 50 milliliters per hour. How many GTTs per minute should be administered if the tube delivers 20 GTT per milliliter? X GTTs per minute equals 50 times 20 over 60 equals 1000 over 60 equals 16.6 GTT. Rounded off to 17 GTT a minute. Rounding off decimals. When calculating doses, you round up a number when the number to the right of it is more than 5 or more by adding 1 to the number. When the number to the right of it is 5 or less, you do not change the number. So if you are rounding a 3.68 to the nearest tenth, the answer is 3.7 because 8 is more than 5. And if you are rounding off 3.22 to the nearest tenth, the answer is 3.2 because 2 is 5 or less. Similarly, if you are rounding of 3.687 to the nearest hundredth, the answer is 3.69 because the 7 in the hundredths place is more than 5. And if you are rounding off 3.222 to the nearest tenth, the answer is 3.22 because the 2 in the hundredths place is 5 or less. Using clinical decision-making when calculating doses. Nurses apply clinical decision-making skills to these calculations. The nurse should be alerted to the fact that a dosage calculation is wrong when the calculation is solved and it says that the nurse should be administering 8 tablets. In practice, rarely more than 2 tablets are given. If a higher dose is needed, tablets containing a higher dose are used so that fewer pills or tablets have to be given. Similarly, nurses should be alerted to the fact that a dosage calculation is wrong when the calculation is solved and it says that the nurse should be administering 2 1/2 milligrams of digoxin because the nurse has the knowledge that this dosage of digoxin is much higher than the safe dosage. Lastly, nurses should be alerted to the fact that a dosage calculation is wrong when the calculation is solved and it says that the nurse should be administering 300 drops per minute of an intravenous fluid because it is impossible to accurately count these rapidly falling drops. The nurse must recalculate or recalculate with another nurse when things like this occur. Expected actions and outcomes. Identifying the client's expected response to medication. All medications have expected outcomes and therapeutic effects, but they also have other effects like a cumulative effect, a potentiating effect, an inhibiting effect, an idiosyncratic effect, and adverse effects. Nurses administering medication must monitor clients and identify the client's therapeutic responses to medications among other non-therapeutic and unexpected effects. For example, The patient's potassium level should decrease when they are given K-acylate. All effects, including expected responses, are documented. Using resources to check on the purposes and actions of pharmacological agents. Some of the reliable resources that nurses can use to access information about a client's medications are the Physician's Desk Reference, PDR, a nurse's drug handbook or textbook, the facility's formulary, and a pharmacist. These resources contain full information about medications, including their purposes, actions, dosage, side effects, and other details. Applying a knowledge of pathophysiology when addressing client pharmacological agents. Nurses apply knowledge of pathophysiology when they are addressing the patient's pharmacological agents. The indications for a patient medication are closely aligned with the pathophysiology that is affecting the patient. For example, anticoagulant indications are closely aligned with pathological prolonged clotting, and antibiotic indications are closely aligned with the pathological growth and multiplication of pathogenic infective microorganisms. Monitoring the client's use of medications over time. Nurses monitor the client's use of medications over time in terms of their compliance and the continued efficacy of prescribed medications, over-the-counter medications, and home remedies to achieve the desired therapeutic effects. Reinforcing education to the client regarding medications, including the reinforcement of teaching about the actions and therapeutic effects of medications and pharmacological interactions. Nurses reinforce education relating to all aspects of the medications that the patient is taking when a knowledge deficit is identified. Evaluating client response to medications. Again, the licensed practical nurse observes, identifies, and documents all responses to medications. Medication administration. Identifying the client's need for PRN medications. A PRN medication is given when a specified condition in the order presents. For example, a PRN pain medication is given when pain is present, and an antipyretic is given when the patient's temperature is more than 100 degrees. In addition to documenting that a PRN medication was administered, the nurse should also document the data that indicated the need for the PRN medication. Mixing client medications from 2 vials as necessary. Medications can only be mixed together when they are, like NPH and regular insulin, compatible. The procedure for mixing NPH and regular insulin is to instill an amount of air into the NPH bottle that is equal to the NPH dose, and then inject an amount of air into the regular insulin bottle that is equal to the regular insulin dose. Now, withdraw the regular insulin dose and then withdraw the NPH dose using the same insulin syringe. Medication safety. Following the rights of medication administration. The 10 rights of medication administration are the right or correct. 1. Patient. 2. Medication. 3. Dose. 4. Time or frequency. 5. Route. 6. Client education. 7. Documentation. 8. Right to refuse. 9. Assessment. And 10. Evaluation. Maintaining medication safety practices. In addition to the 10 rights of medication administration and identifying the patient using at least 2 different identifiers, nurses must also ensure medication safely in respect to the storage of medications. the checking for expiration dates, checking for any patient allergies, and checking for any incompatibilities. Narcotics must be in a locked and secure place. Other medications must be stored in a place that is secure and one that prevents accidental poisonings among the pediatric population and also among those who are confused and/or cognitively impaired. Additionally, medications that need refrigeration must be refrigerated. Reconciling and maintaining a medication list or medication administration record. Medication reconciliation is a process that maintains a list of all current medications, including all prescription medications, vitamins, over-the-counter medications, herbal remedies, and nutritional and/or dietary supplements. Collecting the required data prior to medication administration. Nurses collect and check pertinent data prior to administering a medication. For example, the nurse checks and documents the apical heart rate before giving digoxin. The nurse checks blood pressure before giving an antihypertensive. Nurses also check blood glucose before administering insulin. Assisting in preparing the client for the insertion of a central line. Nurses are sometimes asked to assist with invasive procedures, such as the placement of a central venous catheter or the placement of a respiratory tube, such as an endotracheal or tracheostomy tube. Sterile procedure and a sterile field, as detailed previously, are used for these procedures in care. Administering medications by the oral route. The nurse will identify the patient, inform the patient about the medication that you will be giving, and then give the oral medication to the patient and remain with the patient until the medication is swallowed. Administering intravenous piggyback medications. The nurse will identify the patient, inform the patient about the medication, and ensure that the IV solution is compatible with the piggyback medication. The piggyback is hung. The primary IV site is cleansed with alcohol. The piggyback is inserted into the primary IV line, and then the primary IV and the piggyback are then allowed to run together until it is done. Administering medications by a gastrointestinal tube. After positioning the patient in the Fowler's position and verifying that the tube is properly placed, the procedure for administering medications by a gastrointestinal tube is 1. Insert the syringe without the piston into the end of the nasogastric tube. 2. Pour the medications into the syringe and let it flow freely with the natural force of gravity. 3. After the medication is completely administered, instill 30 to 50 milliliters of water to flush the tube, and 4. Keep the patient in the Fowler's position for at least 30 minutes after the administration of the medication in order to prevent any aspiration. Administering medications by the subcutaneous route. The steps for administering a medication with the subcutaneous route are: 1. Clean the injection site with an alcohol swab in an outward circular pattern of about 2 inches. 2. Pinch the site for a 1-inch fold. 3. Position the needle with the bevel up and insert the needle at a 45-degree angle. 4. Pull the plunger back to check for blood. 5. Slowly inject the medication. 6. Withdraw the needle and cover the site with an alcohol swab. And 7. Gently massage the site, except when heparin was administered. Administering medications by the intramuscular route. The steps for administering a medication with the intramuscular route are: 1. Clean the injection site with an alcohol swab. 2. Position the needle with the bevel up and insert at a 90-degree angle. 3. Pull the plunger back to check for blood. 4. Slowly inject the medication. 5. Withdraw the needle and wipe the site with an alcohol swab. And 6. Gently massage the site except for certain medications. Administering eye medications. The steps for administering eye medications are: 1. Ask the patient to tilt their head back and towards the eye getting the drops or ointment. 2. Rest your hand against the client's forehead to steady it. 3. Pull the lower lid down and instill the ordered number of drops. And 4. Ask the person to now close their eyes and then blink so the drops will spread over the eye. Administering ear medications. The procedure for administering ear medications is: 1. Warm the eardrops to body temperature. 2. Have the patient lie on their side with the ear to get the medication up. 3. Straighten out the ear canal by pulling the auricle up and back. You should pull the auricle down and back for pediatric patients less than 3 years of age. 4. Instill the ordered drops against the side of the inner ear and hold the auricle in place until the medication is no longer visible. And 5. Have the person remain in the side-lying position for at least 10 minutes. Administering medications by the inhalation route. The steps to using a metered dose inhaler are: 1. Shake the bottle and remove the cap. 2. Ask the person to exhale. 3. Have the person then firmly place their lips around the mouthpiece. 4. Release the medication while the person is taking a long, slow inhalation. And 5. Have the patient hold their breath for a couple of seconds and then slowly exhale. The steps to using a turbo inhaler are: 1. Slide the sleeve away from the mouthpiece. 2. Turn the mouthpiece counterclockwise in order to unscrew it. 3. Place the colored part of the medication into the stem of the mouthpiece. 4. Rescrew the inhaler. 5. Slide the sleeve all the way down to puncture the capsule. 6. Tilt the head backwards and after a full exhalation, tell the client to deeply inhale and hold their breath for several seconds. And 7. Repeat inhalations until all of the medication has been used. Administering medications by the sublingual and buccal routes. Buccal medications are placed between the teeth and the inner aspect of the cheek. Sublingual medications are administered under the back of the tongue. Administering medications by the vaginal route. The procedure for administering medications vaginally is: 1. Position the patient in the lithotomy position. 2. Lubricate the vaginal suppository with a water-soluble jelly. And 3. Spread the labia and insert the suppository about 3 inches into the vagina. Administering medications by the rectal route. The procedure for administering medications rectally is: 1. Position the patient in the left Sims position. 2. Lubricate the rectal suppository with a water-soluble jelly. 3. Lift the person's upper buttock with a non-dominant hand and insert the suppository with the tapered end first into the rectum about 3 inches. 4. Ask the patient to lie still so the suppository can be retained. And 5. If the person has the urge to defecate, place a gauze pad over the rectum and press until the urge to defecate passes. Disposing of client unused medications according to facility agency policy. Unused and expired medications are disposed of according to the facility's policy. Counting narcotics and controlled substances. Controlled substances and narcotics are immediately documented on the narcotic record when they are taken from their secure and double-locked cabinet. This documentation is not done after the medication is administered. Narcotics and controlled substances are then documented in the patient's medication record as soon as they are administered. If a controlled substance is wasted, this waste must be witnessed by and documented by the wasting nurse and another nurse. During the change of shift, 2 nurses perform a complete count of all narcotics and controlled substances. If a discrepancy occurs, it is immediately reported for further investigation. Calculating and monitoring intravenous IV flow rates. The calculation and monitoring of intravenous flow rates were previously detailed under dosage calculations. Monitoring the transfusion of blood products. The 4 blood types are types A, B, AB, and O. Type A blood is compatible with types A and O blood types. Type B blood is compatible with types B and O blood types. Type AB blood is compatible with types A, B, AB, and O blood types. Type O blood is compatible only with type O blood. Blood is also classified as Rh negative or Rh positive. This Rh compatibility is also essential to safe blood administration and to prevent hemolysis. Whole blood and blood products such as packed red blood cells, platelets, clotting factors, and plasma are administered to clients for a number of different reasons, including platelet disorders, chronic renal failure, anemia, coagulation disorders, and hemorrhage. Blood transfusions can be a homologous transfusion or an autologous blood transfusion. Before blood transfusions, the patient laboratory values are checked. The doctor's order is checked. The patient's blood is typed and cross-matched, and the blood is obtained from the blood bank just prior to administration. Just prior to the administration of the blood or blood product, 2 nurses identify the patient using 2 unique identifiers, ensure that the 20-gauge intravenous line is patented, prime the intravenous line with normal saline, and attach the filter if ordered. Inspect the blood for abnormalities. Check the expiration date and time and ensure that it is not expired, and check the compatibility of the blood, the client's blood type, and cross-match. 1 nurse must stay with the patient for at least the first 15 to 30 minutes after the transfusion has begun to monitor for any reactions to the blood, which typically occur shortly after a transfusion has begun. Vital signs are checked at least every 15 minutes for at least 1 hour, and then every hour after that. The blood transfusion rate is monitored and deemed sufficient enough to complete the transfusion within 2 to 4 hours after it began. The patient is also monitored for any signs of reaction to the blood. Some of these signs and symptoms can include level of anxiety, respiratory distress, and neck vein distension. Some of the complications of blood and blood product administration include sepsis, which can be signaled with nausea, vomiting, fever, hypotension and abdominal pain, circulatory overload, which can be signaled by chest pain, hypertension, crackles, edema, anxiety, neck vein distension, dyspnea and trachypnea, and hemolysis, which can be present with dyspnea, hypotension, anxiety, chest pain, and back pain. Blood transfusions are immediately stopped when a possible blood reaction is occurring. the doctor must be notified and any necessary emergency interventions are provided as indicated by the patient's condition. The blood bag and the administration tubing are kept for possible testing and analysis whenever a reaction to a blood transfusion has occurred. Reinforcing client teaching on client self-administration of medications. Nurses reinforce education relating to all aspects of the medications that the client is taking, as previously mentioned. Some examples of this education reinforcement include asepsis, mixing insulins, drawing up of insulin, proper subcutaneous injection procedures, and the proper use of an insulin pump. Pharmacological pain management. Patient reports of pain are far more accurate and reliable than other pain assessments, like those related to behavioral changes. Pain can be categorized in a number of different manners. Pain can be classified acute and chronic. Pain can also be categorized as nociceptive and neuropathic. Pain can be also described as superficial, somatic, radicular, referred, or visceral pain. Lastly, it can be classified as localized or diffuse, and as mild, moderate, or severe. Acute pain is short-lived and often self-limiting and possibly even correctable. Acute pain lasts usually less than 3 months in duration. Acute pain usually has an abrupt and sudden onset. Acute pain is usually confined to a localized area that can be identified by the patient. Some of the signs and symptoms of acute pain are tachycardia, anxiety, muscular tension, increased blood pressure, diaphoresis, and pupil dilation. Acute pain warns the body that something is physically wrong. Chronic pain is long-lasting, and it usually cannot be completely eliminated. Chronic pain is more difficult to identify and more difficult to measure in terms of its intensity than it is for acute pain. Chronic pain is also more difficult to locate than acute pain. Cancer pain, or malignant pain, is often intraceable. Other subcategories of chronic pain are non-malignant pain, continuous chronic pain, and intermittent chronic pain. Unlike acute pain, there are usually no vital sign changes with chronic pain. However, chronic pain is often accompanied with emotional responses such as anorexia, insomnia, irritability, depression, and fatigue. Nociceptive pain can be somatic or radicular. Nociceptive pain, which occurs with an injury, like a hip fracture, sends a signal to the intact central nervous system that an injury has occurred. Unlike nociceptive pain, neuropathic pain often occurs when the nervous system has been damaged. The source of the nociceptive pain cannot be readily identified and located. Nociceptive pain can be reported by the patient as sharp, severe, burning, and spasmodic. Central neuropathic pain occurs as the result of damage to the central nervous system, such as a spinal cord injury. Peripheral neuropathic pain occurs with peripheral nervous system damage, such as occurs with neuropathy, carpal tunnel syndrome, and post-amputation phantom pain. Lastly, sympathetically medicated pain occurs when there is an abnormal pathological connection between the sympathetic nervous system and nerves. Uncontrolled pain leads to grave and serious consequences, such as a decreased quality of life, social withdrawal, depression, anxiety, diaphoresis, muscular tension, pallor, nausea, vomiting, restlessness, crying, moaning, sleep disorders, suffering, lassitude, sedation, fatigue, insomnia, anger, anorexia, immobility, exhaustion, and even neurogenic shock. It also affects the patient's vital signs. These vital sign changes include increased blood pressure, an increased pulse rate, and an increased respiratory rate. There are many myths and misconceptions about pain, the pain experience, and pain management. Some people believe that pain is expected whenever the person has an illness or injury. Others believe that pain medications cause addiction. Still more think that neonates and infants are not able to feel pain. And others believe that the elderly have inevitable pain because of the aging process. These myths are false and not true. The American Nurses Association's position statement on the use of pain medications at the end of life supports the ethical use of opioids at the end of life to relieve pain if the use of these medications hasten death. Administering pharmacological pain medications. Analgesics are medications that are used to help alleviate pain. Analgesics are categorized into two separate categories, which are the opioid analgesics and the non-opioid analgesics. Opioids are narcotics that are used for severe pain. Non-opioid analgesics are used to treat mild and moderate pain. Pharmacological pain medications are typically ordered and administered on a PRN basis. The nurse determines the patient's level of pain before and after the administration of an analgesic. Identifying the client's need for pain medication. Pain is identified with subjective and objective data. Subjective reports of pain by the patient are more reliable and accurate than the signs and symptoms that are observed by the nurse. For example, a client's report of severe abdominal pain is a more reliable indicator of pain than a nurse's observation that the patient is crying, splinting, and is not able to perform their activities of daily living. Nonetheless, some of the other behavioral indications of pain include deep breathing, guarding, muscular tension and rigidity, the loss of appetite, a loss of sleep, a lack of ability to perform activities of daily living, a lack of focus of attention, and crying. Some of the biological and physiological objective signs and symptoms of pain are an increased pulse, diaphoresis, increased blood pressure, increased or decreased rate and depth of respirations, and the dilation of the pupils. The PQRST acronym is useful to remind nurses of the pain-related data that is collected. P stands for what provoked or precipitated the symptoms. Q stands for the quality of pain. Is it burning, aching, stabbing, sharp, dull, etc.? R stands for what region or area the pain is in. Does the pain radiate to another area? S stands for severity and intensity of the pain. T stands for the things that trigger the pain. Some of the questions that the nurse asks the patient about their pain and their level of pain include questions such as, where is the pain? Describe your pain. When did the pain begin? What precipitates the pain? What relieves the pain? What makes the pain worse? How often does the pain occur? Tell me the character of the pain. For example, is the pain crushing, sore, stabbing, etc.? How would you rate your level of pain from 1 to 10? Monitoring and documenting client responses to pharmacological interventions. Client responses to pain interventions can be calculated in a number of different ways, including the use of pain rating scales, verbal reports of pain, and an objective determination and evaluation of any physical and/or behavioral cues that can be associated with the patient's pain. The level of pain should be determined prior to the administration of pain drug, and the level of pain must also be determined after the medication was administered in order to determine whether or not it was effective in terms of a decrease in the patient's level of pain. Maintaining pain control devices. Nurses also play an important role in maintaining pain control devices such as an epidural pain control, patient-controlled analgesia, and peripheral nerve catheter. Patient-controlled analgesia is defined as the use of a patient-controlled analgesia infusion pump that is used to deliver analgesia intravenously or epidurally to clients in acute or chronic pain. Patient-controlled analgesia, including the intravenous pump, is the most commonly used pain management device. Patient-controlled analgesia devices are pre-programmed electronic devices that are set for the prescribed dosage of a pain medication. The patient activates the device when they are in pain. The prescribed dosage of the medication is then automatically administered unless the next dosage is not yet due. Some patient-controlled analgesia devices beep to let the patient know that the pain medication was not delivered because their next dosage of the medication is not yet due. Some of the advantages of patient-controlled analgesia include the rapid relief of pain, the self-control and self-administration of a pain medication when the patient wants it, and the delivery of the pain medication within prescribed limits. The disadvantages of patient-controlled analgesia include the fact that some patients, like confused or lethargic patients, may not be able to use and manipulate the patient-controlled analgesia device. In some cases, another person can be authorized to press the button and deliver the pain medication when the patient is not able to do it by themselves. The use of the patient-controlled analgesia device by another person, a surrogate, must be authorized by the doctor who has ordered the analgesic medication before the surrogate is able to assist the patient with the patient-controlled analgesia. Epidural analgesia is most often used among patients who have chronic uncontrollable back pain when other interventions, such as other medications and the services of a physical therapist, have not been effective. These epidural injections are sometimes done in a community-based doctor's office with or without the guidance of an X-ray. The expected outcome for epidural analgesia, like all other pain management techniques, is a decrease in the patient's level of pain after the procedure is done. Peripheral nerve blocks using a peripheral nerve catheter are most often used for anesthesia, but they can also be retained and used for a continuous infusion of analgesia postoperatively. Reduction of risk potential. The practical vocational nurse reduces the potential for clients to develop complications or health problems related to treatments, procedures, or existing conditions. Licensed practical nurses must be able to check and monitor client vital signs, perform an electrocardiogram, EKG, ECG, perform venipuncture for blood draws, perform blood glucose monitoring, maintain central venous catheters, collect specimen for diagnostic testing, for example, blood, urine, stool, or sputum, monitor diagnostic or laboratory test results, identify signs or symptoms of potential prenatal complication, perform neurological checks, perform circulatory checks, check for urinary retention, for example, bladder scan, ultrasound, or palpation. Administer and check proper use of compression stockings, sequential compression devices, SCD. Perform risk monitoring and implement interventions. Monitor continuous or intermittent suction of nasogastric NG tube. Implement measures to prevent complication of client condition or procedure, for example, circulatory complication, seizure, aspiration, or potential neurological disorder. Evaluate client oxygen O2 saturation. Provide care for client before surgical procedure, including reinforcing teaching. Insert, maintain, and remove urinary catheter. Insert, maintain, and remove nasogastric NG tube. Maintain and remove peripheral intravenous IV catheter. Assist with the performance of a diagnostic or invasive procedure, for example, call a timeout, bronchoscopy, needle biopsy. Changes and abnormalities in vital signs. Checking and monitoring the client's vital signs. The vital signs include blood pressure, the pulse, body temperature, respirations, and oxygen saturation. Changes and abnormalities of the vital signs are highly sensitive to changes in terms of the physical status of the patient. Changes and abnormalities of the vital signs must be addressed by the nurse. For example, a significant drop in patient's oxygen saturation may indicate life-threatening hypoxia. A rise in the patient's blood pressure may indicate fluid overload. A rise in the client's temperature can indicate the presence of infection or sepsis. The vital signs are highly sensitive to pathophysiology and pathophysiological changes in the patient. For example, the respiratory rate is regulated by the baroreceptors or chemoreceptors, which are located in the aorta and the carotid arteries as well as the brainstem. For this reason, pathophysiological alterations affecting the brainstem will impact on the patient's respirations. Blood pressures are the function of cardiac rate in combination with systemic vascular resistance. Pathophysiological changes that affect either or both of these factors will affect the patient's blood pressure. For example, increases or decreases in terms of peripheral resistance will alter the blood pressure. Bodily temperatures are maintained by the neurological system and the cardiovascular system. Bodily temperatures are adversely affected by pathophysiological changes such as dehydration, head injuries, hypothalamus damage, and the inflammatory process. Normal pulses are maintained with the cardiovascular system, the autonomic nervous system, and the parasympathetic nervous system. Some of the pathophysiological disorders that affect the pulse include fever, pain, hyperthyroidism, and hypoxemia. Comparing vital signs to the client's baseline vital signs. Baseline vital signs are taken during the admission process. They are then monitored in an ongoing manner. When nurses take patients' vital signs, they compare and contrast the patient's current vital signs to the patient's baseline vital signs. They also compare and contrast these vital signs to the normal vital sign parameters as based on the age of the patient in order to determine whether or not the patient's vital signs are within normal limits. All significant changes in terms of vital signs must be reported and documented. Many facilities use a graphic flow chart for their patients' vital signs. Reinforcing client teaching about normal and abnormal vital signs. Licensed practical nurses reinforce patient and family teaching about normal and abnormal vital signs, as well as things that may change their vital signs. The content of this reinforcement should include the correct method for taking and recording one's vital signs, information about the relationship of diseases and illnesses with the different vital signs, when to call a doctor about abnormal vital signs, the possible causes of significant changes for each of the vital signs, and when to take their vital signs. For example, a patient should be knowledgeable about the need to check their blood pressure before taking an antihypertensive medication. They should also be knowledgeable about the need to check their blood glucose level prior to taking any of their ordered insulin. Diagnostic tests. Performing an electrocardiogram, EKG, ECG. The electrocardiogram traces the electrical activity of the heart over a period of time with an electrocardiograph which is connected to the patient with the external application of electrocardiogram leads. The procedure for performing a 12-lead electrocardiogram will now be discussed. The steps for this procedure are: check the patient's identity. Explain what you will be doing for the patient. Place the patient in a supine position and ask them to remain as still as possible during the electrocardiogram. Expose the patient's chest. Cleanse all of the skin sites where the leads will be placed, so that there are no oils and other matter on the sites which can interfere with the clarity and quality of the electrocardiogram. Secure the electrodes to flat areas on each of the patient's extremities, above wrists and ankles. Place the other 6 electrodes on the chest in the correct areas. Print electrocardiogram data off and then place or enter it into the client's medical record as established by the particular facility's policy and procedure. Performing diagnostic testing. Some laboratory tests are done exclusively in the laboratory, and others can be performed at the bedside by the licensed practical nurse. Nurses can collect specimens and perform a number of diagnostic tests at the bedside, including oxygen saturation testing, blood glucose testing, and feces for occult blood. Oxygen saturation reflects the amount of oxygen saturation in arterial blood. Oxygen saturation is measured by placing a sensor on the person's finger that then measures and shows the nurse the patient's oxygen saturation level. Oxygen saturation levels are often checked with the same frequency as the patient's vital signs. Pulse oximetry can be done by trained and competent certified nursing assistants in the same manner that they can take and record patients' vital signs. Fecal occult blood testing is done by taking 2 small portions of the patient's stool and placing them on a commercially prepared slide. A drop of reagent liquid is then placed on the slide. The test is positive for occult hidden blood when the slide turns blue within 60 seconds. Nurses document the color after the reagent was applied. They also report a positive test for blood to the physician and supervising nurse whenever a blue color is observed after the reagent was applied. Fecal occult blood testing, also referred to as guaiac screening, is a screening tool for colon cancer. Fecal occult blood testing is also used as part of the diagnostic tests used to determine the source of anemia. Now we will go over the procedure for measuring blood glucose using a blood glucose monitor. Check the patient's identity. Explain what you will be doing for the patient. Don clean gloves. Disinfect the finger with an alcohol swab. Verify and confirm that the code strip corresponds to the meter code. Prick the side of the finger using the lancet. Turn the finger down so the blood will drop with gravity. Wipe off the first drop of blood using sterile gauze. Collect the next drop on the test strip. Hold gauze to the client's finger after the specimen has been obtained. Read the client's blood glucose level on the monitor and document the test results and notify the registered nurse if the results are abnormal. Reinforcing client teaching about diagnostic tests, including the purposes of laboratory tests. Nurses reinforce client teaching relating to the purposes, required preparation, procedures, results, and the implications of abnormal and normal diagnostic tests, including the results of all laboratory tests and testing. Laboratory values. Identifying normal and abnormal laboratory values. Now, we will discuss normal and abnormal laboratory values. The normal adult laboratory values for blood chemistry are: sodium. The normal range is from 137 to 147 milliequivalents per liter. Sodium is an indication of the patient's fluid balance. It can indicate the presence of dehydration and fluid overload. Potassium. The normal range is from 3.5 to 4.8 milliequivalents per liter. An elevated potassium level indicates metabolic acidosis, and a low potassium level indicates metabolic alkalosis. Creatine. The normal range is from 0.7 to 1.3 milligrams per deciliter. Creatinine is elevated with renal disease. Chloride. The normal range is from 98 to 105 milliequivalents per liter. A low level of chloride indicates metabolic alkalosis. Blood urea nitrogen. The normal range is from 7 to 20 milligrams per deciliter. Blood urea nitrogen is high with renal failure. The normal adult laboratory values for hematology are red blood cells. The normal range for men is from 4.6 to 6.2. The normal range in females is from 4.2 to 5.4. Red blood cells are an indicator of oxygenation. Hemoglobin. The normal range for men is from 13.5 to 16.5 grams per deciliter. The normal range in females is from 12 to 15 grams per deciliter. Hemoglobin is an indicator of oxygenation. Hematocrit. The normal range for men is from 40 to 54%. The normal range in females is from 38 to 47%. Hemoconcentration is present when the hematocrit is elevated. A low level of hemoconcentration is present when the hematocrit is low. White blood cells. The normal range is from 4,500 to 11,500. Elevated white blood cell counts indicate the presence of infection. Platelets. The normal range is from 150,000 to 400,000. A low platelet count indicates poor clotting. A high platelet count indicates rapid clotting. Prothrombin time. The normal range is from 12 to 14 seconds. A high prothrombin time indicates poor clotting, and a low prothrombin time indicates rapid clotting. Partial thromboplastin time. The normal range is from 25 to 37 seconds. An elevated partial prothrombin time indicates poor clotting. International Normalized Ratio, INR. The normal range is from 0.8 to 1.1 seconds. The therapeutic range when the patient is taking warfarin is 2 to 3. The higher the INR, the slower the clotting. An A1C blood test, also known as hemoglobin A1C, glycated hemoglobin, glycosylated hemoglobin, and HbA1c, can be used for both diagnosing diabetes and also determining how well the diabetes is being controlled and managed over time. The hemoglobin A1c test determines and measures the percentage of hemoglobin that is in the patient's blood. Technically, hemoglobin transports oxygen and hemoglobin particles are glycated and covered with a sugar. An A1C level of 6.5 or higher indicates diabetes. An A1C level of between 5.7 and 6.4 indicates the presence of prediabetes when an A1C test is done for the screening and diagnosis of diabetes. After initial diagnosis, A1C is tested to determine how well the diabetes is being controlled and how effective the diabetes treatment plan has been. Poor diabetes management and the increasing risk of diabetes complications are signaled when the A1C level is elevated. The higher the A1C level is, the greater the risk for complications for the patient and the poorer the patient's control over the illness. Unlike blood glucose levels, the A1C levels are an indication of long-term management and control over 2 to 3 months rather than a short-term indicator of glucose control. The activated partial thromboplastin time, or the APTT test, measures the effectiveness of clotting factors. Prolonged activated partial thromboplastin times are an indication that the clotting factors are abnormal and that the patient is at risk for bleeding. These patients may be affected with a bleeding disorder such as factor VIII. A shorter than normal activated partial thromboplastin time can indicate that the patient is at risk for thrombosis. Lipid levels are also important diagnostic and screening tools. Lipid levels are the indicator of the patient's levels of fats in the blood. Lipid levels include both cholesterol and triglyceride levels. Lipid profiles can be affected by age, gender, cigarette smoking, consumption patterns, genetics, pre-existing medical conditions, and lifestyle choices, including diet and physical activity levels. As you should now know, some of these risk factors can be eliminated and others cannot. Patients should be encouraged to correct and eliminate all risk factors when the lipid levels are not normal. For example, dietary changes may be indicated for the patient. According to the American Diabetes Association, diabetic adults should have an LDL cholesterol level of less than 100 milligrams per deciliter, an HDL cholesterol level of more than 40 milligrams per deciliter, and a triglycerides that is less than 150 milligrams per deciliter. Arterial blood gases provide data and information about the patient's level of oxygenation as a function of the gas exchange in the patient's lungs, carbon dioxide elimination, and acid-base balance in the patient's extracellular fluid. The norms for the arterial blood gas levels are: the normal pH is from 7.35 to 7.45. The normal PaO2 is from 80 to 100. The normal PaCO2 is from 35 to 45. The bicarbonate level, which is HCO3, should be from 22 to 26 milliequivalents per liter, and the SO2 should be from 95 to 100%. Levels of hypoxemia are considered mild when the SO2 is from 60 to 79. The hypoxemia is considered moderate when the SO2 is from 40 to 59. The hypoxemia is considered severe when the SO2 is less than 40. Some of the commonly used blood laboratory tests that are used for the diagnosis and management of infections include the C-reactive protein, the erythrocyte sedimentation rate, and the plasma viscosity. These tests measure and are sensitive to the protein increases that occur during the inflammation process. C-reactive protein, erythrocyte sedimentation rate, and the plasma viscosity rise with bacterial infections as well as with the presence of other disorders such as burns and of myocardial infarction. Low erythrocyte sedimentation rates can indicate the presence of sickle cell anemia, heart failure, and polycythemia. C-reactive protein levels increase by up to 1,000 times normal during the inflammation phase of an infection, as well as when a patient is affected with a severe burn, with some types of cancer, and even possibly with heart disease. The normal C-reactive protein is less than 1 milligram per deciliter or less than 10 milligrams per liter. Erythrocyte sedimentation rates reflect the rate with which red blood cells separate from the blood's plasma and fall to the bottom of the laboratory test tube. Elevated erythrocyte sedimentation rates are suggestive of the presence of an infection. The normal erythrocyte sedimentation rate among females is from 0 to 20 millimeters per hour. The normal erythrocyte sedimentation rate among members of the male gender is from 0 to 15 millimeters per hour. The elderly may have a higher than normal sedimentation rate as a result of the normal aging process. Blood viscosity measurements reflect the thickness of the blood. Blood viscosity can be altered with such things as a hematocrit, the patient's temperature, and the degree of red blood cell aggregation. For example, the blood viscosity decreases when the patient is febrile and affected with hyperthermia. The blood viscosity increases when the patient's temperature is low and the patient is affected with hyperthermia. The analysis of sputum analysis includes the examination of sputum in terms of the color, consistency, odor, amount, and the presence of any pathogens. Sputum analysis is often done for patients affected with a respiratory disorder or infection. For example, A thick sputum specimen can indicate the stasis of respiratory system secretions. Green sputum can indicate the presence of a respiratory system infection. The lack of foul-smelling sputum may indicate that the patient does not have a respiratory system infection. Laboratory tests of renal function include the laboratory testing of the patient's urea and creatinine levels. Urea and creatinine levels increase with renal disease because the kidneys are no longer able to clear and eliminate these waste products from the blood. Diagnostic imaging tests like ultrasound testing, laboratory urine tests, and renal biopsies are also used to diagnose renal impairments as well as to monitor patients with known renal disease. Liver function tests, like renal function tests, are used to diagnose hepatic impairments as well as to monitor patients with known liver disease. These tests determine and measure different proteins and enzymes in the patient's blood. Poor liver functioning can be diagnosed and determined when tests of liver function are too high or too low. Some examples of commonly used tests for hepatic functioning are laboratory tests for bilirubin, L-lacetate dehydrogenase, and serum glutamic oxaloacetic transaminase, which is also referred to as SGOT. Elevated bilirubin levels occur with hepatic disease. Bilirubin consists of the waste products that formed when the red blood cells break down. Albumin levels that are lower than normal can also indicate hepatic disease. Low albumin levels also place the patient at risk for infections. L-lacetate dehydrogenase levels, higher than the normal limit, indicate liver disease. L-lacetate dehydrogenase is an hepatic enzyme. Lastly, serum glutamic oxaloacetic transaminase, another enzyme, also rises in the presence of liver disease and hepatic failure. Comparing the client's laboratory values to normal laboratory values. Like vital signs and other physiological measurements, the patient's current laboratory values are compared to normal laboratory values as well as their prior laboratory values to determine the presence or absence of a physiological disorder, as well as to monitor the patient's improvement or decline in their physiological functioning. Performing venipuncture for blood draws. Drawing a peripheral vein blood sample is done using this procedure. Use sterile supplies and sterile technique to obtain the specimen. Use the correct laboratory tubes for the specimens that you will be collecting. Choose a suitable site for the venipuncture. Place the tourniquet on the client's arm 3 to 4 inches above the selected site. Palpate the vein. Clean the site with an alcohol prep pad with a circular pattern from the site of the venipuncture to the area surrounding the site of the venipuncture. Permit the area to dry. Ask the patient to make a fist. Do not ask them to pump the limb. Pull the skin taut so that the desired and suitable vein is accessible. Insert the sterile needle into the vein at a 15 to 30 degree angle. Pop the tube onto the tubing. Take the tourniquet off when the last tube is filled. Take the needle out. Place sterile gauze on the site using sufficient pressure to prevent bleeding for about 1 or 2 minutes. Remove the gauze. Place an adhesive bandage over the site and label the specimen with the data that is required according to your facility's policy and procedure for laboratory blood samples. Performing blood glucose monitoring. The procedure for monitoring blood glucose using a blood glucose monitor is as follows. Don clean gloves. Disinfect the patient's finger with an alcohol swab. Verify and confirm that the code strip corresponds to the meter code. Prick the side of the finger using the lancet. Turn the finger down so the blood will drop with gravity. Wipe off the first drop of blood using sterile gauze. Collect the next drop on the test strip. Hold gauze to the client's finger after the specimen has been obtained. read the client's blood glucose level on the monitor, and document the test results and notify the registered nurse if the results are abnormal. Collecting specimens for diagnostic testing. The procedure for collecting routine stool specimens is as follows. Ask the patient to void before the stool specimen is collected, because it can contaminate the stool specimen. Ask the patient to eliminate their stool in a clean bedpan, bedside commode, or on the toilet using a hi-hat. Collect the specimen. Tighten the lid on stool specimen container. Label the specimen with the data that is required according to your facility's policy and procedure, and transport the specimen to the laboratory as quickly as possible. The procedure for the collection of stools for occult blood was previously discussed above under Performing Diagnostic Testing. The procedure for collecting a routine urine specimen is to ask the patient to void into a clean bedpan, a bedside commode, or on the toilet using a hi-hat. Tighten the lid on the receptacle after the specimen is obtained. Label the specimen with the data that is required according to your facility's policy and procedure, and transport the specimen to the laboratory as quickly as possible. Collecting a clean catch or midstream urine specimen varies among the genders. Males should cleanse the penis from the urinary meatus to the peripheral area using a circular pattern and using only one disposable antiseptic wipe for each swipe. Females should use one antiseptic wipe for each swipe from the front to the back, from the inner labia to the outer labia. Then, ask the patient to void a small amount of urine into the toilet without collecting it. Then, ask the patient to void into the laboratory collection bottle. Tighten the lid on the receptacle and use a disinfectant to clean the outside of the container. Label the specimen with the data that is required according to your facility's policy and procedure, and transport the specimen to the laboratory as quickly as possible. Timed urine specimens are collected during a specific period of time, as indicated in the doctor's order. For example, urine is collected for a full day when a 24-hour urine specimen is ordered. Nurses will then collect all urine passed during this period of time, or they will ask the patient to collect all voided urine so that the nurse can place it into the urine collection bottle. When the duration of collection has been reached, all the collected urine is then labeled and delivered to the diagnostic laboratory for testing. Sputum specimens are collected by providing the patient with a specimen collection container and asking the client to deep breathe, cough, and expel sputum into the container. They should also be instructed not to allow saliva into the container. Once the specimen is collected, it is then labeled and delivered to the diagnostic laboratory for testing. Maintaining a central venous catheter. Strict sterile technique is used for maintaining and caring for a central venous catheter. Central venous catheter dressings are changed at least every 48 hours unless it is an occlusive transparent dressing. These occlusive transparent dressings can be changed every 7 days unless they are wet, soiled, or loosened. Some central venous catheters have a couple or several lumens. Each lumen must be flushed with a heparin solution on a daily basis in order to maintain patency. The injection cap on each lumen should be changed every 7 days or at any time that the cap is leaking. Reinforcing client teaching on the purposes of laboratory tests. Nurses also reinforce patient teaching relating to the purposes of laboratory testing. They also receive the information that is necessary for the patient to prepare for some laboratory tests, like maintaining NPO status after midnight and the implications of abnormal and normal results of all laboratory tests and testing. Monitoring diagnostic and laboratory test results. Monitoring laboratory test results requires the ability of the nurse to recognize and identify all findings that are outside of normal limits. They must also know when these laboratory values are considered critical values that must be reported to the patient's doctor immediately. Repeated client diagnostic findings are compared to previous test results to determine whether or not a change has occurred. For example, changes in the patient's hemoglobin and hematocrit can possibly indicate that the patient is affected with bleeding and hemorrhage. Notifying the primary healthcare provider about client laboratory test results. Throughout the course of care, nurses monitor the results of diagnostic tests. They notify the physician when laboratory results are outside of normal limits and/or a significant change has occurred, as just mentioned. Potential for alterations in body systems. Identifying the signs and symptoms of potential prenatal complications. The potential prenatal complications are numerous and varied. Some women are more at risk for some complications than other pregnant women without these risk factors. Pre-existing heart disease and diabetes are two of the physiological disorders that place the woman at risk during pregnancy and the prenatal period of time. Some of the most commonly occurring prenatal complications and their signs and symptoms will be discussed now. Pre-existing heart disease. Pre-existing heart disease is a major cause of maternal mortality during pregnancy. Pregnancy leads to increased cardiovascular demands, and because many women with pre-existing cardiac already have cardiovascular compromise, the demand of pregnancy may be very serious. The signs and symptoms vary according to specific maternal cardiac disorder and its severity. Fatigue and angina-type chest pain are often present. Palpitations, rales, and coughing can occur when heart failure develops. Gestational hypertension. Gestational hypertension presents when the pregnant woman has a blood pressure of more than 140/90 and 2+ ketones in the urine. Other than a high blood pressure, the other signs and symptoms of gestational hypertension are a headache, a rapid weight gain, edema, and visual alterations such as photosensitivity. Gestational hypertension can lead to preeclampsia, eclampsia, as well as a premature baby with a low birth rate. Like pre-existing and gestational hypertension, pregnant women can also be affected with pre-existing and gestational diabetes. The signs and symptoms are the same for both kinds of diabetes during pregnancy, except the fact that gestational diabetes should be self-limiting after the birth of the baby. Cardiopulmonary maternal collapse. Cardiopulmonary maternal collapse is a life-threatening medical emergency that can lead to both fetal and maternal death. Some of the signs and symptoms of cardiopulmonary maternal collapse include increased tidal volume, elevated maternal oxygen consumption, tachycardia, rises in blood pressure, a decrease in terms of the mother's cardiac output, and the sequestration of maternal blood to the uterus. Immediate treatment with CPR and advanced cardiac life support are often necessary to save the mother and the developing fetus. At times, an emergency cesarean section, either while the mother is alive or a post-mortem cesarean section, is indicated. Iron deficiency anemia. Iron deficiency anemia can present primarily during the second trimester when the mother's need for iron is greatest. The signs and symptoms of iron deficiency anemia can include maternal fatigue, low hemoglobin levels, and low iron levels. The physiological need for iron during pregnancy can be met with 60 to 120 milligrams of iron per day, either with the diet or with supplemental iron. This iron can prevent iron deficiency anemia during pregnancy. Spontaneous abortion. Spontaneous abortion is defined as all losses of the fetus with the exception of an elective abortion to end an unwanted pregnancy. Spontaneous abortions can be classified as an inevitable abortion, which is accompanied with bleeding, abdominal cramping, cervical dilation, and perhaps the rupture of the membranes. A spontaneous abortion can also be threatened. Threatened spontaneous abortions can be signaled with bleeding and abdominal and back pain that is not accompanied with any cervical dilation or the rupture of the membranes. An incomplete abortion also has the signs and symptoms of abdominal and back cramping as well as bleeding, but only part of the membranes is lost. A complete spontaneous abortion presents with severe bleeding, severe cramping, and the complete loss of the membranes well before the expected date of delivery. Ectopic pregnancy. Ectopic pregnancy is another complication of pregnancy. Ectopic pregnancy occurs when the fertilized egg is implanted anywhere other than the uterus. Most ectopic pregnancies occur when the fertilized egg is implanted in the fallopian tube. Unilateral pain, nausea, vomiting, and a brown vaginal discharge and faintness are some of the signs and symptoms that can occur with an ectopic pregnancy. Preeclampsia. Eclampsia and preeclampsia are a leading cause of maternal death and a leading cause of poor fetal outcomes. Although preeclampsia usually precedes eclampsia, this is not always the case. At times, eclampsia can develop without the prior presence of preeclampsia. The signs and symptoms of preeclampsia are hypertension, proteinuria, oliguria, elevated creatinine, pulmonary edema, peripheral edema, and neurological symptoms such as visual changes, a headache, and hyperreflexia. The signs of severe preeclampsia can be easily remembered with the HELLP acronym. H for hemolysis, EL for elevated liver enzymes, LP for low platelet count. Eclampsia. The major sign that separates and differentiates eclampsia from preeclampsia is seizures. Seizures are present with eclampsia, but not present with preeclampsia. Eclampsia can cause permanent damage to the vital organs, which include the liver, kidneys, and brain. If eclampsia is not treated, it can lead to coma, brain damage, and death for both the mother and the child. Disseminated intravascular coagulation. Disseminated intravascular coagulation, also referred to as DIC, is an acquiring clotting factor abnormality that can occur during pregnancy, particularly when the pregnant woman is affected with another disorder, such as amniotic fluid embolism, eclampsia, an incomplete abortion, a retained dead fetus, or the retention of the placenta. The signs and symptoms of disseminated intravascular coagulation include the signs and symptoms of blood clotting and the signs and symptoms of bleeding. Other signs and symptoms include possible decreases in the level of consciousness, cyanosis, hypotension, hypothermia, tachycardia, and behavioral and mood changes. Without treatment, disseminated intravascular coagulation can lead to death. Subchorionic hematoma. A subchorionic hematoma occurs when there is a blood clot between the membranes of pregnancy and the wall of the uterus that separates and leads to maternal bleeding. Although a rare complication of pregnancy, the signs and symptoms of a subchorionic hematoma include vaginal bleeding and abdominal cramps. At times, the pregnant woman may be asymptomatic. Hydatid-form moles. A hydatid-form mole occurs as the result of a paternal chromosomal aberration. A hydatid-form mole can be a complete or a partial molar pregnancy. There is no fetus with a complete hydatidiform mole. The classic sign of a hydatidiform mole is the formation of grape-like clusters that can even be seen in the vagina. Other signs and symptoms include pelvic pressure, maternal hypertension, vaginal bleeding during the first trimester, an abnormally rapid growth of the uterus, anemia, and maternal nausea and vomiting. Hyperemesis gravidarum. Hyperemesis gravidarum, affectionately known as morning sickness, is a persistent and excessive amount of maternal nausea and vomiting. Hyperemesis gravidarum often occurs during the first trimester of pregnancy, but some pregnant women may be affected with hyperemesis gravidarum throughout the course of the entire pregnancy. It is medically defined as the nausea for the majority of the day and vomiting 3 or more times per day. Other signs and symptoms include hypotension, tachycardia, dizziness, dehydration, and maternal weight loss. An incompetent cervix. Simply defined, an incompetent cervix, or cervical insufficiency, is a cervix that effaces and dilates too early during the pregnancy. An incompetent cervix is diagnosed typically as early as the 4th month of gestation. This premature effacement and dilation can lead to the rupture of the membranes and a miscarriage unless it is successfully treated. The signs and symptoms of an incompetent cervix include back, pelvic, and abdominal cramping, vaginal spotting or bleeding, and other changes in the vaginal discharge. Multiple gestations. Although a multiple gestation is a blessing to most, multiple pregnancies pose special risks of complications during the pregnancy for the mother and the developing fetus. The signs and symptoms associated with the multiple gestations include a larger than expected maternal weight gain, a more rapid than expected abdominal growth, earlier than expected fetal movements, a greater degree and extent of hyperemesis gravidarum, and a greater level of maternal fatigue than normally encountered by pregnant women without multiple gestations. The complications of multiple gestations that affect the developing fetuses include the loss of the entire pregnancy, the fetus's restriction of growth, congenital abnormalities, a maternal incompetent cervix, the spontaneous vanishing twin phenomena that signals the resorption of one of the fetuses, spontaneous abortion, premature birth, a low birth weight, and the rarely occurring cojoined multiples. The maternal complications associated with multiple gestations include hypertension, gestational diabetes, the HELLP syndrome, which consists of hemolysis, elevated liver enzymes, low platelet count, eclampsia, preeclampsia, embolism, anemia, hydramnios, hypoglycemia, and the premature rupture of the membranes. Pulmonary emboli. Pulmonary embolism is the leading cause of death among pregnant women. Some of the signs and symptoms of pulmonary emboli include chest pain, tachypnea, hypotension, shortness of breath, tachycardia, chest pains, cyanosis, and hemoptysis. Pulmonary emboli can lead to pleural effusion, pulmonary infarcts, respiratory failure, and death. Placenta previa. Placenta previa occurs when the placenta normally covers part of the cervix or all of the cervix. Placenta previa can be asymptomatic, or it can be present with signs and symptoms such as vaginal bleeding without pain. Placenta abruption. Placental abruption occurs when the placenta separates from the wall of the uterus before the date of delivery. The signs and symptoms of placenta abruption can include abdominal cramping and pain as well as vaginal bleeding. Identifying the client with an increased risk for insufficient blood circulation. Some of the risk factors associated with impaired circulation include disorders and diseases such as diabetes, peripheral vascular disease, and the immobilization of a limb with a cast or a restraint, for example. Unmanaged and poorly controlled diabetes can lead to complications that are related to microvascular or microcirculation and macrovascular or macrocirculation damage to all the circulatory vessels of the body, both large and small. Peripheral vascular disease, like diabetes, also adversely affects blood circulation, particularly to the lower extremities. Immobilization with medical devices and other interventions such as restraints, splints, braces, surgical dressings, and casts for fractures can impair circulation with mechanical means. Nurses monitor clients at risk and perform circulatory checks to identify any abnormalities which could possibly lead to the loss of a limb. Circulatory checks will be further discussed below. Recognizing a change in the client neurological status. Some of the commonly occurring changes in the client include changes in the client's level of consciousness, level of orientation, and muscular strength. Levels of consciousness can change as the result of both metabolic and structural causes. For example, a patient's level of consciousness may decrease as a result of a cerebral tumor, which is a structural cause for a changing level of consciousness. Similarly, a patient with hypoglycemia or seizure activity will have a decreased level of consciousness as the result of a metabolic cause. The 6 levels of consciousness in descending order from the highest level of consciousness to the lowest level of consciousness are 1. Alert. 2. Confused. 3. Lethargic. 4. Obtunded. 5. Stuporous. And 6. Comatose. Alert patients follow commands and answer questions appropriately. Confusion is evident when the patient is in need of cues in order to respond to commands and questions. When the patient is not oriented to their environment, and/or when the patient lacks good judgment and good thinking processes. Lethargic clients are sleepy, but they can be awakened with verbal or tactile stimuli. Obtunded patients respond, but very slowly and only with repeated stimulation. Stuporous clients respond to vigorous stimulation with merely basic responses like a grunt or a groan. Finally, the lowest level of consciousness, which is coma, is characterized with complete unresponsiveness to all stimuli. Levels of consciousness can also be categorized as a persistent vegetative state, locked-in syndrome, and brain death. Brain death occurs when the coma is irreversible. The patient is completely unresponsive to all stimuli, and the patient has a total loss of all respiratory function as well as all the total loss of all brainstem reflexes and functioning. Patients with locked-in syndrome have some retained cognitive function, but they lack all motor functioning. In this state, the client is able to communicate with eye movements, and they are typically aware of their surroundings. A persistent vegetative state is characterized with no cognitive functioning and the retention of only basic human functions, like eye opening. Levels of consciousness can be determined and measured using the standardized Glasgow Coma Scale for adults and children, or the Rancho Los Amigos Scale. The pediatric and adult Glasgow Coma Scales measure the patient's motor responses, verbal responses, and eye opening. The Rancho Los Amigos scale determines the patient's functioning, which can range from a 1 to an 8, when a 1 is the complete lack of all responsiveness to all stimulation, and an 8 when a patient is fully alert, oriented, appropriate, and purposeful. A patient's level of orientation is an indication of the patient's level of consciousness and awareness. A patient that is oriented to self, the environment, and the date is oriented times 3. Muscular strength is also an indication of the patient's neurological status in terms of their motor skills and functioning. Muscular strength should be equal bilaterally, and the muscles should be able to fully contract and move. Muscular strength is determined and measured using a scale of 0 to 5. 0 strength is defined as the lack of all muscular contraction. A score of 1 indicates the presence of a contraction, but there is no movement. A score of 2 indicates muscular contraction and muscular movement, but the lack of any movement when gravity is introduced. A score of 3 means that the patient has full contraction and movement even with gravity. A score of 4 is contraction and movement that is somewhat limited when resistance is applied to the limb. A score of 5 indicates full movement and full contraction even when high levels of resistance are applied. Comparing current client clinical data to baseline information. As discussed on multiple occasions previously in this review, comparing the patient's current clinical data to baseline data and information allows nurses to recognize any changes in the client's condition, to identify new disorders and risk factors, and to determine the effectiveness of the plan of care. Performing neurological checks. Neurological checks consist of checking and determining the patient's level of consciousness, muscular strength and equality, responses to sensory stimulation like sounds and touch, level of orientation and awareness, pupil reactivity to light and accommodation, pupil size and shape, balance, gait, and reflex response. Performing circulatory checks. Circulatory checks include data and information that is collected for the medical history, data and information that is collected during the physical examinations, and data and information that is observed, determined, and documented during the course of nursing care. Some common signs and symptoms of impaired circulatory function include diminished pulses, absent pulses, scant or absent hair on the lower extremities, cool and or cyanotic extremities, thick toenails, capillary refill time that is more than 3 seconds, femoral or aortic artery bruits, skin that is scaly and dry, and muscular atrophy. Checking for urinary retention. Urinary retention occurs when urine accumulates in the bladder because the patient is not able to empty their bladder, and at least 200 and 250 milliliters are retained in the bladder because the patient is not able to void. Some of these signs and symptoms of urinary retention include a distended abdomen, pain, bloating, a persistent feeling that the person has to void to no avail, urinary leakage between voiding, and a scant urine flow. Checking for urinary retention can be done with an ultrasound and manual palpation of the bladder to determine whether or not bladder fullness is present. Administering, applying, and checking the proper use of compression stockings sequential compression devices. Compression stockings, or anti-embolism stockings, and sequential compression devices are used to promote venous return and prevent emboli, both of which can occur as the result of patient immobilization and other causes. Compression stockings and sequential compression devices are ordered by the doctor in terms of millimeters of mercury that they will apply. These stockings are applied to the patient's legs while they are still in bed and before rising from bed. Monitoring client output for changes from the baseline. Patient output consists of measurable visible outputs and also undetectable and immeasurable losses. Nurses measure and monitor visible and immeasurable losses like emesis and urine, but they cannot measure immeasurable outputs like diaphoresis. In addition to measuring urinary output and the volume of emesis, nurses also monitor and measure nasogastric tube drainage, wound drainage, and stools, including the volume of diarrhea. Output is monitored by the nurse in terms of volume, color, and other characteristics such as the amount of blood and the consistency. Again, current findings are compared to baseline findings and characteristics to determine if there are any changes for the better or for the worse in terms of the patient's condition. Reinforcing client teaching on methods to prevent complications associated with activity level and diagnosed illness and disease. All diseases and disorders have possible complications. Some of these complications can be rare and others can be more common. Patients are also prone to complications simply because they are ill and immobilized. These hazards or complications of mobility, such as skin breakdown, pressure ulcers, contractures, muscular weakness, muscular atrophy, disuse osteoporosis, renal calculi, urinary stasis, urinary retention, urinary incontinence, urinary tract infections, atelectasis, pneumonia, decreased respiratory vital capacity, venous stasis, venous insufficiency, orthostatic hypotension, decreased cardiac reserve, edema, emboli, thrombophlebitis, constipation, and the loss of calcium were previously discussed with the topic mobility and immobility. Patients with impaired mobility are reminded, coached, and instructed by the nurse to exercise in the bed, in the chair, and out of the bed. Nurses also coach patients to cough and deep breathe to mobilize respiratory secretions and to prevent the respiratory complications associated with immobility. They also assist the patient to use the incentive spirometer as ordered and to resume out-of-bed activities and transfers as soon as possible. Despite the fact that virtually all acute and chronic illnesses can lead to complications, the complications of diabetes are perhaps the most frequently occurring because the incidence and prevalence of diabetes is great, and this chronic disorder can last a lifetime. The complications of diabetes can be acute or long-term. The acute complications of diabetes include diabetic ketoacidosis, also referred to as DKA, hypoglycemia, hyperglycemia, and hyperglycemic hyperosmolar non-kinetic syndrome. Some of the long-term complications of diabetes include chronic and acute infections, renal disease, renal failure, retinopathy, osteoporosis, cardiovascular disease, peripheral and autonomic nervous system neuropathy, cerebrovascular accidents, and foot disorders including impaired perfusion, infections, and necrosis. Diabetic patients must be fully knowledgeable about the signs, the symptoms, the prevention, and the treatments of all of these long-term and acute complications of diabetes. Medication compliance, exercise, and the management of the diabetes are the pillars of prevention in terms of these complications. The potential for complications of diagnostic tests, treatments, and procedures. As the old saying goes, sometimes the treatment is worse than the disease is often true. All diagnostic tests, treatments, and procedures can lead to complications. Some of these complications are more common than others. Some of these complications are more severe and life-threatening than others. Some of these complications increase in frequency because of some innate risk factor that the patient has. For example, all invasive procedures are associated with the possible occurrence of infection after the test or treatment. Some allergic responses to a medication or medical supply components, such as latex, can be minimal and harmless, and other allergic responses, such as anaphylaxis, can be severe and life-threatening. Lastly, some complications can occur as the result of the patients having a risk factor such as diabetes, hypertension, or respiratory disease. Diabetes is one of the most commonly occurring risk factors that place patients at risk for complications secondary to diagnostic tests, treatments, and procedures. For example, patients who are diabetic have more risk for infection than other patients who are not affected with this chronic disease. Throughout the course of treatment, nurses apply their knowledge, skills, and abilities to the care of the patient who may potentially have or actually does have a complication to a diagnostic test, treatment, or procedure. Identifying the client's responses to diagnostic tests, treatments, procedures. Nurses monitor clients and clients' responses to all diagnostic tests, treatments, and procedures. But the closest and most frequent nurse monitoring occurs when the client has multiple risk factors, when the test or procedure is invasive, and when the test, treatment, or procedure can potentially adversely affect the most vital organs of the body, such as the heart and the lungs. Invasive tests and procedures like bronchoscopy, other endoscopic examinations, cardiac catheterizations, and major surgical procedures, for example, pose the greatest risk of complications. They can lead to infection, bleeding and hemorrhage, emboli, and an accidental laceration or puncture of the internal organs. Non-invasive diagnostic tests can also lead to complications, some of which can be mild and not threatening, and others can be severe and life-threatening. For example, contrast media used for diagnostic imaging tests can lead to allergic and life-threatening complications such as anaphylaxis. Non-invasive radiation therapy for the treatment of cancer can cause skin itchiness and scaling. Other complications and side effects of radiation therapy for cancer, local and systemic, can be almost immediate after treatment, and others are delayed and cumulative. Most of the complications and side effects of radiation are local. Some of the local complications of therapeutic radiation therapy include blanching of the skin, cracking of the skin erythema, sloughing, disquamination, and alopecia. Some of the systemic complications of radiation therapy are fatigue, nausea, vomiting, diarrhea, and radiation pneumonia. Chemotherapy is also associated with a number of complications and serious side effects. These complications vary according to the particular chemotherapeutic agent that is being administered. For example, anti-tumor antibiotics are associated with bone marrow suppression, cardiac toxicity, and pulmonary fibrosis. One of the side effects of anti-tumor antibiotics, particularly in high dosage, is anorexia. Similarly, the complications associated with alkylating chemotherapeutic medications include bone marrow suppression, acute leukemia, cystitis, leukopenia, anemia, the syndrome of inappropriate antidiuretic hormone, and thrombocytopenia. Lastly, the complications of antimetabolite chemotherapeutic drugs are leukopenia, bone marrow suppression, thrombocytopenia, and pulmonary toxicity, among others. Maintaining the client's tube patency. Nurses monitor and maintain the patency of a wide variety of tubes and catheters, including nasogastric tubes, tracheostomy tubes, and chest tubes. The patency of nasogastric tubes are maintained by irrigating the nasogastric tube with about 15 to 30 milliliters of warm water every 4 to 6 hours when continuous nasogastric tube feedings are being given, and before and after each intermittent nasogastric tube feeding. It is also irrigated after the administration of a nasogastric tube medication is administered. Tracheostomy tube patency can be ensured by providing continuous humidified oxygen, by ensuring that the tracheostomy tube is maintained without the accumulation of respiratory secretions by suctioning the patient as needed, by securely anchoring the tube at the patient's neck and by keeping the tracheostomy tube cuff uninflated during mechanical ventilation. Pleural drainage devices and chest tubes are also maintained to ensure patency. Pleural drainage devices, such as the Pleur-Evac pleural drainage system, have either 3 or 4 chambers. These pleural drainage systems have 1 chamber to suction, 1 chamber for suction control, 1 chamber for the water seal, and 1 chamber for drainage. The vacuum level of suction is typically set at from -15 to minus or -20 centimeter of water. The suction control chamber is typically filled with 15 to 20 centimeters of water, which bubbles under normal patency. The water seal chamber typically has about 2 centimeters of water. Pleural drainage systems are properly functioning when bubbling air from the area of the pneumothorax is seen in the water seal. Providing care for the client receiving electroconvulsive therapy, ECT. Electroconvulsive therapy, also referred to as ECT, is used for severely depressed psychiatric mental health patients. Electroconvulsive therapy delivers an electrical shock to the brain that is conducted to the brain with electrodes that are externally placed on the patient's head. The nurse's role prior to the electroconvulsive therapy treatments includes ensuring that the patient has been in PO for at least 6 hours prior to the treatment, ensuring that the required pre-procedure checklist and informed consent are completed and in the patient's medical record, and making sure that the patient has no extraneous items on or in the body like dentures and jewelry. The nurse will also administer any ordered pre-electroconvulsive therapy medications. Throughout the procedure, the nurse will closely monitor the patient's physical status as well as the intended seizure activity and also ensure the patient's safety throughout the procedure. After the procedure, the nurse will monitor the patient, their vital signs, and their mental status, and reorient the patient because some temporary confusion may occur as a result of this treatment. Patient safety is a major nursing consideration during and after electroconvulsive therapy. Providing appropriate follow-up after an incident. In addition to the complete documentation of incidents on the facility's required incident or accident report, nurses perform other roles as they follow up on an incident or accident. Some of these roles and responsibilities include the monitoring and care of the patient in terms of their physical or emotional needs, and also participating in quality improvement and performance improvement activities, including root cause analysis to prevent further similar incidents and accidents in the organization. Performing risk monitoring and implementing interventions. Risk monitoring prevents complications secondary to care, treatments, and procedures. Knowing your patient's risks and modifying care and treatment according to these risks prevents incidents, accidents, and complications. For example, knowing that your patient has a visual sensor disorder gives you the opportunity to prevent falls and other medical errors because the knowledge of the sensory deficit alerts you to the need for the provision of the patient's eyeglasses to the patient during care. Similarly, knowing that a client has a risk such as a low level of albumin alerts you to the fact that this patient needs preventative measures, such as turning and positioning every 2 hours, to prevent skin breakdown and pressure ulcers, particularly when the patient is immobilized with complete bed rest. Monitoring continuous and intermittent suctioning of a nasogastric NG tube. In addition to using nasogastric tubes for nutrition, nasogastric tubes connected to suctioning are used for gastric decompression and gastric emptying. When nasogastric tubes are connected to suctioning, the nurse monitors the volume, color, and other characteristics of the drainage. They also ensure that the suction is working properly and that it is running at the ordered negative pressure. Implementing measures to prevent complication of the client condition or procedure. Nurses also perform interventions to prevent complications relating to both the patient's condition and any treatments or procedures that they receive. For example, Postoperative patients are encouraged to perform leg exercises and to use anti-embolus stockings to prevent venous stasis and other circulatory complications. Patients who have a seizure disorder are cared for using seizure precautions, and their safety is ensured at all times. Patients who are receiving tube feedings and those with dysphagia are at risk for aspiration. Therefore, the nurse maintains the patient's position at a 30-degree angle or more to prevent aspiration. Pediatric patients with a cast for a skeletal fracture are monitored closely for the circulatory status of the limb to ensure that the patient is not affected with compartment syndrome, which could possibly lead to the loss of a limb. Reinforcing teaching to prevent complications due to client diagnostic tests, treatments, procedures. Nurses reinforce patient teaching to prevent complications relating to diagnostic tests, treatments, and procedures. For example, the nurse can remind the patient to maintain NPO after midnight prior to a surgical procedure. The nurse can reinforce teaching about leg exercises as well as coughing and deep breathing during the postoperative period of time to prevent venous and respiratory complications, respectively, after surgery. They can also encourage early ambulation after total hip replacement to prevent complications such as venous stasis, emboli, and the loss of calcium secondary to the lack of weight-bearing activity. Notifying the primary healthcare provider if the client has signs of potential complications. Nurses are accountable and responsible for notifying the primary healthcare provider and the supervising nurse whenever a patient has or possibly has a complication. For example, the nurse will report the presence of a fever after surgery. They will monitor and report surgical wound drainage and hypotension that could be an indication that the client is experiencing bleeding and hemorrhage after surgery. They should also report any signs or symptoms which could indicate the presence of emboli. Evaluating the client's oxygen O2 saturation. Pulse oximetry is a non-invasive procedure to measure the patient's level oxygen saturation in the arterial blood. This non-invasive procedure is simply done by placing a sensor on the person's finger that then measures and shows the nurse the patient's oxygen saturation level. Although these oxygen saturation levels are not as rich in data as arterial blood gases, they have some distinct benefits. They are not invasive, they are inexpensive to use, and they are readily accessible for use at the bedside. The normal range of oxygen saturation is from 95% to 100%. The levels can be slightly lower but normal among the elderly, among those with a low hemoglobin level, and among those patients who are experiencing hypothermia and/or have a dark skin tone. Oxygen saturation levels less than 85% should be immediately reported and recorded. Suggesting changes in interventions based on the client's responses to diagnostic tests, treatments, procedures. All diagnostic tests, treatments, and procedures are done with a goal in mind. These things are done to accurately diagnose patients and to effectively treat them. As this information becomes available to nurses and other members of the healthcare team, make changes to the plan of care according to these changes, data, and other information. For example, nurses may recommend supplemental oxygen therapy when the oxygen saturation is low. They may recommend increased exercise for a sedentary patient with diabetes who is not able to control their diabetes and their blood glucose levels. They may recommend a decrease in the dosage of a medication for an elderly client whose level of medication is higher than it should be. The potential for complications from surgical procedures and health alterations. Identifying the client's response to surgery or health alterations. In this section, we will be discussing the perioperative period of time and the patient responses to surgical procedures and other health alterations. Providing care for client before the surgical procedure, including reinforcing teaching. The preoperative period of time is an intensive one. Ideally, some of the preoperative preparation, such as laboratory testing, the signing of consents, and patient and family teaching, is done in the doctor's office prior to admission. When this does not occur, as is in the case for unplanned and/or emergency surgeries, this preparation is done in the hospital in an often rapid and expeditious manner. Preoperative checklists are highly useful to ensure that all components of the preoperative preparation are done and complete. The patient's complete medical history, physical examination, the signed and completed consent form, and the necessary laboratory and other diagnostic test results should be done and in the patient's medical record. Additionally, the nurse also participates in the identification and marking of the surgical site to avoid wrong site surgeries. In addition to this data and information, patient and family education should be done and documented during the preoperative period of time because the patient may be lethargic, in pain, and preoccupied with other things after the surgery, all of which can interfere with the teaching and learning processes. The content of this preoperative teaching and the reinforcement of this preoperative teaching should include postoperative exercises like leg exercises, the proper techniques for coughing, deep breathing, and splinting the surgical area, the correct use of and importance of using an incentive spirometer, the correct use of and importance of using compression stockings or an intermittent sequential device, the use of non-pharmacological stress and pain management techniques, and details about the care that the patient will receive, such as wound care and pain management after their surgical procedure. Providing intraoperative care. Depending on the nurse's specific assignment during the intraoperative phase of the surgical process, the nurse may be expected to be able to set up and maintain the sterile field, position the patient according to the type of surgery that is being done, and also monitor and observe the patient during the surgical procedure. The procedure for setting up and maintaining the sterile field was previously detailed with the topic entitled Setting Up a Sterile Field. In addition to placing the patient in the correct position for surgery, nurses must ensure that the position minimizes joint pain, prevents neurological damage, protects the skin from shearing and friction, and also ensures that the patient is safe and supported to prevent injury. Nurses also participate in the mandatory timeout before surgery that aims to prevent surgical medical errors such as wrong patient surgery and wrong site surgery. The monitoring and observation of the patient during the operative procedure can include monitoring the patient's vital signs, measuring the patient's oxygen saturation level, in addition to specimen collection, and managing the instruments that are being used for the surgical procedure. Reinforcing teaching to prevent complications due to surgery or health alterations. In addition to the physical care of the postoperative patient, nurses also reinforce teaching that aims to prevent complications due to the surgery and/or health alterations. Again, the content of this teaching and the reinforcement of this teaching should include postoperative exercises like leg exercises, the proper techniques for coughing, deep breathing, and splinting the surgical area, the correct use of and importance of using an incentive spirometer, the correct use of and importance of using compression stockings or an intermittent sequential device, the use of non-pharmacological stress and pain management techniques, and the care that the patient will receive, such as wound care and pain management. Suggesting changes and interventions based on client response to surgery or health alterations. As with other client treatments and procedures, nurses may make recommendations and suggestions for a change in the patient's plan of care based on the patient's responses to surgery and/or any other alterations of health. For example, the nurse may recommend an increased dosage of analgesic based on an inadequate response to the currently administered analgesic. The nurses may also recommend the services of a respiratory therapist when the patient's respiratory status is compromised. Suggested changes in interventions should be done when the patient's responses indicate the possibility of a complication or an actual complication associated with the surgery, such as airway obstruction, respiratory compromise, wound evisceration, wound infection, thrombocytopenia, wound adhesions, hypoxia, and a paralytic ileus. Therapeutic procedures. Inserting, maintaining, and removing urinary catheters. The procedures for inserting, maintaining, and removing urinary catheters were fully detailed previously in the topic entitled Using Alternative Methods to Promote Voiding. Inserting, maintaining, and removing nasogastric NG tube. These processes and procedures were previously detailed in the topic Inserting, Maintaining, and Removing a Nasogastric NG Tube. Inserting, maintaining, and removing peripheral intravenous IV catheter. The intravenous catheter size depends on the patient's condition and their anticipated needs. For example, an 18-gauge catheter is used for a surgical patient because they may have the need for blood transfusion during or after surgery, and an 18-gauge catheter is needed for the administration of blood. It is also recommended that a large-bore 16-gauge catheter be used for trauma patients. All other patients can typically have a 22 or 24-gauge intravenous catheter. Vein selection should be based on a number of considerations. The best veins to select are the distal veins on the non-dominant hand, so the patient will have full use of the dominant hand. Veins should be selected when they feel somewhat elastic and strong. Veins that should be avoided include those which are near the wrist, those that feel too firm, those veins that are bumpy and irregular, and all veins of the lower extremities unless it is absolutely necessary to use these. Additionally, right or left upper extremity veins are not used on the same side as a mastectomy or the placement of a central venous line. The procedure for inserting a peripheral intravenous catheter is as I will discuss now step by step. Use sterile supplies and sterile technique to start the intravenous line. Choose a suitable vein. Place the tourniquet on the client's arm 3 to 4 inches above the selected site. Palpate the vein. Clean the site with an alcohol prep pad with a circular pattern from the site of the venipuncture to the area surrounding the site for the venipuncture. Permit the area to dry. Ask the patient to make a fist. Do not ask them to pump the limb. Pull the skin taut so the vein is accessible. Insert the catheter needle into the vein at a 15 to 30 degree angle with the bevel up. Look for the flashback of blood into the catheter. Lower the angle of the catheter needle. Gently advance the catheter so it is at the same level as the surrounding skin. Remove the tourniquet and connect the intravenous tubing to the hub of the catheter. Secure the catheter and apply a sterile dressing to the site and adjust the infusion rate according to the doctor's orders. After the intravenous catheter is inserted, it is monitored and maintained by the nurse. The intravenous line is monitored to ensure that it is patent and running at the rate that was ordered by the doctor. The intravenous site is inspected for signs of infiltration and infection. The dressing is changed and dated according to the particular healthcare facility's policy and procedure. The nurse also checks to ensure that the dressing is not impeding circulation. Assisting with the performance of a diagnostic or invasive procedure. Licensed practical vocational nurses are often asked to assist others, such as the physician or the respiratory therapist, with diagnostic and invasive procedures such as intubation, bronchoscopy, thoracentesis, tracheostomy tube placement, chest tube placement, timeouts, and needle biopsies. Nurses also often gather and inspect the equipment that is needed for various procedures in preparation for a diagnostic or invasive procedure. The equipment that is needed for intubation can be easily remembered with the MS-MAID mnemonic. The MS-MAID mnemonic stands for M for monitors, like pulse oximetry, ECG, and blood pressure monitors. S stands for suctioning equipment and supplies like a suctioning machine and suction catheters. M stands for machines like a mechanical ventilator. A stands for airway supplies like artificial airways and a laryngoscope. I stands for intravenous supplies and equipment as well as maintained intravenous access. D stands for drugs for emergency drugs and anesthetics. Diagnostic bronchoscopy is done with a flexible fiber optic bronchoscope to visualize the airway. Bronchoscopy can also be done to obtain a biopsy. The patient is in PO for at least 6 hours before the procedure unless an extreme emergency has occurred that mandates an immediate bronchoscopy after the patient has eaten or has had fluids to drink. Prior to the procedure, the patient is given atropine to decrease respiratory secretions, general anesthesia or conscious sedation, and a sprayed nebulized lidocaine to numb the patient's pharynx and vocal cords. After preparation, the bronchoscope is lubricated and then passed into the patient's airways and into the bronchi of the lungs. Timeouts, as previously mentioned, protect patients from serious surgical errors including wrong site errors, wrong procedure errors, and the wrong person surgery errors. Timeouts, as required by the Joint Commission of the Accreditation of Healthcare Organizations, must be participated in by all members of the surgical team, including the nurses and the surgeon, and they must also be documented when done. Needle biopsies are another sterile procedure that nurses assist with and participate in. The nurse will position the patient to expose the site of the needle biopsy. The nurse will prep the skin with betadine. They will cover the surrounding area with a sterile fenestrated drape, and they will also administer any topical local lidocaine that is ordered by the doctor. After this preparation, the doctor administers a local anesthetic and obtains the specimen using the needle. Reinforcing client teaching on treatments and procedures. Nurses reinforce client teaching about treatments and procedures in an ongoing and repeated manner as often as necessary. Some of the content that should be included in the teaching activity should include the purposes of the treatment or procedure, the procedures that will be followed, the patient's role in terms of self-care, and the prevention of complications and untoward effects. Physiological adaptation. The practical vocational nurse participates in providing care for clients with acute, chronic, or life-threatening physical health conditions. Practical vocational nurses must be able to identify, intervene to control signs of hypoglycemia and hyperglycemia, recognize and report basic abnormalities on a client cardiac monitor strip, provide care for client drainage device, for example, wound drain or chest tube, provide cooling, warming measures to restore normal temperature, provide care for a client with a tracheostomy, provide care to client with an ostomy, for example, colostomy, ileostomy, or urostomy. Provide care to client on ventilator. Perform wound care and/or dressing change. Perform check of client pacemaker. Perform care for client after surgical procedure. Remove wound sutures or staples. Remove client wound drainage device. Intervene to improve client respiratory status, for example, breathing treatment, suctioning, or repositioning. Reinforce education to client regarding care and condition. Identify signs and symptoms related to an acute or chronic illness. Respond, intervene to a client life-threatening situation, for example, cardiopulmonary resuscitation and Recognize and report change in client condition. Alterations in body systems. Identifying the signs and symptoms of infection. Some of the commonly used blood laboratory tests used for infections include the erythrocyte sedimentation rate, C-reactive protein, and plasma viscosity. The signs and symptoms of infection include both local and systemic signs. The local signs of infection, like the signs and symptoms of the inflammatory process, include site pain, redness, heat, swelling, and some bodily part dysfunction to some degree. Some of these symptom signs of infection include fever, mental confusion, malaise, fatigue, chills, an increased respiratory and cardiac rate resulting from the fever, nausea, vomiting, anorexia, abdominal cramping, and diarrhea, among other specific pathogenic signs and symptoms as based on the site of the infection. These include things like foul-smelling urine and foul-smelling sputum that can occur with a urinary tract infection and a respiratory tract infection, respectively. Identifying and intervening to control the signs of hypoglycemia, hyperglycemia, and diabetic ketoacidosis. Extremely low blood glucose level, or hypoglycemia, is associated with diabetics who have taken too much insulin, too little food, or have exercised too excessively. Diabetes is managed and controlled when the medications like insulin and oral hypoglycemic agents are balanced with the patient's diet and exercise. The signs and symptoms of hypoglycemia include sweating, anxiety, shakiness, hunger, heart palpitations, double or blurry vision, and confusion. Later symptoms occur when the episode of hypoglycemia is not adequately corrected. The later symptoms of hypoglycemia include seizures, a complete loss of consciousness, coma, and death. Hypoglycemia can lead to death, so immediate treatment is necessary. Candy, fruit juice, glucose, or glucose tablets can be given when the client is still conscious and not at risk for aspiration. Unconscious patients are treated with intravenous glucose and other emergency interventions as indicated by the patient's condition. Hyperglycemia, or high blood glucose, is the opposite of hypoglycemia. Unlike hypoglycemia, however, hyperglycemia more often leads to long-term adverse effects than life-threatening situations, but this too can happen. The early signs and symptoms of hyperglycemia include the classic signs of diabetes like excessive thirst and frequent urination, in addition to include fatigue, blurred vision, and a headache. Hyperglycemia is treated with the administration of insulin. When left untreated, hyperglycemia can lead to diabetic ketoacidosis. In addition to the presence of ketones, the signs and symptoms of diabetic ketoacidosis have a relatively rapid onset of nausea, vomiting, confusion, excessive thirst, extreme fatigue, shortness of breath, abdominal pain, a fruity scented breath, and excessive urination. Left untreated, diabetic ketoacidosis can lead to unconsciousness and even death. The treatment of diabetic ketoacidosis includes the replacement of lost fluids and electrolytes like chloride, sodium, and potassium, and insulin therapy intravenously. Recognizing and reporting basic abnormalities on a client's cardiac monitor strip. One of the only disadvantages of audio review books, like this one, is that you cannot see pictures or diagrams as I speak. So you should look at and study some of the basic cardiac arrhythmias in your textbook so that you will be thoroughly prepared for graphics of normal and abnormal heart rhythms. Some of the basic abnormalities on the patient's cardiac monitor strip that the licensed practical nurse should be able to recognize and report include sinus brachycardia, sinus tachycardia, arterial flutter, arterial fibrillation, first-degree heart block, second-degree heart block, complete heart block, premature arterial contractions, premature atrial contractions, premature ventricular contractions, ventricular tachycardia, ventricular fibrillation, and asystole. Providing care for a client drainage device. Nurses provide care to patients with a number of different drainage devices, including chest tubes and wound drains. The care and maintenance of chest tubes were fully discussed previously with the topic Maintaining the Client's Tube Patency. Wound drains will now be discussed. There are a number of different wound drains available, including the most popular, which is the Hemovac drain and the Penrose drain. Wound drains are placed by the surgeon during surgery to collect and evacuate wound drainage. Nurses care for patients with wound drains. Nurses also monitor and measure the drainage that is collected in these wound drains after a surgical procedure. Nurses should monitor these drains and measure drainage during the immediate postoperative period of time at the same frequency that they check and monitor the patient's vital signs. Drainage is monitored and assessed in terms of its volume and in terms of its other characteristics, such as its color. In terms of color, wound drainage follows a relatively predictable path of change. Initially, wound drainage is bloody and red. Later, the wound drainage becomes sanguineous, which then later becomes serosanguineous. Then, lastly, the wound drainage is expected to be serous and minimal in terms of quantity. All drainage color that does not follow this course is considered not normal, and therefore, this abnormality should be reported to the supervising nurse and the doctor. The volume of the wound drainage is measured and recorded on the client's intake and output form, and the characteristics of the wound drainage are typically recorded on either a flow sheet or in the progress notes. Providing cooling, warming measures to restore normal temperature. As somewhat discussed above under Applying Therapies for Comfort and the Treatment of Inflammation Swelling, heat constricts the vessels and cold dilates the vessels. Vasodilation moves fluids and blood away from areas of inflammation, and vasoconstriction decreases the flow to the inflamed and injured area of the injury. These actions prevent and reduce swelling, inflammation, and muscle spasms. Both heat and cold are used to reduce the pain and discomfort of inflammation and swelling. They can both be applied as a moist or dry application. Moist applications tend to be more effective than dry heat and cold. Heat and cold also modulate the patient's bodily temperatures when they are affected with hypothermia or hyperthermia. Hypothermia occurs when heat production is less than heat loss. Technically speaking, hypothermia is a core bodily temperature of less than 95 degrees. Some of the risk factors associated with hypothermia are aging, thyroid disease, diabetes, trauma, and exposures to extremely cold environmental temperatures, including exposures to the globe's natural waterways and oceans. Hypothermia can be signaled with signs and symptoms such as shivering, lethargy, confusion, slurring of the speech, and shallow respirations. In its extreme form, hypothermia can lead to a loss of consciousness, coma, and death. Hypothermia is treated with the provision of warmth, using warm blankets, a hyperthermia blanket, warm packs, and warm oral fluids if the patient is able to drink fluids safely. Hyperthermia, the opposite of hypothermia, occurs when heat production is more than heat loss. Technically speaking, hyperthermia is a core bodily temperature of more than 99.5 degrees. Some of the risk factors associated with hyperthermia include exposures to extremely hot and humid environmental conditions, intensive exercise, damage to the hypothalamus, which is the thermostat of the brain, and some medications like monoamine oxidase-inhibiting psychotropic drugs. Some of the signs and symptoms of hyperthermia are a fever, hot skin, dehydration, confusion, dizziness, tachycardia, tachypnea, nausea, vomiting, hypotension, seizures, coma, and even death when the hyperthermia is not treated effectively. The treatments for hyperthermia include the correction of any underlying causal disorders, fluid hydration to make up for the patient's fluid losses, and the provision of coolness with wet packs or a hypothermia blanket. Providing care for a client with a tracheostomy. The care of the client with a tracheostomy tube, including client monitoring, tracheostomy tube placement, and suctioning, were discussed previously under Maintaining the Client's Tube Patency. Providing care for a client with an ostomy, colostomy, ileostomy, or urostomy. There are several different types of colostomies. Some are permanent, and others can be temporary. Briefly stated, colostomies are methods of fecal diversion from the gastrointestinal system to the surface of the patient's skin. The different types of colostomies are the ascending colostomy, the transverse colostomy, the double-barreled transverse colostomy, and the descending sigmoid colon colostomy. Most patients with colostomies wear a pouch to collect fecal waste. Patients with a colostomy near the end of the intestinal tract have less frequent and more formed stool than those who have a colostomy higher in the intestinal tract, because the lower the colostomy is, the greater the chance for the large intestine to absorb water. Based on this physiology, patients with a descending colon type or sigmoid colon type of ostomy may be candidates for irrigation techniques which eliminate the need for a pouch. Pouches are emptied, cleaned, and replaced as often as necessary. The goal of irrigation is to facilitate evacuation and the control of evacuation so the patient can wear a gauze cap over the stoma opening rather than an ostomy pouch. Ostomy irrigation is done by placing a catheter into the stoma and flushing it out so the feces comes out into the irrigation sleeve. Many patients irrigate only once a day or even every other day when they have experimented with irrigation and their diet is not problematic in terms of gas and fecal production. An ileostomy, similar to a colostomy, is performed when there is some pathological condition that prevents the stool from being evacuated through the anus. The difference between a colostomy and an ileostomy is that the entire colon and rectum are removed with an ileostomy, and the entire colon and rectum are removed with a colostomy. Because the entire rectum and colon are removed with an ileostomy, the stool is evacuated at the level of the small intestine rather than the large intestine. The fecal material with an ileostomy is, therefore, loose and green in color. A pouch must be worn at all times because stool evacuation cannot be predicted. It cannot be controlled with irrigation when the patient has an ileostomy. Lastly, a urostomy, unlike an ostomy, is a urinary diversion rather than a fecal diversion. The different types of urostomy are the ileoconduit, the neobladder, the Miami pouch, the Indiana pouch, and a nephrostomy. Patients with a urostomy should be encouraged to consume at least 6 to 8 glasses of fluid per day to prevent some of the complications of an ileostomy. These complications can include alterations of the urinary pH, the formation and accumulations of salts, and infections. Patients should also be instructed to dissolve mucus plugs that are clogging the pouch by using Marlin Mucosperse. Providing care to a client on a ventilator. Mechanical ventilation delivers air under pressure that keeps the alveoli open during inspiration, and it prevents alveolar collapse during expiration. Mechanical ventilation improves gas exchanges. It improves oxygenation. It increases lung expansion, and it decreases the patient's work of breathing. Despite the great benefits of mechanical ventilation, nurses must be aware that there are some complications associated with the use of mechanical ventilation. Some of the complications that nurses must monitor for include cardiovascular complications, airway complications, oxygen toxicity, alveoli overdistension and inflation, hypoventilation, hyperventilation, infection, and ventilator asynchrony, among other complications. Providing care to correct client alterations in body systems. All client care aims to enhance health and also correct and maintain bodily systems. A knowledge of anatomy, physiology, pathophysiology, and acute as well as chronic disorders is necessary for nurses so that they are better able to anticipate and meet the complex needs of their patients. Providing care to the client undergoing peritoneal dialysis. Renal dialysis filters waste from the body. It removes excessive bodily fluids, and it maintains the patient's pH balance. Dialysis employs the physical principles of osmosis, filtration, ultrafiltration, and diffusion. The two types of dialysis are peritoneal dialysis and hemodialysis. Both forms of dialysis can be done by the patient in their own home. Both can be done in a community dialysis center. Peritoneal dialysis treatments are done with a fill phase, a dwell phase, and a drain cycle, using a dialysis solution referred to as a dialysate. In other words, the dialysate fills the abdominal space. It then remains and dwells there for a period of time. Then it is drained out of the abdomen. The drainage consists of some dialysate in addition to body wastes and excessive bodily fluids that typically increase and accumulate as the result of their renal failure. Peritoneal dialysis can be done with or without a dialysis machine. For example, continuous ambulatory peritoneal dialysis in the home does not require the use of a dialysis machine, but a dialysis machine is needed when cycler-assisted peritoneal dialysis is done. Peritoneal dialysate is delivered into the patient through a peritoneal dialysis catheter that is placed in the patient's abdominal space. Peritoneal dialysis is the only dialysis choice that end-stage renal disease patients have when they have poor venous access. However, peritoneal dialysis has its distinct advantages. It is more easily done in the home by the patient because it is less complicated and complex than hemodialysis. It is also primarily done while the patient is sleeping and hooked up to an automated dialysis machine, unlike hemodialysis in the home that requires constant monitoring. Like hemodialysis, peritoneal dialysis can also be done in a community dialysis center during the day or during the nighttime hours. During the dialysis treatment, the nurse monitors and assesses the dialysis treatment, the patient, and their physical condition. For example, the nurse will monitor and measure the patient's weight prior to and subsequent to the peritoneal dialysis treatment. The nurse will check and monitor the patient's vital signs. The nurse will monitor the client for any respiratory changes. The nurse will measure and record the amount of dialysate that is administered. The nurse will observe and measure the output in terms of its volume and its characteristics, such as its color. They also ensure that the flow is not obstructed and that the drainage bag is maintained below the level of the patient's abdomen. The nurse repositions the patient and milks the tubing if the output is obstructed. Providing care to the client experiencing increased intracranial pressure. The pressure within the cranial cavity is referred to as intracranial pressure. Under normal circumstances, the intracranial pressure is from 5 to 15 millimeters of mercury. Intracranial pressure is affected by several things, some of which are mechanical and congenital, such as an infant being born with hydrocephalus, and other things can include events such as a brain tumor, an infection, and a closed head injury. Brainstem herniation and death will occur when intracranial pressure increases to the point that the hard skull can no longer accommodate it. Among the most commonly occurring disorders and diseases that increase intracranial pressure are a congenital anomaly, such as spina bifida, a brain tumor, a cerebral infarction, an intracranial subarachnoid bleeding, an intracranial hematoma, closed head trauma, a subdural or epidural hematoma, and brain infections. Early signs of increased intracranial pressure include a decreased level of consciousness, dilated pupils, a headache, slow and poor pupil constriction with light, motor function losses, sensory losses, and visual disturbances. The later signs of increased intracranial pressure include a fever, vomiting, the hiccups, decerebrate posturing and/or decorticate posturing, a widening pulse pressure, Cushing's reflex, and Cheyne-Stokes respirations. The pulse pressure is defined as the mathematical difference between the systolic blood pressure and the diastolic blood pressure. For example, the pulse pressure is 60 when a client's blood pressure is 130/70, because 130 minus 70 is 60. A patient whose blood pressure is 190/40 has a pulse pressure of 150, because 190 minus 40 is 150. When the patient's current pulse pressure is greater than the previous one, the pulse pressure is becoming greater and the pulse pressure is widening. When the patient's current pulse pressure is less than the previous one, the pulse pressure is lessening and the pulse pressure is narrowing. The signs and symptoms of Cushing's reflex, a late sign of increased intracranial pressure, signal the possibility of a severe, life-threatening brainstem ischemia. The signs and symptoms of Cushing's reflex include a widening pulse pressure, hypertension, and brachycardia, among other signs and symptoms. Decerebrate and decorticate posturing are abnormal body postures that include the presence of severe increased intracranial pressure. Decerebrate posturing is occurring when the patient's head and neck are extended and arched backward. The legs and arms are extended straight out from the body, and the patient's toes are pointed downward. The patient's muscles are extremely rigid and tight. It is often very difficult for the nurse to move these rigid extremities. Additionally, very pronounced and severe muscle spasms of the back and neck can occur. This phenomenon is referred to as opisthotonos. Decerebrate posturing is typically bilateral. However, there are some occasions when decerebrate posturing can be unilateral, affecting only one side of the patient's body. Decorticate posture, on the other hand, occurs when the patient's fists are tightly clenched and held on the chest, while the arms are tightly bent and turned inward towards the body. The goal of treatment for increased intracranial pressure is to resolve the underlying cause of the increased intracranial pressure in order to sustain life whenever possible. The interventions vary according to the underlying cause. For example, surgical interventions may be necessary in many cases. Intravenous osmotic diuretics to remove excessive intracranial fluid, like mannitol, and/or corticosteroids to reduce edema may be indicated for other cases. Because the patient with increased intracranial pressure is prone to seizures, seizure precautions and the administration of anticonvulsant medications are often done. Additionally, a medically induced coma using a barbiturate is typically done to conserve brain tissue by decreasing the metabolic demands and needs of the patient's brain. Lastly, mechanical ventilation is indicated when respiratory failure occurs and the patient or their healthcare surrogate has chosen to have such an intervention. Providing care to a client who has had a seizure disorder or seizure. Abnormal electrical activity in the brain causes seizures. Seizures can be classified as epileptic seizure and non-epileptic seizure. Epileptic seizures occur secondary to epilepsy. Non-epileptic seizures occur as the result of one or more disorders other than epilepsy. Some of these other causes are things like central nervous system infections, brain tumors, severe hypoglycemia, drug abuse, cardiovascular disorders, withdrawal from illicit drugs, and metabolic disorders. Seizures are also classified as generalized seizures and partial seizures. Most seizures are short-lived, lasting less than 2 minutes, and they can be very temporary in nature. However, seizures can be a life-threatening situation when a seizure lasts more than 5 minutes, when the patient does not return to their normal level of consciousness, and/or when the patient is experiencing several serial seizures in succession. Status epilepticus, which is ongoing seizure activity and loss of consciousness without cessation, is a life-threatening condition that requires emergency medical treatment and interventions. Seizures can be treated with the correction of any underlying cause and/or anticonvulsant medications like Dilantin. Patients with a seizure disorder should be instructed to wear a medical alert bracelet or necklace. Additionally, the client should be taught about the warning signs of a seizure, how to avoid seizure triggers such as flashing lights, and when to notify their doctor. Providing care to the client experiencing complications of pregnancy, labor, and/or delivery. The care of patients experiencing the complications of pregnancy, labor, and/or delivery was previously detailed under the topics identifying the signs and symptoms of potential prenatal complications, assisting with the monitoring of a client in labor, and monitoring the recovery of stable postpartum clients. Performing wound care and/or dressing changes. Wound care and dressing changes are sterile procedures that require surgical asepsis. The wound and the area surrounding must be inspected for drainage, any signs of infection, and extraneous debris. The wound is gently cleansed, as ordered by the doctor, and in a manner that does not disrupt or damage any fragile granulating healing tissue. Cleansing the wound should begin with the cleanest area first and then done to the dirtiest area. Additionally, a fresh swab or piece of gauze is used for only one swipe, after which it is then discarded and a new one used. The three main types of dressings are the traditional dressing, the interactive dressing, and the bioactive dressing. Traditional dressings consist of sterile gauze covered with tape to simply protect and cover the wound. Interactive dressings have some additive to promote wound healing. These dressings are transparent, so the wound can be readily visualized, and they are also permeable to water vapor and oxygen in the environment. Examples of interactive dressings are foam interactive dressings, hyaluronic acid interactive dressings, and hydrogel interactive dressings. Performing a check of client pacemakers. Nurses also monitor and manage pacemaker functions. Some of the complications related to pacemakers include cardiac arrhythmias, the introduction of infection, bleeding, accidental punctures of the lung or heart during insertion, mechanical failures, and the loss of battery power. Generally speaking, batteries are meant to last from 5 to 10 years. The three types of pacemakers are single-chamber pacemakers, double-chamber pacemakers, and biventricular pacemakers. Biventricular pacemakers have one lead in the right ventricle, one lead into the right atrium, and one lead into the left ventricle of the heart, making a total of 3 leads. Double-chamber pacemakers, also referred to as a double-barreled pacemaker, have 2 leads. One enters the right atrium, and one lead enters the right ventricle of the heart. Lastly, single-chamber pacemakers have 1 lead. This lead enters either the right ventricle or the right atrium of the heart. Performing care for the client after a surgical procedure. Nurses monitor and observe the patient's risk factors and complications associated with surgical procedures. They determine the patient's need for pain relief. They administer pain medications. Nurses evaluate the effectiveness of any pain relief measures that were implemented. The complications of surgery, among others, include infection, airway obstruction, thrombocytopenia, wound dehiscence, wound evisceration, hypoxia, and paralytic ileus. Infection, airway obstructions, and hypoxia were previously discussed. Dehiscence occurs when an incisional wound separates after surgery. Evisceration occurs when an incisional wound separates and a bodily organ protrudes through the incision and becomes visible. Some of the risk factors associated with wound disruption include diabetes, vomiting, sneezing, obesity, coughing, and a patient's failure to splint the wound. Dehiscence and evisceration can sometimes be prevented when the postoperative patient splints the incision when they cough, when they routinely deep breathe, and when they move about in bed. These wound disruptions are life-threatening. Do not, under any circumstances, leave the patient unattended if you witness wound dehiscence or wound evisceration or observe any evidence of these serious conditions. Instead, call for help. Place a sterile saline-dampened dressing or a sterile towel over the wound. Maintain light pressure over the wound, and closely monitor the patient for any signs and symptoms of shock and emotional distress. Again, do not leave the patient unattended. Also, do not attempt to reinsert any organs into the abdominal cavity. Removing wound sutures or staples. The process for removing surgical sutures and staples entails the nurse to 1. Cleanse the surgical wound with an antiseptic in a circular pattern from the suture or staple to the outer periphery, and then 2. Pick up each knot with a sterile forceps and clipping each suture with sterile scissors, or removing each staple with a special surgical staple remover. The wound is then cleansed again with an antiseptic, after which the staples or sutures were removed, and, if indicated, steri-strips can be placed over the incision for further wound support. Removing the client's wound drainage devices. Wound drain removal is most often done by the physician or a physician extender, such as a nurse practitioner or physician's assistant. Nurses may, after the drain has been removed, cover the site with a sterile dressing and care for the site in the same manner that other wounds are cared for. Intervening to improve client respiratory status. Nurses perform many roles using a number of different techniques and procedures to maintain and improve a client's respiratory status. Nurses encourage coughing and deep breathing. They encourage the patient to use their incentive spirometer. At times, nurses may be assigned to perform postural drainage, percussion, and vibration to mobilize respiratory secretions so that the patient is better able to cough up and eliminate accumulated respiratory secretions. Reinforcing client teaching on ostomy care. Clients should be taught about all aspects of ostomy care. For urinary and fecal diversions ostomies, the client should be taught about normal and abnormal findings in terms of the stoma, the surrounding skin and the ostomy output, methods of irrigation, and the application of appliances such as a pouch. When a client has a respiratory ostomy, such as a tracheostomy, the client is taught how to care for it. They are also taught about suctioning and changing the dressing in addition to the normal and abnormal appearance of this stoma. Reinforcing education to clients regarding their care and condition. Some of the content that is typically included in the patient teaching plan includes information about the modifiable and non-modifiable risk factors, the pathophysiology of the disease, condition, or illness, the signs and symptoms, the diagnostic tests that will be done to facilitate diagnosis, and the ongoing monitoring of the client's progress, the treatment interventions, including medications, self-care strategies, the need for follow-up care, and the signs, symptoms, and other concerns that must be reported to the doctor. Notifying the primary healthcare provider of a change in the client's status. As repeated numerous times throughout this review, nurses are accountable and responsible for notifying the primary care provider and the supervising nurse when a significant change in the client's physical and/or mental status occurs. Documenting client responses to interventions for alterations in body systems. All therapeutic treatments and interventions have expected outcomes. For example, a client with a pacemaker is expected to be without bradycardia when it is functioning properly, and the client's cardiac status should remain relatively stable. A client with a pneumothorax or hemothorax is expected to have the restoration of pulmonary functioning and the re-expansion of a lung or lungs as the result of their treatment with chest tubes. Throughout the course of care, nurses monitor for these desired outcomes and responses. Nurses thoroughly document this information in the client's medical record. All abnormal findings are documented and reported. Basic pathophysiology. Identifying the signs and symptoms related to acute or chronic illnesses. The pathophysiology of many acute and chronic conditions include etiologies, risk factors, and changes in signs, symptoms, laboratory findings, etc. were and are discussed throughout this review book. Considering general principles of client disease processes when providing care. Some of the general principles of pathophysiology include the signs of infection, the immunological body responses, wound healing, as well as the role of cellular structures. Signs of infection. The signs of infection were previously discussed under the signs and symptoms of infection. Immunity. Immunity is protection against a disease. Immunity can be active, passive, natural, and artificial. Active immunity occurs when antibodies are created in response to an antigen. Passive immunity occurs when the fetus gets immunity from the mother in utero or from the injection of an immune globulin. Natural immunity occurs when the person develops antibodies to an infection because they have been infected with it. Artificial immunity is acquired when the person has received an immunization against the infection. Active and natural immunity are more long-lasting and even permanent when compared to artificial and passive immunity. Here are some examples of immunity. Active immunity is having the infection or getting an immunization that produces antibodies in response to the presence of an antigen. Passive immunity is the presence of antibodies that were not produced by an antigen-antibody reaction. Natural immunity is immunity that occurs as the result of natural, not man-made mechanisms. Artificial immunity is immunity that occurs as the result of man-made, not natural mechanisms. Artificial active immunity is immunity that occurs as the result of an immunization against diphtheria. Artificial passive immunity is immunity that occurs as the result of the administration of a gamma globulin injection. Natural active immunity is immunity that occurs as the result of having measles. Natural passive immunity is immunity that occurs as the result of the passage of antibodies to the fetus in utero. Wound healing. There are different types of wound healing, which include the following. Primary healing. The most common type of wound healing used for repairs, lacerations, or surgeries is primary healing or healing by first intention. This type of healing involves the wound being covered completely by suturing, flaps, or split or full thickness grafts. Primary healing is usually found with wounds that are considered clean. Secondary healing. Wound healing, in which the wound is left open and meant to heal through both granulation and epithelialization, is known as secondary healing or healing by second intention in order to prepare the wound bed for healing. When a wound is contaminated or dirty or infected, this type of healing is usually indicated in order to prevent the formation of an abscess and to allow the wound to drain. Tertiary healing. Tertiary healing is also referred to as healing by third intention or delayed primary closure. With this type of healing, initially debriding the wound is performed, and it is left open to begin the healing process. Later, suturing or grafts are used to close the wound. Contaminated wounds, such as animal bites or mixed trauma wounds, oftentimes are healed this way. The 4 phases of the wound healing process in correct sequential order are: 1. Hemostasis. 2. Inflammation. 3. Proliferation and granulation. And 4. Maturation and differentiation. Some of the natural bodily defenses that protect humans from infection include nonspecific and specific defenses. Specific responses to infection include cell-mediated defenses and antibody-mediated defenses. Antibody-mediated defenses include both active and passive immunities. Nonspecific defenses against infection include anatomical and physiological barriers to infection and the inflammation process itself. Skin, the first line of defense, is an example of a nonspecific defense against infection. Applying a knowledge of pathophysiology to monitoring the client for alterations in body systems. The anatomy and physiology of the human body is quite complex, as you have learned in school. As you respond to questions in this area of the NCLEX, recall the normal anatomy and physiology of the human body and compare these normal characteristics to any alteration or abnormalities that are contained in these questions. Fluid and electrolyte imbalances. Electrolytes are ions that can have either a negative or positive charge. The body's electrolytes are sodium, which is abbreviated as Na+ because it has a positive charge. Potassium, which is abbreviated as K+. Calcium, which is abbreviated as Ca+. Magnesium, which is abbreviated as Mg+. Chloride, which is abbreviated as Cl- because it has a negative charge. Bicarbonate, which is abbreviated as HCO3-. Sulfate, which is abbreviated as SO4-. And hydrogen phosphate, which is abbreviated as HPO4-. The normal level of potassium ranges from 3.5 to 5.5. The normal range of sodium is from 135 to 145. The normal range of chloride is from 95 to 105. The normal range for bicarbonate is from 22 to 25. The normal range for calcium is from 4.5 to 5.5. Levels below the lowest normal limit of each electrolyte are hypo, and levels above the highest limit for each electrolyte is referred to as hyper. For example, a sodium level of 94 is hyponatremia, and a potassium level of 6.2 is hyperkalemia. Identifying the signs, symptoms of client fluid and/or electrolyte imbalances. Now, we will discuss the signs and symptoms of fluid and electrolyte imbalances. Hypervolemia, also referred to as a fluid overload, is an excessive volume of fluid in the blood. The commonly occurring signs and symptoms of hypervolemia are dyspnea, particularly when a patient is in a supine position, jugular vein distension, hypertension, edema, ascites, a bounding pulse, and adventitious or abnormal breath sounds, such as crackles. Hypovolemia is also referred to as a fluid deficit, is an excessively low volume of fluid in the blood. Hypovolemia is the opposite of hypervolemia. Hypovolemia is characterized with the signs of dehydration and the signs of hypovolemic shock. Hyperkalemia can be life-threatening. The signs and symptoms of hyperkalemia are potentially life-threatening cardiac dysrhythmias, nausea, muscular weakness and fatigue, paralysis and weakness. Hypokalemia can be asymptomatic when the potassium level is only slightly low. However, the signs and symptoms that can occur with hypokalemia include cardiac dysrhythmias, overall fatigue, lightheadedness, palpitations, constipation, bradycardia, muscle weakness, muscular spasms, tingling, numbness, and in severe cases, cardiac arrest. Hypernatremia, or high sodium, is characterized with the signs and symptoms of dehydration, such as thirst and dry mucous membranes, in addition to agitation, restlessness, confusion, and in more severe cases, coma and convulsions. Hyponatremia signs and symptoms are muscular spasms and cramps, muscular weakness, confusion, nausea, headache, vomiting, seizures, fatigue, restlessness, and irritability. Hypocalcemia can, at times, be asymptomatic or accompanied with the signs and symptoms of muscle cramps, dry skin, brittle nails, coarse hair, and scaly skin. In severe cases, the patient can be adversely affected with delirium, tingling, memory losses, confusion, seizures, cardiac dysrhythmias, muscular tetany, and hallucinations. On the other hand, hypercalcemia is characterized with thirst, urinary frequency, bone pain, muscular weakness, confusion, fatigue, lethargy, constipation, nausea, and vomiting. Hyperchloremia, which is a high chloride level, can adversely affect the patient with hyperglycemia, thirst, pitting edema, dehydration, diarrhea, vomiting, Kussmaul's breathing, dyspnea, tachypnea, hypertension, decreased cognition, and coma. The signs and symptoms of hypochloremia, which is a low chloride level, include nausea, vomiting, dehydration, muscular spasticity, tetany, respiratory depression, muscle weakness, hyponatremia, muscle twitching, sweating, and high fever. Hypermagnesemia can be characterized with drowsiness, decreased level of consciousness, hypotension, cardiac arrhythmias, decreased mental alertness, overall weakness, respiratory paralysis and depression, central nervous system depression, and coma. Hypomagnesemia signs and symptoms can include muscle weakness, muscular spasms, muscular cramps, fatigue, numbness, convulsions, and nystagmus. There are usually no symptoms when the patient is affected with mild hyperphosphatemia. However, signs and symptoms do appear in severe cases. Some of these signs and symptoms of hyperphosphatemia include tetany and vascular calcifications that can be palpated into subcutaneous tissue. Hypophosphatemia signs and symptoms can include respiratory alterations, emotional irritability, confusion, and coma when the phosphorus level is extremely low. Providing interventions to restore client fluid and/or electrolyte imbalances. The treatment of electrolyte imbalances depends on the particular electrolyte that is unbalanced. Generally speaking, in addition to correcting the underlying cause, some episodes of low electrolytes are treated with the administration of the electrolyte, and some cases of high electrolyte levels are treated by ridding the body of excesses. Hypervolemia is treated with fluid restrictions, sodium restrictions, and diuretic medications. Hypovolemia is treated with fluid and/or blood replacements. The treatment of hyperkalemia, depending on the severity of the electrolyte disorder, can include medications to rid the body of potassium and renal dialysis in severe cases. The treatment of hypokalemia can include supplemental potassium, either orally or intravenously, a diet rich in potassium, and the elimination of diuretics that deplete potassium. The treatment of hypernatremia includes fluid replacement intravenously or orally. The treatment of hyponatremia can include fluid restrictions, diuretics, and intravenous sodium administration. The treatment of hypercalcemia can include medications such as prednisone, diuretics, and biophosphate medications in addition to intravenous fluids. The treatment of hypocalcemia includes oral calcium and vitamin D supplementation and intravenous calcium when indicated. The treatment of hyperkalemia can include maintaining hydration, intravenous sodium bicarbonate, intravenous lactated Ringer's solution, and a low-sodium diet. The treatment of hypochloremia can include hydration, electrolyte replacement therapy, and a diet with sodium and potassium. The treatment of hypermagnesemia includes the cessation of drugs like antacids that contain magnesium, calcium gluconate injections, insulin, renal dialysis, and calcium chloride. The treatment of hypomagnesemia entails the administration of intravenous fluids and the administration of oral or intravenous magnesium. Hyperphosphatemia is treated with calcium carbonate tablets to bind the phosphorus in the patient's blood. The treatment for hypophosphatemia includes identifying and treating the underlying condition, magnesium supplementation, and vitamin D supplementation. Monitoring the client's responses to interventions to correct fluid and electrolyte imbalances. Nurses monitor the client's responses to interventions that were used to correct fluid and electrolyte imbalances by comparing baseline and current data. For example, pre-treatment and post-treatment laboratory magnesium levels are compared to determine whether or not the client's electrolyte level is again normal and/or improving. Medical emergencies. Responding to and intervening to a client life-threatening situation, cardiac arrest and cardiopulmonary resuscitation, CPR. The immediate treatment for sudden cardiac arrest is cardiopulmonary resuscitation, starting with the ABCs, in addition to defibrillation, medications such as those used to correct cardiac arrhythmia and/or a calcium channel blocker, an internally implanted cardioverter in combination with a defibrillator. Later treatments can include coronary angioplasty, coronary bypass surgery, corrective heart surgery, and heart transplantation. Of all the basic physiological needs, the ABCs are the priorities. These need to take priority over all other human needs, according to Abraham Maslow's hierarchy of human needs as previously discussed. Airway obstructions can be partial or complete. A complete airway obstruction is signaled with a lack of any cough or other noises from the patient. The airway must be opened using the techniques you have learned when you took your basic life support course. Intubation, when necessary, is also done. A partial airway obstruction can be determined by listening to the patient's cough and other respiratory noises. A cough that is not efficient indicates a more severe airway obstruction than a cough that is effective in terms of clearing the airway of secretions and/or foreign bodies. The patient who is coughing should be encouraged and prompted to continue to cough. Visible foreign bodies that can be removed should be removed if there is no chance of pushing it further into the airway. The look, listen, and feel assessment for breathing to determine whether or not the patient is spontaneously breathing on their own includes looking at the chest to see if it rises and falls, listening for any breath sounds from the nose or mouth, and feeling the chest and upper abdomen to see if there is any movement present. Rescue breathing is done when the patient is not breathing and the airway is open. Chest compressions are done, as you learned in your basic life support course, on all patients who are unconscious, unresponsive, not breathing, and pulseless. Defibrillation gives an electric shock to the heart. There are standard external defibrillators, which are typically found in hospitals and other healthcare facilities and used by nurses. Transvenous defibrillators, implantable cardioverter defibrillators, and automated external defibrillators. Automated external defibrillators are most often found in the community and outside of healthcare facilities. Automated external defibrillators are simple to use. There is no need to be able to recognize cardiac arrhythmias or interpret cardiac rhythm strips. Automated external defibrillators are intended to be used by the general public without any healthcare or nursing knowledge or experience. The steps for using an automated external defibrillation is turn the machine on, put the pads on the patient's chest as shown on the machine, and then listen to and follow the automated instructions of the automated external defibrillation. Notifying the primary healthcare provider about the client's unexpected response emergency situation. All significant changes in the patient's physical status, including unexpected client responses and emergency situations, are reported to the patient's doctor and others, such as the supervising registered nurse, in a timely, accurate, and complete manner. For example, the restoration of spontaneous breathing and the reversal of acetylcholine are reported to the patient's doctors and others. Recommending changes in emergency treatment based upon client response to interventions. At times, the nurse, in collaboration with others, may recommend changes in emergency treatments as based on the lack of complete success to emergency interventions. Reviewing and documenting the client's responses to emergency interventions. In addition to reporting the patient's responses to emergency interventions, such as the restoration of spontaneous breathing and the reversal of acetylcholine, these things are also documented in the patient's medical record. Reinforcing teaching of emergency intervention explanations to clients. As with all other aspects of nursing care, interventions should be explained to the client and informed consent should be given except under special circumstances, such as when an emergency is occurring and these interventions are not possible at the current time. Most often, emergency interventions such as CPR and defibrillation are explained to the family rather than the patient. Unexpected responses to therapies. Identifying and treating a client intravenous IV line infiltration and other IV complications. Some of the complications associated with intravenous lines include infiltration, infection and cellulitis, hematoma, phlebitis, embolus, fluid overload, and extravasation. The signs and symptoms of intravenous infiltration include coolness of the skin near the site, pain, swelling, a slowed rate of the intravenous fluids, and pallor around the site. Infiltrations are treated with the cessation of the intravenous fluids, removing the intravenous catheter, elevating the limb, and the application of warm compresses to the site. Extravasation is highly similar to infiltration, but extravasation involves the infiltration of a caustic chemotherapy medication. It can lead to more serious complications, like the loss of the affected limb. The early signs and symptoms of this serious intravenous therapy complication include erythema, severe pain, swelling, redness, and blistering. The later signs and symptoms, when the extravasation is not treated, can include skin discoloration, invasive ulceration, horrible and constant pain, and the loss of function of the affected limb. Limb loss can occur with severe necrosis secondary to extravasation. Complications of extravasation can be prevented with the immediate cessation of the infusion and the removal of the intravenous line. Other interventions include elevation of the extremity and the application of a cool compress. Infections and cellulitis are treated with the cessation of the intravenous fluids, removing the intravenous catheter, the application of warm compresses, the elevation of the limb, and medications such as antibiotics, analgesics, and/or antipyretics according to the severity of this intravenous therapy complication. The signs and symptoms of intravenous therapy infection include the classic signs of infection, such as swelling, soreness, redness at the site, pain, and fever. Hematomas present with ecchymosis. The treatment of an intravenous therapy-related hematoma includes cessation of the intravenous therapy, the application of a pressure dressing over the site, the elevation of the limb, and the application of warm compresses. Intravenous therapy-related phlebitis is suspected when the intravenous flow rate slows down and when there is redness, swelling, pain, fever, and/or a palpable red streak. The treatment of phlebitis includes the cessation of the intravenous therapy, the elevation of the limb, the application of warm compresses, as well as the administration of analgesics and/or antipyretics as indicated by the patient's condition. The signs and symptoms of phlebitis secondary to intravenous therapy include pain and a slow intravenous fluid flow rate. Again, the intravenous therapy is stopped, and the nurse elevates the limb, applies warm compresses, and administers medications such as an analgesic when ordered. Emboli, secondary to intravenous therapy, can present with chest pain, shortness of breath, and other signs and symptoms associated with pulmonary emboli. Nurses discontinue the intravenous, and they place a tourniquet above the site to prevent further migration of broken catheter pieces. The signs and symptoms of fluid overload, the last complication of intravenous therapy that will be discussed in this review, are lung crackles, hypertension, edema, tachycardia, distended neck veins, and shortness of breath. Intervening in response to a client's unexpected negative responses to therapy. Nurses must be able to identify and respond to negative responses to therapy. For example, the nurse who observes postoperative bleeding and hemorrhage will provide emergency measures and then notifying the supervising nurse and the doctor after the client's condition is observed. Recognizing, reporting, and documenting changes in unexpected responses in the client's condition to therapies. All significant changes, both positive and negative, must be reported and documented. Some of these changes can include bleeding after surgery, an embolus secondary to intravenous therapy, and hemolysis secondary to the administration of blood. Promoting the recovery from clients' unexpected negative responses to therapy. Virtually all treatments and procedures have possible complications and side effects. In addition to providing treatments and therapies, nurses also promote the recovery of the client when they have a negative, unexpected response to therapy. Congratulations! You have reached the end of this review. Remember, you can always rewind this audio review and listen to it again if you need additional review and/or extra practice with test questions. Questions for the management of care. We have just finished the first leg of our journey. You have just completed the first major section of this review class. You have finished the management of care section of the NCLEX test review. So now it is time for some review questions. 4 out of 5 of these review questions will be traditional 4-item multiple choice questions, and 1 will be an alternative format question. We will continue with this pattern of 5 review questions after each major section. At least one of these review questions for each major section will be an alternative format question like you will see on your NCLEX PN examination. Good luck. According to Randy Pausch, the brick walls are there for a reason. The brick walls are not there to keep us out. The brick walls are there to give us a chance to show how badly we want something. Because the brick walls are there to stop the people who don't want it badly enough. They're there to stop the other people. Don't let any obstacles, including brick walls, keep you from your goal of becoming an LPN. Now, here is question number 1 for the management of care section. You have been assigned to care for a patient who is 59 years of age, who has had a recent cerebrovascular accident. The patient has orders for NPH insulin twice a day. The patient also has orders for regular insulin coverage on a sliding scale before meals and also with episodes of hyperglycemia. As you are doing a leg dressing change for this patient, you notice that the patient is somewhat confused and has slurred speech. What is your priority action? A. Call the doctor about the patient's changes. B. Check the patient's blood glucose level. C. Administer the patient's insulin as ordered. Or D. Give the patient a meal, like a sandwich. Based on the patient's diagnosis of diabetes and the signs and symptoms of slurred speech and confusion, it is highly likely, but not yet certain, that the patient is having an episode of hypoglycemia. Your first priority action is to check the patient's blood glucose level to find out if the blood glucose is low, high, or normal, so you can determine, if needed, the patient is affected with hypoglycemia or something else. Question number 2 is, your patient is experiencing a seizure. What is the first thing that you must do? A. Protect the patient's safety. B. Call the doctor. C. administer ordered anticonvulsants, or D. Get help. The correct answer is A. Protect the patient's safety. You must never leave the patient alone when a patient is having a seizure. Your first priority is ensuring the safety of the patient. After you get help, you can call or ask someone else to call the doctor when the patient is stabilized. Question number 3 is, which of the following is not information that the patient must be knowledgeable about before giving informed consent? A. The risks associated with the procedure or treatment. B. The benefits associated with the procedure or treatment. C. The alternatives to the procedure or treatment. Or D. The names of people who can legally consent. The correct answer is D. The names of the people who can legally consent. Information that is given to the patient prior to legal consent includes the risks associated with the procedure or treatment, the benefits associated with the procedure or treatment, and the alternatives to the procedure or treatment that the patient is free to choose from. It is not necessary to tell the patient about the people that can legally sign a consent unless they are unable to sign the consent and they ask about this information. Question number 4 is, you have decided to tie a loose sheet around a patient in a chair because she has a tendency to slide off chairs. What have you done? A. Ensured the patient's safety. B. Prevented a fall. C. Falsely imprisoned her. Or D. Violated her confidentiality. The answer is C. You have falsely imprisoned this patient because tying a bed sheet around a patient to prevent a fall is a restraint. It is a restraint without an order, even though you intended to protect the patient from a fall. Question number 5 is an alternative format question. Which of the following things can a nursing assistant do? Select all that apply. A. Assist the patient with a walker. B. Collect a stool specimen. C. Apply over-the-counter cortisone cream to the arm. D. Obtain a urine specimen from a Foley catheter. E. Empty the Foley catheter drainage bag. Or F. Set up a sterile field for a bedside procedure. The correct answers are A, B, and E. The nursing assistant can assist the patient with a walker, collect a stool specimen, and empty the Foley catheter drainage bag. They cannot apply any medicated creams or lotions. They cannot do sterile procedures such as obtaining a urine specimen from a Foley catheter or setting up a sterile field for a bedside procedure. Questions for safety and infection control. Congratulations! You have just completed our second major section, the Safety and Infection Control section of the NCLEX test review. You are moving right along with this course. Keep the pace going. Feel free to listen to this and any other section over again at any time you feel like you need more review. The review course material is there for you whenever you want or need it. Do not fear failure. Think success. As Robert Kennedy said, only those who dare to fail greatly can ever achieve greatly. So now it's time for some review questions. This is your turn to overcome your fears. Question number 1 is, you have just observed a nursing assistant remove gloves before leaving the room and after providing care to a patient. The nursing assistant removes the gloves correctly, discards them into the proper receptacle in the patient's room, and then leaves the room. Has this nursing assistant done anything incorrectly? A. No. The nursing assistant did everything correctly. B. Yes. The nursing assistant failed to greet the patient. C. Yes. The nursing assistant should have kept the gloves on until they left the room. Or D. Yes. The nursing assistant failed to wash their hands before leaving the room. The correct answer is D. The nursing assistant failed to wash their hands before leaving the room. Hand washing is done using friction for a minimum of 20 seconds before and after each client contact, in addition to other times such as before and after donning and removing gloves. Question number 2 is, you see a small fire in a trash can that you believe you can safely and simply put out using a fire extinguisher. What is the first step you would do to use this fire extinguisher? A. Pull the activating pin. B. Aim the nozzle at the top of the flames. C. Aim the nozzle at the bottom of the flames. Or D. Sweep and spray over the flames. The correct answer is A. Pull the activating pin. The procedure for using a fire extinguisher is PASS. P for pull the pin on the fire extinguisher, A for aim at the bottom of the fire, S for squeeze the trigger on the fire extinguisher to release the spray, and then S for sweep the spray from side to side over the base of the fire until it is extinguished. Question number 3 is, you have been assigned to the emergency department to help receive incoming patients who are being transported from the community to your hospital after a terrorist bomb attack. Which patient is the highest priority of care? A. The patient with the yellow tag. B. The patient with the red tag. C. The patient with a black tag. Or D. The patient with a green tag. The correct answer is B. The patient with the red tag. Red-colored triaged tags are the immediate care group that requires immediate medical attention for life-threatening injuries. This group has a greater possibility of survival than the black-tagged group. The yellow triage color indicates that treatment can be somewhat delayed until the red group's needs are addressed. Lastly, the green triage group, who is referred to as the minimal care group, has only minor injuries. Question number 4 is, you are going to be giving medications to a group of patients. Which of the following is an example of a unique identifier that you could use as one of the 2 unique identifiers that are needed to properly identify a patient? A. The patient's room number. B. The month and date of the patient's birth. C. The last 2 numbers of their Social Security number. Or D. A secret code like a secret word or number. The correct answer is D. A secret code like a secret word or number. The patient's room and bed number, the patient's month and day of birth without a year of birth, and the last 2 numbers of the Social Security number are not unique identifiers because other patients can have these same identifiers. Question number 5 is an alternative format question. Which statement or statements about restraint and restraint use is accurate? Select all that apply. A. Sedating medications to prevent agitation are restraints. B. Side rails to prevent a fall are not considered a restraint. C. Restraints can be ordered only by the doctor. D. A vest restraint is the least restrictive type of restraint. Or E. The most common reason for restraints is to prevent falls. The correct answers are A and E. Sedating medications to prevent agitation are restraints. The most common reason for restraints is to prevent falls. Side rails to prevent a fall are considered a restraint. Restraints can be ordered by the doctor and also by the registered nurse using a protocol and in an extreme emergency. A mitten restraint is the least restrictive type of restraint. Questions for health promotion and maintenance. Wow, you are really making good progress. You have just completed the Health Promotion and Maintenance section of the NCLEX test review. So, now it is time for some more practice review questions. Remember, you can go back and listen to this section again before or after you do these practice questions. Listen and think about these words of Sandra Bullock. I've learned that success comes in a very prickly package. Whether you choose to accept it or not is up to you. It's what you choose to do with it, the people you choose to surround yourself with. Always choose people that are better than you. Always choose people that challenge you and are smarter than you. Now, question number 1 is, who developed the theory that describes the needs of a partly compensatory, wholly compensatory, and educative patient? A. Dorothea Orem. B. Martha Rogers. C. Madeline Leininger. Or D. Sister Callista Roy. The correct answer is A. Dorothea Orem. Dorothea Orem developed the self-care theory that describes the needs of partly compensatory, wholly compensatory, and educative patients in terms of their abilities to perform self-care activities. Question number 2 is, which age-related change places the elderly population at risk for more side effects and toxicities to medications than the young age groups? A. The elderly's increase in their amount of bodily water. B. The elderly's increase in the amount of bodily fat. C. The elderly's increase in the serum albumin. Or D. The elderly's increase in the gastric acid pH. The correct answer is D. The elderly's increase in the gastric acid pH. The normal changes of the aging process that places elders at risk for more side effects and toxicities to medications than the young age groups are decreases in the amount of bodily water, body fat, and serum albumin, as well as increases in their gastric acid pH. Question number 3 is, you are caring for a 27-year-old female client who tells you that her vaginal area has suddenly changed in color to a blue-purple color. What should you tell this client? A. It is possible that you have a sexually transmitted disease. We will check you for this. B. It is possible that you are pregnant because this Chadwick's sign is a probable sign of pregnancy. C. It is possible that you are pregnant because this Goodell's sign is a probable sign of pregnancy. Or D. It is possible that you are pregnant because this Hager sign is a probable sign of pregnancy. The correct answer is B. It is possible that you are pregnant because this Chadwick's sign is a probable sign of pregnancy. Chadwick's sign is a blue tinge to the vagina and cervix. Question number 4 is, you are caring for a preschool child with a severe upper respiratory infection. Which developmental task is this child coping with, according to Erik Erikson? A. Trust versus mistrust. B. Autonomy versus shame and doubt. C. Initiative versus guilt. Or D. Ego integrity versus despair. The correct answer is C. Initiative versus guilt. According to Erikson, the developmental task for the preschool child is initiative versus guilt. Trust versus mistrust is the developmental task for the infant. The developmental task for the toddler is autonomy versus shame and doubt. The developmental task for the elderly is ego integrity versus despair. Question number 5 is an alternative format question. Place the 5 stages of Sigmund Freud's stages of psychological development in the correct sequential order along the lifespan. A. The latency stage. B. the phallic stage, C, the oral stage, D, the anal stage, E, the genital stage. The correct answer is C, D, B, A, and E in that order of sequence from the first to the last along the lifespan. The 5 stages of Sigmund Freud's stages of psychological development in correct sequential order are: 1. The oral stage, 2. The anal stage, 3. The phallic stage, 4. The latency stage, and 5. The genital stage. Questions for psychosocial integrity. Fabulous work. Pat yourself on the back. You are doing a great job. Keep it up. Meditate on the words of the Dalai Lama. To remain indifferent to the challenges we face is indefensible. If the goal is noble, whether or not it is realized within our lifetime is largely irrelevant. What we must do, therefore, is to strive and persevere and never give up. You have just completed the psychosocial integrity section of the NCLEX test review. So now it is time for some more practice review questions. Question number 1 is: which of the following are nurses mandated to report? A lack of quality care, B, a lack of compassion for patients, C, child abuse when you are sure about it, or D, child abuse that you suspect. The correct answer is D, child abuse that you suspect. Nurses are mandated by law to report any child abuse that you suspect. You do not have to prove it. Question number 2 is: whose theory of grief and loss at the end of life includes bargaining? A, Saunders, B, Kubler-Ross's, C, Engels, or D, Orams? The correct answer is B, Kubler-Ross. Kubler-Ross's stages of grieving in the correct sequential order are: 1. Denial, 2. Anger, 3. Bargaining, 4. Depression, 5. Acceptance. Question number 3 is: you are providing post-mortem care for a deceased patient. What kinds of infection-controlled transmission precautions should you use when the deceased patient has no known communicable diseases? A, standard precautions, B, contact precautions, C, airborne precautions, or D, no precautions are needed because the patient is dead. The correct answer is A, standard precautions. Standard precautions are used for all patients regardless of whether or not they have a known communicable disease. Since post-mortem care entails washing the deceased's body, standard precautions are needed to protect against blood and other bodily fluids, such as feces. Question number 4 is: you are taking care of an emaciated adolescent female who has anorexia nervosa. A group of volunteers dressed as clowns is making rounds in the pediatric ward to provide these pediatric clients with some joy and laughter. When the volunteer clowns enter the room, the patient experiences severe anxiety and distress. What is this client most likely affected with? A, bulimia, B, an electrolyte imbalance, C, a phobia, or D, bipolar disorder? The correct answer is C, a phobia. This patient is demonstrating calorophobia. Calorophobia is a specific phobia related to the fear of clowns. This is a relatively common phobia among those affected with phobias. Question number 5 is an alternative format question. Which of the following statements relating to psychosocial integrity are accurate? Select all that apply. A. A sign of sensory overload is sleep deprivation. B. A sign of sensory deprivation is sleep deprivation. C. A sign of sensory overload is racing thoughts. D. A sign of sensory deprivation is apathy. E. A sign of sensory overload is hallucinations. Or F. A sign of sensory deprivation is delusions. The correct answer is A, C, D, and F. The signs and symptoms of sensory overload include sleep deprivation, racing thoughts, anxiety, muscular tension, fatigue, poor problem-solving skills, poor performance, restlessness, anxiety, and disordered thinking. The signs and symptoms of sensory deprivation include apathy, delusions, hallucinations, a poor attention span, a lack of focus, sleepiness, depression, confusion, and impaired memory and somatic complaints. Questions for basic care and comfort. You are moving right along with this review. We're proud of you, and you should be proud of yourself. According to the words of Margaret Thatcher, look at a day when you are supremely satisfied at the end. It's not a day when you lounge around doing nothing. It's a day you've had everything to do and you've done it. Congratulations. Now is the time to do something and do some review questions relating to basic care and comfort. Question number 1 is, your patient has aphasia and has been given an electronic word board to communicate with others as an assistive device. Which member of the healthcare team most likely provided this patient with this assistive device? A. The physical therapist. B. The occupational therapist. C. The speech therapist. Or D. The prosthetic specialist. The correct answer is C. The speech therapist. Speech therapists provide assistive devices for communication and speech disorders. The physical therapist provides assistive devices for ambulation. The occupational therapist provides assistive devices for the activities of daily living. Prosthetic specialists provide artificial limbs. Question number 2 is, you are caring for a patient who has abdominal distension after surgery. The patient states that they feel bloated and cannot pass gas. The bowel sounds are present in all of the 4 quadrants. What type of enema will this patient most likely get? A. A return flow enema. B. An oil retention enema. C. A cleansing enema. Or D. A medicated enema. The correct answer is A. A return flow enema. A return flow enema is used to expel flatus and decrease abdominal distension and pain, such as often occurs after surgery and general anesthesia. Question number 3 is, you have been assigned to transfer your 84-year-old patient from the bed to the chair. This patient has been on complete bed rest for 3 days. This is the patient's first time up in the chair. Which of the following things should you be most aware of during this transfer? A. The possibility of shortness of breath as the result of the patient's immobility. B. The possibility of urinary incontinence as the result of the patient's immobility. C. The likelihood of contractures secondary to immobility. Or D. The likelihood of dizziness secondary to immobility. The correct answer is D. The likelihood of dizziness secondary to immobility. The likelihood of dizziness secondary to immobility occurs during transfers because orthostatic hypotension is a common complication of immobility. Although shortness of breath, urinary incontinence, and contractures secondary to immobility can occur. These things should be evident before the person rises from the bed. It should not be during their first transfer from the bed to the chair. Question number 4 is, which statement about the application of heat and cold is accurate? A. Heat is a vasodilator. B. Cold is a vasoconstrictor. C. Dry applications are more effective than moist applications. Or D. The actions of heat reverse to that of cold after 20 minutes. The correct answer is D. The actions of heat reverse to that of cold after 20 minutes. Because the use of heat or cold after 20 minutes reverses its effect, heat and cold are applied and then removed after 20 minutes. Heat constricts the vessels, and cold dilates the vessels. Moist applications tend to be more effective than dry heat and cold. Question number 5 is an alternative format question. You are assigned to a patient who needs intake and output measured. When you empty and measure the contents of the urinary drainage bag, it measures 32 ounces. How many milliliters has the patient voided during your shift? Fill in the blank. The correct answer is 960 milliliters because 32 times 30 is 960 milliliters. Questions for pharmacological therapies. Okay, now you are done with the pharmacological therapy section. It is time for some review questions. Here we go. The price of success is hard work, dedication to the job at hand, and the determination that whether we win or lose, we have applied the best of ourselves to the task at hand, according to Vince Lombardi. Question number 1 is, select the pharmacological term that is accurately paired with its description or definition. A. An idiosyncratic effect to a medication is a very unusual response that is peculiar to a specific patient. B. An idiosyncratic effect to a medication occurs when the incorrect medication has been given. C. An adverse effect is not as severe as a side effect to a medication. Or D. An inhibiting effect of medications occur when the drug is not metabolized. The correct answer is A. An idiosyncratic effect to a medication is a very unusual response that is peculiar to a specific patient. Idiosyncratic effects are often not even referenced in reliable drug literature. They are highly unusual. An adverse effect is more severe than a side effect to a medication. Some adverse effects are life-threatening. An inhibiting effect of medications occur when 2 or more drugs are taken at one time, and the effects of one or both of the medications are decreased as the result of the presence of the other medication. Question number 2 is an alternative format question. You have to administer 60 cc's of D5 plus water every hour. The infusion set delivers 60 cc's per drop. How many drops per minute will you infuse? Fill in the blank. The correct answer is 60 drops per minute. Question number 3 is also an alternative format question. The doctor's order states that the client will get 800 cc's of fluid over 10 hours. You begin the infusion at 10 a.m. with a 1-liter bag of the ordered fluid. How much should be left in the 1-liter bag of fluid after 4 p.m.? Fill in the blank. The correct answer is 520 cc's. When the doctor's order states that the client will get 800 cc's of fluid over 10 hours, the patient will get 480 cc's from 10 a.m. to 4 p.m., which is 6 hours. The next step is to subtract 480 cc's from 1,000 cc's. The answer is 520 cc's remaining at 4 p.m. Question number 4 is, you will be administering metoprolol PO to a patient who has just returned from surgery. What should you do prior to the administration of this oral medication? A. Check the patient for any postoperative bleeding. B. Monitor the patient's pulse rate. C. Check the patient's blood pressure. Or D. Ensure that the patient is voiding. The correct answer is C. Check the patient's blood pressure. Metoprolol is an antihypertensive medication that is used to treat high blood pressure. Nurses must check the patient's blood pressure before giving an antihypertensive in the same manner that they check blood glucose levels before administering insulin, and they check the apical heart rate before administering digoxin. Question number 5 is another alternative format question. Your patient is getting NPH insulin and regular insulin at 7 a.m. List the steps for drawing up and mixing NPH and regular insulins in the same syringe in correct sequential order. A. Instill the amount of air that is equal to the regular insulin dose into the regular insulin bottle. B. Withdraw the NPH dose. C. Withdraw the regular insulin dose. D. Instill an amount of air into the NPH bottle that is equal to the NPH dose. The correct answer is D, A, C, and B. The procedure for mixing NPH and regular insulin is to instill an amount of air into the NPH bottle that is equal to the NPH dose. Then, inject an amount of air into the regular insulin bottle that is equal to the regular insulin dose. Now, withdraw the regular insulin dose. Finally, withdraw the NPH dose using the same insulin syringe. The regular insulin is drawn up first, so this often life-saving, short-acting insulin is not contaminated with NPH insulin, which is longer-acting. Questions for reduction of risk potential. You are almost done with this review course. After these questions, you will have only one more section to go. Do not give up now. You're near the finish line. Football is like life. It requires perseverance, self-denial, hard work, sacrifice, dedication, and respect, according to Vince Lombardi, a famous football coach. Now, here are your practice questions for the reduction of risk potential. I know you can do it. Question number 1 is, your patient's laboratory values have just arrived on the nursing unit. What should you do when you see these laboratory results? Sodium of 140 milliequivalents per liter, potassium of 4.6 milliequivalents per liter, creatine of 1.1 milligrams per deciliter, chloride of 115 milliequivalents per liter. A. Simply place these results in the medical record because they are all within normal limits. B. Report the potassium level because it is abnormal. C. Report the sodium level because it is abnormal. Or D. Report the chloride level because it is abnormal. The correct answer is D. Report the chloride level because it is abnormal. The normal range of chloride is from 98 to 105 milliequivalents per liter. All of the other laboratory values for this patient are normal. The normal level of potassium ranges from 3.5 to 5.5. The normal range of sodium is from 135 to 145. The normal range of chloride is from 95 to 105. The normal range for bicarbonate is from 22 to 25. And the normal range for calcium is from 4.5 to 5.5. Question number 2 is, which laboratory test is used for the diagnosis of infections? A. C-reactive protein. B. B-reactive protein. C. Blood pH. Or D. creatine level. The correct answer is A, C-reactive protein. C-active protein, the erythrocyte sedimentation rate, the white blood cell count, and the plasma viscosity are tests that are done to diagnose the presence of infection. Question number 3 is, you are observing another LPN who is performing venipuncture to get a blood sample. Which of these actions by the LPN is not correct? A. The LPN puts the tourniquet about 3 inches above the selected site. B. The LPN inserts the needle at a 15-degree angle into the skin. C. The LPN asks the patient to pump their hand so the vein fills. Or D. The LPN preps the desired site with a circular motion outward. The correct answer is C. The LPN asks the patient to pump their hand. The patient should not pump their hand when the nurse is drawing a peripheral blood sample. The LPN in question correctly placed the tourniquet 3 inches above the selected site. The LPN also inserted the needle at the correct 15-degree angle into the skin. The LPN also correctly prepped the site in a circular motion, beginning at the desired site and then moving outward from the cleanest area to the dirtiest area. Question number 4 is, which of the following is a sign of severe preeclampsia? A. Hypercoagulation. B. Elevated red blood cell count. C. Elevated white blood count. Or D. Hemolysis. The correct answer is D. Hemolysis. The signs of severe preeclampsia can be easily remembered with the HELLP acronym. H is for hemolysis. EL is for elevated liver enzymes. LP is for low platelet count, which indicates poor clotting, not hypercoagulation. Question number 5 is an alternative format question. Place these levels of consciousness in the correct sequential order from the most alert to the least alert. A. Confused. B. Stuporous. C. Comatose. D. Lethargic. E. Obtunded. F. Alert. The correct answer is F, A, D, E, B, and C. The levels of consciousness in the correct sequential order from the most alert to the least alert are 1. Alert. 2. Confused. 3. Lethargic. 4. Obtunded. 5. Stuporous. And 6. Comatose. Questions for physiological adaptation. It is time to celebrate. You have completed this audio review. You should be proud of yourself and your accomplishment. But before I leave you, I have a couple of reminders and ending thoughts for you. We care, and we want you to succeed. We want you to waltz and not reluctantly walk into your NCLEX testing center. Hold your head high and give yourself positive self-thoughts. Say, I am a winner. I can do it. I will succeed. Dennis Waitley is quoted as saying, "The reason most people never reach their goals is that they don't define them, learn about them, or even seriously consider them as believable or achievable. Winners can tell you where they are going, what they plan to do along the way, and who will be sharing the adventure with them." Bertie C. Forbes said, "History has demonstrated that the most notable winners usually encountered heartbreaking obstacles before they triumphed. They won because they refused to become discouraged by their defeats." And William Feathers said, "The prizes go to those who meet emergencies successfully. And the way to meet emergencies is to do each daily task the best we can. To act as though the eye of opportunity were always upon us. In the 100-yard race, The winner doesn't cross the tape like a dozen strides ahead of the field. He wins by inches. So we find it in ordinary business life. The big things that come our way are seldom the result of long thought or careful planning, but rather they are the fruit of seed planted in the daily routine of our work. Now, here are your last and final 5 practice questions in terms of physiological adaptation. Question number 1 is, you are caring for a patient who has a hemovac drain. At the end of the shift, you must empty the drain. What things should you observe when you empty the drain? A. The thickness of the sputum. B. The color of the sputum. C. The amount of serosanguinous drainage, or D. The amount of cerebrospinal fluid drainage. The correct answer is C. The amount of serosanguinous drainage. Hemovac drains are wound drains. When a hemovac drain is emptied, the nurse measures the amount of drainage, including serosanguinous drainage, and other characteristics of wound drainage, such as its color. Hemovac drains are wound drains. Hemovac drains do not collect sputum or cerebrospinal fluid drainage. Question number 2 is, your patient has damage to the hypothalamus secondary to cerebrovascular accident. What is this patient most at risk for? A. Hypothermia. B. Dilation of the pupils. C. Right-sided weakness. Or D. Aphasia. The correct answer is A. Hypothermia. A client with damage to the hypothalamus, secondary to a cerebrovascular accident, is at risk for hyperthermia. The hypothalamus is the body's thermostat that controls bodily temperature. Damage to this thermostat can lead to hyperthermia or a high bodily temperature. Question number 3 is, which of the following patients are the best candidate for ostomy irrigation for the control of fecal material? A. A 26-year-old patient with a transverse colonostomy. B. A middle-aged adult with an ileostomy. C. A 76-year-old patient with a sigmoid colon type of ostomy. Or D. An adolescent with an ileostomy. The correct answer is C. A 76-year-old patient with a sigmoid colon type of ostomy. Patients with a sigmoid colon type of ostomy are good candidates for irrigation. Irrigation eliminates the need for a pouch because the ostomy is near the end of the intestinal tract. The ostomy near the end of the intestinal tract means that the patient's stool is more formed and less frequent than other types of ostomies. Question number 4 is, your patient is decerebrate. What is this patient most likely affected with? A. The early stage of increased cranial pressure. B. The late stage of increased cranial pressure. C. The late stage of an ectopic pregnancy. Or D. The early stage of an ectopic pregnancy. The correct answer is B. The late stage of increased cranial pressure. The late stage of increased cranial pressure is characterized with decerebrate posturing, decorticate posturing, fever, vomiting, the hiccups, a widening pulse pressure, Cushing's reflex, and Cheyne-Stokes respirations. Question number 5 is an alternative format question. Select the fluid or electrolyte imbalance that is accurately paired with its sign or symptom. Select all that apply. A. Hypervolemia, crackles. B. Hypovolemia, hypotension. C. Hypokalemia, cardiac arrhythmias. D. Hyperkalemia, cardiac arrhythmias. E. Hypoatremia, muscular weakness. F. Hypernatremia, agitation. The correct answer is A, B, C, D, E, and F. A sign of hypervolemia is lung crackles. A sign of hypovolemia is hypotension. A sign of hypokalemia and hyperkalemia is cardiac arrhythmias. Muscular weakness is a sign of hyponatremia. Agitation is a sign of hypernatremia.
Audio Learn. Welcome to an audio review of pharmacy drugs in the United States. Research has shown that learning in different formats such as audio can help you remember information better on the test day. The drugs are grouped into categories. First, you'll be provided with an overview of all drugs in that category. Then, the script will give details on specific drugs within that category. You'll be provided with the drug's name and brand name. You will also be given what the drug does, what the drug treats, and any side effects. The drug's name will be repeated many times to help your memory. You'll likely want to listen to the audio review more than once. The first time, though, you should listen and try to absorb the information. Take notes on anything you're unsure of. During the second listen, you may find it helpful to take notes on 3x5 cards. During subsequent reviews, you can test yourself as the material is read. As the name of a drug is read, see if you can remember all the important details about the drug. If not, you need more review. Here are the different categories of drugs you'll learn about. Adrenergic drugs, analgesics and anti-inflammatories, anti-anxiety agents, antibiotics, antibacterials, anti-infectives, antihelminthics, antifungals, anticholinergics, anticoagulants and thrombolytic agents, anticonvulsants, antidepressants, antidiabetics, antidiuretics, anti-gout agents, antihistamines, antihypertensives, anti-neoplastic agents, anti-Parkinson agents, antipsychotics, antivirals, blocking agents, bronchodilators and anti-asthmatics, central nervous system stimulants, cholinergic agents, corticosteroids, glucocorticoids, and mineralocorticoids, diuretics and loop diuretics, hemostatics, hormones including estrogen, anti-estrogen, antithyroid, and progesterone products, muscle relaxants, non-steroidal anti-inflammatory drugs, sulfonylurea, sympathomimetics, and vitamins. Let's get started. Welcome to the section on adrenergic drugs. Adrenergic drugs act by inducing the secretion of adrenaline or substances with similar activity. Adrenaline is a hormone produced by the adrenal medulla in mammals. Adrenaline can be produced synthetically for medical purposes. Adrenergic drugs do this. Adrenaline is secreted by the adrenal medulla in responses to low blood glucose, exercise, and stress. Adrenaline causes a breakdown of glycogen to glucose in the liver and encourages the release of fatty acids from adipose tissue. This causes vasodilation of the small arteries within the muscle and increases cardiac output. Here's an overview of adrenergic drugs. The first drug in this category is metaproterenol. Metaproterenol sulfate is also known as Alupent. Metaproterenol sulfate is a bronchodilator and a direct-acting adrenergic agent used to stimulate the beta-2 receptors. This results in relaxation of smooth muscles of the bronchial tree, as well as peripheral vasodilation. Metoprolol sulfate is used as a bronchodilator for asthma, bronchitis, emphysema, and other conditions associated with reversible bronchospasm. Metoprolol is also used in the treatment of acute asthmatic attacks in children over 6. The side effects of metoprolol use include aggravated asthma attacks, nasal congestion, hoarseness, diarrhea, rash, fatigue, and backache. The next drug is epinephrine. Epinephrine is a direct-acting adrenergic agent. Epinephrine is used to stimulate the alpha, beta-1, and beta-2 receptors. This results in sympathomimetic stimulation, pressor effects, cardiac stimulation, bronchodilation, and decongestion. In its inhalation form, epinephrine is used for the temporary relief of wheezing, shortness of breath, and tightness of the chest due to bronchial asthma. Epinephrine is used to relieve respiratory distress during acute bronchial asthma attacks. The injection form of epinephrine is also used in cases of reversible bronchospasm in chronic bronchitis, emphysema, and other obstructive pulmonary disease. Epinephrine is also used during severe acute anaphylactic reactions, such as anaphylactic shock, cardiac arrest, allergic reactions caused by bee stings, allergic reactions due to exposure to pollens, dusts, molds, foods, and severe life-threatening asthma attacks to restore cardiac rhythm. Epinephrine can be used during ocular surgery to induce mydriasis and treat ocular hypertension. Epinephrine is also used topically to control bleeding. Cardiovascular side effects of epinephrine use include fatal ventricular fibrillation, cerebral or subarachnoid hemorrhage, and obstruction of the central retinal artery. Other side effects of epinephrine may include transient stinging or burning during administration, conjunctival hyperemia, ocular discomfort or dysfunction, disorientation, memory impairment, panic, hallucinations, suicidal or homicidal tendencies, or schizophrenic behavior. Prolonged use or overdose of epinephrine may cause elevated serum lactic acid with severe metabolic acidosis. When administered via injection, bleeding, urticaria, wheal formation, and pain may occur at the injection site. Repeated injections at the same site may cause necrosis from vascular constriction. The next drug is ephedrine sulfate. Ephedrine sulfate is a direct and indirect acting adrenergic agent. Ephedrine sulfate triggers the release of norepinephrine from synaptic storage sites. Ephedrine sulfate affects alpha, beta-1, and beta-2 receptors. This causes increased blood pressure due to arteriolar constriction and cardiac stimulation. It causes bronchodilation, relaxation of the gastrointestinal tract, nasal decongestion, mydriasis, and increased tone of the bladder and vesicle sphincter. Ephedrine temporarily relieves shortness of breath, tightness of the chest, and wheezing due to bronchial asthma. Side effects of ephedrine use include nervousness, confusion, delirium, hallucinations, anxiety, precordial pain, and painful urination. Excessive use or overdose may cause hypertension sufficient to result in cerebral hemorrhage. Welcome to the section on analgesics and anti-inflammatories. Analgesics refer to drugs which relieve pain without causing loss of consciousness. Anti-inflammatories are used to counteract or suppress the classic signs of inflammation. These include acute pain, heat, redness, swelling, and loss of function. Histologically, inflammation involves a complex series of events. This includes the dilation of arterioles, capillaries, and venules, increased permeability and blood flow, and the exudation of fluids. Here's an overview of analgesics and anti-inflammatories. Acetaminophen. Acetaminophen is available under the brand name Tylenol. Acetaminophen is a para-aminophenol type of non-narcotic analgesic. Acetaminophen reduces fever by affecting the hypothalamus. This leads to sweating and vasodilation. This also inhibits the effect of pyrogens on the hypothalamic heat regulating centers. Acetaminophen is used in the control of pain due to headache, earache, dysmenorrhea, arthralgia, myalgia, musculoskeletal pain, arthritis, immunization, teething, and tonsillectomy. Acetaminophen is also used to reduce fever in bacterial or viral infections. Acetaminophen can be used as a substitute for aspirin in upper gastrointestinal disease, aspirin allergy, bleeding disorders, patients on anticoagulant therapy, and gouty arthritis. There are few side effects when acetaminophen is taken in normal therapeutic doses. However, chronic and even acute toxicity may develop after long symptom-free usage. Diclofenac potassium. Diclofenac is also available under the name Cataflam. Diclofenac is a non-steroidal anti-inflammatory analgesic. Diclofenac is available as both the immediate-release potassium and delayed-release sodium salts. Diclofenac is used as an analgesic in the treatment of primary dysmenorrhea, rheumatoid arthritis, osteoarthritis, and ankylosing spondylitis. Diclofenac can be used ophthalmically as a treatment for postoperative inflammation following cataract or corneal refractive surgery. Side effects following ophthalmic use of diclofenac can include keratitis, increased intraocular pressure, viral infections, transient burning and stinging on administration. Sulindac. Sulindac is available under the brand name Clinaril. Sulindac is a non-steroidal anti-inflammatory drug used in the treatment of acute and chronic rheumatoid arthritis, osteoarthritis, ankylosing spondylitis, acute gouty arthritis, tendinitis, and bursitis. Side effects of Sulindac use include hypersensitivity, pancreatitis, gastrointestinal pain, maculopapular rash, stupor, hypotension, and diminished urine output. Indomethacin. Indomethacin is also available under the name Indocin. Indomethacin is also a non-steroidal anti-inflammatory drug, analgesic, and antipyretic. Indomethacin is used as treatment in cases of moderate to severe rheumatoid arthritis, osteoarthritis, and ankylosing spondylitis. Indomethacin can also be used to treat acute gouty arthritis, acute tendinitis, and bursitis. There are no serious side effects associated with indomethacin use. Oxaprozin. Oxaprozin is also available under the brand name Daypro. Oxaprozin is a non-steroidal anti-inflammatory drug used in the acute and chronic management of rheumatoid arthritis and osteoarthritis. Side effects of oxaprozin use include blood in the vomit or bloody black or tarry stools, allergic reactions, muscle cramps, numbness, or tingling and rapid weight gain. Piroxicam. Piroxicam is also available under the brand name Feldene. Piroxicam is a non-steroidal anti-inflammatory drug comparable to aspirin. However, piroxicam has fewer gastrointestinal side effects and less tinnitus. Piroxicam is used in the acute and chronic treatment of rheumatoid arthritis and osteoarthritis. Piroxicam's effects in the treatment of juvenile rheumatoid arthritis, primary dysmenorrhea, and sunburn are currently being researched. Side effects of piroxicam use include bloody, black, or tarry stools, allergic reactions, muscle cramps, dizziness, and headache. Acetyl-salicylic acid. Acetyl-salicylic acid is also available under the brand name aspirin or Bayer Children's aspirin. Acetyl-salicylic acid is a non-narcotic analgesic, antipyretic, and anti-inflammatory agent. Acetyl-salicylic acid exhibits antipyretic, anti-inflammatory, and analgesic effects. Acetyl-salicylic acid is used to treat pain arising from integumental structures, neuralgias, myalgias, arthralgias, headache, dysmenorrhea, and similar types of pain. Acetyl-salicylic acid is also used as an anti-inflammatory in cases of arthritis, osteoarthritis, acute rheumatic fever, gout, and many other conditions. There are several dose-related side effects of acetyl-salicylic acid use. These include dyspepsia, anorexia, nausea, occult blood loss, epigastric discomfort, massive gastrointestinal bleeding, potentiation of peptic ulcer, asthma-like symptoms, skin rashes, prolongation of bleeding time, decreased plasma iron levels, thirst, fever, and dimness of vision. Aspirin should not be used in children under adolescent age due to the danger of Reye's disease. Naproxen. Naproxen is also available under the brand name Naprosyn. Naproxen is a non-steroidal anti-inflammatory analgesic. Naproxen is used to treat mild to moderate pain and inflammation of musculoskeletal and soft tissue. Side effects of naproxen use may include constipation, diarrhea, dizziness, drowsiness, gas, and severe allergic reaction. Quinidine bisulfate. Quinidine is also available under the brand name Biquindurols. Quinidine is a Class 1A antiarrhythmic. Quinidine reduces the excitability of the heart and depresses conduction velocity and contractility. Quinidine is used to treat premature atrial, AV junctional atrial flutter, and ventricular contractions. Side effects of quinidine use may include the widening of QRS complex, hypotension, cardiovascular complications, torsade de pointe, paradoxical tachycardia, arterial embolism, complete AV block, abdominal pain, dementia, ataxia, depression, rash, photosensitivity, and pigmentation abnormalities. Naloxone hydrochloride. Naloxone hydrochloride is also available under the brand name Narcan. Naloxone hydrochloride is used in the treatment of respiratory depression induced by natural and synthetic narcotics. These narcotics include butorphanol, methadone, nalbuphine, pentazocine, and propoxyphene. Side effects may include sweating, hypertension, and tremors. Codeine phosphate. Codeine is a morphine-type narcotic analgesic. Codeine is used primarily in the relief of mild to moderate pain. Codeine can be administered via oral solution, tablets, intramuscular injection, or IV. Codeine diazoxide. Diazoxide is also available under the brand name Dalgan. Diazoxide is a narcotic agonist and antagonist analgesic. Side effects may include sedation, dizziness, anxiety, crying, sleep disturbance, delusions, respiratory depression, irregular heart or pulse, hypertension, chest pain, thrombophlebitis, abdominal discomfort, skin rash, blurred vision, congestion of the ears, low hemoglobin, muscle cramps or aches, and slurred speech. Fentanyl citrate. Fentanyl citrate is also available under the brand name Sublimase. Fentanyl citrate is a morphine-type narcotic analgesic. The action and kinetics of fentanyl citrate are similar to those of morphine and meperidine. Fentanyl is used in the pre-anesthetic medication, induction, and maintenance of anesthesia during the short duration and immediate postoperative period. Side effects include skeletal and thoracic muscle rigidity, particularly after rapid IV administration. Other side effects are bradycardia, seizures, and diaphoresis. Hydromorphone hydrochloride. Hydromorphone hydrochloride is also available under the brand name Dilaudid. Hydromorphine hydrochloride is a morphine-type narcotic analgesic. It is used in the treatment of moderate to severe pain. Hydromorphone hydrochloride can be administered via liquid, tablets, and suppositories. Nystagmus is a known side effect of hydromorphone use. Meperidine hydrochloride. Meperidine hydrochloride is also available under the name Demerol hydrochloride. Meperidine hydrochloride is a synthetic narcotic analgesic which is 1/10 as potent as morphine. It is used to treat moderate to severe pain, particularly during minor surgery. Side effects may include transient hallucinations, transient hypotension in high doses, and visual disturbances. The active metabolite may accumulate in renal dysfunction, leading to an increased risk of central nervous system toxicity. Methadone hydrochloride. Methadone hydrochloride is also available under the brand name Dolafine. Methadone hydrochloride is a morphine-type narcotic analgesic which produces only mild euphoria. Methadone is used as a heroin withdrawal substitute. Methadone hydrochloride is primarily used to treat severe pain. Methadone hydrochloride may also be used in the detoxification and maintenance of narcotic dependence. Side effects include marked constipation, excessive sweating, pulmonary edema, and choreic movements. Morphine. Morphine is also available under the brand name Morphitek. Morphine is a narcotic analgesic used intrathecally or epidurally. Morphine can also be used by continuous IV infusion to treat acute or chronic pain. Nalbuphine. Nalbuphine hydrochloride is also available under the brand name Nubain. It is a narcotic agonist and antagonist used in moderate to severe pain. Nalbuphine hydrochloride is also used in preoperative analgesia, anesthesia adjunct, and obstetric analgesia. Side effects may include sedation, psychologic reactions, cramps, dry mouth, bitter taste, dyspepsia, skin irritation, blurred vision, difficulty with speech, and urinary frequency. Naltrexone. Naltrexone is also available under the brand name Revia. Naltrexone is a narcotic antagonist which competitively binds to opiate receptors, reversing or preventing the effects of narcotics. Naltrexone is primarily used to prevent narcotic use in former addicts. Naltrexone is also used as an adjunct to psychosocial treatment for alcoholism. Side effects may include headache, anxiety, sleep disorders, change in energy level, depression, hallucinations, diarrhea, constipation, ulcers, increased blood pressure, changes in the EKG, palpitations, delayed ejaculation, increased urinary frequency or urinary discomfort, sinus trouble, rash, joint or muscle pain, blurred vision or eye pain, painful or clogged ears, chills, swollen glands, inguinal pain, headache, and fever. Oxycodone hydrochloride. Oxycodone hydrochloride is also available under the brand name roxicodone. Oxycodone hydrochloride is a morphine-type narcotic analgesic used to relieve moderate to severe pain. Propoxyphene hydrochloride. Propoxyphene is also available under the brand name Darvon. Propoxyphene is a narcotic analgesic used for the treatment of mild to moderate pain. Side effects may include constipation, abdominal pain, sedation, dizziness, headache, weakness, euphoria, skin rashes, and visual disturbance. Sufentanil. Sufentanil is also available under the brand name Sulfenta. Sulfentanil is a narcotic analgesic used as an adjunct to maintain balanced general anesthesia. Sulfentanil is also used to induce and maintain general anesthesia. Side effects may include erythema, chills, intraoperative muscle movement, and extended postoperative respiratory depression. Mesalamine. Mesalamine is also available under the brand name Asacol, Pentasa, and Roesa. Mesalamine is an anti-inflammatory agent. Mesalamine is used to maintain remission and treatment of mild to moderate active ulcerative colitis. Mesalamine may also be used in the treatment of active mild to moderate distal ulcerative colitis, proctosigmoiditis, or proctitis. Of the numerous side effects of mesalamine use, anaphylaxis, fatal myocarditis, and agranulocytosis are the most severe. Osalazine. Osalazine sodium is also available under the brand name Dipentum. Osalazine sodium is an anti-inflammatory drug. It is used to maintain remission of ulcerative colitis in patients who cannot take sulfasalazine. Side effects may include diarrhea or nausea, bloating, vomiting, headache, drowsiness, vertigo, arthralgia, rash, and upper respiratory tract infection. Welcome to the section on anti-anxiety agents. Anti-anxiety agents include anxiolytics and minor tranquilizers. Anti-anxiety agents are instrumental in the treatment of anxiety, agitation, or tension. Anti-anxiety agents are able to reduce anxiety at doses which do not cause excessive sedation. Certain anti-anxiety agents may also be effective as anticonvulsants, muscle relaxants, or anesthesia adjuvants. Adrenergic beta antagonists are commonly used as the symptomatic treatment of anxiety. Substances with a benzodiazepine ring structures are widely used to treat anxiety and neurosis. Drugs in this class generally have sedative or weak hypnotic properties. Benzodiazepines may also be effective as muscle relaxants, anticonvulsants, and anesthesia adjuvants. Here's an overview of anti-anxiety agents. Alprazolam. Alprazolam is also available under the brand name Xanax. Alprazolam is an anti-anxiety agent used in the treatment of anxiety. Alprazolam also treats anxiety associated with depression with or without agoraphobia. It is available in tablet form. Side effects of alprazolam use include attention disturbance, blurred vision, changes in weight, clumsiness, constipation, decreased appetite, and decreased sex drive. Buspirone hydrochloride. Buspirone hydrochloride is also available under the brand name Buspar. It is a non-benzodiazepine anti-anxiety agent. Buspirone is used in the treatment of anxiety disorders. It is also used in short-term treatment to relieve the symptoms of anxiety due to motor tension, apprehension, autonomic hyperactivity, or hyperattentiveness. Side effects may include dizziness, sleep disturbance, dysphoria, noise intolerance, euphoria, depersonalization, hallucinations, suicidal ideation, seizures, depression, nonspecific chest pain, hypotension, abdominal distress, dry mouth, redness, itching of the eyes, eye pain, skin rash, numbness, urinary hesitancy or frequency, enuresis, amenorrhea, pelvic inflammatory disease, tinnitus, muscle aches or pains, headache, hyperventilation, hair loss, galactorrhea, decreased or increased libido, and delayed ejaculation. Clorazepate dipotassium. Clorazepate dipotassium is also available under the brand names Tranxene T and Tranxene SD. It is a benzodiazepine type of anti-anxiety agent and anticonvulsant. Clorazepate dipotassium is used in the treatment of anxiety, tension, and in cases of acute alcohol withdrawal. Clorazepate dipotassium may also be used as an adjunct in the treatment of seizures. Side effects of clorazepate dipotassium use include blurred vision, depression, difficulty in sleeping or falling asleep, dizziness, drowsiness, dry mouth, double vision, fatigue, and genital and urinary tract disorders. Diazepam. Diazepam is also available under the brand name Valium. Diazepam is an anti-anxiety agent, anticonvulsant, and skeletal muscle relaxant. Diazepam is used in the treatment of anxiety, tension, alcohol withdrawal, and status epilepticus. Diazepam may also be used as a muscle relaxant, a sedative in dentistry, and as an adjunct to treat seizure disorders. Side effects of diazepam use include blurred vision, dizziness, drowsiness, dry mouth, fatigue, headaches, and incoordination. The next drug is lorazepam. Lorazepam is also available under the brand name Ativan. Lorazepam is a benzodiazepine anti-anxiety agent. Lorazepam is used in the treatment of anxiety, tension, anxiety with depression, insomnia, and acute alcohol withdrawal symptoms. Lorazepam may also be used as an amnesic agent, anticonvulsant, anti-tremor drug, an adjunct to skeletal muscle relaxants, pre-anesthetic medication, as an adjunct to endoscopic procedures, and in the treatment of status epilepticus. Side effects of lorazepam use include clumsiness, dizziness, drowsiness, headache, lightheadedness, unsteadiness, and weakness. Meprobamate. Meprobamate is also available under the brand names Equinil, Milltown 200, 400, and 600. Meprobamate is a non-diazepine anti-anxiety agent. Meprobamate is used in the short-term treatment of anxiety. Side effects may include ataxia, drowsiness, dizziness, headache, paradoxical excitement, euphoria, slurred speech, diarrhea, visual disturbance, allergic reactions including hematologic and dermatologic symptoms, and paresthesias. Oxazepam. Oxazepam is also available under the brand name Serax. Oxazepam is a benzodiazepine anti-anxiety agent used in the treatment of anxiety, tension, and anxiety with depression. Oxazepam may also be used as an adjunct in the treatment of acute alcohol withdrawal. Side effects may include paradoxical reactions characterized by sleep disorders and hyperexcitability during the first weeks of therapy. Hypotension may occur after parenteral administration. Welcome to the section on antibiotics, antibacterials, anti-infectives, antihelminthics, and antifungals. Antibiotics, antibacterials, antifungals, and anti-infectives are drugs that are capable of killing infectious agents, including bacterial and fungal agents. These drugs can also prevent infectious agents from spreading and causing infection. Antihelminthics are drugs or agents which are destructive to worms. Antihelminthics are used to remove internal parasitic worms in both animals and humans. Imipenem cilastatin sodium. Imipenem cilastatin sodium is also available under the brand name Primaxin. Imipenem cilastatin sodium is an antibiotic combined with an inhibitor of dehydropeptidase 1. Imipenem cilastatin inhibits cell wall synthesis. It is also bactericidal against a wide range of gram-positive and gram-negative organisms. Imipenem cilastatin sodium is also a bactericidal agent against a wide range of gram-positive and gram-negative organisms. It is also stable in the presence of beta-lactamase. Administered intravenously, it is used to treat the following serious infections: lower respiratory tract, urinary tract, gynecologic, skin and skin structures, bone and joint, endocarditis, intra-abdominal and bacterial septicemia. Imipenem cilastatin also treats infections which are caused by more than one agent, as well as infections which are resistant to aminoglycosides, cephalosporins, or penicillins. Side effects of imipenem cilastatin sodium include pseudomembranous colitis, nausea, diarrhea, hemorrhagic colitis, gastroenteritis, glossitis, pharyngeal pain, tongue papillary hypertrophy, hepatitis, jaundice, staining of the teeth or tongue, fever, confusion, seizures, encephalopathy, tremor, and psychic disturbances, as well as palpitations, rash, toxic epidermal necrolysis, and Stevens-Johnson syndrome. Sulbactam sodium. Sulbactam sodium is also called ampicillin sodium. Ampicillin sodium is also available under the brand name Unicin. It is an antibiotic penicillin used in the treatment of infections caused by beta-lactamase-producing bacteria. These infections produce strains of skin and skin structure infections caused by Staphylococcus aureus, Escherichia coli, Klebsiella species including Klebsiella pneumonia, Proteus mirabilis, Bacteroides fragilis, Enterobacteria species, and Acinetobacter chalcoceticus. Side effects of ampicillin use include pain and thrombophlebitis at the site of injection, diarrhea, abdominal distension, glossitis, fatigue, headache, dysuria, urinary retention, itching, chest pain, edema, facial swelling, erythema, chills, tightness in the throat, epistaxis or nosebleed, substernal pain, mucosal bleeding, and candidiasis. Ciprofloxacin hydrochloride. Ciprofloxacin hydrochloride is also available under the brand name Cipro. It is a fluoroquinoline anti-infective which is effective against both gram-positive and gram-negative organisms. Systemically, ciprofloxacin hydrochloride is used in the treatment of urinary tract infections caused by Escherichia coli, Enterobacter cloaca, Citrobacter diversus, Citrobacter freundii, Klebsiella pneumonia, Proteus mirabilis, Providencia netgeri, Pseudomonas aeruginosa, Morganella morganii, Serratia marcescens, Serratia epidermidis, and Streptococcus faecalis. Ciprofloxacin hydrochloride is also used to treat uncomplicated cervical and urethral gonorrhea due to Neisseria gonorrhea, chancroid due to Haemophilus ducreyi, and uncomplicated or disseminated gonococcal infections. Ciprofloxacin is also useful in the treatment of mild to moderate chronic bacterial prostatitis due to E. coli or P. mirabilis, mild to moderate sinusitis due to strep pneumonia, H. influenza, or M. catarrhalis, and lower respiratory tract infections that are caused by E. coli, E. cloacae, K. pneumonia, P. mirabilis, P. aeruginosa, and Haemophilus influenza, as well as parainfluenza and Streptococcus pneumonia. Ciprofloxacin is often used in cases of bone and joint infections due to E. cloacae, P. aeruginosa, and S. marcescens, as well as skin and skin structure infections caused by E. coli, E. cloacae, Citrobacter freundii, M. morganii, K. pneumonia, P. aeruginosa, P. mirabilis, Proteus vulgaris, Providencia stewarti, Staphylococcus pyogenes, Staphylococcus epidermidis, and penicillinase and non-penicillinase producing strains of Staphylococcus aureus. Ophthalmically, ciprofloxacin is used to treat superficial ocular infections resulting from Staphylococcus and Streptococcus, E. coli, Haemophilus ducreyi, Haemophilus influenza, Haemophilus parainfluenza, Klebsiella pneumonia, Neisseria gonorrhea, and Proteus, Klebsiella, Acinetobacter chalcocecus, Enterobacter aerogenes, Pseudomonas aeruginosa, Serratia marcescens, Chlamydia trachomatis vibrio, and Providentia species. Side effects of ciprofloxacin use may include abdominal pain, diarrhea, dry or painful mouth, intestinal perforation, anorexia, gastrointestinal bleeding, headache, fatigue, hallucinations, depersonalization, seizures, nephritis, hematuria, cylindruria, renal failure, urinary retention, polyuria, vaginitis, urethral bleeding, acidosis, rash, toxic epidermal necrolysis, Stevens-Johnson syndrome, superinfections, cholestatic jaundice, hearing loss, and dysphagia. Ophthalmic side effects may include blurred or disturbed vision, double vision, eye pain, and nystagmus. Norfloxacin. Norfloxacin is also available under the brand name Noroxin. Norfloxacin is a fluoroquinoline anti-infective. It inhibits bacterial DNA, making it active against gram-positive and gram-negative organisms. Norfloxacin is administered in tablets to treat uncomplicated urinary tract infections due to E. coli, K. pneumonia, or P. mirabilis. Superficial and acute ocular infections are treated with ophthalmic solution. Side effects of norfloxacin use include diarrhea, pseudomembranous colitis, stomatitis, headache, depression, insomnia, psychoses, decreased hematocrit, eosinophilia, leukopenia, neutropenia, toxic epidermal necrolysis, erythema, Stevens-Johnson syndrome, visual disturbances, hearing loss, hepatitis, pancreatitis, and arthralgia. In rare cases, myoclonus can be a side effect. Ofloxacin. Ofloxacin is also available under the brand name Floxin. Ofloxacin is a fluoroquinoline antibacterial and is effective against a wide range of gram-positive and gram-negative aerobic and anaerobic bacteria. Systemically, ofloxacin is used to treat pneumonia and acute bacterial exacerbations of chronic bronchitis or community-acquired pneumonia due to Haemophilus influenza or Streptococcus pneumonia. Ofloxacin is also used in cases of acute, uncomplicated urethral and cervical gonorrhea due to Neisseria gonorrhea. Ofloxacin is also used in instances of non-gonococcal urethritis and cervicitis due to Chlamydia trachomatis. Ophthalmically, ofloxacin may be used to treat conjunctivitis caused by Staph aureus, Staph epidermidis, S. pneumonia, Enterobacteria cloacae, Haemophilus influenza, Proteus mirabilis, and Proteus aeruginosa. Side effects of ofloxacin use may include nausea, diarrhea, pseudomembranous colitis, dysgeusia, headache, seizures, sleep disorders, cognitive change, dream abnormality, hallucinations, and vertigo. Cardiovascular side effects may include chest pain, edema, hypertension, palpitations, or vasodilation. Meropenem. Meropenem is also available under the brand name Merom I-4. Meropenem is a broad-spectrum carbapenem antibiotic. It is used in cases of complicated appendicitis and peritonitis resulting from Escherichia coli, Klebsiella pneumonia, Pseudomonas aeruginosa, Bacterius fragilis, Bacteroides thatomicron, Peptostreptococcus species, and Viridans group Streptococci. Gastrointestinal side effects of meropenem may also include gastrointestinal hemorrhage, pseudomembranous colitis, abdominal pain, melena, oral moniliasis, jaundice, and ileus. Cardiovascular side effects may include heart failure, cardiac arrest, pulmonary embolus, tachycardia, hypertension, bradycardia, hypotension, and syncope. Respiratory side effects may include dyspnea. Cefoxidril. Cefoxidril monohydrate is also available under the brand name Duracef. It is a first-generation cephalosporin. It is used in the treatment of skin infections due to staphylococci or streptococci, as well as pharyngitis and tonsillitis resulting from group A beta hemolytic streptococci and urinary tract infections caused by Escherichia coli, Proteus mirabilis, and Klebsiella. There are no known side effects of cefadroxil use. However, its safety in children has not yet been determined. Cefazolin sodium. Cefazolin sodium is also available under the brand name Ancef. Cefazolin sodium is a first-generation cephalosporin. It is used in the treatment of endocarditis, septicemia, bone and joint infections due to Staph aureus, biliary tract infections due to E. coli, and various strains of streptococci, Proteus mirabilis, Klebsiella, and Staph aureus, and skin infections due to Staph aureus. Cefazolin sodium is also used to treat respiratory tract infections due to the presence of Streptococcus pneumonia, Klebsiella, Haemophilus influenza, and Staphylococcus aureus. When cefazolin is administered in high doses in patients suffering from renal failure, side effects may include confusion, tonic-clonic seizures, and mild hemiparesis. Cephalexin hydrochloride monohydrate. Cephalexin is also available under the brand name Keftab. Cephalexin is a first-generation cephalosporin used to treat respiratory tract infections caused by Streptococcus pneumonia and group A and B hemolytic streptococci. It is also used to treat bone infections caused by Proteus mirabilis or Staphylococcus, and otitis media due to strep pneumonia, Haemophilus influenza, Staphylococcus, streptococci, and Neisseria catarrhalis. Side effects of cephalexin use may include nephrotoxicity or cholestatic jaundice. Cefaclor. Cefaclor is also available under the brand name Ceclor. It is a second-generation cephalosporin. Cefaclor is also used in the treatment of otitis media due to Streptococcus pneumonia, Haemophilus influenza, Streptococcus pyogenes, and Staphylococci, as well as lower respiratory tract infections due to strep pneumonia, Haemophilus influenza, and strep pyogenes. Also, upper respiratory tract infections caused by Staph pyogenes, skin infections due to Staphylococcus aureus, and Staph pyogenes. Cefaclor is also used to treat urinary tract infections resulting from Escherichia coli, Proteus mirabilis, Klebsiella, and coagulase-negative staphylococci. Side effects of Cefaclor use may include cholestatic jaundice and lymphocytosis. Sulfonicid sodium. Sulfonicid sodium is also available under the brand name Monocid. It is a second-generation cephalosporin. Sulfonicid is used in the treatment of lower respiratory tract infections, urinary tract infections, and infections of the bones, joints, skin, and skin structures. Sulfonicid is also useful in the treatment of septicemia and prophylaxis in colorectal surgery, vaginal hysterectomy, cholecystectomy, prosthetic arthroplasty, open heart surgery, and cesarean section. Side effects of sulfonicid use may include rash or hives, swelling of the face, throat, or lips, wheezing or trouble breathing, and severe diarrhea. Sulfoxetine sodium. Sulfoxetine sodium is also available under the brand name Mefoxin. Sulfoxetine sodium is a second-generation broad-spectrum cephalosporin. It is both penicillinase and cephalosporinase resistant. Sulfoxetine is stable in the presence of beta-lactamase. Administered intravenously, sulfoxetine is used to treat lower respiratory tract infections such as pneumonia and abscesses, as well as urinary tract infections resulting from E. coli, Klebsiella species, Proteus mirabilis, Morganella morganii, Proteus vulgaris, and Providencia species. Cefotoxin sodium is also useful in cases of uncomplicated gonorrhea due to Neisseria gonorrhea and in the treatment of gynecological infections resulting from the presence of E. coli, Neisseria gonorrhea, and Bacteroides species. High doses of sulfoxetine have been known to cause increased incidence of eosinophilia and increased AST levels in children over 3 months of age. Oral cefixime. Oral cefixime is also available under the brand name Suprax. Oral cefixime is a third-generation cephalosporin. Oral cefixime remains stable in the presence of beta-lactamase enzyme. It is used in the treatment of uncomplicated urinary tract infections caused by E. coli and P. mirabilis, and otitis media resulting from Haemophilus influenza, Moraxella catarrhalis, and strep pyogenes. Oral cefixime is also useful in treating pharyngitis and tonsillitis that are caused by S. pyogenes and acute bronchitis and acute exacerbations of chronic bronchitis caused by strep pneumonia and Haemophilus influenza. Side effects of oral cefixime use may include flatulence, elevated alkaline phosphatase levels, and transient increases in BUN or creatinine. Cefoperazone sodium. Cefoperazone sodium is also available under the brand name Cefabid. It is a third-generation cephalosporin. It is used to treat respiratory tract infections due to strep pneumonia, Haemophilus influenza, Staphylococcus, Pseudomonas aeruginosa, Klebsiella pneumonia, Escherichia coli, Proteus mirabilis, and Enterococcus species. Cefoperazone sodium is also used to treat peritonitis and other intra-abdominal infections resulting from E. coli, P. aeruginosa or Enterococci, and bacterial septicemia due to strep pneumonia, S. agalacticae, Staph aureus, Enterococci, Pseudomonas aeruginosa, Escherichia coli, Klebsiella species, Proteus species, Clostridium species, and anaerobic gram-positive cocci. Cefoperazone is also useful in treating skin infections arising from the presence of Staph aureus, Staph pyogenes, Pseudomonas aeruginosa, and Enterococci, and pelvic inflammatory disease, endometritis, and other female genital tract infections resulting from Neisseria gonorrhea, Staph epidermidis, Staph agalacticae, E. coli, Clostridium species, and Enterococci. Side effects of cefoperazone use may include hypoprothrombonemia, bleeding, or bruising. Cefotaxime sodium. Cefotaxime sodium is also available under the brand name Clafuran. Cefotaxime sodium is a third-generation cephalosporin which is used in the treatment of GU tract infections and lower respiratory tract infections. Cefotaxime sodium is also used to treat infections of the skin, skin structures, bones, joints, and central nervous system. Cefotaxime is also useful in the treatment of intra-abdominal infections such as peritonitis, gynecologic septicemia, bacteremia, and prophylaxis in surgery. The next drug is ceftazidime. Ceftazidime is also available under the brand name Tazidime. It is a third-generation cephalosporin which is used intravenously to treat lower respiratory tract infections, including pneumonia. These infections result from Pseudomonas species, Haemophilus, Klebsiella species, Enterobacter species, Proteus mirabilis, Escherichia coli, Serratia species, Citrobacter species, Streptococcus pneumonia, and Staphylococcus aureus. Ceftazidime is also used in the treatment of skin and skin structure infections, including P. aeruginosa, Klebsiella species, E. coli, Proteus species, Enterobacter species, Serratia species, S. aureus, and S. pyogenes. Ceftazidime is also used to treat both complicated and uncomplicated urinary tract infections resulting from the presence of Pseudomonas aeruginosa, Enterobacteria species, Proteus species, Klebsiella species, and E. coli. Additionally, it is used to treat bacterial septicemia resulting from Pseudomonas aeruginosa, Klebsiella species, Haemophilus influenza, E. coli, Serratia species, S. pneumonia, and S. aureus. Ceftazidime is also used to treat infections of the bone and joint resulting from Pseudomonas aeruginosa, Klebsiella species, Enterobacter species, and Staph aureus. It is also used to treat GYN infections. The next drug is ceftazidime sodium. Ceftazidime sodium is also available under the brand name Cefizox. Cefizox is a third-generation cephalosporin. It is used in the treatment of lower respiratory tract infections due to Streptococcus species, Klebsiella species, Proteus mirabilis, Escherichia coli, Haemophilus influenza, Staphylococcus aureus, Serratia species, Enterobacteria species, and Bacteroides species. Ceftazidime sodium is also used to treat urinary tract infections resulting from Staph aureus, E. coli, Pseudomonas species, P. mirabilis, P. vulgaris, Providentia redgeri, Morganella morgani, Klebsiella species, Serratia species, and Enterobacter species. Cefotaxime sodium is also used to treat uncomplicated cervical and urethral gonorrhea due to Neisseria gonorrhea, the treatment of pelvic inflammatory disease due to Neisseria gonorrhea, E. coli, or S. agalacticae. Ceftazidime sodium is also used to treat intra-abdominal infections due to E. coli, S. epidermidis, Streptococcus species, Enterobacter species, Klebsiella species, Bacteroides species, and anaerobic cocci. Cefotaxazine sodium is also used to treat septicemia due to Streptococcus species, Staph aureus, E. coli, Bacteroides species, Klebsiella species, and Serratia species. Cefotaxime sodium is also used to treat skin and skin structure infections resulting from Staph aureus, Staph epidermidis, E. coli, Klebsiella species, Streptococcus species, Proteus mirabilis, Serratia species, Enterobacter species, Bacteroides species, and anaerobic cocci. Cefotaxime is also used in the treatment of infections of bones and joints resulting from Staph aureus, Streptococcus species, Proteus mirabilis, Bacteroides species, and anaerobic cocci. Cefotaxime sodium is also used to treat meningitis due to Haemophilus influenza and limited use for S. pyogenes. Side effects of cefotaxime use may include transient increased levels of eosinophilia, AST, ALT, and CPK in children over 6 months of age. Ceftriaxone sodium. Ceftriaxone sodium is also available under the brand name Rocephin. Ceftriaxone sodium is a third-generation cephalosporin. It is used in the treatment of lower respiratory tract infections due to Streptococcus pneumonia, Staphylococcus aureus, Haemophilus influenza, Haemophilus parainfluenza, Klebsiella pneumonia, Serratia marcescens, Escherichia coli, E. aerogenes, and Proteus mirabilis. Ceftriaxone sodium is used in the treatment of skin and skin structure infections due to Staph aureus, Staph epidermidis, Staph pyogenes, Viridans group Streptococci, E. coli, Enterobacteria cloacae, K. oxytosa, K. pneumonia, P. mirabilis, Pseudomonas aeruginosa, Morganelli morgani, Serratia marcescens, Acinetobacter chalcosaticus, Bacteroides fragilis, and Peptostreptococcus species. Ceftriaxone sodium is also used in the treatment of both complicated and uncomplicated urinary tract infections resulting from E. coli, P. mirabilis, P. vulgaris, M. morgani, and K. pneumonia. Ceftriaxone sodium is used in the treatment of uncomplicated cervical or urethral and rectal gonorrhea due to Neisseria gonorrhea. Ceftriaxone sodium is used in the treatment of pharyngeal gonorrhea resulting from non-penicillinase-producing strains of Neisseria gonorrhea. Ceftriaxone is also useful in treating bacterial septicemia due to Staph aureus, Strep pneumonia, E. coli, H. influenza, and K. pneumonia. Ceftriaxone sodium is also used to treat infections of the bone and joint due to Staph aureus, Strep pneumonia, E. coli, Proteus mirabilis, Klebsiella pneumonia, and Enterobacter species. It also is used to treat intra-abdominal infections resulting from E. coli, K. pneumonia, B. fragilis, Clostridium species, Peptostreptococcus species, and meningitis due to Haemophilus influenza, Neisseria meningitis, and strep pneumonia. Side effects may include an increase in serum creatinine, the presence of casts in the urine, and in rare cases the alteration of PT segments. Bacitracin. Bacitracin is an antibiotic produced by Bacillus subtilis and interferes with synthesis of cell wall. It prevents the incorporation of amino acids and nucleotides. Bacitracin is bactericidal, bacteriostatic, and active against protoplasts. Bacitracin is administered via ophthalmic and topical ointments. Bacitracin is used as a prophylaxis or treatment of infections in minor cuts, wounds, burns, and skin abrasions. It can also be used as treatment for superficial infections of the skin resulting from susceptible organisms. Ophthalmically, bacitracin is effective against species of Staph aureus, Streptococcus, Strep pneumonia, S. pyogenes, Corynebacterium, Neisseria, Neisseria gonorrhea, and beta-hemolytic streptococci. Topical side effects of bacitracin include allergic contact dermatitis and superinfection. Ophthalmic side effects include transient burning, stinging, itching, irritation, inflammation, angioneurotic edema, urticaria, and both vesicular and maculopapular dermatitis. Vancomycin hydrochloride. Vancomycin hydrochloride is also available under the brand name Vancomycin. Vancomycin hydrochloride is an antibiotic. It is believed to bind to the bacterial cell wall. Vancomycin hydrochloride arrests the synthesis of the cell wall and lyses the cytoplasmic membrane through a mechanism that is significantly different than that of penicillins and cephalosporins. Vancomycin is used to treat cases of antibiotic-induced pseudomembranous colitis resulting from Clostridium difficile. Vancomycin hydrochloride is also used as an effective treatment for Staphylococcus enterocolitis and severe or progressive antibiotic-induced diarrhea caused by C. difficile. Side effects of vancomycin use may include ototoxicity, which may lead to deafness. The deafness may continue to progress after vancomycin hydrochloride is discontinued. Other side effects include nephrotoxicity and red neck syndrome. Cardiovascular side effects of vancomycin use may include exaggerated hypotension, which may include shock and even cardiac arrest. Respiratory side effects of vancomycin use may include wheezing or dyspnea. Dermatologic side effects may include urticaria, pruritus, macular rashes, exfoliative dermatitis, Stevens-Johnson syndrome, toxic epidermal necrolysis, and vasculitis. The next drug is aztreonam for injection. Aztreonam for injection is a synthetic monobactam antibiotic. Aztreonam for injection is used to treat urinary tract infections resulting from Escherichia coli, Klebsiella pneumonia, Proteus mirabilis, Pseudomonas aeruginosa, Enterobacter cloacae, Klebsiella oxytosa, Citrobacter species, and Serratia marcescens. Aztreonam for injections is also used to treat lower respiratory infections due to E. coli, K. pneumonia, P. aeruginosa, Haemophilus influenza, Proteus mirabilis, Enterobacter species, and Serratia marcescens septicemia due to E. coli, K. pneumonia, P. aeruginosa, P. mirabilis, S. marcescens, and Enterobacter species. It is also used to treat both skin and skin structure infection caused by E. coli, P. mirabilis, S. marcescens, Enterobacter species, Pseudomonas aeruginosa, Klebsiella pneumonia, and Citrobacter species. Aztreonam for injection is also useful in treating intra-abdominal infections resulting from E. coli, Klebsiella species including Klebsiella pneumonia, Enterobacter species including E. cloacae, P. aeruginosa, Citrobacter species including C. freundii, and Serratia species including S. marcescens, and gynecological infections due to E. coli, K. pneumonia, P. mirabilis, and Enterobacter species including E. cloacae. Serious side effects may include Clostridium difficile-associated diarrhea, gastrointestinal bleeding, seizures, anemia, neutropenia, thrombocytopenia, leukocytosis, thrombocytosis, pancytopenia, and eosinophilia. Penicillin G benzathine. Penicillin G benzathine is used intramuscularly. It is also available under the brand name Permapen. Intramuscular penicillin G benzathine is a penicillin antibiotic. Intramuscular penicillin G benzathine is used in the treatment of infections due to penicillin G-sensitive microorganisms susceptible to low and prolonged serum levels. Intramuscular penicillin G benzathine can also be used to treat cases of mild to moderate URTI resulting from susceptible streptococci. Side effects of penicillin G may include black or hairy tongue, exaggerated reflexes, mild diarrhea, nausea or vomiting, pain, swelling, redness at the injection site, and twitching. Penicillin G procaine. Penicillin G procaine is also used intramuscularly. Penicillin G procaine is also available under the brand name Aercillin. Penicillin G procaine is a penicillin antibiotic used in cases of penicillin-sensitive staphylococci, pneumococci, streptococci, and bacterial endocarditis. Penicillin G procaine is also effective in the treatment of gonorrhea and all stages of syphilis. Side effects of penicillin G may include black or hairy tongue, exaggerated reflexes, mild diarrhea, nausea or vomiting, pain, swelling, or redness at the injection site, and twitching. Penicillin V potassium. Penicillin V potassium is an antibiotic and used in the treatment of cases of mild to moderate upper respiratory tract streptococcal infections such as scarlet fever and erysipelas. It is also an effective treatment for mild to moderate upper respiratory tract pneumococcal infections such as otitis media and mild staphylococcal infections of the skin and soft tissue. Penicillin V potassium can also be used to treat mild to moderate fusospiroketosis, also called Vincent's infection of the oropharynx. Side effects of penicillin V may include black hairy tongue, irritation of the mouth or throat, mild diarrhea, nausea, upset stomach, and vomiting. Amoxicillin. Amoxicillin is also available under the brand names Amoxil and Polymox. Amoxicillin is an antibiotic. Amoxicillin is used to treat gram-positive streptococcal infections including Streptococcus faecalis, strep pneumonia, and non-penicillinase-producing staphylococci. Amoxicillin is also used to treat gram-negative infections resulting from Haemophilus influenza, Proteus mirabilis, Escherichia coli, and Neisseria gonorrhea. Side effects of amoxicillin use may include diarrhea, dizziness, irritation of the mouth or throat, nausea, and vomiting. Ampicillin. Ampicillin is an oral medication. It is also available under the brand names Omnipen, Polycillin, and Principen. Oral ampicillin is a synthetic broad-spectrum antibiotic suitable for gram-negative bacteria. Oral ampicillin is used in the treatment of infections of the respiratory, gastrointestinal, and GU tracts caused by Shigella, Salmonella, Escherichia coli, Haemophilus influenza, Proteus strains, Neisseria gonorrhea, Neisseria meningitidis, and Enterococcus. Oral ampicillin may also be used to treat cases of otitis media in children, as well as bronchitis, rat bite fever, and whooping cough. Side effects of ampicillin use may include inflammation and redness of the tongue, irritation of mouth or throat, mild diarrhea, nausea, secondary infection, and vomiting. Carbenicillin indonyl sodium. Carbenicillin is also available under the brand name Geocillin. Carbenicillin indonyl sodium is a penicillin antibiotic used in the treatment of both upper and lower urinary tract infections resulting from Escherichia coli, Proteus vulgaris, and Proteus mirabilis, as well as Morganella morganii, Providencia redgeri, Enterobacter, Pseudomonas, and Enterococci. Carbenicillin indonyl sodium is also used in treating prostatitis due to E. coli, Streptococcus faecalis, P. mirabilis, and Enterobacter species. Neurotoxicity is a known side effect in patients with impaired renal function. Meslocillin sodium. Meslocillin sodium is also available under the brand name Meslin. Meslocillin sodium is a broad-spectrum antibiotic which is used parenterally. Meslocillin is used to treat lower respiratory tract infections resulting from Haemophilus influenza, Klebsiella pneumonia, Proteus mirabilis, Pseudomonas aeruginosa, E. coli, and Bacteroides fragilis. Meslocillin sodium is used to treat intra-abdominal infections resulting from E. coli, P. mirabilis, Klebsiella species, Pseudomonas, Streptococcus faecalis, Bacteroides, Peptococcus, and Peptostreptococcus. Meslocillin sodium is also used in the treatment of urinary tract infections due to E. coli, P. mirabilis, Proteus, Morganella morganii, Klebsiella, Enterobacter, Serratia, Pseudomonas, and Strep faecalis. Meslocillin can also be used to treat cases of uncomplicated gonorrhea due to Neisseria gonorrhea and gynecological infections resulting from Neisseria gonorrhea, Peptococcus, Peptostreptococcus, Bacteroides, E. coli, P. mirabilis, Klebsiella, and Enterobacter. Meslocillin sodium is used to treat skin and skin structure infections due to S. faecalis, E. coli, P. mirabilis, indole-positive Proteus, Proteus vulgaris, Providencia redgeri, Klebsiella, Enterobacter, Pseudomonas, Peptococcus, and Bacteroides. Bleeding abnormalities and decreased hemoglobin or hematocrit values are known side effects of meslocillin use. Piperacillin sodium. Piperacillin sodium is also available under the brand name Piperacil. Piperacillin sodium is a semisynthetic broad-spectrum penicillin for parenteral use. Piperacillin is an antibiotic used in the treatment of intra-abdominal infections, gynecological infections, septicemia, lower respiratory tract infections, skin and skin structure infections, bone and joint infections, and uncomplicated gonococcal urethritis. Piperacillin sodium is also used to treat infections due to Streptococcus species and prophylaxis in surgery. A rare side effect of piperacillin use is prolonged muscle relaxation. Ticarcillin disodium. Ticarcillin disodium is also available under the brand name Ticar. Ticarcillin disodium is a parenteral semisynthetic antibiotic. It has an antibacterial spectrum of activity resembling that of carbenicillin. Ticarcillin is primarily used in the treatment of gram-negative organisms. Tricarcillin disodium is also effective for mixed infections. Side effects of ticarcillin use include neurotoxicity and neuromuscular excitability, particularly in patients with impaired renal function. Cloxacillin sodium. Cloxacillin sodium is an antibiotic used in the treatment of infections caused by penicillinase-producing staphylococci. Side effects of cloxacillin use may include mild nausea, vomiting, diarrhea, and abdominal pain. Dicloxacillin sodium. Dicloxacillin sodium is also available under the brand name Dynapen. Dicloxacillin sodium is an antibiotic used in the treatment of infections resulting from penicillinase-producing staphylococci. Dicloxacillin sodium may also be used to initiate therapy in any suspected staphylococcal infection. Side effects of dicloxacillin may include diarrhea, fever, gas, general body discomfort, heartburn, joint pain, muscle aches, nausea, secondary infection, stomach pain, and vomiting. The next drug is nafcillin sodium. Nafcillin sodium is also available under the brand name Unipen. Nafcillin sodium is an antibiotic used in treating penicillinase-producing staphylococci infections. Nafcillin sodium is also used as initial therapy in cases where staphylococcal infection is suspected until the results of the culture have been obtained. Sterile abscesses and thrombophlebitis are known side effects of nafcillin. These side effects may frequently occur in the elderly. Oxacillin sodium. Oxacillin sodium is also available under the brand name Bactocil. Oxacillin sodium is an antibiotic used in the treatment of infections caused by penicillinase-producing staphylococci. Oxacillin sodium may also be used to initiate therapy in cases where staphylococcal infections is suspected. Trimethoxate glucuronate. Trimethoxate glucuronate is also available under the brand name Nutrexin. Trimethoxate glucuronate is an anti-infective. It inhibits the enzyme dihydrofolate reductase, resulting in interference with thymidylate biosynthesis and inhibition of folate-dependent formal transferases. This leads to inhibition of purine synthesis and disruption of DNA, RNA, and protein synthesis, and ultimately cell death. Trimethoxate must be given with leucovorin to prevent serious or life-threatening complications, including bone marrow suppression, oral and gastrointestinal mucosal ulceration, and renal and hepatic dysfunction. Trimethoxate is used as an alternative therapy with concurrent leucovorin for the treatment of moderate to severe cases of pneumocystis carinii pneumonia in immunocompromised patients. Trimethoxate glucuronate is also used in the treatment of non-small cell lung, prostate, or colorectal cancer. Side effects of trimethoxate use include neutropenia, thrombocytopenia, anemia, and hepatic toxicity. These side effects are manifested by increased ALT, AST, alkaline phosphatase, and bilirubin, increased serum creatinine, hyponatremia, and hypocalcemia. Chloramphenicol. Chloramphenicol is also available under the brand name chloromycetin. Chloramphenicol is an anti-infective. It interferes with or inhibits protein synthesis in bacteria by binding to 50S ribosomal subunits. Chloramphenicol is used in the treatment of typhoid fever, but not for the typhoid carrier state. Chloramphenicol is used to treat serious infections caused by salmonella, rickettsia, chlamydia, and lymphogranuloma psittacosis group. Chloramphenicol should not be used for trivial infections, for prophylaxis of bacterial infections, or to treat minor infections such as cold, flu, or throat infections. Serious side effects of chloramphenicol use include aplastic anemia, hypoplastic anemia, thrombocytopenia, granulocytopenia, hemolytic anemia, pancytopenia, and hemoglobinuria. Clindamycin hydrochloride. Clindamycin is also available under the brand name Cleocin. Clindamycin is a clindamycin and lincomycin antibiotic. It is both bacteriostatic and bactericidal. Clindamycin suppresses protein synthesis by microorganisms by binding to ribosomes and preventing peptide bond formation. It is used to treat serious respiratory tract infections, serious skin and soft tissue infections, septicemia, intra-abdominal infections, and infections of the female pelvis and genital tract. Side effects of clindamycin use may include diarrhea, pseudomembranous colitis, abdominal pain, esophagitis, unpleasant or metallic taste after high IV doses, glossitis, stomatitis, hypotension, morbilliform rash, skin rashes, urticaria, erythema multiforme, angioneurotic edema, leukopenia, Stevens-Johnson-like syndrome, thrombocytopenia, transient eosinophilia, agranulocytosis, aplastic anemia, jaundice, renal dysfunction, vaginitis, superinfection, tinnitus, and polyarthritis. Spectinomycin hydrochloride. Spectinomycin hydrochloride is also available under the brand name Trobicin. It is an antibiotic produced by Streptomyces spectabilis. Spectinomycin hydrochloride inhibits bacterial protein synthesis by binding to ribosomes. This interferes with the transmission of genetic information crucial to the life of the microorganism. Spectinomycin is used in the treatment of acute gonorrheal proctitis and urethritis in men and acute gonorrheal cervicitis and proctitis in women. A single dose of spectinomycin has caused the following side effects: soreness at the site of injection, urticaria, dizziness, chills, nausea, fever, and insomnia. Multiple doses have caused a decrease in H&H and CCR and an increase in alkaline phosphatase, BUN, and ALT. In single or multiple doses, a decrease in urine output is not uncommon. Azithromycin. Azithromycin is also available under the brand names Zithromax and Azocyte. It is a macrolide antibiotic derived from erythromycin. Azithromycin acts by binding to the P site of the 50S ribosomal subunit and inhibiting the RNA-dependent protein synthesis. Azithromycin stimulates the dissociation of peptidyl T RNA from ribosomes. Azithromycin is used in the treatment of acute bacterial exacerbations of COPD due to Haemophilus influenza, Moraxella catarrhalis, or Streptococcus pneumonia. Azithromycin is also used as an alternative to first-line therapy to treat streptococcal pharyngitis or tonsillitis due to Streptococcus pyogenes. Azithromycin is available in oral suspension and tablet form. It may also be administered intravenously. Azocyte is a topical ophthalmic solution of azithromycin formulated in Duracite, which consists of polycarbophil, EDTA sodium, and sodium chloride. Side effects of azithromycin use may include diarrhea, abdominal pain, melena, mucositis, cholestatic jaundice, pseudomembranous colitis, dizziness, headache, chest pain or palpitations, ventricular arrhythmias, rash, anaphylaxis, leukopenia, neutropenia, decreased platelet count, superinfection, and bronchospasm. Clarithromycin. Clarithromycin is also available under the brand name Biaxin. Clarithromycin is a macrolide antibiotic which binds to the 50S ribosomal subunit of susceptible organisms. It interferes or inhibits microbial protein synthesis. Clarithromycin treats mild to moderate infections caused by susceptible strains of pharyngitis or tonsillitis due to Streptococcus pyogenes, acute maxillary sinusitis or acute bacterial exacerbation of chronic bronchitis due to Streptococcus pneumonia, Haemophilus influenza, Moraxella catarrhalis, pneumonia due to Mycoplasma pneumonia, S. pneumonia, or chlamydia pneumonia. Clarithromycin is also used to treat uncomplicated skin and skin structure infections due to Staphylococcus aureus or Staph pyogenes and disseminated mycobacterial infections due to Mycobacterium avium. Gastrointestinal side effects of clarithromycin use may include abdominal discomfort or pain, pseudomembranous colitis, glossitis, stomatitis, oral monoliasis, and vomiting. Central nervous system side effects may include behavioral changes, depersonalization, and hallucinations. Other side effects may include mild skin eruptions and, in rare cases, anaphylaxis and Stevens-Johnson syndrome. erythromycin estolate. Erythromycin is also available under the brand name Ilosone. Erythromycin is an antibiotic which is the most active form of erythromycin. It has a long-lasting activity. Doxycycline calcium. Doxycycline is a tetracycline antibiotic and is used in treating infections outside the urinary tract for patients with impaired renal function. Minocycline hydrochloride. Minocycline hydrochloride is also available under the brand name Minocin. It is a tetracycline antibiotic and is used primarily to eliminate meningococci from the nasopharynx of asymptomatic Neisseria meningitis carriers, and in cases where the risk of meningococcal meningitis is high. Side effects of minocycline may include blue-gray pigmentation areas of cutaneous inflammation, vertigo, ataxia, drowsiness, and in rare cases Stevens-Johnson syndrome. The next drug is tetracycline hydrochloride. Tetracycline hydrochloride is a tetracycline antibiotic and is used primarily as part of combination therapy to eradicate H. pylori infections. Side effects of tetracycline use may include oral candidiasis, glossitis, staining of the tongue, severe gingival hyperplasia, pain, and hypersensitivity reactions. Amikacin sulfate. Amikacin sulfate is also available under the brand name Amikin. It is an aminoglycoside antibiotic derived from kanamycin. Amikacin sulfate is effective against both penicillinase and non-penicillinase producing organisms. Amikacin sulfate is primarily used in the short-term treatment of gram-negative bacterial infections such as Pseudomonas, Escherichia coli, Proteus, Providencia, Klebsiella, Enterobacter, Serratia, and Acinetobacter. Amikacin sulfate may also be used to treat infections due to gentamicin or tobramycin-resistant strains of Providencia redgeri, P. stewarti, Serratia marcescens, and Pseudomonas aeruginosa. Gentamicin sulfate, which is also available under the brand name garamycin. It is an aminoglycoside antibiotic and is used to treat serious infections caused by Pseudomonas aeruginosa, Proteus, Klebsiella, Enterobacter, Serratia, Citrobacter, and Staphylococcus. Gentamicin sulfate is also used in the treatment of ophthalmic infections due to Staphylococcus, such as Staph aureus, Streptococcus pneumonia, beta-hemolytic streptococci, Corynebacterium species, Streptococcus pyogenes, Escherichia coli, Haemophilus influenza, Haemophilus aegyptus, Haemophilus ducreyi, Klebsiella pneumonia, Neisseria gonorrhea, Proteus species, Acinetobacter chalcocitus, Enterobacter aerogenes, Pseudomonas aeruginosa, Serratia marcescens, and Moraxella lacunata. Side effects of gentamicin include seizures, increased blood pressure, alopecia, purpura, and pseudotumors cerebri. Side effects after ophthalmic use include transient irritation, angioneurotic edema, urticaria, vesicular and maculopapular dermatitis, mydriasis, conjunctival paresthesia or hyperemia, and bacterial or fungal corneal ulcers. Kanamycin sulfate. Kanamycin sulfate is also available under the brand name Cantrex. It is an aminoglycoside antibiotic and tertiary antitubercular agent. Kanamycin sulfate is used in the initial therapy for infections due to Escherichia coli, Proteus, Enterobacter aerogenes, Klebsiella pneumonia, Serratia marcescens, and Acinetobacter. Side effect of kanamycin use may include sprue-like syndrome with steatorrhea, malabsorption, and electrolyte imbalance. Neomycin sulfate. Neomycin sulfate is also available under the brand name misafredin sulfate. Neomycin sulfate is an aminoglycoside antibiotic and is used as a treatment in cases of hepatic coma and sterilization of the gut prior to surgery. Neomycin sulfate is also used in inhibition of ammonia-forming bacteria in gastrointestinal tract and in hepatic encephalopathy. Neomycin sulfate can also be used as prophylaxis or treatment of infection in burns, minor cuts, wounds, and skin abrasions. Side effects of neomycin may include ototoxicity, nephrotoxicity, sprue-like syndrome, and skin rashes after topical or parenteral administration. Tobramycin sulfate. Tobramycin sulfate is also available under the brand name Nebsin. Tobramycin sulfate is an aminoglycoside antibiotic. Tobramycin sulfate is used to treat cases of complicated and recurrent urinary tract infections due to Pseudomonas aeruginosa, Proteus, Escherichia coli, Klebsiella, Enterobacter, Serratia, Staphylococcus aureus, Citrobacter, and Providencia. It is also used to treat cases of lower respiratory tract infections due to P. aeruginosa, Klebsiella, Enterobacter, E. coli, Serratia, and S. aureus. Tobramycin sulfate is also used to treat intra-abdominal infections, skin, bone, and skin structure infections due to Pseudomonas aeruginosa, Proteus, E. coli, Klebsiella, Enterobacter, and S. aureus, as well as serious central nervous system infections. Ophthalmic side effects of tobramycin use may include transient irritation, angioneurotic edema, urticaria, and vesicular or maculopapular dermatitis. Streptomycin sulfate. Streptomycin is an aminoglycoside antibiotic. It is used with other drugs to treat Mycobacterium tuberculosis infections. Streptomycin is administered intramuscularly. Welcome to the sections on anticholinergics. Anticholinergics are agents which are used to block the parasympathetic nerves or to annul or antagonize the effects of the parasympathetic nervous system. Anticholinergics work by blocking certain nerve impulses, preventing certain muscle contractions, and causing gland secretions within the body. Here's an overview of anticholinergics. Edrophonium chloride. Edrophonium is also available under the brand name Enlon and Tensilon. Edrophonium is an indirect-acting cholinesterase inhibitor. It is used to increase the duration of action at the motor end plate. Edrophonium also causes a transient increase in muscle strength in patients suffering from myasthenia gravis. It is used primarily as a diagnostic tool to determine the requirements for treating patients with myasthenia gravis. It is also used as an adjunct in treating respiratory depression. Neostigmine bromide. Neostigmine is an indirect-acting cholinergic acetylcholinesterase inhibitor. Neostigmine induces an increase in the concentration of acetylcholine at the myoneural junction. This facilitates transmission of impulses across the myoneural junction. In cases of myasthenia gravis, this will increase muscle strength. Neostigmine is used in the treatment and diagnosis of myasthenia gravis. Neostigmine is an antidote for tubocurarine and other non-depolarizing drugs and is used in treatment and prophylaxis of postoperative distension or urinary retention. Serious side effects may include fecal incontinence, excessive salivation, dysphagia, increased gastric secretion, tachycardia, hypotension, ECG changes, nodal rhythm, cardiac arrest, syncope, substernal pain, anaphylaxis, and urticaria. Physostigmine salicylate. Physostigmine is also available under the brand name Antilirium. Physostigmine is an indirect-acting cholinergic acetylcholinesterase inhibitor. It causes an increased concentration of acetylcholine at the nerve endings and antagonizes anticholinergic drugs. In this way, physostigmine produces meiosis, increased accommodation, and a decrease in intraocular pressure with decreased resistance to outflow of aqueous humor. Physostigmine is useful in the treatment of cases of overdose due to cholinergic blocking drugs such as atropine and tricyclic antidepressants. The side effects of physostigmine use include nausea, gastrointestinal discomfort, diarrhea, hypotension, bronchial constriction, and increased salivation. Pyridostigmine bromide. Pyridostigmine bromide is also available under the brand name Mestinon. Pyridostigmine bromide is an indirect-acting cholinergic acetylcholinesterase inhibitor. It has a slower onset, longer duration of action, and fewer side effects than neostigmine. It's used in the treatment of myasthenia gravis and is an antidote for non-depolarizing muscle relaxants such as tubocurarine. Skin rash is one side effect of pyridostigmine bromide, and thrombophlebitis may occur following intravenous use. Atropine sulfate. Atropine sulfate is also available under the brand name Atropare. Atropine sulfate is a cholinergic blocking agent. It blocks the action of acetylcholine on postganglionic cholinergic receptors in smooth muscle, cardiac muscle, exocrine glands, urinary bladder, and the AV and SA nodes of the heart. Used ophthalmologically, atropine blocks the effect of acetylcholine on the sphincter muscle of the iris and the accommodative muscle of the ciliary body, resulting in dilation of the pupil and paralysis of the muscles required to accommodate for close vision. Atropine is used as an adjunct in peptic ulcer treatment, irritable bowel syndrome, and in the treatment of spastic disorders of the biliary tract. Atropine has both parenteral and ophthalmological use. Parenterally, atropine sulfate is used as an antiarrhythmic. Ophthalmologically, it is used in cases of acute inflammation of the iris and uveal tract. Ophthalmologic side effects of atropine use can include blurred vision, increased intraocular pressure, and dermatitis. Long-term use may cause irritation, photophobia, eczematoid dermatitis, conjunctivitis, hyperemia, or edema. Scopolamine hydrobromide. Scopolamine is also available under the brand name Hyoscine. Scopolamine is an anticholinergic antiemetic drug with central nervous system depressant effects. Scopolamine causes pupillary dilation and paralysis of the muscles of accommodation. This enables the physician to examine the inner structure of the eye. Scopolamine is used in the control of cycloplegia and mydriasis during diagnostic procedures. Scopolamine is also used both preoperatively and postoperatively in the treatment of iridocyclitis and to dilate the pupil of the eye when treating uveitis and posterior synechii. Side effects of scopolamine use include disorientation, delirium, decreased respiratory rate, blurred vision, and increased intraocular pressure. Ipratropium bromide. Ipratropium bromide is also available under the brand name Atrovent. It is an anticholinergic quaternary ammonium compound. Ipratropium bromide antagonizes the action of acetylcholine and prevents the increase in intracellular levels of cyclic guanosine monophosphate, which leads to bronchodilation. Ipratropium bromide is used in the treatment of chronic bronchitis and emphysema and for the symptomatic relief of rhinorrhea. Side effects of inhalation aerosol may include cough, dizziness, headache, fatigue, dryness of the oropharynx, gastrointestinal distress, heart palpitation, tachycardia, hives, alopecia, difficulty in accommodation, drying of secretions, urinary difficulty, paresthesias, and mucosal ulcers. Side effects included with ipratropium bromide inhalation solution include dizziness, insomnia, nervousness, tremor, headache, dry mouth, nausea, constipation, hypertension, tachycardia, heart palpitations, flu-like symptoms, back or chest pain, and arthritis. Propanthyline bromide. Propanthyline bromide is also available under the brand name probanthine. It is an anticholinergic and quaternary ammonium compound. It is used as an antispasmodic. It is used in cases of spastic and inflammatory disease of the gastrointestinal and urinary tract and for the control of salivation and enuresis. Propanthyline bromide is also used as an adjunct in peptic ulcer therapy. Welcome to the section on anticoagulants and thrombolytic agents. Anticoagulants are drugs or agents which are used to prevent blood clotting by inhibiting the progression of fibrinogenesis. Thrombolytic agents are medications that dissolve blood clots. A blood clot is characterized as the conversion of blood from a liquid form to solid through the process of coagulation. A thrombus is a blood clot which forms inside of a blood vessel. If the thrombus moves away from its original site, it is referred to as an embolus or an embolism. Anticoagulants are usually administered to patients with myocardial infarction, venous thrombosis, peripheral arterial emboli, and pulmonary emboli. Anticoagulants have been used to prevent transient ischemic attacks. Anticoagulants are also used to reduce the risk of recurrent myocardial infarction. Here are the three mechanisms of action for anticoagulants. 1. The activation of anti-clotting factors, especially antithrombin 3. 2. The inhibition of synthesis of blood coagulation factors. 3. Direct inhibition of thrombin. Here's an overview of anticoagulants and thrombolytic agents. Anistroclase. Anistroclase is also available under the brand name Eminase. Anistroclase is a thrombolytic enzyme used in the management of acute myocardial infarction in adults. It is also used in the improvement of ventricular function and reduction of mortality. Side effects may include bleeding, hematuria, hemoptysis, gastrointestinal hemorrhage, intracranial bleeding, gum or mouth hemorrhage, epistaxis, anemia, eye hemorrhage, arrhythmias, hypotension, cardiac rupture, chest pain, and emboli. Streptokinase. Streptokinase is also available under the brand name cabekinase. Streptokinase is a thrombolytic agent. It is used as a treatment in cases of deep vein thrombosis, arterial thrombosis and embolism, acute evolving transmural myocardial infarction, and pulmonary embolism. Streptokinase is also used in the clearing of occluded arteriovenous and intravenous cannulae. Side effects may include superficial bleeding, severe internal bleeding, fever, the possible development of Guillain-Barré syndrome, or the development of anti-streptokinase antibodies. Urokinase. Urokinase is also available under the brand name abokinase. Urokinase is a thrombolytic agent. It is used in cases of acute pulmonary thromboembolism and coronary artery thrombosis. Urokinase is also used to clear IV catheters that are blocked by fibrin or clotted blood. Urokinase is administered through intravenous infusion. Side effects may include superficial bleeding, severe internal bleeding, transient hypotension or hypertension, and tachycardia. Heparin calcium. Heparin is also available under the brand name Calcilean. Heparin is an anticoagulant. It is used in the treatment of pulmonary embolism, peripheral arterial embolism, prophylaxis, and venous thrombosis. Side effects of heparin use may include hemorrhage, thrombocytopenia, chills, fever, urticaria, and in rare cases, asthma, lacrimation, and headache. Warfarin sodium. Warfarin sodium is also available under the brand name Coumadin. Warfarin sodium is an anticoagulant. It is used in the prophylaxis and treatment of venous thrombosis, atrial fibrillation, pulmonary embolism, and thromboembolic complications associated with atrial fibrillation. Hemorrhage is the most common side effect of warfarin use. Hemorrhage may also occur in any tissue or organ. Dipyridamole. Dipyridamole is also available under the brand name Persantine. Dipyridamole is a platelet adhesion inhibitor. It is used as an adjunct to Coumadin in preventing postoperative thromboembolic complications of cardiac valve replacement. Side effects may include gastrointestinal intolerance, diarrhea, dizziness, headache, syncope, peripheral vasodilation, flushing, and in rare cases angina pectoris or aggravation of angina pectoris. Ticlopidine hydrochloride. Ticlopidine hydrochloride is also available under the brand name Ticlid. Ticlopidine hydrochloride is used to reduce the risk of thrombotic stroke in patients who have impending stroke who have had a thrombotic stroke. Side effects of ticlopidine hydrochloride may include neutropenia, agranulocytosis, thrombotic thrombocytopenia purpura, pancytopenia, immune thrombocytopenia, hemolytic anemia with reticulocytosis, diarrhea, hepatitis, cholestatic or hepatocellular jaundice, hepatic necrosis, ecchymoses, hematuria, epistaxis, conjunctival hemorrhage, gastrointestinal or perioperative bleeding, post-traumatic bleeding, and in rare cases, intracerebral bleeding. Welcome to the section on anticonvulsants. Anticonvulsants are drugs which are used to prevent or reduce the severity of seizures. Seizures are defined as attacks of cerebral origin consisting of sudden and transitory abnormal phenomena of a motor, sensory, autonomic, or psychic nature resulting from transient dysfunction of the brain. Signals passing from one part of the brain to the other involve the movement of electrically charged substances called ions in and out of cells. Many anticonvulsants act by affecting the movement of ions through specific channels in the nerve cells. This tends to normalize the electrical activity of the brain. Important ions in this regard include sodium, calcium, chloride, and potassium. GABA, also called gamma-aminobutyric acid, has an inhibitory effect on nerve signaling. Some anticonvulsants intensify these inhibitory effects. Here's an overview of anticonvulsants. Acetazolamide. Acetazolamide is also available under the brand name Diamox. It is an anticonvulsant carbonic anhydrase inhibitor. Acetazolamide is used as an adjunct in the treatment of edema due to congestive heart failure or drug-induced edema. Acetazolamide is administered via extended-release capsules, tablets, or intravenously. Side effects of acetazolamide use may include anorexia, melena, constipation, renal colic or calculi, crystalluria, polyuria, phosphaturia, impotence, seizures, malaise, flaccid paralysis, lassitude, paresthesias of the extremities, bone marrow depression, thrombocytopenic purpura, hemolytic anemia, leukopenia, pancytopenia, agranulocytosis, skin rashes, Stevens-Johnson syndrome, toxic epidermal necrolysis, photosensitivity, weight loss, fever, acidosis, electrolyte imbalance, transient myopia, and hepatic insufficiency. Carbamazepine. Carbamazepine is also available under the brand name Tegretol. Carbamazepine is an anticonvulsant. It is used to treat partial seizures with complex symptoms. It may also be used in the treatment of tonic and clonic seizures, diseases with mixed seizure patterns, or other partial or generalized seizures. Serious side effects of carbamazepine use may include gastric distress, glossitis, stomatitis, aplastic anemia, leukopenia, eosinophilia, thrombocytopenia, agranulocytosis, leukocytosis, pancytopenia, bone marrow depression, visual hallucinations, hyperacusis, abnormal involuntary movements, behavioral changes in children, paralysis and other symptoms of cerebral arterial insufficiency, arrhythmias, Stevens-Johnson syndrome, alopecia, oculomotor disturbance, conjunctivitis, abnormal liver function studies, cholestatic or hepatocellular jaundice, hepatitis, inappropriate ADH secretion syndrome, and frank water intoxication with hyponatremia and confusion. Clonazepam. Clonazepam is also available under the brand name Klonopin. Clonazepam is an anticonvulsant benzodiazepine derivative. Clonazepam increases presynaptic inhibition and suppresses the spread of seizure activity. Clonazepam is used primarily in the treatment of petit mal absent seizures, including Lennox-Gastaut syndrome, akinetic, and myoclonic seizures. Clonazepam may elicit or precipitate grand mal seizures in patients suffering from multiple types of seizure disorders. Ethosuximid. Ethosuximid is also available under the brand name Zorantin. Ethosuximid is a succinimide-type anticonvulsant used in the treatment of absent seizures, also called petit mal. Gabapentin. Gabapentin is also available under the brand name Neurontin. It is an anticonvulsant. Gabapentin is used as an adjunct in the treatment of partial seizures, both with and without secondary generalization. The most common side effects of gabapentin use include somnolence, ataxia, dizziness, and fatigue. Phenobarbital. Phenobarbital is also available under the brand name Solphaton. It is a barbiturate-type sedative and anticonvulsant. Phenobarbital is used for the emergency control of acute seizure disorders such as status epilepticus, meningitis, tetanus, eclampsia, and toxicity of local anesthetics. Serious side effects may include apnea, respiratory depression, circulatory collapse, angioedema, Stevens-Johnson syndrome, and toxic epidermal necrolysis. Phenytoin. It is also available under the brand name Dilantin. Phenytoin is a hydantoin-type anticonvulsant and type 1 antiarrhythmic. It acts in the motor cortex of the brain to reduce the spread of electric discharge from the rapidly firing epileptic foci in this area. Phenytoin is used in cases of chronic epilepsy, specifically of the tonic-clonic psychomotor type of epilepsy. Serious side effects of phenytoin use may include seizures, Stevens-Johnson syndrome, epidermal necrolysis, agranulocytosis, aplastic anemia, hemolytic anemia, hepatocellular necrosis, and pulmonary fibrosis. Rapid parenteral administration may cause serious cardiovascular side effects. Primidone. Primidone is also available under the brand name Misoline. Primidone is an anticonvulsant. It is used either alone or with other anticonvulsants to treat psychomotor seizures, focal seizures, or tonic-clonic seizures. Side effects may include ataxia, vertigo, fatigue, emotional or personality disturbance, anorexia, painful gums, megaloblastic anemia, thrombocytopenia, diplopia, nystagmus, impotence, morbilliform and maculopapular skin rash. Valproic acid. Valproic acid is also available under the brand name Depacaine. Valproic acid is an anticonvulsant. It can be used either alone or in combination with other anticonvulsants for the treatment of simple and complex absence seizures called petit mal seizures. Valproic acid is also used as an adjunct treatment in multiple seizure patterns, which include absence seizures. Side effects may include indigestion, abdominal distress, sedation, psychosis, emotional upset, hyperactivity, tremor, headache, dizziness, spots before the eyes, thrombocytopenia, leukopenia, eosinophilia, anemia, bone marrow suppression, relative lymphocytosis, hypofibrinogenemia, myelodysplastic type syndrome, transient alopecia, petechiae, erythema multiforme, skin rashes, Stevens-Johnson syndrome, hepatotoxicity, and in rare cases, coma. Welcome to the section on antidepressants. Antidepressants are used to stimulate the moods of patients suffering from all forms of clinical depression. Tricyclic antidepressants are a group of antidepressant medications that share chemical characteristics, side effects, and toxicity. Monoamine oxidase inhibitors are a chemically heterogeneous group of drugs. Monoamine oxidase inhibitors block oxidative deamination of naturally occurring monoamines. Monoamine oxidase inhibitors are as effective as tricyclic antidepressants in the treatment of major depression. However, the complex, sometimes severe, and often unpredictable interactions between monoamine oxidase inhibitors and many other drugs and food make their medical use difficult and potentially hazardous. Here's an overview of antidepressants. Transilipramine sulfate. Transilipramine sulfate is available under the brand name Parnate. It is an antidepressant and monoamine oxidase inhibitor. Due to inhibition of monoamine oxidase during transilipramine use, the concentration of epinephrine, norepinephrine, and serotonin increases in storage sites throughout the nervous system. This increase is believed to be the cause of antidepressant effects. Transilipramine is used in the treatment of major depressive episodes. However, the benefits of using transilipramine sulfate is still being investigated for the following: bulimia, obsessive-compulsive disorder, and manifestations of psychotic disorders as well as social phobia, seasonal affective disorder, multiple sclerosis, and idiopathic orthostatic hypotension called Shy-Drager syndrome. The side effects of transilipramine use include anxiety, significant anorexia, nausea, palpitation, urinary retention, impaired ejaculation, muscle spasm, leukopenia, agranulocytosis, thrombocytopenia, blurred vision, hepatitis, skin rash, and tinnitus. Imipramine hydrochloride. Imipramine hydrochloride is available under the brand name Tofranil. Imipramine hydrochloride is a tricyclic antidepressant. It triggers moderate anticholinergic effects, sedative effects, and high orthostatic hypotensive effects. In high dosage, a known side effect of imipramine use is increased frequency of seizures in epileptic patients and potential seizures in non-epileptic patients. Amitriptyline hydrochloride. Amitriptyline is also available under the brand name Elavil. Amitriptyline is a tricyclic antidepressant. It is metabolized to an active metabolite, nortriptyline. Amitriptyline has a significant anticholinergic and sedative effect with moderate orthostatic hypotension. In addition, amitriptyline significantly blocks serotonin uptake and moderates activity with respect to norepinephrine uptake. Amitriptyline is useful in the treatment of symptoms of depression, anxiety, and insomnia, as well as the relief of chronic pain resulting from cancer or other pain syndromes. The benefits of amitriptyline are still being investigated for the following. In cases of pathologic emotional outbursts due to forebrain disease, bulimia nervosa, anti-ulcer agent, enuresis, and as an adjunct analgesic for phantom limb pain, migraine, chronic tension headache, diabetic neuropathy, tic douloureux, cancer pain, peripheral neuropathy with pain, postherpetic neuralgia, and arthritic pain. Amoxapine. Amoxapine is also available under the brand name Ascendin. Amoxapine is a tricyclic antidepressant used to treat endogenous and psychotic depression. Amoxapine is used to treat neurotic or reactive depression. Side effects may include tardive dyskinesia. Bupropion hydrochloride. Bupropion hydrochloride is also available under the brand name Wellbutrin. It is an antidepressant smoking deterrent. Bupropion hydrochloride is generally used for the short-term treatment of depression and as an aid to stop smoking. Serious side effects of bupropion use may include anxiety, seizures, sensory disturbances, impaired sleep quality, decreased memory, pseudo-Parkinsonism, akathisia, hyperkinesia, paresthesias, central nervous system stimulation, increased or decreased libido, delusions, suicidal ideation, mania or hypomania, hallucinations, depression, psychosis, formal thought disorder, stomatitis, bruxism, glossitis, jaundice, liver damage, cardiac arrhythmias, hypertension, testicular swelling, prostate disorder, rash, infection, cutaneous temperature disturbance, flu-like syndromes, and nonspecific pain. The next drug is clomipramine hydrochloride. Clomipramine hydrochloride is also available under the brand name anafranil. Clomipramine hydrochloride is a tricyclic antidepressant. Clomipramine hydrochloride is used in the treatment of obsessive-compulsive disorder in cases where the obsessions or compulsions cause marked distress or significantly interfere with social or occupational activity. Clomipramine may also be used to treat panic attacks and cataplexy associated with narcolepsy. Side effects may include hyperthermia, especially when used in combination with other drugs, increased risk of seizures, asthenia, anemia, eructation, sexual dysfunction in males, laryngitis, vestibular disorders, and muscular weakness. Dicipramine hydrochloride. Dicipramine hydrochloride is also available under the brand name Norpramin and Pertorfrane. Dicipramine hydrochloride is a tricyclic antidepressant. It is used to treat symptoms of depression, bulimia nervosa, and to decrease craving and depression during cocaine withdrawal. A bad taste in the mouth is the most commonly reported side effect of dicipramine hydrochloride use. Nortriptyline hydrochloride. Nortriptyline hydrochloride is also available under the brand name Aventil. Nortriptyline hydrochloride is a tricyclic antidepressant. It manifests moderate anticholinergic and sedative effects, but slight orthostatic hypotensive effect. Nortriptyline hydrochloride is used to treat the symptoms of depression, as well as chronic severe neurogenic pain, dermatologic disorders including chronic urticaria, angioedema, and nocturnal pruritus in atopic eczema. Paroxetine hydrochloride. Paroxetine hydrochloride is available under the brand name Paxil. Paroxetine hydrochloride is an antidepressant. It is used in the treatment of major depressive episodes, panic disorder with or without agoraphobia, obsessive-compulsive disorders, and social anxiety disorders. Side effects of paroxetine use may include headache, seizures, activation of mania or hypomania, drugged feeling, myoclonus, central nervous system stimulation, amnesia, emotional lability, vertigo, abnormal thinking, akinesia, alcohol abuse, ataxia, convulsions, possibility of suicide, depersonalization, hallucinations, hyperkinesia, hypertonia, lack of emotion, manic or paranoid reactions, abdominal distress, oropharyngeal disorders, rectal hemorrhage, moniliasis, and anorexia. Phenylzine sulfate. Phenylzine sulfate is also available under the brand name Nardil. Phenylzine sulfate is an antidepressant in the category of monoamine oxidase inhibitor. Phenylzine sulfate presents MAO from metabolizing biogenic amines. The antidepressant effect is due to accumulation of biogenic amines in presynaptic granules. This increases the concentration of neurotransmitters released upon nerve stimulation. Phenylzine is used to treat cases of depression characterized as atypical, non-endogenous, or neurotic, particularly in patients who have mixed anxiety and depression and phobic or hypochondriacal symptoms. Side effects may include dizziness, headache, sleep disturbance including insomnia and hypersomnia, palalia, euphoria, nystagmus, paresthesias, ataxia, shock-like coma, toxic delirium, manic reaction, convulsions, acute anxiety reactions, schizophrenia, reversible jaundice, and in rare cases, fatal necrotizing hepatocellular damage. Protriptyline hydrochloride. Protriptyline is also available under the brand name Vivactil. Protriptyline is a tricyclic antidepressant with significant anticholinergic effects. Tritryptyline has low sedative and orthostatic hypotensive effects. Protriptyline is primarily used to treat the symptoms of depression. Sertraline hydrochloride. Sertraline hydrochloride is also available under the brand name Zoloft. It is an antidepressant and used in the treatment of depression with reduced psychomotor agitation, anxiety, and insomnia. Sertraline hydrochloride may also be used to treat obsessive-compulsive and panic disorders. Serious side effects may include vomiting, teeth grinding, eructation, palpitations, hypertension, hypotension, peripheral ischemia, postural hypotension or dizziness, syncope, tachycardia, activation of mania or hypomania, seizures, anxiety, aggressive reaction, amnesia, apathy, delusion, depersonalization, aggravated depression, emotional lability, euphoria, hallucinations, neurosis, paranoid reaction, suicidal ideation, hypokinesia, rigors, lymphadenopathy, and purpura. Trazodone hydrochloride. Trazodone hydrochloride is also available under the brand name Deserel. Deserel is an antidepressant used in the treatment of depression, either with or without accompanying anxiety. Side effects may include dermatitis, blurred vision, constipation, skeletal muscle aches and pains, hypertension or hypotension, syncope, palpitations, tachycardia, priapism, hematuria, and impaired memory. Rare side effects include hallucination, impaired speech, tremors, and paresthesias. Doxepine hydrochloride. Doxepine hydrochloride is also available under the brand names Adipin and Sinequan. Doxepine hydrochloride is a tricyclic antidepressant. Doxepine hydrochloride is used to treat psychoneurotic patients with depression or anxiety due to organic disease or alcoholism. Doxepine hydrochloride is also used to treat psychotic depressive disorders with associated anxiety and depression or anxiety associated with organic disease. Doxepine has a high incidence of side effects, including a high degree of sedation, decreased libido, extrapyramidal symptoms, dermatitis, pruritus, fatigue, weight gain, edema, paresthesia, breast engorgement, insomnia, tremor, chills, tinnitus, and photophobia. Fluoxetine hydrochloride. Fluoxetine hydrochloride is also available under the brand name Prozac. Fluoxetine hydrochloride is an antidepressant. It is used primarily for the treatment of depression, obsessive-compulsive disorders, and bulimia in adults and geriatric patients. Side effects of fluoxetine use include activation of mania or hypomania, anxiety, decreased libido, disturbances in sensation, abnormal dreams, vomiting, abdominal pain, palpitations, sexual dysfunction, urinary tract infection, dysmenorrhea, pharyngitis, rash, excessive sweating, muscle, joint, or back pain, flu-like symptoms, visual disturbance, weight loss, bacterial or viral infections, and chills. The next drug is meprotylene hydrochloride. Meprotylene is also available under the brand name Ludiamil. Meprotylene is a tetracyclic antidepressant. Meprotylene is used to treat depressive illnesses such as depressive neuroses, manic depressive illness, and major depressive disorder. Duloxetine. Duloxetine is also known under the brand name Cymbalta. Duloxetine is an oral, dual, reuptake inhibitor that enhances the levels of the neurotransmitters serotonin and norepinephrine, which are involved in depression. Duloxetine is indicated for the treatment of major depressive disorder. Duloxetine is also indicated for the management of diabetic peripheral neuropathic pain. Side effects include nausea, dry mouth, constipation, decreased appetite, fatigue, somnolence, and increased sweating. Welcome to the section on anti-diabetics. Anti-diabetics are agents that are used to treat, prevent, or alleviate the occurrence of diabetes. Diabetes is a general term referring to disorders which are characterized by excessive urine excretion, such as diabetes mellitus and diabetes insipidus. When used alone, the term diabetes usually refers to diabetes mellitus. Here's an overview of anti-diabetics. Metformin hydrochloride. Metformin hydrochloride is also available under the brand name Glucophage. Metformin hydrochloride is an oral anti-diabetic. It decreases the production of hepatic glucose. Metformin hydrochloride also decreases intestinal absorption of glucose and increases the peripheral uptake and utilization of glucose. Metformin can be used either alone or as an adjunct to lower blood glucose in patients having non-insulin dependent diabetes whose blood glucose cannot be managed satisfactorily with diet alone. Metformin hydrochloride can also be used with insulin in type 2 diabetes. Side effects of metformin use may include diarrhea, abdominal bloating, anorexia, unpleasant or metallic taste, asymptomatic subnormal serum vitamin B12 levels, and lactic acidosis. Lactic acidosis is fatal in approximately 50% of cases. Exenatide. Exenatide is also known under the brand name Yetta. Exenatide is derived from a compound found in the saliva of the Gila monster, a large lizard native to the southwestern United States. Exenatide is a functional analog of glucagon, like peptide 1, a naturally occurring peptide which enhances insulin secretion in response to elevated plasma glucose levels. By mimicking the function of glucagon like peptide 1, the drug helps more strongly activate this pathway to improve glycemic control. Exenatide is specifically indicated as adjunctive therapy to improve glycemic control in patients with type 2 diabetes mellitus who are taking metformin, a sulfonylurea, or a combination of both, and have not achieved adequate glycemic control. Side effects include nausea, vomiting, diarrhea, jittery sensation, dizziness, headache, and dyspepsia. Pramlintide. Pramlintide is also known under the brand name Simlin. Pramlintide is an anti-hyperglycemic agent. It is designed to mimic the activity of the naturally occurring hormone amylin, which is secreted together with insulin and is involved in postprandial glucose control. Pramlintide is specifically indicated for the mealtime treatment of type 1 and type 2 diabetes in combination with standard insulin therapy in those patients who have failed to achieve adequate glucose control on insulin monotherapy. Pramlintide can also be administered to type 2 diabetics on metformin or sulfonylurea therapy. Side effects include nausea, headache, anorexia, vomiting, abdominal pain, fatigue, dizziness, and coughing. Sitagliptin phosphate. Sitagliptin phosphate is also known under the brand name Januvia. Sitagliptin phosphate is an orally active inhibitor of the dipeptidyl peptidase 4 enzyme called DPP4. The DPP4 enzyme inactivates incretin hormones, which are involved in the physiological regulation of glucose homeostasis. By inhibiting DPP4, sitagliptin phosphate increases and prolongs active incretin levels. This in turn increases insulin release and decreases glucagon levels in the circulation in a glucose-dependent manner. Sitagliptin phosphate is specifically indicated for the improvement of glycemic control in patients with type 2 diabetes mellitus as monotherapy. Sitagliptin phosphate is also used as combination therapy with metformin or a peroxisome proliferator activated receptor gamma agonist when the single agent does not provide adequate glycemic control. Side effects include upper respiratory tract infection, nasopharyngitis, and headache. Welcome to the section on antidiuretics. Antidiuretics are used to suppress the rate of urine formation in patients suffering from abnormal flow. Here's an overview of antidiuretics. Desmopressin acetate. Desmopressin acetate is also available under the brand name Stymate. Desmopressin acetate is a synthetic antidiuretic hormone. It is used in cases of hemophilia A with factor VIII levels greater than 5%. Desmopressin acetate is used in the treatment of von Willebrand's disease with factor VIII levels greater than 5%. Side effects of desmopressin use include agitation, balanitis, chest pains, chills, dizziness, dyspepsia, edema, insomnia, itchy or light-sensitive eyes, pain, palpitations, somnolence, tachycardia, and vomiting. Vasopressin. Vasopressin is also available under the brand name Pitressin Synthetic. Vasopressin is a pituitary hormone. It is used to treat neurogenic diabetes insipidus. Side effects may include increased intestinal activity, abdominal cramps, flatus, facial pallor, tremor, sweating, allergic reactions, vertigo, skin blanching, bronchoconstriction, anaphylaxis, pounding in the head, and water intoxication. Welcome to the chapter on anti-gout agents. Anti-gout agents are used to treat recurrent acute arthritis of peripheral joints called gout. Gout is caused by the accumulation of monosodium urate crystals. Here's an overview of anti-gout agents. Allopurinol. Allopurinol is also available under the brand name Xyloprim. Allopurinol is an anti-gout agent and is a potent inhibitor of xanthine oxidase. This results in decreased levels of uric acid. Allopurinol is used in the treatment of leukemia, lymphoma, and solid tumor malignancies. One common side effect of allopurinol use is pruritic maculopapular skin rash, which may be accompanied by fever and malaise. Other side effects may include vesicular bullous dermatitis, eczematoid dermatitis, lichen planus, Stevens-Johnson syndrome, toxic epidermal necrolysis, intermittent abdominal pain, leukopenia, eosinophilia, thrombocytopenia, leukocytosis, cholestatic jaundice, hepatic necrosis, necrotizing angiitis, hypersensitivity vasculitis, ecchymoses, epistaxis, arthralgia, acute attacks of gout, renal failure, uremia, and alopecia. Colchicine. Colchicine is an anti-gout agent used in cases of prophylaxis. Colchicine is also used in the treatment of acute attacks of gout. Colchicine is toxic, and patients must be carefully monitored. Side effects include diarrhea, abdominal cramping, aplastic anemia, agranulocytosis or thrombocytopenia following long-term therapy, peripheral neuritis, purpura, myopathy, neuropathy, alopecia, reversible azospermia, dermatoses, hypersensitivity, thrombophlebitis at the injection site, and liver dysfunction. If any of these side effects occur, colchicine use should be discontinued at once. Sulfenpurazone. Sulfenpurazone is also available under the brand name Anturain. Sulfenpurazole is a uricosuric agent. It inhibits tubular reabsorption of uric acid, increasing its excretion. Sulfenpurazone is used in cases of chronic and intermittent gouty arthritis. Side effects of sulfenpurazone use include abdominal discomfort, leukopenia, agranulocytosis, anemia, thrombocytopenia, aplastic anemia, skin rash, and bronchoconstriction in aspirin-induced asthma. Acute attacks of gout may become more frequent during initial therapy. If this occurs, sulfenpurazone should be given concomitantly with colchicine. Probenecid. Probenecid is also available under the brand name Benamid. Probenecid is an anti-gout agent and uricosuric agent. It increases the excretion of uric acid by inhibiting the tubular reabsorption of uric acid. This results in a decreased serum level of uric acid. Probenecid also inhibits the renal secretion of penicillins and cephalosporins. This effect increases plasma levels of antibiotics and therefore is a useful adjunct in the treatment of infections. Side effects of probenecid use can include headaches or dizziness, anorexia, abdominal discomfort, skin rash, fever, nephrotic syndrome, uric acid stones with or without hematuria, renal colic or costovertebral pain, anemia, sore gums, hepatic necrosis, aplastic anemia, and, in rare cases, anaphylaxis. Welcome to the section on antihistamines. Antihistamines are used to counteract the histamine which is released during an allergic reaction. They block the action of histamine on the tissue. Antihistamines do not prevent the formation of histamine, nor do they stop the conflict between IgE and antigen. Therefore, antihistamines do not stop the allergic reaction. However, antihistamines relieve the symptoms of the allergic reaction and protect tissues from some of its effects. Here's an overview of antihistamines. Chlorpheniramine maleate. Chlorpheniramine maleate is also available under the brand name chlortrimeton. It is an alkalimine-type antihistamine. It is used in the treatment of allergic rhinitis and allergic reactions to blood and plasma. Chlorpheniramine maleate may also be used as an adjunct to anaphylaxis therapy. Cimetidine. Cimetidine is also available under the brand name Tagamet. Cimetidine is a histamine H2 receptor blocking agent. Cimetidine reduces postprandial daytime and nighttime gastric acid secretion. Cimetidine is primarily used in the treatment and maintenance treatment of active duodenal ulcers. Side effects may include diarrhea, hepatitis or hepatic fibrosis, delirium, hallucinations, double vision, dysarthria, and ataxia. Cyclazine hydrochloride. Cyclazine is also available under the brand name Marazine. It is an antiemetic antihistamine used to treat nausea, vomiting, and dizziness of motion sickness. Side effects may include drowsiness, nervousness, insomnia, euphoria, vertigo, auditory or visual hallucinations, diarrhea, constipation, anorexia, urinary frequency or retention, hypotension, tachycardia, palpitations, dry nose and throat, blurred or double vision, tinnitus, rash, and urticaria. Cyproheptadine hydrochloride. Cyproheptadine hydrochloride is also available under the brand name Periactin. It is a piperidine-type antihistamine. It is used in the treatment of hypersensitivity reactions such as perennial and seasonal allergic rhinitis, vasomotor rhinitis, allergic conjunctivitis, and uncomplicated allergic skin reactions of urticaria and angioedema. Cyproheptadine hydrochloride is also used to treat allergic reactions to blood or plasma, cold urticaria, and also as an adjunct to treating anaphylaxis and dermographism. Increased appetite is a known side effect of cyproheptadine use. Dimenhydrinate. Dimenhydrinate is also available under the brand name Dramamine. Dimenhydrinate is an antiemetic antihistamine which contains both diphenhydramine and chlorotheophylline. Dimenhydrinate is primarily used in the treatment of motion sickness to relieve nausea, vomiting, and dizziness. Diphenhydramine hydrochloride. Diphenhydramine hydrochloride is also available under the brand name Benadryl. Diphenhydramine hydrochloride is an ethanolamine-type antihistamine antiemetic. It is used in the treatment of hypersensitivity reactions, motion sickness, Parkinsonism, and as a nighttime sleeping aid. Fexofenadine hydrochloride. Fexofenadine hydrochloride is also available under the brand name Allegra. Fexofenadine hydrochloride is an antihistamine, and it is used to treat seasonal allergic rhinitis, which may result in sneezing, rhinorrhea, itchy nose, throat, or palate, and itchy, watery, and red eyes. Side effects may include fatigue, headache, nausea, dyspepsia, sinusitis, throat irritation, viral infection, and dysmenorrhea. Meclizine hydrochloride. Meclizine hydrochloride is also available under the brand name Antivert. Meclizine hydrochloride is a piperidine-type antihistamine, antiemetic, and anti-motion sickness drug. Meclizine hydrochloride is used to treat nausea and vomiting, dizziness, vertigo, and other diseases associated with the vestibular system. Side effects may include drowsiness, excitation, nervousness, euphoria, vertigo, auditory or visual hallucinations, diarrhea, constipation, anorexia, difficulty with urination, hypotension, tachycardia, palpitations, dry nose or throat, blurred or double vision, tinnitus, rash, and urticaria. Promethazine hydrochloride. Promethazine hydrochloride is also available under the brand name Phenergan. Promethazine hydrochloride is a phenothiazine-type antihistamine. It is used for prophylaxis and treatment of motion sickness, as well as the prophylaxis of nausea and vomiting due to anesthesia or surgery. Promethazine hydrochloride may also be used as a pre- or post-operative sedative or as an obstetric sedative. Promethazine hydrochloride can be used to treat hypersensitivity reactions and as an adjunct in the treatment of anaphylaxis or anaphylactoid reactions. Side effects of promethazone use may include leukopenia and agranulocytosis. Famotidine. Famotidine is also available under the brand name Pepcid. Famotidine is a histamine H2 receptor antagonist. Famotidine is used in the treatment of active duodenal ulcers and the maintenance therapy for duodenal ulcer. Side effects may include abdominal discomfort, dizziness, headache, paresthesias, depression, anxiety, hallucinations, insomnia or fatigue, grand mal seizure, psychic disturbances, rash, palpitations, arthralgia, asthenia, musculoskeletal pain, thrombocytopenia, fever, orbital edema, conjunctival injection, bronchospasm, tinnitus, taste disorders, decreased libido, and transient pain at the injection site. Nizatidine. Nizatidine is also available under the brand name Axid. Nizatidine is a histamine H2 receptor antagonist. Nizatidine decreases gastric acid secretion by blocking the effect of histamine or histamine H2 receptors. Nizatidine is primarily used in the treatment of acute duodenal ulcer and maintenance following healing of a duodenal ulcer. Side effects may include headache, fatigue, abnormal dreams, anxiety, nervousness, pancreatitis or abdominal discomfort, exfoliative dermatitis, rhinitis, pharyngitis, chest pain, infection, fever, myalgia, impotence, gout, cholestatic or hepatocellular effects, and in rare cases cardiac arrhythmias or arrest following rapid IV use. Levocetirizine dihydrochloride. Levocetirizine dihydrochloride is also known under the brand name Prezista. It is an antihistamine which is orally active and a selective H1 receptor antagonist. Histamines acting on H1 receptors cause the symptoms commonly seen in allergic reactions. Levocetirizine inhibits these H1 receptors. Levocetirizine is specifically indicated for the relief of symptoms associated with allergic rhinitis, both seasonal and perennial. Levocetirizine is also indicated for the treatment of uncomplicated skin manifestations of chronic idiopathic urticaria in adults and children 6 years of age or older. Side effects in the adult population include somnolence, nasopharyngitis, fatigue, dry mouth, and pharyngitis. Side effects for the pediatric population, age 6 to 12, include fever, cough, somnolence, and epistaxis. Welcome to the section on antihypertensives. Antihypertensives are agents that are used to reduce high blood pressure. Here's an overview of antihypertensives. The first drug in this category is guanethidine monosulfate. Guanethidine is also known as ismalin sulfate. Guanethidine is a peripherally acting antiadrenergic antihypertensive drug. It is used to moderate hypertension, including renal hypertension, renal artery stenosis, and renal amyloidosis. Guanethidine is instrumental in depleting norepinephrine reserve and inhibiting norepinephrine release. This produces selective adrenergic blockade of efferent peripheral sympathetic pathways. This results in a prolonged, gradual drop in systolic and diastolic blood pressure, as well as a decreased pulse pressure and a lowering of peripheral vascular resistance. Side effects of guanethidine use include dizziness, weakness, and lassitude. In rare cases, fatigue and depression have been known to occur. Clonidine hydrochloride. Clonidine is also known under its brand name Catapress. Clonidine is a centrally acting antiadrenergic antihypertensive. It stimulates the alpha-adrenergic receptors of the central nervous system. This results in the inhibition of the sympathetic vasomotor centers and decreased nerve impulses. Notably, during the use of clonidine, plasma renin levels are decreased. However, peripheral venous pressure remains unchanged. Clonidine is administered either orally in tablet form or transdermally. It is used in cases of mild to moderate hypertension. The benefits of clonidine are still being investigated for the following: alcohol withdrawal, opiate detoxification, atrial fibrillation, attention deficit hyperactivity disorder, cyclosporine-associated nephrotoxicity, constitutional growth delay in children, Tourette syndrome, hyperhidrosis, diagnostic testing of pheochromocytoma, and postherpetic neuralgia and schizophrenia. Clonidine is effective in the relief of neuropathic pain when administered via epidural injection. Common side effects of clonidine include drowsiness and dry mouth. Guanabenz acetate. Guanabenz is a centrally acting anti-adrenergic hypertensive. It decreases the pulse rate, sympathetic impulses, and sympathetic tone by stimulating the alpha-2 adrenergic receptors in the central nervous system. Guanabenz is used either by itself or with thiazide diuretics to treat hypertension. Common side effects of Guanabenz use are drowsiness and dry mouth. Other known side effects include dizziness, headache, depression, sleep disturbance, heart palpitation, chest pain, and arrhythmias. Guanfacine hydrochloride. Guanfacine hydrochloride is also known under its brand name Tenex. It is a centrally acting hypertensive drug. Though its mechanism is undetermined, guanfacine hydrochloride is thought to act by centrally stimulating the alpha-2 receptors. This causes a decrease in peripheral sympathetic output and heart rate, thereby resulting in a decrease in blood pressure. Guanfacine can be used alone or with a thiazide diuretic to treat hypertension. The benefits of guanfacine hydrochloride in the treatment of heroin withdrawal and migraine headache are currently being investigated. Side effects of guanfacine use include nausea, bradycardia, substernal pain, palpitations, cardiac fibrillation, congestive heart failure, and heart block. Ophthalmic side effects include conjunctivitis, iritis, and blurred vision. Methyl-dopa. Methyl-dopa has the brand name Aldomet. It is a centrally acting anti-adrenergic antihypertensive and is used in the treatment of hypertension. Alpha-methylnorepinephrine is the active metabolite used to lower blood pressure by stimulating central inhibitory alpha-adrenergic receptors. Methyl-dopa is effective in cases of moderate to severe hypertension. It is particularly useful for patients with impaired renal function, renal hypertension, and resistant cases of hypertension which have been complicated by stroke, carotid artery disease, or nitrogen retention. The side effects of methyl-dopa include transient sedation, asthenia, paresthesias, chorioathetotic movements, Bell's palsy, decreased mental acuity, verbal memory impairment, and Parkinson-like syndrome. Cardiovascular side effects include bradycardia, orthostatic hypotension, and hypersensitivity of the carotid sinus. Other side effects of methyl-dopa are toxic epidermal necrolysis, jaundice, hepatitis, abnormal liver functions, lupus-like symptoms, and septic shock-like syndrome. Doxazosine mesylate. Doxazosine mesylate is available under the brand name Cardura. It is an antihypertensive which blocks the postjunctional alpha-1 adrenergic receptors. This results in a decrease in systemic vascular resistance and a corresponding decrease in blood pressure. Doxazosine mesylate is used either alone or in combination with diuretics, calcium channel blockers, or beta blockers to treat hypertension. The most frequent side effect of doxazosine mesylate use is dizziness. Prazosine hydrochloride. Prazosine hydrochloride is available under the brand name Minipress. Prazosine hydrochloride is an antihypertensive alpha-1 adrenergic blocking agent that produces selective blockade of postsynaptic alpha-1 adrenergic receptors and dilates arterioles and veins. This decreases total peripheral resistance, which decreases diastolic blood pressure more than systolic while leaving cardiac output intact. Heart rate and renal blood flow are not affected. Prazosine can be used to initiate antihypertensive therapy. However, prazosine hydrochloride is most effective when used in combination with other agents such as diuretics or beta-adrenergic blocking agents. Prazosine is used to treat mild to moderate hypertension, either alone or in combination with other antihypertensive drugs. Cardiovascular side effects of prazosine use include palpitations, syncope, tachycardia, orthostatic hypotension, and aggravation of angina. Gastrointestinal side effects include diarrhea or constipation, abdominal pain, and pancreatitis. Other known side effects of prazosine use include paresthesias, depression, hallucinations, urinary frequency or incontinence, impotence, priapism, lichen planus, asthenia, edema, symptoms of lupus erythematosus, blurred vision, reddening of the sclera, eye pain, conjunctivitis, edema, and fever. Taurazocine. Taurazocine is available under the brand name Hytrin. Taurazocine is an antihypertensive alpha-1 adrenergic receptor blocking agent that acts by blocking postsynaptic alpha-1 adrenergic receptors. This leads to a dilation of both arterioles and veins and ultimately a reduction in blood pressure. Taurazocine is used either alone or in combination with diuretics or beta-adrenergic blocking agents to treat hypertension and to treat the symptoms of benign prostatic hyperplasia. Side effects of taurazocine use include a first dose effect of marked postural hypotension with syncope, palpitations, tachycardia, and bronchospasm, cold, and flu symptoms, as well as vomiting, abdominal discomfort or pain, arthritis, urinary tract infection, conjunctivitis, abnormal vision, edema, and facial edema. Mecamylamine hydrochloride. Mecamylamine hydrochloride is also available under the brand name Inversine. Mecamylamine hydrochloride is an antihypertensive ganglionic blocking agent used to treat hypertension. Side effects of mecamylamine use may include constipation, glossitis, anorexia, ileus, weakness, impotence, and in rare instances, choreiform movements, mental aberrations, tremors, and seizures. Amlodipine. Amlodipine is also available under the brand name Norvasc. Amlodipine is a calcium channel blocking anti-anginal antihypertensive agent used in the treatment of hypertension. Side effects may include headache, lethargy, sleep disturbance, depression, amnesia, psychosis, hallucinations, tremor, depersonalization, nausea, abdominal discomfort, palpitations, ventricular extrasystole, peripheral ischemia, cardiac failure, pulse irregularity, and parosmia. Benazepril hydrochloride. Benazepril hydrochloride is also available under the brand name Lotensin. Benazepril hydrochloride is an antihypertensive and angiotensin-converting enzyme, or ACE, inhibitor. Benazepril hydrochloride is used either alone or in combination with thiazide diuretics to treat hypertension. Side effects may include headache, anxiety, insomnia, abdominal pain, symptomatic or postural hypertension, palpitations, peripheral edema, impotence, bronchitis, arthritis, decreased hemoglobin, and angioedema. Captopril. Captopril is also available under the brand name Capoten. Captopril is an antihypertensive inhibitor of angiotensin synthesis. It may be used alone or in combination with other antihypertensive drugs to treat hypertension. Captopril is also used in combination with diuretics and digitalis in treatment of congestive heart failure. Side effects may include Stevens-Johnson syndrome, reversible pemphigoid-like lesions, bullous pemphigus, scalded mouth sensation, gastric irritation, abdominal pain, peptic or aphthous ulcers, jaundice, cholestasis, hepatitis, Raynaud's phenomenon, rhinitis, and eosinophilic pneumonitis. Nitroprusside sodium. Nitroprusside sodium is also available under the brand name NitroPress. It is an antihypertensive. Nitroprusside sodium has a direct action on vascular smooth muscle. This leads to peripheral vasodilation of arteries and veins. Nitroprusside sodium acts on the excitation-contraction coupling of vascular smooth muscle by interfering with both influx and intracellular activation of calcium. Nitroprusside sodium has no effect on the smooth muscle of the duodenum or uterus. Nitroprusside sodium is more active on veins than on arteries. It is used in cases of hypertensive crisis to reduce blood pressure immediately. Nitroprusside may also be used to produce controlled hypotension during anesthesia to reduce bleeding and as a treatment in cases of acute congestive heart failure. Side effects may include excessive hypotension. Diazoxide. Diazoxide IV is also available under the brand name Hyperstat IV. Diazoxide IV is an antihypertensive. It takes direct action on vascular smooth muscle, causing arterial vasodilation and decreased peripheral resistance. Administered via IV push, diazoxide IV is primarily used in treating malignant and non-malignant hypertension. Side effects may include hypotension severe enough to cause shock. Other side effects include sodium and water retention, atrial or ventricular arrhythmia, cerebral or myocardial ischemia, marked ECG changes with the possibility of MI palpitations, seizures, paralysis, sensation of choking, transient neurological findings due to alteration in regional blood flow to the brain, hyperosmolar coma in infants, cellulitis without sloughing, warmth or pain along the injection site, phlebitis at the injection site, extravasation, and in rare cases, acute pancreatitis. Diltiazem hydrochloride. Diltiazem hydrochloride is also available under the brand name Cardizem. Diltiazem hydrochloride is an antiaginal, antihypertensive calcium channel blocking agent. It is used to treat cases of vasospastic angina called Prinzmetal's variant. Diltiazem hydrochloride is also used to treat chronic stable angina, particularly in patients who cannot use beta-adrenergic blockers or nitrates, or who remain symptomatic after clinical doses of these agents. Side effects of diltiazem use may include AV block, bradycardia, arrhythmias, angina, Stevens-Johnson syndrome, joint pain or stiffness, nasal or chest congestion, sexual difficulties, hematoma, eye irritation, bundle branch block, abnormal gait, and hyperglycemia. Guanidrel sulfate. Guanidrel sulfate is also available under the brand name Hylarel. Guanidrel sulfate is a peripherally acting antiadrenergic antihypertensive. It has action and kinetic similar to that of guanethine. Guanidrel sulfate inhibits vasoconstriction by blocking efferent peripheral sympathetic pathways and depleting norepinephrine reserves and inhibiting norepinephrine release. This causes increased sensitivity to norepinephrine. Guanedril is used in the treatment of hypertension in patients who do not respond to a thiazide diuretic. Side effects may include fainting, fatigue, headache, psychological problems, visual disturbance, abdominal distress or pain, impotence, joint pain or inflammation, and aching of the limbs. Hydralazine hydrochloride. Hydralazine hydrochloride is also available under the brand name apresoline and is an antihypertensive. Hydralazine hydrochloride exerts a direct vasodilating effect on vascular smooth muscle. Hydralazine hydrochloride also alters cellular calcium metabolism that interferes with calcium movement within the vascular smooth muscle responsible for initiating or maintaining contraction. Hydralazine hydrochloride preferentially dilates arterioles compared with veins, thereby minimizing postural hypotension and increases cardiac output. Hydralazine hydrochloride also increases renin activity in the kidney. This leads to an increase in angiotensin II, which then causes stimulation of aldosterone and thus sodium reabsorption. Hydralazine is used in combination with other drugs for the treatment of essential hypertension. It may also be used to treat cases of severe essential hypertension where PO use is not possible or where there is an urgent need to lower blood pressure. Hydralazine is also the drug of choice for eclampsia. Side effects of hydralazine use may include orthostatic hypotension, angina pectoris, palpitations, paradoxical pressor reaction, tachycardia, psychoses, tremors, depression, anxiety, disorientation, paralytic ileus, a decrease in hemoglobin in red blood cells, lupus-like syndrome, lymphadenopathy, and splenomegaly. Lisinopril. Lisinopril is also available under the brand name Prinavil and Zestril. Lisinopril is an antihypertensive and ACE inhibitor. Lisinopril reduces both supine and standing blood pressures. Lisinopril is primarily used either alone or in combination with a diuretic, usually a thiazide, to treat hypertension. Lisinopril is also used in combination with digitalis and a diuretic for the treatment of congestive heart failure in cases where the patient is not responding to previous therapy. Serious side effects of lisinopril use may include hypotension, stroke, worsening of heart failure, decreased blood pressure, pulmonary embolism or infarction, paroxysmal nocturnal dyspnea, arthritis, hepatocellular or cholestatic jaundice, acute renal failure or dysfunction, angioedema which may be fatal if laryngeal edema occurs, bone marrow depression, malignant lung neoplasm, hemoptysis, and breast pain. Losartan potassium. Losartan potassium is also available under the brand name Cozar. Losartan potassium is an angiotensin II receptor antagonist. It is used in the treatment of hypertension. Severe side effects of losartan use may include CVA or stroke, myocardial infarction, ventricular tachycardia, and ventricular fibrillation. Minoxidil. Minoxidil is given in oral form. Minoxidil is also available under the brand name Loniten. Minoxidil is an antihypertensive. It depresses the sympathetic nervous system and decreases elevated blood pressure by decreasing peripheral resistance through a direct effect. Serious side effects of minoxidil use may include pericardial effusion that may progress to tamponade and Stevens-Johnson syndrome. Used topically under the name Rogaine, it is used to treat male pattern alopecia. Nicardipine hydrochloride. Nicardipine hydrochloride is also available under the brand name Cardene. Nicardipine hydrochloride is an anti-anginal, antihypertensive, calcium channel blocking agent. It moderately increases cardiac output and significantly decreases peripheral vascular resistance. Nicardipine hydrochloride is used in the treatment of chronic stable angina and hypertension. Side effects may include pedal edema, palpitations, tachycardia, hypotension, ventricular extrasystole, peripheral vascular disease, psychosis or hallucination, equilibrium disturbances, abnormal or blurred vision, infection, and atypical chest pain. Nifedipine. Nifedipine is also available under the brand name Procardia. Nifedipine is an anti-anginal, antihypertensive, calcium channel blocking agent. It is used to treat cases of vasospastic angina, which can be either Prinzmetal's or a variant. Nifedipine is also used to treat chronic stable angina without vasospasm and essential hypertension. Side effects may include peripheral and pulmonary edema, hypotension, palpitation, decreased platelet aggregation, arrhythmias, gastroesophageal reflux, sleep disturbance, psychoses, hallucinations, rash, Stevens-Johnson syndrome, arthritis, sexual difficulties, transient blindness, hyperglycemia, hypokalemia, hepatitis, facial and periorbital edema, gout, abnormal lacrimation, breast pain, dysuria, and hematuria. Quinapril hydrochloride. Quinapril hydrochloride is also available under the brand name Acupril. Quinapril hydrochloride is an angiotensin-converting enzyme, or ACE, inhibitor. Quinapril hydrochloride is used either alone or in combination with a thiazide diuretic for the treatment of hypertension. Serious side effects of quinapril use may include hypertensive crisis, rhythm disturbances, cardiogenic shock, gastrointestinal hemorrhage, agranulocytosis, angioedema of the lips, tongue, glottis, and larynx, acute renal failure, and possibly fatal severe heart failure. Ramipril. Ramipril is also available under the brand name Altace. Ramipril is an angiotensin-converting enzyme inhibitor. Ramipril is used either alone or in combination with other antihypertensive agents for the treatment of hypertension. Serious side effects may include myocardial infarction, stroke, arrhythmia, and bronchospasm. Amlodipine and atorvastatin. In combination, they are known under the brand name Caduet. Caduet is the first medicine to treat two different conditions at once, high blood pressure and high cholesterol. Caduet is indicated for the treatment of hypertension, chronic stable angina and vasospastic angina, and Prinzmetal's or variant angina. It is also indicated for primary dis-beta lipoproteinemia, elevated serum TG levels, hypercholesterolemia, and mixed dyslipidemia. Caduet is indicated also as an adjunct to diet to reduce total cholesterol, HDL and LDL, and apo-beta lipoprotein levels in boys and postmenarchal girls 10 to 17 years of age with heterozygous familial hypercholesterolemia. Side effects may include headache, abdominal pain, rash, chest pain, nausea, insomnia, and dizziness. Ambrisentan. Ambrisentan is also known under the brand name Letairis. Ambrisentan is a potent type A selective endothelin receptor antagonist. Endothelin is a peptide made by the body in the endothelial cells. Endothelin constricts blood vessels and elevates blood pressure. Endothelin receptor antagonists are a class of drugs which prevent the constriction or narrowing of blood vessels, thereby enhancing blood flow throughout the body. Endothelin is specifically indicated for the treatment of pulmonary arterial hypertension in subjects with World Health Organization Class 2 or 3 symptoms to improve exercise capacity and delay clinical worsening. Side effects may include peripheral edema, nasal congestion, sinusitis, flushing, palpitations, nasopharyngitis, abdominal pain, or constipation. aliskiren. Aliskiren is also known under the brand name Tecturna. It is an orally active, non-peptide potent renin inhibitor. Aliskiren is the enzyme at the beginning of the renin-angiotensin system, one of the key regulators of blood pressure. Suppression of the renin-angiotensin system has been shown to lower hypertension and reduce cardiovascular events. Aliskiren is specifically indicated for the treatment of hypertension. It may be used alone or in combination with other antihypertensive agents. The use of aliskiren with maximal doses of ACE inhibitors has not been adequately studied. Side effects include hand, face, and/or body edema, diarrhea, abdominal pain, dyspepsia, gastroesophageal reflux, rash, elevated uric acid, gout, and renal stones. Welcome to the chapter on anti-Parkinson agents. Anti-Parkinson agents are used in the treatment of Parkinson's disease. The most commonly used anti-Parkinson agents act either on the dopaminergic system in the striatum and basal ganglia or are centrally acting muscarinic antagonists. Here's an overview of anti-Parkinson agents. Selegiline hydrochloride. Selegiline hydrochloride is available under the brand name Eldepril. Selegiline hydrochloride is an anti-Parkinson agent. It is administered in capsule form. Selegiline hydrochloride is used as an adjunct in the treatment of Parkinson's disease in patients who are being treated with levodopa and/or carbidopa and who have manifested a decreased response to therapy. The precise mechanism of action is not known. However, selegiline does inhibit MAO type B and may act through other mechanisms to increase dopaminergic activity. The side effects of selegiline use include dizziness, fainting, confusion, hallucinations, vivid dreams and nightmares, headache, anxiety, drowsiness, depression, mood changes, delusions, fatigue, disorientation, apathy, malaise, vertigo, overstimulation, sleep disturbance, transient irritability, weakness, lethargy, and personality change. Physical side effects may include tremors, chorea, loss of balance, blepharospasm, restlessness, bradykinesia, facial grimace, dystonic symptoms, tardive dyskinesia, involuntary movements, muscle cramps, heavy leg, falling down, stiff neck, freezing, festination, slow urination, urinary hesitancy or retention, prostatic hypertrophy, urinary frequency, and increased apraxia. Benztropine mesylate. Benztropine mesylate is also available under the brand name Cogentin. Benztropine mesylate is a synthetic anticholinergic and anti-Parkinson agent. It is used as an adjunct in the treatment of all forms of Parkinsonism. Benztropine mesylate is also used to reduce the severity of extrapyramidal effects in phenothiazine or other antipsychotic drug therapy. Benztropine mesylate is administered both in tablets and intravenously. Trihexafenadiel hydrochloride. Trihexafenadiel hydrochloride is also available under the brand name Artane. Trihexafenadiel hydrochloride is an anti-Parkinson agent and anticholinergic that causes a direct antispasmodic effect on smooth muscle and which relieves rigidity in cases of Parkinsonism. Trihexafenadiel hydrochloride is available in tablet or elixir. It is used primarily as an adjunct in the treatment of all forms of Parkinsonism. Side effects of trifenadil use may include serious central nervous system stimulation, which may result in restlessness, insomnia, delirium and agitation, as well as psychotic manifestations. Carbidopa. Carbidopa is also available under the brand name Lodicin. Carbidopa is an anti-Parkinson agent which inhibits peripheral decarboxylation of levodopa. Carbidopa does not inhibit central decarboxylation, which allows more levodopa to be available for transport to the brain. There, the levodopa is converted to dopamine, relieving the symptoms of Parkinsonism. Carbidopa is used in the treatment of all forms of Parkinsonism. Side effects of carbidopa use may include dyskinesias at lower doses. Patients who abruptly withdraw from levodopa while using carbidopa may experience neuroleptic malignant-like syndrome, including symptoms of muscular rigidity, hyperthermia, increased serum phosphokinase, and changes in mental status. Bromocriptine mesylate. Bromocriptine mesylate is also available under the brand name Parlodel. Bromocriptine mesylate is an anti-Parkinson agent and prolactin secretion inhibitor. Bromocriptine mesylate inhibits the release of the hormone prolactin by the pituitary. Bromocriptine mesylate is administered in capsules or tablets. It is used in the short-term treatment of amenorrhea with or without galactorrhea, infertility, or hypogonadism. Bromocriptine mesylate is also used either alone or as an adjunct in the treatment of acromegaly and as an adjunctive therapy with levodopa in the treatment of idiopathic or postencephalitic Parkinson's disease. The type and incidence of bromocriptine side effects depend on the use of the drug. When used for hyperprolactinemia, gastrointestinal side effects may include abdominal cramps, diarrhea, and constipation. Other side effects may include headache, nasal congestion, hypotension, dizziness, fatigue, drowsiness, lightheadedness, and psychoses. When used for treating acromegaly, the gastrointestinal side effects of bromocriptine use may include anorexia, dry mouth, dyspepsia, indigestion, and gastrointestinal bleeding. Other side effects may include dizziness, syncope, drowsiness, fatigue, headache, lightheadedness, lassitude, vertigo, sluggishness, paranoia, insomnia, heavy-headedness, decreased sleep requirement, delusional psychoses, visual hallucinations, orthostatic hypotension, digital vasospasm known as Raynaud syndrome, and in rare cases, arrhythmias, ventricular tachycardia, bradycardia, or vasovagal attack. When used for Parkinsonism, the side effects of bromocriptine use may include abdominal discomfort, constipation, anorexia, dry mouth, dysphagia, confusion, hallucinations, fainting, drowsiness, dizziness, insomnia, depression, vertigo, anxiety, fatigue, headache, lethargy, nightmares, urinary incontinence, urinary retention, urinary frequency, abnormal involuntary movements, asthenia, visual disturbances, ataxia, hypotension, edema of the feet and ankles, blepharospasm, erythromelalgia, skin mottling, nasal stuffiness, paresthesia, and skin rash. Pergolide mesylate. Pergolide mesylate is also available under the brand name Permax. Pergolide mesylate is a potent dopamine receptor agonist. Pergolide mesylate may act by directly stimulating postsynaptic dopamine receptors in the nigrostriatal system. This relieves symptoms of Parkinsonism. Pergolide mesylate is administered in tablets. The most common side effects of pergolide use include postural hypotension, palpitation, vasodilation, syncope, arrhythmias, nausea, hallucinations, anxiety, tremor, abnormal dreams, psychoses, personality disorder, extrapyramidal syndrome, speech disorders, rash, abnormal vision, urinary tract infection, chest pain, abdominal, neck, or backache, headache, flu syndrome, infection, peripheral edema, anemia, and weight gain. Procyclidine hydrochloride. Procyclidine is also available under the brand name Kemadrin. Procyclidine is a synthetic anticholinergic anti-Parkinson agent. Procyclidine is used in the treatment of all types of Parkinsonism and in treating drug-induced extrapyramidal symptoms. Levodopa. Levodopa is also available under the brand names Dopar, Larodopa, and L-Dopa. Levodopa is an anti-Parkinson agent which is used to treat cases of idiopathic, arteriosclerotic, and post-encephalitic Parkinsonism resulting from carbon monoxide or manganese intoxication. In the elderly, this is associated with cerebral arteriosclerosis. The side effects of levodopa are numerous and usually dose-related. Central nervous system side effects may include choreiform or dystonic movements, paranoid ideation, psychotic episodes, depression, suicidal tendencies, hallucinations or delusions, euphoria, and, in rare cases, seizures. Gastrointestinal side effects may include abdominal pain, sialorrhea, dysphagia, dysgeusia, burning sensation of the tongue, and, in rare cases, gastrointestinal bleeding and duodenal ulcer. Cardiovascular side effects include cardiac irregularities, palpitations, orthostatic hypotension, hypertension, phlebitis, and hot flashes. Ophthalmologic side effects include diplopia, dilated pupils, development of Horner syndrome, and oculogyric crises. Apomorphine hydrochloride. Apomorphine hydrochloride is also known under the brand name Apokin. Apomorphine is a non-ergoline dopamine agonist. Apomorphine is indicated for the treatment of motor symptoms associated with late-stage Parkinson's disease. Apomorphine is specifically indicated for the acute, intermittent treatment of hypomobility episodes. These episodes are also called, quote, end-of-dose wearing off and unpredictable on-off episodes, unquote. These episodes are associated with advanced Parkinson's disease. Apomorphine is also used as an adjunct or supplemental therapy to standard levodopa therapy. Side effects include yawning, dyskinesias, drowsiness, dizziness, postural hypotension, rhinorrhea, hallucinations, edema, and inflammation. In addition, apomorphine has been associated with a very high incidence of mild to moderate treatment-responsive nausea and vomiting, especially early in the treatment while the subject is still acclimating to Apokin. It is recommended that subjects begin antiemetic treatment with or just prior to treatment with Apokin and continue for as long as needed. Rivastigmine tartrate. Rivastigmine tartrate is also known under the brand name Exelon. Rivastigmine tartrate is a cholinesterase inhibitor. The exact mechanism of rivastigmine's action is unknown. However, rivastigmine tartrate is thought to exert its therapeutic effect by enhancing cholinergic function. Rivastigmine tartrate inhibits the cholinesterase enzyme from breaking down acetylcholine. It increases both the level and duration of action of the neurotransmitter acetylcholine. Rivastigmine tartrate is specifically indicated for the treatment of mild to moderate dementia of the Alzheimer's type and for the treatment of mild to moderate dementia associated with Parkinson's disease. Side effects include nausea, vomiting, diarrhea, depression, headache, anxiety, anorexia, and weight loss. Rotigotine. Rotigotine is also known under the brand name Nupro. Rotigotine is a non-ergolinic dopamine agonist which acts continuously over a 24-hour period. The exact mechanism of action of rotigotine in the treatment of Parkinson's disease is unknown. Rotigotine is specifically indicated for the treatment of the signs and symptoms of early-stage idiopathic Parkinson's disease. Side effects include somnolence, nausea, application site reactions, dizziness, headache, fatigue, extremity edema, and insomnia. Welcome to the section on antipsychotics. Antipsychotics are drugs that are effective in the treatment of psychoses. Psychosis is characterized by a gross impairment in reality testing as evidenced by delusions, hallucinations, markedly incoherent speech, or disorganized and agitated behavior. The patient does not have apparent awareness of the incomprehensibility of his behavior. Here's an overview of antipsychotics. Chlorpromazine hydrochloride. Chlorpromazine hydrochloride is also available under the brand name Thorazine. Chlorpromazine hydrochloride is a dimethylamino type phenothiazine antipsychotic. Chlorpromazine hydrochloride is used in the treatment of both acute and chronic psychoses, including schizophrenia and the manic phase of manic depressive illness. The next drug is clozapine. Clozapine is also available under the brand name Clozaril. Clozapine is an antipsychotic which interferes with the binding of dopamine to both D1 and D2 receptors. Clozapine is primarily used in the treatment of severe schizophrenic patients who do not respond adequately to conventional antipsychotic therapy. Side effects of clozapine use may include seizures, drowsiness, sedation, confusion, rigidity, fatigue, epileptiform movements, orthostatic hypotension, cardiac abnormalities, muscle rigidity, altered mental status, irregular pulse or blood pressure, abdominal discomfort, pain of the back, legs, and neck, muscle spasm, muscle ache, visual disturbance, transient fever, rash, weight gain, and numbness or soreness of the tongue. Lithium carbonate. Lithium is also available under the brand names Lithobid and Lithonate. Lithium is an antipsychotic agent used for the control of mania in manic depressive patients. Side effects of lithium use may include fine hand tremor, polyuria, transient and mild nausea, general discomfort, arrhythmia, hypotension, sinus node dysfunction with severe bradycardia causing syncope, reversible flattening, isoelectricity or inversion of the T waves, blackout spells, epileptiform seizures, slurred speech, psychomotor retardation, hallucinations, cogwheel rigidity, and tongue movements. Loxapine hydrochloride. Loxapine is also available under the brand name Loxetane. Loxapine is a tricyclic antipsychotic. Loxapine causes significant extrapyramidal symptoms, moderate sedative effects, and a low incidence of anticholinergic effects, as well as orthostatic hypotension. Loxapine is believed to act by blocking dopamine at the postsynaptic brain receptors. Loxapine is used in the treatment of psychotic disorders. Side effects of loxapine use may include tachycardia, hypertension, hypotension, lightheadedness, and syncope. Olanzapine. Olanzapine is also available under the brand name Zyprexa. Olanzapine is used in the management of psychotic disorders. Neuroleptic malignant syndrome, acute renal failure, rectal hemorrhage, heart arrest, and death are among the serious side effects of olanzapine use. Risperidone. Risperidone is also available under the brand name Risperdal. Risperidone is an antipsychotic. Serious side effects of risperidone use may include neuroleptic malignant syndrome, acute renal failure, torsade de pointes, AV block, myocardial infarction, and vaginal hemorrhage. Thioridazine hydrochloride. Thioridazine hydrochloride is also available under the brand name Mellaril. Piperidine-type phenothiazide antipsychotic. Thioridazine hydrochloride is used in the management of psychotic disorders. Thiothixine. Thiothixine is also available under the brand name Navaine. Thiothixine is an antipsychotic used in the symptomatic treatment of psychotic disorders. Side effects may include drowsiness, extrapyramidal symptoms, persistent tardive dyskinesia, cholestatic jaundice, orthostatic hypotension, tachycardia, blurred vision, moderate breast enlargement in women, neuroleptic malignant syndrome, polydipsia, peripheral edema, fine lenticular pigmentation, and in rare cases, anaphylaxis. Trifluoperazine. Trifluoperazine is also available under the brand name Stelazine. Trifluoperazine is a piperazine-type phenothiazine antiemetic antipsychotic. Trifluoperazine is used to manage psychotic disorders. It is also suitable for patients with apathy or withdrawal and for short-term treatment of non-psychotic anxiety. Droperidol. Droperidol is also available under the brand name Inapsine. Droperidol is a butyrophenone antipsychotic and anti-anxiety agent. Droperidol causes sedation, alpha-adrenergic blockade, peripheral vascular dilation, and has antiemetic properties. Droperidol is used preoperatively for the induction and maintenance of anesthesia. Side effects include postoperative drowsiness, restlessness, hyperactivity, anxiety, dizziness, postoperative hallucinations, extrapyramidal symptoms, hypotension and tachycardia, increase in blood pressure when combined with fentanyl or other parenteral analgesics, respiratory depression when combined with fentanyl, laryngospasm, bronchospasm, chills, and shivering. Flufenazine decanoate. Flufenazine is also available under the brand name Modicate, decanoate, and prolixine decanoate. Flufenazine is a piperazine-type phenothiazine antipsychotic. Flufenazine has a high incidence of extrapyramidal symptoms and a low incidence of sedation, anticholinergic effects, antiemetic effects, and orthostatic hypotension. Flufenazine is used in the treatment of psychotic disorders and as an adjunct to tricyclic antidepressants for chronic pain states. Flufenazine is administered via elixir, oral solution, and tablets. Haloperidol. Haloperidol is also available under the brand name Haldol. Haloperidol is a butyrophenone antipsychotic. Haloperidol is used in the treatment of psychotic disorders including manic states, drug-induced psychoses, and schizophrenia. Side effects may include extrapyramidal symptoms, particularly akathisia and dystonia. Perfenazine. Perfenazine is also available under the brand name Trilofan. Perfenazine is a piperazine-type phenothiazine antipsychotic. It has antiemetic effect as well. Perfenazine has a high incidence of extrapyramidal effects, strong antiemetic effects, and moderate anticholinergic effects. Perfenazine has a low incidence of orthostatic hypotension and sedation. Paliperidone. Paliperidone is also known under the brand name Invega. Paliperidone is an oral, extended-release, major active metabolite of risperidone. Paliperidone is an antagonist and thus interferes with neurotransmitter communication in the brain. Paliperidone blocks dopamine type 2, serotonin type 2, and alpha-2 adrenergic receptors, all of which have been implicated in schizophrenia. Paliperidone is specifically indicated for the treatment of schizophrenia. Side effects include Parkinsonism, akathisia, dyskinesia, tachycardia, headache, somnolence, anxiety, hyperkinesia, extrapyramidal disorder, and dystonia. Welcome to the section on antivirals. Antivirals are drugs which stimulate cellular defenses against viruses. This reduces cell DNA synthesis and makes cells more resistant to viral genes. This enhances cellular immune responses or suppresses their replication. The first drug in this category is foscarnet sodium. Foscarnet sodium is also available under the brand name Foscavir. Foscarnet sodium is an antiviral agent. It inhibits the replication of all known herpes viruses by selective inhibition at the pyrophosphate binding site on virus-specific DNA polymerases. Foscarnet is used in the treatment of CMV retinitis in patients with AIDS. Foscarnet sodium is also used in the treatment of acyclovir-resistant HSV infections in immunocompromised patients. Renal impairment is the most common side effect of Foscarnet use. Didanosine. Didanosine is also available under the brand name Videx. Didanosine is an antiviral drug. It is primarily used in cases of advanced HIV infection in adult and pediatric patients who are either intolerant to AZT therapy or have demonstrated decreased effectiveness to AZT therapy. Pancreatitis and peripheral neuropathy are the most common side effects of didanosine use. Lamivudine. Lamivudine is also available under the brand name Epivir. Lamivudine is a nucleoside analog antiviral drug. Lamivudine is used in combination with AZT for the treatment of HIV infection. Side effects of lamivudine include diarrhea, anorexia or decreased appetite, abdominal pain or cramps, severe hepatomegaly with steatosis, pancreatitis, post-treatment worsening of hepatitis, neuropathy, insomnia or other sleep disorders, depressive disorders, peripheral neuropathies, musculoskeletal pain, myalgia, fatigue, fever or chills, skin rashes, and weakness. Zidovudine. Zidovudine is also called azidothybidine, or AZT, and is also available under the brand name Retrovir. Zidovudine is used in the initial treatment of HIV-infected adults who have a CD4 cell count of 500 milliliters or less. The active form of the drug is AZT triphosphate, which is derived from AZT by cellular enzymes. Known side effects of zidovudine include severe anemia, fever, diaphoresis, malaise, body odor, chills, edema of the lips, flu-like syndrome, hyperalgesia, abdominal, chest, and back pain, lymphadenopathy, nausea, gastrointestinal pain, edema of the tongue, eructation, bleeding gums or mouth ulcers, rectal hemorrhage, somnolence, anxiety, and emotional lability. Indinavir sulfate. Indinavir sulfate is an antiviral drug and protease inhibitor. Indinavir sulfate binds to active sites on the HIV protease enzyme, resulting in inhibition of enzyme activity. Indinavir is used in the treatment of HIV infection in cases where antiretroviral therapy is indicated. Serious side effects of indinavir use may include acid regurgitation, jaundice, liver cirrhosis, neurotic disorder, peripheral neuropathy, sleep disorder, cardiovascular disorder and palpitations, musculoskeletal pain, respiratory failure, skin disorder, skin infection, sweating, and urticaria. Ritonavir. Ritonavir is an antiviral protease inhibitor. Ritonavir can be used either alone or in combination with the nucleoside analogs such as DDC or AZT for the treatment of HIV infection. Side effects of ritonavir use include diarrhea, taste alteration, anorexia, abdominal pain, dyspepsia, local throat irritation, circumoral paresthesia, peripheral paresthesia, dizziness, insomnia, paresthesia, somnolence, dementia, asthenia, headache, malaise, fever, sweating, rash, vasodilatation, hyperlipidemia, myalgia, and pharyngitis. Saquinavir mesylate. Saquinavir mesylate is an antiviral drug and protease inhibitor. Saquinavir mesylate is usually combined with AZT or zalcitabine, called DDC, for treatment of advanced HIV infection. Saquinavir is administered in both Invirase and Fortovase capsules. Interferon alpha-Con 1. Interferon alpha-Con 1 is also available under the brand name Infergen. Interferon alpha-Gen 1 is a drug prepared by recombinant technology for the treatment of chronic hepatitis. Interferon alpha-Con 1 has antiviral, antiproliferative, and immunomodulatory effects. Side effects of interferon alpha-Con 1 use may include flu-like symptoms, urticaria, angioedema, bronchoconstriction, amnesia, hypoesthesia, emotional lability, abdominal pain, tender liver, hypertension, palpitation, respiratory tract congestion, rash, back, limb, neck, or skeletal pain, dysmenorrhea, and vaginitis. Acyclovir. Acyclovir is also available under the brand name Zovirax. Acyclovir is an antiviral anti-infective. It is used as a treatment for both initial and recurrent genital herpes in immunocompromised and non-immunocompromised patients. Acyclovir is also used as treatment for chickenpox in children and herpes zoster, also known as shingles, in adults. Side effects of acyclovir use may include diarrhea, anorexia, sore throat, headache, dizziness, fatigue, edema, skin rashes, leg pain, and inguinal lymphadenopathy. Ganciclovir sodium. Ganciclovir sodium is also available under the brand name Cytovine. Ganciclovir sodium is an antiviral drug used intravenously. Ganciclovir sodium is used in the treatment of immunocompromised patients with CMV retinitis, such as AIDS patients. Fever is the most common side effect of ganciclovir use. Ribavirin. Ribavirin is also available under the brand name Virazole. Ribavirin is an antiviral agent and is used primarily in treating hospitalized pediatric patients, including infants with severe lower respiratory tract infections such as viral pneumonia and bronchiolitis due to RSV. Ribavirin is administered via aerosol only. In the cases involving infants, ribavirin is administered via an infant oxygen hood using a small particle aerosol generator 2, otherwise known as SPAG-2. Side effects of ribavirin use may include a worsening of respiratory status, pneumothorax, apnea, bacterial pneumonia, dependence on the ventilator, manifestations of digitalis toxicity, bradycardia, bigeminy, reticulocytosis, conjunctivitis, and rash. Vidarabine. Vidarabine is also available under the brand name Vira-A. Vidarabine is an antiviral and is used in the treatment of acute keratoconjunctivitis and recurrent epithelial keratitis. Vidarabine is more generally effective than idoxuridine for deep recurrent infections. Side effects of vidarabine use may include photophobia, lacrimation, conjunctival infection, foreign body sensation, temporal visual haze, burning, irritation, superficial punctate keratitis, pain, punctal occlusion, and sensitivity to bright light. Amantadine hydrochloride. Amantadine hydrochloride is also available under the brand name Simitrel. Amantadine hydrochloride is an antiviral and anti-Parkinson agent. Amantadine hydrochloride is used in the treatment of influenza A viral infections of the respiratory tract. Side effects may include constipation, anorexia, xerostomia, depression, psychosis, convulsions, hallucinations, lightheadedness, confusion, ataxia, irritability, anxiety, headache, dizziness, fatigue, and insomnia, peripheral edema, urinary retention, leukopenia, neutropenia, mottling of the skin of the extremities due to poor peripheral circulation, skin rash, visual problems, slurred speech, oculogyric episodes, dyspnea, weakness, and eczematoid dermatitis. Fosamprenavir calcium. Fosamprenavir calcium is also known as Lexiva. Fosamprenavir calcium is a new protease inhibitor for the treatment of HIV infection. It is a prodrug of amprenavir, an inhibitor of HIV protease. Fosamprenavir is rapidly converted to amprenavir, an inhibitor of HIV-1 protease, by cellular phosphatases in vivo. Amprenavir binds to the active site of HIV-1 protease, preventing the processing of viral GAG and GAG pol polyprotein precursors. This results in the formation of immature, non-infectious viral particles. Lexiva is indicated for the treatment of HIV infection in adults in combination with other antiretroviral agents. Side effects may include diarrhea, vomiting, headache, and rash. Typranavir. Trypanavir is also known under the brand name Aptivus. Trypanavir is a non-peptide protease inhibitor. The drug disrupts the formation of mature viral particles by disrupting synthesis of viral proteins. Typranavir is specifically indicated as a combination therapy with the approved drug ritonavir for the treatment of HIV-1 infected adult patients with evidence of viral replication. Typranavir is indicated as a second-line or later therapy for use in patients who are highly treatment experienced or whose HIV-1 strain has shown resistance to other protease inhibitors. Side effects include anemia, neutropenia, pancreatitis, pyrexia, hepatic failure, anorexia, peripheral neuropathy, lipoatrophy, diarrhea, nausea, fatigue, and headache. Welcome to the section on blocking agents. Blocking agents are a class of drug that inhibit a specific biologic activity or process, such as axonal conduction or transmission, or ions across a cell membrane. Blocking agents are frequently referred to as blockers. Here's an overview of blocking agents. The first drug in this category is phenoxybenzamine hydrochloride. Phenoxybenzamine hydrochloride is also available under the brand name dibenzoline. Phenoxybenzamine hydrochloride is an alpha-adrenergic blocking agent. It increases blood flow to the skin, mucosa, and abdominal viscera, and lowers blood pressure. Phenoxybenzamine is used to control hypertension and sweating in pheochromocytoma before surgery, when surgery is contraindicated, or in malignant pheochromocytoma. Due to adrenergic blockade, side effects of phenoxybenzamine use include meiosis, postural hypertension, tachycardia, nasal congestion, and inhibition of ejaculation. Other known side effects include drowsiness, fatigue, and gastrointestinal upset. The next drug is phentolamine mesylate. Phentolamine mesylate is also available under the brand name Regitine. Phentolamine mesylate is an alpha-adrenergic blocking agent. It competitively blocks adrenergic receptors. Both presynaptic receptors, called alpha-2, and postsynaptic receptors, called alpha-1, are blocked. This produces vasodilation and a decrease in peripheral resistance. Phentolamine mesylate is used in the prophylaxis or treatment of hypertension in pheochromocytoma resulting from stress or manipulation during surgery. The cardiovascular side effects of phentolamine mesylate use include acute and prolonged hypotension, tachycardia, cerebrovascular spasm, cerebrovascular occlusion, and arrhythmia. Other side effects include orthostatic hypotension, flushing, diarrhea, dizziness, weakness, and nasal stuffiness. Acebutolol hydrochloride. Acebutolol hydrochloride is a beta-adrenergic blocking agent which, at higher doses, inhibits beta-2 receptors. Acebutolol is administered in capsule form and is effective in the treatment of hypertension and premature ventricular contraction. The next drug is atenolol. Atenolol is available under the brand name Tenormin. Atenolol is a beta-adrenergic blocking agent. Atenolol is used in the treatment of hypertension, angina pectoris due to hypertension, coronary atherosclerosis, and acute myocardial infarction. The benefits of atenolol in treating prophylaxis of migraine, alcohol withdrawal syndrome, situational anxiety, and ventricular arrhythmias are currently being studied. Esmolol hydrochloride. Esmolol hydrochloride is available under the brand name Brevibloc. Esmolol hydrochloride is a beta-adrenergic blocking agent which inhibits the beta-1 receptors. Esmolol is used to treat supraventricular tachycardia, or arrhythmias, and sinus tachycardia. Dermatologic side effects of esmolol use include inflammation at the site of infusion, flushing, pallor, induration, erythema, burning, skin discoloration, and edema. Other side effects include urinary retention, midscapular pain, asthenia, and changes in taste. The next drug is metoprolol succinate. Metoprolol succinate is available under the brand name Lopressor. Metoprolol succinate is a beta-adrenergic blocking agent. Metoprolol succinate primarily exerts beta-1 adrenergic blocking activity, although at high doses, beta-2 receptors are blocked as well. Metoprolol is used in the treatment of hypertension, acute myocardial infarction in hemodynamically stable patients, and angina pectoris. Though there are no known side effects of metoprolol use, its safety and effectiveness have not been established in children. Metoprolol succinate should be used with caution in cases of impaired hepatic function and during lactation. Cartiolol hydrochloride. Cartiolol hydrochloride is available under the brand name Cartrol. Cartiolol hydrochloride is a beta-adrenergic blocking agent. It is both a beta-1 and beta-2 receptor blocker. Cartiolol hydrochloride has no membrane-stabilizing effect. However, cartiolol hydrochloride does have moderate intrinsic sympathomimetic effect and low lipid solubility. Cartiolol is primarily used in the treatment of hypertension. The benefits of cartiolol hydrochloride in reducing the frequency of anginal attacks is currently being studied. Cartiolol can also be administered via ophthalmic solution to be used either alone or with other drugs to lower intraocular pressure in chronic open-angle glaucoma and intraocular hypertension. The known side effects of cartiolol ophthalmic include transient irritation, burning, tearing, conjunctival hyperemia, edema, blurred or cloudy vision, photophobia, decreased night vision, ptosis, blepharoconjunctivitis, abnormal corneal staining, and corneal sensitivity. Nadolol. Nadolol is also available under the brand name CoreGuard. Nadolol is a beta-adrenergic blocking agent used in the treatment of hypertension and angina pectoris. The benefits of nadolol in the treatment of the following are being studied: migraine headaches, ventricular arrhythmias, aggressive behavior, tremors associated with lithium or Parkinsonism, antipsychotic-induced akathisia, rebleeding of esophageal varices, and situational anxiety. Pindolol. Pindolol is also available under the brand name Visken. Pindolol is a beta-adrenergic blocking agent. It manifests both beta-1 and beta-2 adrenergic blocking activity. Pindolol has significant intrinsic sympathomimetic effects. Pindolol also has minimal membrane stabilizing activity and moderate lipid solubility. Pindolol is administered in tablet form and is primarily used in the treatment of hypertension. Timolol maleate. Timolol maleate is also available under the brand name Biocadren and Timoptic. Timolol maleate is an ophthalmic agent and beta-adrenergic blocking agent. Timolol maleate exerts both beta-1 and beta-2 adrenergic blocking activity. Timolol maleate has minimal sympathomimetic effects, direct myocardial depressant effects, or local anesthetic action. Timolol maleate does not cause pupillary constriction or night blindness. The mechanism of the protective effect in myocardial ischemia is not known. Timolol maleate is useful in tablet form for the treatment of hypertension. The ophthalmic solution called Timoptic is used to lower intraocular pressure in chronic open-angle glaucoma, selected cases of secondary glaucoma, ocular hypertension, and aphakic patients with glaucoma. Side effects of timolol maleate in ophthalmic solution use include ocular irritation and local hypersensitivity. Succinylcholine chloride. Succinylcholine chloride is also available under the brand names anectine and qualicine. Succinylcholine chloride excites skeletal muscle by combining with cholinergic receptors, preferentially to acetylcholine. Succinylcholine chloride prevents the muscle from contracting by prolonging the time during which the receptors at the neuromuscular junction cannot respond to acetylcholine. Succinyl chloride is primarily used as an adjunct to general anesthesia to facilitate endotracheal intubation and to induce relaxation of skeletal muscle during surgery or mechanical ventilation. Known side effects of succinylcholine chloride use include severe persistent respiratory depression or apnea, muscle fasciculation, postoperative muscle pain, fever, salivation, hyperkalemia, postoperative muscle pain, anaphylaxis, myoglobinemia, myoglobinuria, skin rashes, increased intraocular pressure, muscle fasciculation, myalgia, jaw rigidity, perioperative dreams in children, and rhabdomyolysis. Verapamil. Verapamil is also available under the brand name Kalane and Isoptin. Verapamil is a calcium channel blocking agent. It slows AV conduction and prolongs effective refractory period. Verapamil is used as treatment in cases of angina pectoris due to coronary artery spasm called Prinzmetal's variant, chronic stable angina, unstable angina such as pre-infarction and crescendo, and with digitalis to control rapid ventricular rate at rest. Verapamil is also used during stress in cases of chronic atrial flutter or atrial fibrillation. Verapamil is also used as prophylaxis of repetitive paroxysmal supraventricular tachycardia. Serious side effects of verapamil use may include premature ventricular contractions and tachycardia after IV use, peripheral and pulmonary edema, hypotension, abdominal discomfort or cramps, and hallucinations. IV verapamil may increase intracranial pressure in patients with supratentorial tumors at the time of induction of anesthesia. Atropine sulfate. Atropine sulfate is also available under the brand name Atropare. Atropine sulfate is a cholinergic blocking agent. Atropine sulfate is used as an adjunct in peptic ulcer treatment, irritable bowel syndrome, in the treatment of spastic disorders of the biliary tract, urologic disorders, and urinary incontinence. Atropine sulfate is used during anesthesia to control salivation and bronchial secretions. Side effects of atropine use include blurred vision, increased intraocular pressure, and contact dermatitis. Acebutolol hydrochloride. Acebutolol hydrochloride is a beta-adrenergic blocking agent used in the treatment of hypertension. Acebutolol hydrochloride is administered in capsules. Bepridyl hydrochloride. Bepridyl hydrochloride is an anti-anginal calcium channel blocking drug. It inhibits the transmembrane influx of calcium ions into cardiac and vascular smooth muscle. Bepridyl hydrochloride also increases the effective refractive period of the atria, AV node, His-Purkinje fibers, and ventricles. Bepridyl hydrochloride is used in the treatment of chronic stable angina in patients who have failed to respond to other anti-anginal medications or who are intolerant to such medications. Side effects of Bepridyl use may include the induction of serious new arrhythmias, sinus bradycardia, palpitations, gastrointestinal distress, depression, tremor, respiratory infection, fever, superinfection, rash, arthritis, blurred vision, impotence, and agranulocytosis. Labetalol hydrochloride. Labetalol hydrochloride is also available under the brand names Normodyne and Trandate. Labetalol hydrochloride is an alpha and beta-adrenergic blocking agent. It decreases blood pressure by blocking both the alpha and beta-adrenergic receptors. Labetalol hydrochloride is used in tablet form, either alone or in combination with other drugs to treat hypertension. Side effects of labetalol use may include diarrhea, cholestasis with or without jaundice, fatigue, drowsiness, paresthesias, headache, and in rare cases, syncope. Levobunolol hydrochloride. Levobunolol hydrochloride is also available under the brand name Betagan. Levobunolol hydrochloride is a beta-adrenergic blocking agent which is used to decrease intraocular pressure in chronic open-angle glaucoma or ocular hypertension. Side effects may include transient stinging and burning, decreased corneal sensitivity, blepharoconjunctivitis, urticaria, and pruritus. The next drug is mivacurium chloride. Mivacurium chloride is also available under the brand name Mivacron. Mivacurium chloride is a neuromuscular blocking agent. Mivacurium chloride competitively inhibits the action of acetylcholine on the motor end plate, resulting in the block of neuromuscular transmission. Mivacurium chloride is used primarily as an adjunct to general anesthesia to facilitate tracheal intubation and to provide relaxation of skeletal muscle during surgery or mechanical ventilation. Side effects may include prolonged neuromuscular blockade, muscle spasms, flushing of the face, neck, or chest, hypotension, tachycardia, bradycardia, cardiac arrhythmias, phlebitis, bronchospasm, wheezing, hypoxemia, rash, urticaria, erythema, dizziness, and reaction at the injection site. Nimodipine. Nimodipine is also available under the brand name Nimotop. Nimodipine is a calcium channel blocking agent. Nimodipine has a greater effect on cerebral arteries than arteries elsewhere in the body. Nimodipine is used to improve neurologic deficits resulting from spasm following subarachnoid hemorrhage from ruptured congenital intracranial aneurysms. Side effects may include hypotension, peripheral edema, tachycardia, bradycardia, palpitations, rebound vasospasm, hypertension, hematoma, diarrhea, gastrointestinal hemorrhage, vomiting, headache, depression, hepatitis, jaundice, thrombocytopenia, anemia, purpura, ecchymoses, rash, muscle pain or cramps, diaphoresis, wheezing, and hyponatremia. Pancuronium bromide. Pancuronium bromide is also available under the brand name Pavulon. It is a non-depolarizing neuromuscular blocking agent which is 5 times as potent as D-tubocurarine. Pancuronium bromide is used variously as an adjunct to anesthesia to produce relaxation of skeletal muscle and facilitate ET intubation. Pancuronium bromide is also used to facilitate management of patients undergoing mechanical ventilation. Side effects include apnea, respiratory insufficiency, salivation, skin rashes, hypersensitivity reactions. Penbutylol sulfate. Penbutylol sulfate is also available under the brand name Levitol. Penbutylol sulfate is a beta-adrenergic blocking agent used to treat mild to moderate cases of arterial hypertension. Pipercuronium bromide. Pipercuronium bromide is also available under the brand name Arduan. It is a non-depolarizing neuromuscular blocking agent which competes for cholinergic receptors at the motor end plate and is antagonized by acetylcholinesterase inhibitors. Pipercuronium bromide has no effect on consciousness, pain threshold, or cerebration, and therefore must be accompanied by adequate anesthesia. Pipercuronium is used as an adjunct to general anesthesia to provide relaxation of skeletal muscle during surgery and to foster skeletal muscle relaxation for endotracheal intubation. It is administered intravenously. Side effects may include muscle atrophy, difficult intubation, hypotension, bradycardia, hypertension, thrombosis, myocardial ischemia, atrial fibrillation, ventricular extrasystole, hyposthesia, depression, respiratory depression, hypoglycemia, increased creatinine, rash, urticaria, and anuria. Rocuronium bromide. Rocuronium bromide is also available under the brand name Zemuron. Rocuronium bromide is a neuromuscular blocking agent and generally used as an adjunct to general anesthesia to facilitate rapid sequence and routine tracheal intubation. Rocuronium bromide may also be used to relax the skeletal muscle during surgery or mechanical ventilation. Side effects may include arrhythmias, abnormal ECG, transient hypotension and hypertension, tachycardia, symptoms of asthma, rash, edema at the injection site, and pruritus. Sotalol hydrochloride. Sotalol hydrochloride is also available under the brand name Beta-Pace. Sotalol hydrochloride is a beta-adrenergic blocking agent and is used in the treatment of documented ventricular arrhythmias. Sotalol hydrochloride is also used in the reduction and delay of incidence of atrial fibrillation or flutter in those with normal sinus rhythm who have a recent history of severe or disabling symptoms. Side effects may include new or worsened ventricular arrhythmia and torsade de pointe. Tubocurarine chloride. Tubocurarine chloride is a non-depolarizing neuromuscular blocking agent. Tubocurarine chloride is used as a muscle relaxant during surgery or during the setting of fractures and dislocations. Side effects may include excessive secretion and circulatory collapse. Vercuronium bromide. Vercuronium bromide is also available under the brand name Norcuron. Vercuronium bromide is a non-depolarizing neuromuscular blocking agent and is used to induce skeletal muscle relaxation during surgery or mechanical ventilation. Vercuronium bromide may also be used to facilitate endotracheal intubation and may be used as an adjunct to general anesthesia. Side effects include moderate to severe skeletal muscle weakness and malignant hyperthermia. Doxycurium chloride. Doxycurium chloride is also available under the brand name Neuromax. Doxycurium chloride is a neuromuscular blocking agent which binds to cholinergic receptors on the motor end plate to block the action of acetylcholine. This results in a blockade of neuromuscular transmission. Doxycurium chloride is used as an adjunct to general anesthesia to provide skeletal muscle relaxation during surgery. Side effects include skeletal muscle weakness, profound and prolonged skeletal muscle paralysis, hypotension, flushing, ventricular fibrillation, myocardial infarction, wheezing, bronchospasm, urticaria, fever, and diplopia. Esmolol hydrochloride. Esmolol hydrochloride is also available under the brand name Brevibloc. Esmolol hydrochloride is a beta-adrenergic blocking agent. It preferentially inhibits beta-1 receptors. It is used in the treatment of supraventricular tachycardia, arrhythmias, and sinus tachycardia. Side effects may include inflammation at the site of infusion, flushing, pallor, induration, erythema, burning, skin discoloration, edema, urinary retention, midscapular pain, asthenia, and changes in taste. Felodipine. Felodipine is also available under the brand name Plendil. Felodipine is a calcium channel blocking agent. Felodipine can be used either alone or with other antihypertensives in the treatment of mild to moderate hypertension. Side effects include significant hypotension, syncope, angina pectoris, peripheral edema, palpitations, arrhythmias, tachycardia, anxiety, psychosis, hallucinations, muscle cramps, pain, inflammation, nausea, nasal and chest congestion, respiratory infection, sexual difficulties, urinary frequency or urgency, and dysuria. Pregabalin. Pregabalin is also known under the name Lyrica. Pregabalin is a modulator of voltage-gated calcium channels designed to affect neurological transmission in multiple systems. Pregabalin binds to the alpha-2 delta auxiliary subunit of voltage-gated calcium channels. Blockade of these channels has been shown to inhibit the calcium-dependent release of a number of neurotransmitters. It is specifically indicated for the treatment of neuropathic pain associated with diabetic peripheral neuropathy and postherpetic neuralgia. Pregabalin is also indicated as an adjunctive therapy for the treatment of adult patients with partial onset seizures. Side effects include dizziness, somnolence, peripheral edema, diplopia, dry mouth, tremor, abnormal thinking, infection, headache, pain, asthenia, ataxia, blurry vision, constipation, and edema. Use of pregabalin has been associated with creatinine kinase elevations, including mean maximum elevations of 60 UI. Use of pregabalin has also been associated with weight gain. Natalizumab. Natalizumab is also known under the brand name Tysabri. Natalizumab is a recombinant humanized IgG4K monoclonal antibody produced in murine myeloma cells. Multiple sclerosis is an autoimmune disease that damages and prevents the creation of tissues that protect nerves called myelin. This creates lesions or scar tissue known as sclerosis. Lesions are believed to occur when activated inflammatory cells cross the blood-brain barrier. Leukocyte migration involves interaction between adhesion molecules on inflammatory cells and their counter-receptors present on endothelial cells of the vessel wall. Natalizumab works by blocking the integrin molecule and preventing immune cells from migrating through blood vessels in the brain to areas of inflammation. However, the specific mechanism by which natalizumab exerts its effects in multiple sclerosis have not been fully defined. Natalizumab is indicated for the treatment of patients with relapsing forms of multiple sclerosis to reduce the frequency of clinical exacerbations. Side effects include infections, hypersensitivity reactions, depression, cholelithiasis, and urticaria. Welcome to the section on bronchodilators and antiasthmatics. Bronchodilators and antiasthmatics dilate the lumen of the airway to allow the unrestricted passage of air and to relieve the spasms of asthma. Here's an overview of bronchodilators and antiasthmatics. The first drug in this category is aminophylline. Aminophylline is also available under the brand name Trufilin. Aminophylline is a bronchodilator and is used in cases of neonatal apnea. Aminophylline is also used as a respiratory stimulant in Cheyne-Stokes respiration. The ethylene diamine in aminophylline may cause exfoliative dermatitis or urticaria. Cromolyn sodium. Cromolyn sodium is also available under the brand name Intal. Cromolyn is an antiasthmatic and antiallergic drug. It is used as a prophylactic and adjunct agent in the management of bronchial asthma. It is used in patients who have significant bronchodilator reversible component to their airway obstruction. Cromolyn is also used as a prophylaxis in exercise-induced bronchospasm and bronchospasm due to allergens, cold, dry air, or environmental pollutants. Side effects of cromolyn use may include severe bronchospasm, which may be associated with a precipitous fall in pulmonary function. Other side effects include cough, eosinophilic pneumonia, pharyngeal irritation, nasal congestion, wheezing, nasal stinging or sneezing, dizziness, drowsiness, headache, and in rare cases, laryngeal edema. Theophylline. Theophylline is an antiasthmatic bronchodilator. It is used as a prophylaxis and treatment of bronchial asthma. Side effects may include cardiac arrhythmia, seizures, brain damage, life-threatening ventricular arrhythmias, and peripheral vascular collapse. Netochromyl sodium. Netochromyl sodium is also available under the brand name Tylade. Netochromyl sodium is an anti-asthmatic. It inhibits the release of various mediators from a variety of cell types associated with asthma. This drug is used as maintenance therapy in patients with mild to moderate cases of bronchial asthma. Side effects may include coughing, pharyngitis, rhinitis, increased sputum, bronchitis, dyspnea, bronchospasm, dyspepsia, abdominal pain, dry mouth, diarrhea, dizziness, dysphonia, rash, sensation of warmth, headache, chest pain, fatigue, arthritis, viral infection, and unpleasant taste. Zafirlukast. Zafirlukast is also available under the brand name Accolate. Zafirlukast is an anti-asthmatic used in the prophylaxis and chronic treatment of asthma. Side effects may include diarrhea, abdominal pain, dyspepsia, headache, dizziness, urticaria, angioedema, rash, infection, generalized pain, asthenia, accidental injury, myalgia, fever, back pain, and systemic eosinophilia with vasculitis consistent with Sturge-Strauss syndrome. Xyluton. Xyluton is an anti-asthmatic leukotriene receptor inhibitor. Xyluton is used in the prophylaxis and chronic treatment of asthma in adults and children over 12 years of age. Side effects of Xyluton use may include dyspepsia, constipation, unspecified pain, abdominal or chest pain, asthenia, fever, myalgia, arthralgia, neck pain, urinary tract infection, vaginitis, conjunctivitis, hypertonia, lymphadenopathy, and pruritus. Tiotropium bromide. Tiotropium bromide is also known as Spiriva handihaler. Tiotropium is an antimuscarinic agent. It is administered through an inhalation device used to inhale the dry powder with tiotropium capsules. The capsule is pierced by the device, dispersing the drug into the airstream. Tiotropium is an antimuscarinic agent or anticholinergic with similar affinity to the subtypes of muscarinic receptors M1 to M5. The drug inhibits M3 receptors at smooth muscle sites, leading to bronchodilation. Tiotropium is indicated for the treatment of bronchospasm associated with chronic obstructive pulmonary disease, including chronic bronchitis and emphysema. Side effects include dry mouth, arthritis, coughing, influenza-like symptoms, and sinusitis. Arformoterol tartrate. Arformoterol tartrate is a selective beta-2 adrenergic bronchodilator. Beta-2 receptors are the predominant adrenergic receptors in bronchial smooth muscle. They cause stimulation of intracellular adenyl cyclase, which in turn causes relaxation of the bronchial smooth muscle. Arformoterol tartrate is specifically indicated for the long-term, twice-daily maintenance treatment of bronchoconstriction in patients with chronic obstructive pulmonary disease, including chronic bronchitis and emphysema. Side effects include chest pain, back pain, diarrhea, sinusitis, leg cramps, dyspnea, and rash. Welcome to the chapter on Central Nervous System or CNS stimulants. CNS stimulants are a loosely defined group of drugs. CNS stimulants work by a variety of mechanisms to increase behavioral alertness, agitation, or excitation. Amphetamine sulfate. Amphetamine sulfate is a central nervous system stimulant. It is used to treat attention deficit hyperactivity disorder in children. It is also used to treat narcolepsy in both children and adults. Loss of appetite is a known side effect of amphetamine sulfate use. Methamphetamine hydrochloride. Methamphetamine hydrochloride is available under the brand name Desoxin. Methamphetamine is an amphetamine-type central nervous system stimulant. Methamphetamine is used to treat attention deficit disorder in children over 6 years of age. Methamphetamine is sometimes recommended for the treatment of obesity. It is administered in tablet form. Methylphenidate hydrochloride. Methylphenidate is available under the brand name Ritalin. Methylphenidate is a central nervous system stimulant. It acts by blocking the reuptake mechanism of dopaminergic neurons. This decreases motor restlessness and increases attention span in children with attention deficit disorder. The drug is primarily used in cases of attention deficit disorder in children as part of an overall treatment regimen. The benefits of methylphenidate are being investigated for the following: treatment of depression in the elderly, cancer, post-stroke patients, and anesthesia-related hiccups. Side effects of methylphenidate use include palpitations, tachycardia, angina, arrhythmias, hyper or hypotension, cerebral arteritis or occlusion, nausea, hair loss, abnormal liver function, toxic psychoses, dyskinesia, Tourette syndrome, and psychological dependence. Telithromycin. Telithromycin is also known under the brand name Ketek.